straight away jumping to the topic. My presentation title was Clinical Profile of KRAS mutated non-small cell lung cancer, a single center retrospective study conducted at Amrita Institute in Kochi. So EGFR mutation dominates Asian NSCLC pattern, but the KRAS still remains a key global oncogenic driver. Distinct KRAS subtypes differ in the biological as well as the therapeutic behavior. KRAS targeted therapies, the G12C inhibitors, have renewed the interest in this particular pathway, and the Indian data about this is still limited, and especially from the South Indian profile. That's why it is wanting a regional profiling. So the primary objectives were to evaluate the clinical, pathological, and the molecular characteristics of the KRAS mutated NSCLC in South Indian cohort, and the secondary were to determine the subtype distribution of KRAS mutants and to analyze the demographic associations and the co-mutations pattern. It was a single center retrospective study conducted from 22 to 25 with a population of NSCLC patients with KRAS mutants. Of the 307 patients of non-small cell lung cancers, 50 were found to have harboring this mutation. Data regarding demographic, clinical, and the molecular profile was collected, and the KRAS mutation was determined on the basis of the next generation sequencing. Analysis was done on the basis of the association between the KRAS subtypes, co-mutations, and the clinical variables. The frequency was determined on using the SPSS version. The results were as follows. So the total number of patients who were taken up for the surveillance were 307, of which 249 had at least one of the pathogenic variants on the NGS panel, and of them 50 were found to have harboring the KRAS mutation. The median age was 70 years with a range of 32 to 88. 83% were males and 35% were smokers. The most dominant histopathology which was found was adenocarcinoma, seen in 93% of the patients, and the most common stage at presentation was stage 4 with 62%. On the basis of the different subtypes, the most common KRAS subvariant which was observed was G12D, which was around 32%, followed by G12C, which was 24%, followed by G12A and G12V. And the other co-mutations that were found along with the KRAS positivity, of which the most common one was the TP53, which was observed in 18% of the patients, followed by PI3K, which was seen in 10% of the patients. On the base, further PDL1 expression was correlated with the different KRAS variants, and G12C, total 34% of the patients under this cohort was found to have a tumor proportion score of 1%. And among the different variants, G12C was the one which was of which 25% of the patients were found to have a PDL1 score of more than 50%. So we tried to correlate our data with the data from the different parts of the country, primarily coming from the RGCI in Delhi and Tata from Mumbai. So we didn't have the surveillance size from Tata, but on the basis of the Rajiv Gandhi, our proportion was of around 16%, whereas that of around from Rajiv Gandhi was around 30%. In median age, most of our population median age had 70 years, which makes it distinguished from the other two cohorts, where it was around 57 and 63. There were male predominance, which was observed in all the three cohorts, and smoking prevalence was comparable with around 33%. Histology was similar to the adenocarcinoma past patterns. The point of distinction was the different KRAS subtypes which was observed, wherein both the other two cohorts, G12C followed by G12D, followed by G12V, came out to be the most dominant KRAS subtypes. In our population, G12D was the most common pattern, followed by G12C. Most common co-mutation which was associated with KRAS mutation was KRAS, which was TP53, which was similar to the ones which found in our population. So G12D predominance, along with an older age group and a comparable smoking, associated with the higher TP53 co-mutations, were the distinguishing features that we found in our cohort. So this study represents the first detailed report from the South India, contributing valuable data to the Indian KRAS NSCLC landscape and supporting a multi-regional molecular epidemiology, showing G12D predominant pattern, which is distinct from the north as well as the western cohorts. G12D and TP53 co-mutant tumors represent a biologically distinct subgroup with a potential implication of immunotherapy sensitivity due to higher PD-L1 expression. Thank you.
Good presentation. Just wanted to ask why it is different, like the percentage. I'll just ask one in the global scenario, what is the KRAS percentage in NSCLC compared to what we see in Indian or Asian continent?
Sir, in the KRAS is one of the most common mutations. It's the most common mutations among the adenocarcinoma among the Western populations. It is the EGFR in our as well as the
We'll stick to KRAS.
Sorry, sir?
I'm just asking about KRAS. What is the global percentage of KRAS and what is it different than what we see in Asian or Indian continent?
So we don't have extensive data, especially from the Indian population. With our different cohorts, it is ranging for the global percentage, which is around 15 to 25%, whereas in our study it was around 16%, and in the Rajiv Gandhi we found it to be around 38%.
I think in global it is roughly 30%. That is what exactly what RGCI was showing. And in Asian country, if you see, it is close to 5 to 12%. That is what I think matches your data. And once you find this, what are your treatment armamentarium? First line as well as second line.
So first line, as per the guidelines, is to go ahead with a cytotoxic chemotherapy. And second line, if G12C variant is found, is to go with G12C inhibitors like sotorasib and adagrasib.
Would you like to add immunotherapy for these patients upfront or any time in second line or beyond, irrespective of PD-L1?
It will depend upon, sir, whether the EGFR co-mutation is found along with the KRAS, and if there is high PDL variant, we can plan for an immunogenic therapy.
Co-mutations are very, very less. I think less than 1 or 2% will be co-mutation with EGFR.
Yes, sir, only.
Most of them will not have co-mutation.
Yes, sir.
Nice presentation. I mean, there were two, co-mutations are very less. 2 patients had EGFR co-mutation. Would you like to add anti-EGFR TKIs in those patients no, with this profile?
I think we can go ahead.
See, that's how this is a down pathway. So if that is mutated and default active, whatever inhibition you give upfront might not act. That is the role of combination. Thank you.
Thank you, sir.
Thank you, sir, for your presentation. Now, we would like to call Imogen Timitin Sai, sir. Topic about estimation of plasma epidermal growth factor receptor mutation status and its correlation with the tumor tissue mutation status in advanced non-small cell lung cancer.
Good morning, everyone. Myself, I am Dr. Nitin from the Department of Medical Oncology, SWIMS, Tirupati. Firstly, I would like to invite all the delegates for this conference being held at Templeton, Tirupati. So, as we all oncologists face this common problem that the tissue sample is not adequate for the EGFR mutation analysis, we have done this study of estimation of plasma epidermal growth factor receptor mutation status and its correlation with tumor tissue EGFR mutation status in advanced non-small cell lung cancer patients. As I have discussed, tissue-based EGFR testing is facing the following practical challenges, that is limited biopsy material, tissue heterogeneity, and molecular changes between the biopsy sampling and treatment initiation, and repeat biopsies are invasive and risky, especially in the frail patients. Therefore, a minimally invasive alternative for molecular testing is clinically valuable. So, plasma-derived circulatory-free DNA, which is also known as liquid biopsy, offers a potential non-invasive source for EGFR mutation detection. As we know, there are several sensitive molecular techniques like ARMS PCR, digital PCR, and NGS studies showing promising correlation with the tissue EGFR status. The aim of our study was to determine whether tumor tissue EGFR analysis can be replaced with plasma EGFR analysis to assess the mutation status. And the primary objective of our study was to assess concordance and discordance rates between the tumor tissue and the plasma EGFR mutation analysis. And we calculated sensitivity, specificity, positive and negative predictive values of the plasma EGFR mutation analysis, and a secondary objective was to compare progression-free survival of tumor tissue EGFR mutant patients with or without EGFR mutants in this plasma. Coming to material and methods, it was done in a tertiary care center, which is SWIMS, and the type of study was a prospective cohort study. We have taken newly diagnosed biopsy or cell block proven stage 3 or stage 4 non-small cell lung cancer patients who were recruited to assess EGFR mutation analysis in the tumor as well as plasma samples. Mutation analysis of EGFR gene on tumor tissue were done in real-time based amplification refractory mutation system PCR on formalin-fixed paraffin embedded blocks. Blood was collected in EDTA bottle, and the DNA was extracted from the human blood, and the extracted DNA was analyzed using allele-specific PCR. The PCR was used to amplify the exons 18, 19, 20, and 21, compromising the EGFR gene using the DNA. And we have taken tissue EGFR analysis as a gold standard, and we have calculated the concordance and discordant rates, sensitivity, specificity, positive predictive value, and negative predictive values for this plasma EGFR detection. So, a total NSCLC patients attended during our study period was around 80 patients, and out of this 68 patients were only eligible, and biopsy tissue was not sufficient in 6 patients. So we have taken 62 patients and we have done the study, and the most common site from where we have biopsied was the primary tumor followed by the lymph nodes. And the most common histology seen in the study sample was adenocarcinoma, which we already know. So these are the results of the tumor tissue EGFR mutation analysis. Out of the total recruited 68 subjects, there was positivity in only 14 patients, and the most common exon deletion was exon 19, followed by exon 20 and exon 21. These are the results of plasma EGFR analysis. So in this analysis, we have taken the 62 patients in whom EGFR status was available, out of which only 25 patients turned out to be positive. And the most common again here is exon 19 deletion, followed by exon 20 and exon 25. There were also patients who had both exon 18 and 21 mutation and exon 18, 20 and 21 mutations. So coming to the rates of EGFR mutations detected in the plasma and tissue samples, although tissue EGFR was positive in only 14 patients, plasma EGFR was found positive in 25 patients. We have extrapolated that this can be because of the more heterogeneity and the less availability of that tissue sample. And the overall concordance rate was 66%, and the Cohen's-Kappa coefficient is 0.24, which is fair, and the p-value was 0.038, which is significant. Coming to the diagnostic sensitivity, specificity, and positive predictive value, sensitivity is 64%, specificity is 67%, and positive predictive value in our study was 36%, and the negative predictive value was higher, which is 87%. So this slide shows the progression-free survival of tumor tissue EGFR mutant patients, which was 6 months when compared to 3 months for tissue EGFR wild-type patients. But the difference was not statistically significant in our study because of our low sample size. Among the tumor tissue EGFR mutant patients, PFS of plasma mutation detected versus undetected was 6 and 11 months respectively, but the difference was not statistically significant. Concluding this, EGFR gene mutation analysis of plasma is feasible with allele-specific PCR assays with a high negative predictive value. It can be considered in frail patients who are not suitable for biopsy, but further studies are required to determine whether plasma sample can be considered for determining EGFR mutation status in future. Our limitation for this study is low sample size, which is 62. Thank you.
nice thought actually, and this is what we want to do in private clinical practice also. So in otherwise, whatever the data, I think you didn't put the discussion part, but what is the usual concordance of liquid versus tissue biopsy for EGFR positivity?
Normally in the real world setting, it is around 55 to 70%, sir. Like it's a range depending on the different studies and different places where they have done the study, sir. Our study yielded 66% concordance, but usually it range in the real world setting it ranged from around 50 to 70%, sir. Some studies had even higher. Especially there is a study in Denmark which showed more concordance of around 60, around 70%, sir.
So, and this was done specifically only for EGFR, or it is a one part of your big master chart?
Sorry,
I mean,
sir?
the liquid biopsy was detecting only EGFR specific for this study?
Yes, sir.
Or it was a big study in which this was one part?
No, sir. We have taken only EGFR with the primers of 19, 20, 21.
Good.
Yeah, nice work. As sir said, it has of practical importance.
Yes.
And you said positive predictive value and negative predictive value.
Yes,
can you explain those two terms and what exactly you mean by NPV, negative predictive value?
Positive predictive value, like we take the total number of true positive patients by total number of true positives along with false positives, sir. So by assessing the positive predictive value, like our study will be telling us how much plasma EGFR patients, the mutations was, it can tell whether they are actually positive when compared with the tissue EGFR positivity.
In simple terms, I mean, I understand you are telling the formula and all. In simple terms, a test is positive, a test is negative. And what's the role
How
of
good,
NPV and positive? If you say NPV of 95% and a test is negative, what do you mean by that?
How good the, coming to positive predictive value, it is about how good the test is able to predict the positivity in those patients when compared with the gold standard. And coming to negative predictive value, it is again how good the test is able to detect the negative status when compared to the gold standards.
Yes, so if a test is negative, whether it is truly negative or not, if it is, say for example, negative predictive value is 100%, then it is negative all the times.
Yes.
Similar to the positive. Thank you.
Thank you, sir.
Thank you, sir, for sharing your valuable work with us. Moving forward, our next presenter is Dr. Sunil K.R., who is here to present on spectrum of mutational analysis in advanced non-small cell lung cancer patients.
Good morning, respected chairperson, esteemed faculties, and my dear colleagues. Myself, Dr. Sunil Regmi. I'm from Medical Oncology at Sher-e-Kashmir Institute of Medical Science, Srinagar. And today's my topic for presentation is mutational landscape and outcome in advanced non-small cell lung cancer. Like we all know, lung cancer is the major cause of mortality, consisting around 18.7% as per Globocon 2022. And in India, if we look, it constitutes around 5.9% of the total cancer burden. If we look at the recently published population-based cancer registry, Srinagar is considered to be one of the hotspots for the lung cancer, especially in males with the age-adjusted incidence rate of 39.5. Majority of these patients are non-small cell lung cancer and they present in advanced stage, and molecular profiling become very important in such patients, which has improved the therapeutic as well as the outcomes in the patients. So we conducted a retrospective observational study in our department in which the patient from January 2018 to December 2022 were observed, and we aimed at profiling of somatic genetic aberration in this advanced non-small cell lung cancer and prognostic influence of this alteration on long-term outcome in advanced non-small cell lung cancer. And the primary objective was progression-free survival and secondary objective was overall survival. And the patient who were metastatic non-small cell lung cancer were included, and those patients who were locally advanced and not fit for the curative treatment were included. And the patients who were harboring the genetic alteration were also included. So if you look at the results, the demographic profile, almost 501 patients were included in the study, and median age was around 58.99, a decade earlier as compared to that of the Western cohort. Majority of the patients were male, with the ratio of 2.1:1, and almost 69% of the patients were smokers, and pattern of smoking was cigarette smoking in majority of them. And the median duration of smoking was 33.1 years. If we look at the histology, adenocarcinoma is the most common subtype overall, consisting around 57%. And if we look at the histology as per the smoking history, in those who had a smoking history positive, there were equal adeno as well as the squamous percentages, almost 50%. But in those who were non-smoker, the adenocarcinoma was predominant. And out of all these 501 patients, the mutational analysis was done in 374 patients, consisting around 74% of testing. And the mutation analysis was done based on either NGS or RT-PCR. If we look at the result of molecular analysis, the most common subtype, subtypes we observed was 30.9% were EGFR, followed by TP53 considering around 17.2%. Then ALK, it was present in 9.7% of the patient, and KRAS was present only in around 6% of the patient. Among the subtype of EGFR, most common was EGFR deletion 19, consisting around almost 60%, followed by exon 21 L858R, then exon 20 insertion. If we look at the correlation of this positivity rate with various parameters like adenocarcinoma, those who were non-smoker and female, they have a slightly higher prevalence of this mutation positivity as compared to that of the other counterparts. So when we tested the patient, we started on treatment. Overall population, majority of the patient received first-line chemotherapy, and only 27% of the patient had received the targeted therapy, and 25% of the patient received best supportive care. Among the patients who were positive for the mutation, mutations or the alterations, targeted therapy was given in 65% of the patient, and most common agent used was erlotinib, because of the resource and financial burden, followed by the osimertinib in EGFR and seritinib and crizotinib in ALK positive patients. If we look at the progression-free survival, the median overall progression-free survival was 10.8. And if we look at the subgroups, the female, those who were non-smoker and adenocarcinoma histology, and those who had a mutation positive had slightly higher PFS as compared to that of the other counterpart. And first-line targeted therapy, those who had received median PFS was almost 18 months, and in chemotherapy group, it was 8.37 months. We can look clearly from the graph below that. First graph is first-line treatment, either chemotherapy versus targeted agent versus the best supportive care. There is a clear gap between the Kaplan-Meier curve. And second is anti-EGFR versus the chemotherapy, and third is ALK versus the chemotherapy, which has shown that there is clear benefit with targeted therapy in compared to chemotherapy. If we look at the overall survival, again the overall survival for all population, it was around 15.4 months, and it was again seen that in subgroup, the female who were non-smoker and adenocarcinoma histology and those patients who received the targeted therapy in first-line setting had shown significant improved overall survival as compared to that of the patient who were smokers, who had squamous histology, who were non-mutated, and who has received chemotherapy in the first line. The median OS with anti-EGFR ranges from 29 months, and anti-ALK it was almost 34.5 months, which can be seen in these curves. There is a clear separation between the two curves who has received anti-EGFR and anti-ALK treatment. So to summarize, we have observed that we had a younger cohort of patients, mainly smokers with adenocarcinoma is the most common histology. Actionable mutation were present in 56.7% of the patient, where EGFR and ALK were higher in females and non-smoker, while TP53 was predominant among the smokers. The chemotherapy remained the primary treatment because of the financial burden. Targeted therapy is limited by the axis, and immunotherapy is very rare. The targeted therapy achieved the best outcome in females, non-smoker, and adenocarcinoma. To conclude, the molecular profiling identified the actionable mutation with EGFR being the most prevalent. The targeted therapy has revolutionized the outcome in advanced non-small cell lung cancer. The broader access to the molecular testing and targeted agent is essential to bridge the gap between clinical trial outcome and real-world practice. Strengthening the infrastructure for NGS-based testing and improving affordability can substantially enhance the precision oncology outcome in India. Thank you.
Good presentation actually. This is something what we always want to see from our own data. Just wanted to ask first thing that why almost 1/4, 25% you could not do analysis of molecular markers. Any specific reason?
Yes, sir. Sir, actually this was the data collected during the period of 2018 to 22. And during that time there was a COVID pandemic as well. So most of the patients which were diagnosed, they defaulted or somehow missed with the testing, sir.
Okay. And this consistency of the data and the treatment part, the outcome, do you think it syncs with the global standard or it is lesser than that?
Sir, it is lesser than that. The fact being, we are not having the luxury of using the third generation TKI like osimertinib or lorlatinib. None of our patients has received lorlatinib. Only 17 patients has received the osimertinib in this group. So first generation TKI, it has an inferior outcome as compared to the global standard, sir.
And any relevance of TP53 in the treatment part, because that was probably the second most common scenario. This is what we see even in practice.
Yes, sir. Yes, sir. Actually, sir, those patients who harbors TP53, usually they are, they don't do well with the, when we combine, like if they have co-mutation, they won't do well with the targeted therapy. So like FLAURA2, we combine them with the chemotherapy, with targeted therapy. So it remains, chemotherapy remains the backbone for such patients, sir.
See, I mean, you said like when Sir asked, when compared with the old data, how your data stands. One thing I want to tell is, see, if you take only EGFR, if you take only first generation TKIs, when it's around 30 or 31 months, I mean, it's 29 months at your institute, it is same. So maybe if you add third generation TKIs and all, that will give extra advantage over survival. But if you take only first generation TKIs, I mean, this is, your data is at par with old data. The second thing is, have you been TP53 and role of the mutations, have you checked any variables which are associated with better survivals among the EGFR? Like L858, I mean, exon 21 versus exon 19 and TP53 and other variables?
Sir, among the EGFR mutation, EGFR deletion 19 and L858 has a favorable survival, but those who are harboring TP53 along that we have not analyzed, sir.
Okay. Thank you.
Thank you, sir.
Thank you, sir, for your insightful presentation. Now I would like to call upon Dr. Nalccon Joshi, sir, who will be presenting about longitudinal changes in comprehensive geriatric assessment and parameters in older patients with cancer.
Good morning to all. I will be presenting today the longitudinal changes in comprehensive geriatric assessment parameters in older patients with cancer. This study was conducted at Tata Memorial Hospital, Parel, Mumbai. In 2018, ASCO first presented the guidelines for geriatric assessment in the cancer patient, and according to that guidelines, in patients who are 65 years or more receiving chemotherapy, geriatric assessment should be used to identify the vulnerabilities that are not routinely captured in our oncological assessment. After this, there are multiple studies were conducted, that is GAIN, Jericho, and GAP 70+. They have demonstrated that doing a geriatric assessment in a cancer patient who is receiving the cancer-directed treatment have improved the outcomes. Again in 2025, guidelines were published by ASCO. In these guidelines, apart from doing a geriatric assessment, they have also recommended that after identifying the domains, in which the patients are vulnerable, we should also do interventions and try to correct those vulnerabilities during the cancer treatment. Despite of the above recommendation by ASCO, there is a dearth of studies with serial geriatric assessment. So aim of the study is to identify the longitudinal changes in geriatric domains and frailty in older patients undergoing cancer treatment. This is a prospective cohort study conducted from November 2020 to November 2023. Here we included the patients with cancer who underwent geriatric assessment at baseline and follow-up. The appropriate referrals were made to dietitian, physiotherapist, and psychiatrist. Now these are the different domains, geriatric domains, that is functional, nutritional, cognition, comorbidities, medication, and psychological. For assessing these domains, we have used the different parameters which I have enlisted in this chart. For assessment of functional domain, we have used time up and go test, activities of daily living, instrumental activities of daily living. For assessing the nutrition, we have used MNA, that is mini nutritional assessment, a body mass index. For assessment of cognition, we have used mini mental scale examination, and for assessment of comorbidities, predominantly we have used Charlson Comorbidity Index, Mobility Tiredness Scale, Mobility Health Scale, and Fatigue Assessment Scale. To identify the potentially inappropriate medication used in adult population, we have used the Bayes criteria, and we have defined polypharmacy as use of 5 or more drugs. For assessing the psychological parameters, we have used GDS and GAD-7 scale. GAD-7 is a generalized anxiety disorder scale which includes the 7 items. In this, we have enrolled, the total number of patients enrolled in this study were 50, and 42% of the patients were diagnosed with a carcinoma lung, and 26% of the patients were carcinoma esophagus. All the patients in this study have received chemotherapy. Surgery and radiotherapy was done in 20 and 22% of the cases. Physiotherapy, psychiatry, and dietitian referral were made in 78, 48, and 92% of the cases. Now these are the different domains, that is frailty was seen in 92% of the cases at baseline and 84% of the cases at follow-up, while falls were recorded in 50% of the patient at baseline and 48% of the patient at follow-up, while nutrition was seen in abnormal nutrition was seen in 92% of the cases at baseline and 93% of the cases at follow-up, while cognitive impairment was recorded in 16% of the cases at baseline and 13% of the cases at follow-up, while comorbidities were detected in 38% of the cases at baseline and 42% of the cases at follow-up, and inappropriate medication use was seen in 56% of the patient at baseline and 50% of the patient at follow-up. While psychological derangements were detected in 54% of the patients at baseline and 43% of the patient at follow-up. The resolution of frailty was noted in 12% of the cases, and new onset frailty was seen in 4% of the cases at follow-up. The improvement was noted in cognition, medication, and psychological domains. In this from this study, we learned that the serial geriatric assessment is an easy to use tool on OPD basis, OPD based assessment for the longitudinal assessment of frailty. And in our study, we could objectively identify the changes in individual geriatric domains. So the conclusion from this study is serial geriatric assessment can objectively identify changes in geriatric domains and frailty. There is an assessment of frailty and geriatric domains in temporal relation to treatment may help to modify treatment in future. And this study underscores the role of supportive interventions in this population. The larger intervention trials are required to explore the use of GA in cancer care.
So good and extensive, actually. Geriatric assessment is not very easy. I can understand it takes a lot of time to do it. Important part is how did it impact your treatment? Because I think you gave chemotherapy to everybody. So irrespective of whatever was their geriatric assessment score, everybody received chemotherapy. So how do you think that this has impacted the treatment part of the, choosing the treatment part?
So by assessing frailty, especially if the patient is frail, we have defined the frailty as if patient has abnormality in 2 or more domains, then that patient is frail. So we can reduce the intensity of the treatment for that patient, especially if the patient is in a palliative setting, where the quality of life is also important.
So like in the treatment part, what is changed? Like have you reduced the doses of chemotherapy, or you have not given chemotherapy and have given some TKIs? I mean, what you have done? What changes you have done?
So predominantly, if for example, some patient has abnormalities in nutrition, then we refer the patient to dietitian so that we can improve on that part. And secondly, like if the patient is a metastatic CA lung, generally according to new guidelines, the standard of care for those metastatic patients is chemotherapy plus TKI. But if patient is frail, then generally we have avoided giving the chemotherapy in them and continued with the TKI only.
In the interest of time, only one question. You said for few patients, frailty resolved, and for some patients, you again told that they were frailty. What are the reasons for that?
So the frailty may be resolved in some patients because there are some correctable factors like correcting the nutritional deficiencies and in some patients we corrected the nutritional deficiencies or correcting they are taking some inappropriate medications, we have stopped them. So that at the first follow-up, these reversible factors we could by doing this intervention we could reverse those factors which are easily doable. That's why the frailty has improved in some patients, and frailty may have worsened in some patients due to the disease progression itself.
Thank you, sir, for your insightful presentation. Moving forward, our next presenter of the day is Dr. Muthuveerappan, who will be presenting on multi-center study on the outcomes of pleural mesothelioma.
Good morning, everyone present here. I'm going to present on a multi-center study on the outcomes of pleural mesothelioma. And we have conducted this study in various institutes from JIPMER, primarily from JIPMER, Cancer Institute Adyar, Malabar Cancer Center, Amala Institute, and AIMS Rishikesh. There is limited data on pleural mesothelioma treatment and outcomes from India. Actually, only few registries report about mesothelioma data in India. And the largest series and the only series reported about treatment outcomes in India is 25 cases from AIMS Delhi. And in that, asbestos exposure was 32%. And the current series is from the 5 centers. And methods is, it's a retrospective study. We have retrospectively evaluated from 2011 to 2025 of mesothelioma patients, and IEC approval from all centers were obtained. And we have analyzed the clinical presentation, pathological diagnosis, stage at presentation, treatment strategies, and survival data. and PFS OS was calculated using the Kaplan-Meier method. Moving on to the results, from 2011 to 2025, from 5 centers, we are able to collect 17 patients, in total of 17 patients, and the median age of the population is 54 years, and it was male and female almost similar, and the most presenting symptom is dyspnea in 50% of the patients, and around 50% are metastatic disease at presentation. And if you see the pleural and extrapleural disease, the extrapleural disease is around 88.7%, that is 15 patients out of 17 patients. And the histology commonly encountered is epithelioid histology, that is around 60%. So among the 17 patients, 3 patients doesn't receive any treatment, and only 14 patients receive treatment. Among that, 4 patients received a multimodality curative intent treatment, that is combining surgery, radiotherapy and chemotherapy. And almost remaining 10 patients received chemotherapy plus or minus RT. The chemotherapy is a platinum doublet, that is PEM-carbo or pemetrexed plus cisplatin. And the median number of cycles completed is 3 cycles. And among which the radiations, in total 8 patients has received, among which that 4 patients are received as a curative intent, either adjuvant or a radical. So moving on to the progression-free survival, after a median follow-up of 52 months, the number of events were 13, and the progression-free survival is 3.7 months actually. Some patients at presentation itself, they are in a very PS of 3 to 4 actually, 3 to 4, and after 2 to 5 days itself, they are almost in a dreadful conditions. So the subsequent therapies has been received by 4 patients out of 17 patients as a second line or third line. And that therapies were oral metronomic therapy with cyclophosphamide etoposide, a platinum re-challenge, a gemcitabine, pembrolizumab or nivolumab plus ipilimumab patients have received. And with the subsequent therapies, the overall survival is with the median follow-up of 52 months, the number of events was 7, and the median overall survival is 14.1 months. And so the epithelioid mesothelioma is the most common histology, and the majority of the patients actually present in an extrapleural or a metastatic setting. And the progression-free survival in our study is 3.7 months, which is lesser than the literature data reported with the platinum doublet, that is PEM plus cisplatin, which is 5.7 months. And the overall survival is 14.1 months, which is preserved due to immune salvage-based treatment in around 4 patients. So to conclude, Indian pleural mesothelioma patients present with extensive disease, precluding surgery, and the asbestos exposure was also not documented in majority of the patients, and we don't know about it. And the outcomes with systemic therapy are generally poor in this pleural mesothelioma patients. Thank you.
Good. I mean, mesothelioma, that's a good presentation. Mesothelioma is very rare, very difficult to find and very difficult to treat. Just one question. What was the reason for few patients who did not receive treatment?
Sir, 3 patients doesn't receive treatment. 2 patients expired in actually they came and within 5 days. And 1 patient not received any treatment, and they were about for some 12 days.
Any prognostic factors for?
Yes, sir. Prognostic factors actually I have not mentioned here. The prognostic factor is generally a good PS, actually 0 to 1, that which in this study we have not seen. Almost all patients are 2 and 3 PS. And female gender is good prognosis, which is almost similar here. And epithelioid histology is one of the good prognostic factor, and which is around 10 patients was there. And then next prognostic factor is WBC count actually, but we don't have for few patients.
Fine, thank you.
Thank you, Doctor, for your wonderful presentation. Now, I would like to call upon Dr. Saman Singh, who will be presenting evaluation of dosimetric emesis and outcomes of SBRT in the early stage, MOM-SCLC.
A very good morning to everyone, respected all the judges, all delegates. and on the organizing committee. Today I'll be presenting on the topic evaluation of dosimetric indices and outcome of SBRT in early stage non-small cell lung carcinoma. Giving a brief background about it, historically, lobectomy with or without mediastinal lymph node dissection has been regarded as the gold standard of management of early stage non-small cell lung carcinoma. However, with the emergence of SBRT, that is stereotactic body radiotherapy, has introduced a non-invasive and clinically comparable alternative to surgical resection. Studies have shown similar outcomes with SBRT in comparison to surgical approaches in appropriately selected patients. SBRT provides a very precise high-dose radiation, optimizing local control with minimal toxicity. And SBRT is an excellent option for inoperable high-risk and patients who refuse surgery. The objectives of my studies were to evaluate the dosimetric parameters and plan evaluation with conformity index, heterogeneity index, and the organ at risk dose volume metrics. The toxicities were evaluated for acute and late, and we evaluated the clinical outcomes with local control by response assessment done at 3rd, 6th, and 9th and 12th month. For the study design, it's a prospective study done over a period of 1 year, starting from March 2023 to April 2024. 10 patients were evaluated, of which 7 were male and 3 were female, aged from 22 years to 73 years. Median age would be 52.4. The 22nd year patient could be considered as an outlier. The performance status of the patient were ECOG PS 0 to 1, and the stages which were evaluated were stage T1 N0 M0, which were 4 patients, and T2 N0 M0, which were 6 patients. If we categorize the lesion according to the location, there were 2 central patients, 2 ultracentral patients, and 6 peripheral patients. We took all these patients and they were contoured on the basis of 4D CT planning, and the margins for GTV were given around 3 mm to plan for PTV, and the dose fractionations were given according to the location of the tumor for central, ultracentral, and the peripheral tumor. It was planned using a 6 MV non-coplanar X-ray using a Monaco TPS, and an individualized QA was done for all the patients of Versa HD Linac using daily image guidance. The treatment given was on alternative days, and no major treatment gaps were observed. 9 of the 10 patients had a very good local control at 1 year follow-up, and only 1 patient developed a systemic progression at 8 months duration. And there was no grade 3 or grade 4 toxicities observed either in acute or late follow-up period at 12 months. So assessing the parameters, the GTV volume, median was 17.71 cc. For PTV, it was 30.63 cc. The heterogeneity index median that we got was 0.52, and the conformity index was 0.89. For OARs, all the dose metrics were conformal, and it met the standard criteria. For spinal cord, it was met for 13.83 gray, and for the bilateral lung minus PTV volume, we achieved a 5.5 cc volume. And for esophagus, a 16.31 gray Dmax was achieved, and for heart, a 5.8 gray Dmean was achieved. Coming to discussion, SBRT is safe and a non-invasive alternative to lobectomy in patients with early stage non-small cell carcinoma. And SBRT has consistently achieved an optimal dosimetric parameters across various lesion locations, ensuring precise radiation targeting, and has achieved dose constraints for organ at risk consistently. It offers a very high local control with minimal toxicity, supports for effectiveness. In discussion part, the prospective and there are various prospective and retrospective studies which has demonstrated the superiority of SBRT over the conventional and the best supportive care in early stage local non-small cell lung carcinoma, and the control rates have exceeded more than 90%. Its equivalence to surgical outcomes has also been reported in various studies, and there is a matched pair analysis which has proved the evidence. And it's always considered as an utmost importance to discuss it in the MDT or the multidisciplinary tumor board before we go for any treatment. So concluding it, SBRT offers a very safe and effective and a non-invasive option for early stage non-small cell lung carcinoma patients. And the advances in radiotherapy, including the event of 4D CT it has evolved our treatments into a precise dose delivery while minimizing the toxicity to OARs. The tumor size and location are critical in determining the appropriate dose fractionation. Careful patient selection is of utmost importance, done at least via an MDT discussion, and a daily imaging will ensure our conformal dose delivery to the tumor, which enhances treatment precision. So, SBRT demonstrate an excellent local control and represent a well-tolerated curative treatment for early-stage non-small cell lung carcinoma. Thank you.
Good presentation. Just one question. Compared to surgery in the same setting, how do you find radiation has limitation, SBRT has limitation compared to surgery? What all points you will say for the limitations?
So for limitation, I would say it is still not a level 1 evidence. The evidences which are there are match pair analysis. There is no randomized phase 3 trial which has evaluated it. All the trials are still phase 2 or a retrospective analysis. So we need a prospective analysis, and mostly it is done that SBRT is offered to patients who are inoperable or have comorbidities or have either denied for surgeries. So it has not really been evaluated for patients who are operable and who even distribution of surgery and SBRT patient population has not been done. So phase 3 RCT should be deemed important.
How have you categorized central and ultra-central?
So for according to the no-fly zone that we define, it is the area which is surrounded by the proximal bronchial tube, which is proximal bronchial tube. We say that the proximal 2 centimeter of the trachea, the lobar bronchis, and the starting of the segmental bronchi, that is the intermedius bronchus, these are considered as the proximal bronchial tube. And a 2 centimeter volume is formed around it. So any tumors which is present inside this volume will be considered as central. Any tumor which is abutting the proximal bronchial tree or the heart or the great vessels will be considered as ultracentral. Okay, thank you.
Thank you all the residents for a very beautiful and engaging presentation. And good morning, everyone. I'm Dr. Lakshmi Sandhya, the Organizing Secretary for Nalccon 2025. And we are very happy to welcome you all. And we would start our scientific program. And thank you for being here.
So we now start the first session of the day, and to chair the session, I invite Dr. H.S. Singh, Dr. Bhushan onto the stage. So the first talk of the day is by Dr. Digambar Behra, and the talk is about global and regional epidemiology of lung cancer. Where do we stand?
Good morning, everyone. Thanks to the organizing for giving us a chance to share this very, very important session. And I congratulate Dr. Prashant and Dr. Sandhya for organizing such a beautiful event. So, this I call upon Dr. D. Behera, the president of this association, to deliver his talk on the epidemiology of lung cancer.
Thank you, Dr. Prashant Pennumadi and Dr. Sandhya, for bringing such a wonderful crowd, even at 9 o'clock, 9:30 a.m. in morning. I think so. We are at the reach the horizon where India should consider lung cancer epidemic in a big way, and everyone, surgical oncology, medical oncology, radiation oncology, should know in depth about lung cancer, because the treatment is going to evolve and keep on evolving. So we hand over to Professor Digambar Behera for continuing his talk.
Okay, thank you, chairpersons, and very good morning, ladies and gentlemen, and welcome to the nice city of Tirupati. And we'll be starting the ball rolling. The first talk of the session is on the global and regional epidemiology of lung cancer, and where do we in India stand. This is the Globocan 2024 report. As of 2022, there are about 20 million cases of cancer, and out of that, nearly 50% died in that year. So this one again shows the distribution of the different regions. Have I got a pointer? You can give us a pointer. You see the most of the cases are reported from countries, the Asian region, both the incidence wise. If you also see most of the mortality again from the Asia, nearly 60% of these cases they are from Asia. If we go to this is the distribution in both sexes about the different types of cancer. When you see lung cancer stands out as the number one cancer, both the incidence wise as well as mortality wise. And this one again, the same thing is showing. If you see the first row, that is the lung cancer, both the incidence wise as well as mortality wise, it is the number one cancer world over. This is again the sex wise distribution. This is in case of males. Again you can see the commonest cancer reported in 2022 is lung cancer, about 15% of all cancers, and the mortality again is higher, about 23% of all mortality was because of lung cancer in case of males. Of course, the situation is little different in case of females. You see the lung cancer is the second commonest cancer incidence wise, and so also the mortality wise. But overall, when you take both sexes, it is the lung cancer stands out. This is the ranking of the 10 most common cancer. The number is given about 2.4 million cases. That is again ranked as number one. So also the mortality, that is again number one, which I had already told you. This is the distribution about from the human development index wise. Also you see, even at the most commonly in the high and very high human development index countries, it is again the commonest. Lung cancer stands out. The lung cancer in case of males, and in case of females it is about the third one. And of course in the low and medium human development index countries it is a little less. But as I said, if you take everything together, it stands out to be the commonest one. Then again the bar chart of the region specific incidence rates, particularly the Eastern Asia. You see, this is the commonest, both the incidence wise as well as this is the incidence wise both in case of males and in case of females. So why it disappeared? Any problem? Any problem? Projection team, any problem here? I did nothing. What happened? Yeah. I think the charge possibly it was. I think the charge went up. This one is again, you can see this is the cancer incidence and the trends from 2020 to 2024. That has again shown the human development index categories. You see the medium, if you see the second one from the below, you see the incidence is rising. So also in the very high HDI, although there is a slight decrease in the other areas, but the medium HDI group that is rising over the years. This is what is the projected number of new cases for all cancers combined. If you can see in both cases, by 2050 what will be happening. You see in the low human development index countries, so it is going to be increased by about 142%. All regions actually it is going to increase, but the most one will be low and medium human development index countries. So this is this one I think I have already tell you, but this slide only shows you the numbers. I think we have already discussed in both in males it was the commonest one, about 1.5 million cases of lung cancer, then followed by others, and in females it is the second common one, followed by following the breast cancer, and this is the numbers, and the last one shows about both sexes, about 2.4 million cases. So what we saw, there is a regional variation in the cancer burden. In the Western Europe and Northern Americas, it had the highest incidence rates for lung, breast and colorectal cancer, and lung cancer is leading in both regions, that is around 2,000 cases per 100,000 in Western Europe. On the contrary, the Sub-Saharan Africa and Central Asia, there is a significantly lower incidence rates, and the lung cancer was still being the most common, but at much lower levels, around 1,058 cases per 100,000 in Sub-Saharan Africa. So these disparities underscore the influence of socioeconomic factors, healthcare infrastructure, and environmental exposures on the cancer prevalence. So this is the one shows this is the mortality to incidence ratio. That means the mortality rate and the incidence. This is the ratio. That is the MIR by region wise. You can again see the ratio is quite high. That means the mortality in comparison. Again, this is this one, the 5-year change in the incidence rates that I had shown you, I think, one of the slides. You can see the lung cancer, there is a rise that I think, if you remember, I had seen one of the slides. So these are the different regional differences I have already told you. So now coming to India, about the number of new cases in 2022. So this is about 1.4 million cases of cancer, and then out of that about 9 lakh deaths. And this is about the lung cancer scenario in 2022 as per the Globocon pictures. In case of males, it is the second one following the lip and oral cavity, and in case of females, it is of course not a very common cancer in females, but when we do for the both sexes, it is the incidence is quite high. If we go to the individual reports, it was a very rare cancer in I think the first reported report about lung cancer in India that I could lay my hands in 1935. That was the first report. Then subsequently all over the country, these are these two slides that I have just summarized, that where they are presented. I think one of the largest series we had reported from PGI Chandigarh in 1990, and then subsequently from all over all parts of the country, the lung cancer has been reported, and this is the Globocon report in 22. You see about the total new cases of lung cancer was about 81,000 cases, and out of that around 75,000 died in the same year. Then these are the three series of largest series from the country. That is one from PGI Chandigarh by Kaur et al., and then Mohan from AIMS New Delhi, and then the another report that I had told in 1990. So this is the more than 1,000 cases they are reported, and they are different epidemiological series that I will tell you summary part. What the most interesting part it was seen. I had tried to summarize them between the histological types. That is one of the very interesting observations. You see, this arbitrarily I have divided them into two parts. One is between 56 to 85, and then 86 onwards. You can see the squamous cell carcinoma in the earlier parts was still the common one. Even in the second half, you can see the squamous cell carcinoma was still the common till about 2001. But only thing, please note that adenocarcinoma was rising. In the earlier half, the arbitrary half, what about 15%, and then in the subsequent half it was around 24%. That means you are noticing a rising in a trend of lung cancer. This is the the ICMR data, the histological types of lung cancer in India. This is the National Cancer Registry data for 2020. You can see of about 22,000 cases totally in males and females. So what you are seeing, the adenocarcinoma now is becoming the predominant one in about 34% of cases in males, and squamous around 23% of cases. In females again it is the commonest form of cancer, lung cancer is adenocarcinoma. And this is what in the three different periods, if you see roughly between 60 to 2004, then 2006 to 2015, and then 2016 onwards. So what you are trying to see, the adenocarcinoma is rising, and correspondingly squamous cell carcinoma is decreasing. This again shows the same thing in a linear form. Again you can see the adenocarcinoma which was around 18% in the first arbitrary period, and then now it is rising to about 44%, and this is over the period. It is adenocarcinoma has been increasing in India over the years, and now it is similar to that what we observe in the Western countries and other Southeast Asian countries. So we have got, of course, you all know, get the data, both the hospital-based and the population-based cancer registries. The ICMR has got these registries, you all know, and this is the same thing I have already discussed that, so I am not going into those details. And one of the very interesting observations is you can see in both in case of males and females, it is the northeastern region, that is the Aizawl part. So that is the hotspot of lung cancer in India. So those regions are having the highest number of lung cancer in terms of the per 100,000 population. So these are the highest regions. So these are the lung cancer of the leading sites of cancer for male individuals at several of the population-based cancer registries. You can see the ICMR cancer registries, and what we are seeing in the many parts, the both in case of males and females, they are rising, and in some cases they are also decreasing. This is again you see at different age groups. Of course, as the age advances, the incidence rises both in males and females. that is understandable. Again, in the some of the areas, the age-adjusted rates per 100,000 population, you see there is a rise. You can see the most of the places over the years. So this is again the comparison what happened in 1990 and 2019. You see the what we have observed that lung cancer presents approximately a decade earlier in India as compared to the Western countries, with a mean age at diagnosis of around 54 to 70 years. The unique risk factor is air pollution and germline mutations that predispose to non-smoking related lung cancer. I think we have a talk soon after about lung cancer in non-smokers. Again, between 1990 and 2019, you can see both the overall and men and women. So there is a standardized incidence rates per 100,000 is rising, and the possible causes include the tobacco smoking and then the air pollution, particularly the particulate matter of 2.5 micrometer or less. So this is a comparison between the surrounding areas and India. Of course, there are other areas like China and the Bhutan. They are having the highest numbers in comparison to India. So this is one of the demographic that I had shown you this slide little earlier about the large number of population data, and here this is the clinical presentation, although it is a busy slide. So what I just like to highlight is most of the clinical features of lung cancer is akin to that of tuberculosis. So that is how the chest physician gets confused, and then the diagnosis is they get varying periods of ATT before a definite diagnosis is made, because as you can see most of the symptoms are similar to that of lung cancer. But I think except very few, if you focus on that, I can just summarize. Say for example, presence of a SBC, presence of hemorrhagic pleural effusion, presence of hoarseness of voice, then the presence of a collapse. If you are doing a good clinical examination or a mass lesion, they will be favoring a case of lung cancer rather than tuberculosis. But I think this is on the clinical grounds. Of course, nobody diagnoses only on the basis of clinical features, but that gives us a clue that is particularly for the colleagues from the pulmonary medicine department. They should be little careful. So this is again these are the clinical extent of disease at presentation. You can see by the time they present, they are in an advanced stage of the disease. That is what it shows, and then these are the delays between the starting of the symptoms and a diagnosis is made. That is what I was hinting at. So I think I will just like everybody to go through this nice paper. That is the uniqueness of lung cancer in Southeast Asia from the Tata group, and it is I think from the other centers are also their authors. So this is the published in the Lancet Regional Health Southeast Asia. So that gives a very good summary of what is happening about lung cancer in our country, including the Southeast Asian regions. So as I had told you in the beginning, you see the Asian countries have got the highest number of lung cancer cases, and particularly in never smokers. That is one of the event factors other than smoking is very important. And then again the clinical staging that I had already told you. So this is the socio-demographic factors. This is about the smokers, and about more than a third will have never smokers. And then the adenocarcinoma is the commonest one in this region. 75% had adenocarcinoma, and another 21 squamous cell carcinoma. So again the hazard ratio is the never smoker versus currently smoker, and then the smokers had got worse overall survival, and then the current smoking had got the worse overall survival, and these associations were consistent with each stage. And in pairwise comparisons, those who formerly or currently smoke had a similar overall survival to patients in the next higher stage. So these associations remain consistent. The among patients with early stage smoking had a greater prognostic impact. And then the overwhelmingly the major cause of lung cancer, although it is smoking, we know we have got other factors that you will hear next one. And again, these are the smoking prevalence in different populations, as you can see. So they in the lower part, if you see the Singapore, Korea, Indonesia, China, Taiwan, there are factors other than smoking, they are more important. And again, we know, as I have already told you, in different countries in this region, so tobacco and lung cancer, that has shown the overall risk factor is higher depending upon which country we are reporting from. This again, you know, BD smoking and lung cancer is reported by different authors from this country. So it varies between, you see, 3.9 to about 6.1. And then the passive smoking is also another important contributory factor. So this is the comparison of different type of smoking products like cigarettes, hookah, BD. The BD has got in fact the highest overall risk. And then of course there are other types of smokers. They are all risk factors. So they will again, you all know the variables of smoking include dosage and the duration, etc. So they will be important. So and the biomass fuel again another important risk factor for people who are non-smokers. So I think again the various socio-economic factors in cancer outcomes is important. That is the healthcare investment and economic development SDI category. I have already told you Human Development Index. So these are the average mortality to incidence ratio. I had already discussed about that. So I think just maybe there is no time, but one of the important thing is the molecular epidemiology. There is a, you know that now there are many, that is a, this is the era of molecular diagnosis and molecular epidemiology. So what I'll just like you to focus about this slide, you see this is a EGFR mutation, say for example. So there is a variation in 3 different areas. If you see in the right hand corner, that is the Southeast Asian or the Asian countries where the EGFR mutation is the highest in case of the adenocarcinoma. And in comparison to the left hand side, if you see the more advanced countries or Western countries like North America and Europe, so that is in between, and then that is about lesser. There is a great difference where the figures in the Asian countries is about 50 to 60%, but in the more developed countries it is around 15 to 17%, and in India we are somewhere in between. So it is roughly about 30% of adenocarcinoma, female patients, non-smokers and younger patients. So that is what there is a genetic variation also. Similarly about this again shows the mutation in the both early stage and then the metastatic form of mutations and the different countries that right hand side shows. That is what I was trying to say. This is again the lung cancer in the Indian subcontinent that I have already told you. EGFR is around 30%, and there are other mutations that is coming to different regions. So I will be stopping here since I have already overstepped my time. So over the years, what, ladies and gentlemen, we are trying to see a epidemiological transition in India. We are seeing, as obviously it was there from the beginning. So we are about a decade earlier. That was the median age. Number 2, we are seeing the histological change, and then the factors other than smoking is another important epidemiological factor. And then the most of our cases, although we are little lower than the, as we see in the Asian countries, but higher than the other Western countries, the EGFR mutation. And of course the PDL1, the ones that is about again 30% of our cases, they will have PDL1 positivity. So there is that is almost same as we see in other countries of the world. So there is a transition, and most of the patients, they can be subject to some of these, you know, the depending upon the molecular and the PDL1 testing, most of these people can be treated. And I think we saw some of the presentations in the morning, but only thing the affordability, getting the more costly drugs, so that we have to wait for a few more years so that it is easily affordable to everybody. So with this, thank you very much for your kind attention.
Thank you, Digambar sir. We will now move ahead with the next talk. Since a sincere request to all speakers, we will be cutting short the time. So may I request Dr. Raghunandha Rao to come over dais for lung cancer in never smokers, a rising subgroup with distinct clinical challenges.
Thank you, chairpersons. My name is Raghunandha Rao. It's not Raghunandha Rao. It's all right. First, thanks to Dr. Sandhya and Prashant for the invitation. I would like to acknowledge the presence of my teacher, Professor Digambar Behra, during my MD at PGI in the audience. And my task today is to give you a brief overview. Since the chairperson said we'll cut short the time, I'll cut short the presentation as well, on never smokers and lung cancer. So first, let us see who are non-smokers. Basically, this is a definition probably forced on us. We have many non-smokers, but that's not the definition of non-smokers. If you smoked fewer than 100 cigarettes, so if you smoke, say, over 10 years, 10 cigarettes, 1 cigarette a month, probably you are a non-smoker. So, but you could still have smoked 10 years of 10 cigarettes. This definition actually, if I remember right, was forced upon us by Lilly. It was not there earlier to the original trial of adenocarcinoma or the pemetrexed trial. Prior to that, this definition did not hold. Now, let us see how common is lung cancer in non-smoking individuals. Worldwide, it is supposed to be between 15 and 20% of all lung cancers are supposed to be in non-smokers, need not necessarily in pockets where smoking is not so common, especially in women. Well, Professor Behra did allude to the list of causes which can be. I will not go through all of them. We will see a few of them which are quite relevant. The first one, of course, being radon, and then go ahead with the rest of them. Let us have a view of what is the difference essentially between smokers and non-smokers. The age at diagnosis seems to be pretty much the same over the world. Sex predominance, very important. Non-smokers predominantly is seen in the female population. That is understandable if you take that fewer women smoke all across the world as compared to men. And the most common subtype, once again alluded to in the previous talk, adenocarcinoma. The time to medical care and the stage at presentation seems to be a little longer in those who are non-smokers as opposed to be smokers. But look at the mutational pictures. Yes, you have driver mutations more commonly. Once again, EGFR and ALK seem to be the predominant mutations. I'll come back to radon. Well, this is one of the first papers which said that radon actually done in miners. What is the problem with radon? Radon, of course, is a byproduct of uranium mining. So, uranium decays into radium, radium decays into radon, and that is how you have radon. Radium is, of course, a metal, but it's so in a solid form. But radon is a gas which, of course, seeps from the floor or through the soil into the water or into the atmosphere. So this is important to understand that radon can be one of the most prominent features of an increase in lung cancer, not just in non-smokers but also in non-smokers. Indeed, if you are a smoker and you have an exposure to radon, your risk as opposed to a person who is a non-smoker and exposed to radon is supposed to be 25% higher. So it's understandable that if you are a smoker and you are exposed to radon, your risk is higher. So there are many ways through which radon the ground, but that's not the definition of a basement. If you have a basement within the ground, that is to save heating and make it warmer during the winters. Yes, there is a likelihood that the radon leaches from the bedrock and into the rises through the cracks in the floor or at the junction of the wall with the floor and then enters the house, and that is how indoor exposure to radon in ill ventilated area. The basement is supposed to be an ill ventilated area. It's may let in some light, but there is no air which is entering the basement, and that is where radon gets trapped. This is important to understand. So there are very many industries, you don't have to worry about the list, in which radon can be. Of course, at the top is the uranium ore mining, and many other rare earth elements also go ahead into that. But contrary to our belief that all of it is associated with mining, there are many areas where you can get radon contamination. For example, in Hyderabad city, if you dig deeper, you may get actually oil rather than water. So that is the depth at which you have to reach to get water. Yes, that is supposed to be. Water is supposed to be quite easily contaminated with radon, and it is very difficult to actually quantify it when it is contaminated with water. So you can have coal, you can have fly ash, you can have bottom ash. In an industry like a coal industry, any industry which uses coal, for example, you are near a steel plant, yes, working in a steel plant, you have a higher exposure to anything which can, because the coal is mined and the coal which is brought out is already showing radon contamination. So also, we all think that urea production is quite safe. No, urea production involves a coal-driven process. So you can have a higher radioactivity in fertilizer industry workers, and fertilizer, the fertilizer which is produced in the factory also may contain a higher incidence of higher radon. Accordingly, you can see in construction industry also, so many things can be like cement, like brick, clay, tiles and rock. Most of us are very fond. The higher you are in the income group, the greater will be the lining of the walls of your house or the tabletops with granite blocks. Yes, granite is a formation from clay. It is found in clayey soils, and you can actually get a higher exposure to radon from your building materials as well. So also in tobacco industry, as I told you, tobacco can say, tobacco again, the flue is used, what you use is coal, and from there you get radon. So sir has already alluded this to you. Non-smokers show more genomic alterations, but the driver mutation alterations of EGFR and ALK are positive more often in smokers. So this is already been alluded to. Variation frequency of EGFR can be as high as 43% in non-smokers as opposed to 11% in smokers. So also in ALK 12 and 2%, and you can go on. So all driver mutations are likely to be more common in non-smokers as opposed to smokers, as opposed to the PDL1 mutations in those who are smokers. So I have given you here, in low tobacco consumptions were higher in the French region with a higher radon exposure. So it looks like if you have a higher radon exposure as opposed to a lower consumption of cigarettes, you are more likely to have a EGFR ALK mutation or rearrangements. Then once again, you need to understand that it's not always a targetable mutation. We may not be able to target KRAS. Yes, in future we may be. So 3.8% more common in adenocarcinoma of never smokers in North America and Europe than in East Asia. So there seems to be a slight difference in East Asia as opposed to North America in KRAS mutations in non-smokers. So many driver mutations are pretty common in patients. This is an example of Asia versus East Asians versus North American and European continent. Particulate matter is the next important, sir has alluded to 2.5. Particulate matter consists of tiny solid and liquid particles in air. So categorized by size into PM10, that is 10 microns, and 2.5. So 2.5 microns will not get deposited in the upper airway, but will penetrate further into the lung, all the way to the respiratory bronchiole and into the alveolar sac. So PM 2.5 is what we are interested in. The composition of PM 2.5 will vary from place to place, and what is the source of the dust, what you are getting. So it may vary from many things like nitrates, sulfates, ammonia, organic and elemental carbon, metals, polycyclic aromatic hydrocarbons. We already know what the carcinogenicity of PAH is. So it can result from waste incineration, traffic emission. Most of us are very worried about the vehicular traffic emission, mining, incomplete combustion of biomass or oil. What type of mining? It is open cast mining. If you go to the Singareni collieries near Khammam, you can see this is called open cast mining. So their coal is actually done, you don't go into the earth, it's an open cast mine. So it keeps expanding 5 kilometers, 10 kilometers, 20 kilometers like that. It's an open cast mine, it is full of dust. Forever it is dusty. This is important to understand. So globally air pollution is estimated to cause about 29% of lung cancer death, apart from COPD, ischemic heart disease and stroke. So important to understand that there is a very good association between particulate matter 2.5 and specific signatures that can affect the so-called lung cancer in never smokers. So lung cancer in never smokers with a high air pollution have an increased prevalence of TP53 mutation, shorter telomeres and heightened mutagenesis. So this is important to understand. We talked about radon, which is driving some mutations. Here we are talking of particulate matter, which is driving some other mutations. Is there a screening program for lung cancer in non-smokers? No. The US Task Force doesn't believe that there's any recommendation to screen non-smoking individuals for lung cancer, which they recommend for low-dose CT scans. In contrast, Taiwan has started a national lung cancer early detection program in 2022. It's a biennial, once in 2 years, low-dose CT scan for non-smoking individuals with a family history of lung cancer, but without people who are actually smoking. So this is the summary slide of my talk, what I have told you, that the people, lung cancer in people with a history of smoking, yes, of course, 80 to 85% of them are smokers. Here, lung cancer in non-smoking individuals, the proportion of non-cancer worldwide is supposed to be 15 to 20%. So if you take lung cancer as a whole, probably we will see an increase in people who are reducing their smoking, but the other, especially air pollution, is likely to increase. So with that, I conclude my talk. Thank you very much for your attention. So if Sherlock Holmes had lived long, he probably would have died of lung cancer.
Thank you very much. Dr. Rao. Now I have called upon the next speaker, role of AI in lung cancer. Dr. Amit.
As we continue through the sessions, a kind note to everyone that our refreshment station is now open and offers working coffee and tea in the same hall. Please feel free to grab your coffee anytime and take a moment to recharge and stay focused.
Thank you so much, Prashant, for inviting me for this talk. Without any discussion, we will continue into the topic. What is the role of AI in pulmonary imaging and lung cancer? We know that we are actually living in an era where there is a precision medicine, and that requires a precision radiology. Comprising of radiomics, artificial intelligence, and there is a big data that is coming because we want improved value as well as efficient systems. But we will say we are in still early days. So what we are actually moving, we are moving from morphology that we have seen on the CT scan and trying to turn into functional, physiological and molecular information that we are trying to get from that data sets. and from the qualitative into the quantitative aspects, and from a generic to a more specific, actionable phenotypic characterization. That is the information that we are trying to get it. And if there is an isolated image, whether we can actually do a multi-disciplinary synthesis, putting clinical inputs, lab reports, imaging, and provide some actionable details into that. So that is happening because there is very high demand for improved value. And at the same time, there is a demand that it has to be reduced cost and there has to be improved productivity. And the system that probably we are thinking that the human mindset is suboptimal and the machine workflow can actually enhance it and make it more feasible. So typically if we follow that, we are into the hype cycle, when the hype cycle is actually subsiding and actually now it is taking the true trajectory where exactly the role of actually AI is coming into the picture. And similarly, like human mind, it has its own neural networks, but the neural networks, when they are actually hidden, that is called as a deep learning thing that is there. And we know that once there is an image, it will have a lot of information. Today we click an image, it will have its own coordinates, size, facial recognition, another thing, and it can identify people from that image data sets. And that is, we know that it is a part of the AI that is happening into our email system as well. If we go into the lung cancer aspect of radiology, this paper is 1963. It is very old paper, and in that it has classified into 80 variables and try to characterize and map out the disease in that aspect, and we can see that we are actually 6 decades ahead, and still we are actually trying to do the same thing by the computer-aided detection and adding the deeper layers because of the fast computing. What we want to know that what we have added into the system, whether it can give into yes or no answer, whether if there is a car or if there is a no car, whether it is with the human interference or without human interference. And that is something which we want to get out of these data. So if we go into the aspects, we will try to pick it up, classify, localize the lesion, segment it, filter it, and try to get the output. And actually can do a multidisciplinary synthesis where there is an information of imaging and the liquid biopsy data, whether it can help that it might respond to the inhibitors or immunotherapy or something like that. But there are definite challenges with our hopes. And if we want to know what are the challenges, that we need to know that these data are actually obscure and we don't know how the AI is actually synthesizing these data and whether there is a validation and sufficient amount of information that is there, whether the diversity of these things, and it can be generalized into our own setup. Even if today, if some model is suitable for some another hospital, it may not be suitable for us, and we need to validate into our own data sets. That is actually extremely important. We want the linear collinearity, and if we see that it's yes between no, but that is not happening into any of the system. We need to adapt to the requirements that are there and actually try to fit into those projections. This is our own case study, and in that we wanted to see there are few variables, whether there is a consolidation, fibrosis, mediastinal widening, and there are many other variables, and it will give a threshold. We have decided that the threshold is at a 60%, and then it actually try to market whether it is picking up those areas, and actually it will say that yes, there is a consolidation in these areas, these segments, but again it is not able to characterize. Sometimes, yes, there is a feasibility that these may be wrong, and it has wrongly estimated, yes, there is a pneumothorax, which is actually not there, and actually it will giving a false positive indicator and actually happening to do a CT scan where there is no pneumothorax. So in lung cancer pathway, we can actually apply AI into all the aspects from prevention to screening, to diagnosis, to prognosis, to treatment, to monitoring. It can be helped in like smoking carving patterns. It can help identify the high risk nodules that are present in the CT scan. And actually when actually we have to call them up, whether it is a 3-month, 6-month or 9-month interval, whether actually we can target that yes, it is EGFR or ALK mutations before doing a biopsy, and can do a multimodal predictions when we have all the data sets, how the patient is going to survive and how it is responding to the treatment. All this can be done. So coming to the heterogeneity, once there is a follow-up, which metastatic nodule is likely to get benefit, which is harboring the mutation in that aspect. So the green is harboring probably a mutation that might respond, but the other two that are not harboring, that is something actually we want to drive from the AI into the RESIST follow-up. This is something which is going to be difficult to explain, and we know that we are into the area where there is a trust is an issue. We are trusting a machine more than a human, and that is actually leading a different kind of expertise in the healthcare, and actually whether we are actually going to adapt and survive this kind of transformation. Yesterday only there has been a tweet from the AIIMS that yes, we have started including all the X-rays that are done on the OPD basis, and it is around 1,000 X-rays with a very high negative predictive value. But again, the disclaimer has become much, much wider. Actually, the disclaimer is saying that we are not taking any care of responsibility, whether it is the software developer, the AIIMS, and the other things. And actually, it is the area where actually we need to work out. If these are not getting reported, yes, they may be getting reported. But if they are positive, then what has to be done in these about? And the amount of information has to be consumed correctly. So if we talk about AI, yes, in the lung cancer screening, there are multiple studies has been done. We need to identify how much false positive, how much false negative, and then try to leverage whether it is feasible into our own setup that is there. And if we see the variability is ranging from 3 to 15% in various setups. And with that thing in mind, actually, we have started the biobank project in ACTRAC that is there, and the details will be out soon once it is analyzed. And we need to also be concerned about the security in the privacy considerations, and these are becoming more and more actually common, and that is the why actually we have started the federated distribution learning, and we have our own high power computing facility that is located in ACTRAC, so we can do our things in our own campus. There are few suggestions that will be there. It has to be appropriately consumed, and it may take little longer than actually what we are actually anticipating and what we want to wish from the artificial intelligence, and there need to be a hedge strategy. We need to prepare our IT infrastructure that is required, and we need to re-engineer the existing electronic medical data records, because we are actually trying to consume them into our own system, and we need to redesign and restructure these data systems. And there has to be deeper integration within the daily routine workflow, and that is the case where we can actually have a meaningful outcomes, and we need to properly engaged into these areas so we can actually validate whether how AI is going to be helpful in our own setup. So thank you so much.
Thank you, Dr. Amit Jano. I think so future will be AI everywhere.
So it has to be properly consumed, I will say.
Yes.
Where exactly it is required.
I feel that it should not take away our jobs as it is seen in IT industry.
So it is not like that, because IT is something which is, the work profile is going to be different, and our work profile, because they are protocol based, and our is day-to-day monitoring of each and everything in very minute detail. So it is little bit difficult here, but yes, it is coming into various workflows.
And also with AI, who is going to take the responsibility and the onus if any error is there? And with how much confidence you can speak to the general population that this is 100% right and not? I think so human interface has to be there always to give that human touch.
Yeah. So
what are your insights?
Yeah. Human interface is required, and the most important is that it is difficult for you. Whether you want to trust your radiologist or you want to trust your AI, that is one thing. And if you are buying so costly softwares, it lies with the seller, because they are giving the very high hopes that our system is 98% sensitive. So yes, in rest of the except 2%, they have to be liable for that reporting.
Okay, thank you.
Thank you,
sir.
Thank you, sir. And I thank the chairpersons, Dr. H.J. Singh and Dr. Bhushan, for chairing the session. Now we move on to the panel discussion, and I invite the moderator, Dr. Naveen Kumar. The topic of the session is the Indian paradox, maximizing early detection while minimizing misdiagnosis in lung cancer. The panelists for the sessions Dr. Prashanta Mahapatra, Dr. Ashish Jaketia, Dr. Ramkaran Chowdhury. I invite all of them to the stage.
Yes, yes, sir.
Dr. Ramkant Deshpande, Dr. Badrinath V, Dr. Ramkumar G.
First of all, thank you to the organizing committee, Dr. Prashant and Dr. Sandhya for inviting me and for this panel. And I think this is a very controversial topic, and we hardly see any early cancer because in government sector, I think 90% of our cancer patients are locally either metastatic or locally advanced. So probably in our OPD, 40 to 50% patients are metastatic, and rest of the patients are locally advanced, inoperable, or maybe operable after chemo-immuno, and early lung cancer is hardly 10%. So detecting early lung cancer is a very challenging for the surgeons, and I think when the surgeon sees any early lung cancer, they are always happy to see those patients. So India is facing actually a unique challenge because what we saw and what we are seeing in nowadays is like nobody is a non-smoker. We all are smokers actually. I'm living in Delhi, so you can expect that we are consuming almost 30 to 40 cigarettes per day. So it's like we are not non-smokers, we are all are smokers who are living in metropolitan cities. So it's very important to diagnose early lung cancer because it will going to be the incidence of incidence of the lung cancer is going to rise in the future. If we see next 5 years or 10 years, I think there will be an epidemic of lung cancer. What we saw in Western countries, like they are picking up all early lung cancers, GGOs, in very early stage, and they are operating. So maybe we have that condition, and maybe in the next 5 years or 10 years. So. And the problem is what the India is facing is we don't have resources too much to to stage the patient, to diagnose the patient. And if I talk about my institute, or we'll talk about all, I don't know about the all government institutions, but majority of the government institutions are overburdened as far as radiology, pathology is concerned. So when we see the patients, they're almost like take 1.5 months to get the complete all the staging workup. So by that time, usually the lung cancer progressed, and we hardly see the early lung cancers. And the other challenges that we face is the other non-granulomatous disease that are very much mimic to the lung cancer. So that is why like TBs and the COPD and other granulomatous disease, we pick up the nodules, solitary pulmonary nodules, and we hardly, and that phase actually this give a huge burden to the hospital settings. So we'll not take too much time. So it's all, if we see the literature, it's almost 10 to 15% early lung cancer incidence. And so we have to balance, somehow we have to balance for the diagnosis and the treatment, and the early lung cancer versus the other non-lung cancer patients. So early detection and accurate diagnosis, these are the main two constants of any diagnosis of early lung cancer in the patients. So we are discussing very few challenging cases, and after that we'll have a discussion with all the panelists. We have very much senior persons here, so we'll take their opinion. And this is a 60-year-old man who's a heavy smoker, and actually he presented with a chronic cough with occasional hemoptysis and malaise. And actually he has shown these patients to a periphery with a physician, and he did an X-ray. So I just want to, from radiology, so can you just comment on the X-ray, whether it's looking any suspicious for the lung cancer or any other granulomatous disease or TB or something like that?
X-ray actually shows there is a opacity in the left parahilar region. Looks like sort of a wedge-shaped flat lesion, and it has a central cavitation. I think there is a lucency in the center. So at this stage, we cannot go ahead and call this as a mass which is suspicious for lung cancer, but there definitely is a significant finding there. As a radiologist, I would prefer to have a contrast enhanced CT done on this to further characterize it.
So would you recommend CT scan, low-dose CT scan or HRCT to the patient?
No, I think in this case, I would advise a contrast enhanced CT.
CT.
Not just a low-dose CT is for screening purpose, not in this case.
Okay. Any opinion by the pulmonologist for this, Sir Prashant Sir? CCT. So this is the CECT, and there is a cavitary lesion in the upper lung, upper lobe, left upper lobe. And so he has shown to pulmonologist there, and this is the PET scan, and there is a avidity there in the left upper lobe, suspicious for malignancy. And he has shown to pulmonologist, and pulmonologist did a EBUS also. And there was a lesion in the lower lobe superior segment. So he took a biopsy from there. So was it a right approach for this patient to just go for directly for the EBUS after the CT scan, or what would you suggest for this patient? Because he did a EBUS directly outside. It was evaluated outside. Prashant sir. Biopsy. So the biopsy suggested negative for malignancy, and this was an endobronchial biopsy. So we suggested him for the CT guided biopsy, and the CT guided biopsy was necrotizing granulomatous disease. So still, would you consider for further workup for this patient, or this is a diagnostic dilemma? Still, there is a malignancy versus non-malignancy in this patient. Maybe sir, surgeons. Raman sir.
I think basically all the workup has been done nicely, and it is going in the favor of infective etiology. CT also showing some signs of infective disease, but again, at the moment we cannot rule out the malignancy also. So we after starting the treatment, because he is a chronic smoker, elderly, all the high risk for malignancy is there. We have to keep him on close follow-up after starting the treatment for all this infective pathology first, because we can see the infective changes in the contralateral lung as well. And again, in our country, it is very common to have infective etiology combined with malignancy. So we cannot rule out at the same time. A close vigilance should be there in such cases.
I am slightly referring this particular in these cases because necrotizing granulomatous is, I believe, non-specific. You have to re-biopsy from the, I think, PET guided biopsy or something.
So, but sir, as far as India is concerned, we don't have too much, the PET guided biopsy.
Doesn't matter. You take, did you have a PET CT?
Yes.
Re-biopsy will confirm. Recently, 2 weeks before, we have a patient similar necrotizing granuloma come out with malignancy.
Okay. Any sir opinion by the Raman sir, or maybe?
See, necrotizing granulomatous disease is not a very specific diagnosis in our country. And if you have clinical suspicion, I think this is only a working diagnosis. It's better that you do a CT-guided biopsy. And only thing is you need to have a good expertise for a CT-guided biopsy. Otherwise, what happens is the person does it who's not very experienced, then, you can again get a misdiagnosis. So you have to have a center where you're confident that the person will be able to achieve adequate tissue.
So biopsy was done at AIIMS, sir. So maybe I will take an opinion by the pathologist and the radiologist, how they face the challenges in these cases, kind of cases, for the as far as biopsy is concerned and as far as pathology is concerned.
I think we have to rule, at least we do as a gene expert or CBNet, and we have to rule out some, even if infective pathology.
Pathologies.
And re-biopsy is a must. We have to get a diagnosis. There's no way they can follow up this patient.
Yes.
So if the clinical suspicion of malignancy is high, and if the biopsy is showing only necrotizing granulomatous disease, most likely there might be concomitant malignancy might be there, which is not biopsy.
Which is not biopsy.
So the ideal thing is we have to go for a repeat biopsy from the representative areas.
Yes.
So only thing I will disagree the doing a PET CT before a biopsy. You said they have done a CT and you suspect a lesion. So better to get in sampling. How the PET CT is going to solve that problem at that stage? So I think that can be avoided from us.
So obviously the PET is like everybody is now prescribing the PET. So that is why if there is any suspicious for malignancy, definitely I think the people, definitely the physician directly goes for PET scan nowadays.
No, PET will not sort out the problem because see, necrotizing granulomatous disease
Still,
also
sir,
will show
still, yes, they'll
it
pick
will
up the
also
lesion,
show
sir.
an uptake.
Yes.
So you are again back to square one.
Yes.
That yes, there is a lesion. I don't know what that lesion is. So best is to do a CT guided biopsy at the same. Your competent bronchoscopist has already tried that. Maybe the person has not reached there. So CT guided true cut biopsy is something which you need to do. If that also comes in the same way, kind of a diagnosis, then it's a case for observation. I would not like to explore this kind of a patient or do a thoracoscopy merely for a diagnosis. So you've done your endobronchial biopsy, CT guided biopsy, you can repeat it if you want, and then that's provided you have a very strong suspicion. If that also says the same thing, then you can continue treating that way.
Yes. So might be, I think the Prashant sir will agree that if it comes negative again, if we do a CT guided biopsy or maybe endobronchial biopsy repeat, if it comes negative, would you start ATT for these patients or still would you consider for wait and watch?
No, we will not start. In today's world, unless you get something positive, but tuberculosis, don't start it.
Okay.
I mean, in such cases also, there is other diseases like connective tissue disease can be possibility in such cases also that we have to find, but not that common.
Yes. So this is a second case. Actually, this is a 45-year-old man with chronic cough, presented with chronic cough, low-grade fever, weight loss, malaise, and evaluated outside. And they did a chest X-ray, and based on the chest X-ray, they started the ATT. So I would like to take comment from the radiologist. It looks malignancy again, or it's a suspicious for infective pathology also.
Yeah, actually, there is a well-defined kind of circumscribed lesion in the right upper zone. Only thing is this lesion is not showing the typical lobar type of consolidation, rather it looks circumscribed. And again, there is a cavitation with air fluid level inside, which also shows the wall to be thick because the cavitation is just limited to the center and you have a thick wall around that, which can be seen in the superior aspect. So again, with this, we cannot straight away call it as TB and start treatment, I suppose. Again, we would like to do a CT, and if we definitely see thick wall and it appears like a mass rather than an area of consolidation, we prefer to do a biopsy on that.
So, yes.
I need more information, like patient has diabetes or any other risk factors, and probably which region patient belongs to. Accordingly, I have to guess. If patient is from Kerala, patient from Odisha, maybe from South, so and patient is diabetic, definitely DDs are many.
So both AFB and CBNet was negative, that was done outside, and still they started ATT this patient because it is evaluated by some local physician. They started ATT based on this image, X-ray. So, sir, was it the right decisions to start the ATT? And being a pulmonologist in a government institution, you are already professor and head. So, what you take and what you suggest all the physician and the pulmonologist when to start ATT and about the workup for these kind of patients?
So when to start ATT is a very clear-cut guidelines. In such lesions, such extensive disease, we will not get a gene expert positivity. Very, 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 very uncommon. Definitely should get it. If patient is, suppose the patient is from tropical countries with cavitating pneumonia, I mean thick walled, I mean lot of things DD is coming up. And if AB negative, then you have to think of many things. I mean the DDs are many in double disease.
So that was evaluated. Again, the patient came to our institute and we evaluated and we did a biopsy. It was SCC and it was a N2 disease also. So that actually patient has lost the time, which was 4 months. So that is, I think, the awareness, not to the patient. In fact, for the physician, it is always important to aware about the workup of these kind of patients. This is case 3, which is, he's a 31-year-old male presented with chest pain for 5 months. And he has shown to local physician multiple times and he's just prescribed the painkillers to the patient. And this was a CT scan and PET CT. So because first the CT was done, there was suspicious for nodule there. So we thought that because the lesion of the size of the lesion was 2 centimeter, so the PET was prescribed, whether it is picking up the lesion in the PET or not. Because was it the right approach for these kind of patient? Raman sir, would you consider for these kind of patients to go for PET scan if you pick up these kind of indeterminate lesions in the lung, or would you consider directly for the biopsy?
See, a biopsy will give you directly a tissue biopsy, this thing, diagnosis itself. And then based on that, you can actually go ahead with PET CT scan. But often to a surgeon, particularly an oncosurgeon in thoracic surgery, patients come with a PET CT scan. They've already been investigated. So I will get a patient like this. So the next is a no-brainer, a CT-guided true-cut biopsy straight away. So that will give me a clear diagnosis as to the patient. There are people who are allergic, they say, you don't do a true-cut biopsy, you take it out. But the problem of doing that kind of a thing is if it's a benign kind of turns around to be an aspergilloma or something like that, which doesn't really warrant an immediate kind of a surgery, then you unnecessarily subjected the patient for a surgery. So I almost always insist in a CT-guided true-cut biopsy for this kind of
patients. So by radiologist, would you consider as an infective pathology or would you consider as a malignant pathology?
Actually, in this case, it looks more like a peripheral pleural-based lesion rather than primary lung lesion. So I would like to know the entire picture. I would want to see the entire images, including the abdomen, so that whether this is a primary lesion or is it a metastasis.
This is a single lesion in the chest. This was a single lesion in the chest.
Okay, in that case, I think we'll have to go and sample it, do a biopsy. And in this case, it can even be done ultrasound guided because it's in the periphery.
So Dr. Ramkaran, would you take directly to the patient for the surgery without doing biopsy? Because we can treat him as like a solitary pulmonary nodule, which is picking up on the PET. Can we go directly for the surgery in these kind of patients?
No, I would like to be biopsied and then have a tissue diagnosis, kind of malignancy you might require, if you see a lung, you might require EBUS and lymph node staging, everything. So it should be biopsied first.
Dr. Ashish? Yes.
So, Dr. Naveen, because first we get a CT done, and if we found such a peripherally placed lesion, which can be biopsied easily, and suppose, because PET is not, though it is very easily available nowadays everywhere, but suppose you have done a biopsy, and it is inconclusive or suspicious. So, what's your, I would like to take an opinion, whether we should go for a PET scan first or we should do the biopsy first? Because it's a peripherally placed, easily accessible lesion.
Dr. Nilendu is sitting here. He was watching it. Do you want to say something? He is a
So your question is, what should be done first, a biopsy first, or do you get a PET scan? So then it is based on, if you get a solitary pulmonary nodule in the lung, then it should follow the algorithm of an SPN, look at the pretest probability, accordingly. But PET essentially should be used for staging. If you see a nodule, which if your pretest probability of it turning into a malignant nodule is higher, the patient should undergo a CT-guided biopsy first. If those biopsies are inconclusive and you still have a high suspicion, then probably you can do a PET and use the metabolic information to guide the biopsy rather than doing the PET first. But I agree with Dr. Deshpande that often in clinical practice, patients come to you with a PET scan which is already done. But essentially, PET should not be done just to guide biopsies, because a simple CT scan, or even now with good ultrasound, you can do guided biopsies before PET scan is even done. PET should be reserved for staging.
So, yes. So my question is, like you said, that if the CT is showing some solitary pulmonary nodule and suspicious for malignancy is high, so if we send the patient for biopsy, like as you suggested that we biopsy, have the expertise of CT guided biopsy across India. So to accommodate all the solitary pulmonary nodule, if we go for directly for all the patients to the biopsy, I think it's a huge load and challenge for as far as India is concerned.
Can we go in for radial EBUS for solitary nodules? I think that will be a better approach if facilities exist with you.
But sir, that is for hilar lesions, probably not for the very peripheral
nodules I'm talking about.
Okay.
If it is peripheral nodule, radial EBUS can be done to diagnose.
Oh yeah. Go on.
I think expertise is now available, but then you have to look for an expert. You can't just because it's not.
Difficult to look for expert in tier 2 cities.
I think now it is reasonably available. But it is essential. You can't say that it's an essential part of lung cancer diagnosis.
Yes.
So just to answer that, see, PET CT cannot characterize into benign and malignant, because SUV can be high both in
malignant
and malignant conditions. And if you need to establish a diagnosis, we definitely require tissue sampling. And the tissue sampling has to be done. There is no answer that only imaging can provide that.
Yes, absolutely.
We cannot go anywhere actually.
Yes.
So to establish a diagnosis, we need to do a CT scan and CT guided biopsy, and now the expertise is available. It is more readily available as compared to earlier.
Yes. So biopsy was few galanomas with atypia. Would you consider it still for rebiopsy for those patients? Or sir, would you, Raman sir, and would go for directly for maybe wedge resection of nodule and VETS guided?
With few granulomas with ATP, I'll take it out. Thoracoscopy, take it out, wedge resection, non-anatomical wedge resection first. Get a frozen section.
Yes.
Malignancy, you can consider either a segmentectomy or a lobectomy. Based on whatever is your preference, along with the lymphadenectomy. So that if it proves to be malignant, not otherwise. Okay. The only thing is this is a little tricky. If you go back to the image, it is actually sitting in the interspace.
Yes.
If it is involving the interspace, the intercostal muscle,
yes.
then you are stuck a little bit, but then it will involve the resection of a wall also. Yeah, but then that's not such a big surgery, so
yes.
it's a straightforward
yes.
thing.
So how often you encounter these kind of patients? Like, everybody is sitting.
This is not unusual. This presentation is not very unusual.
Yes.
It's not very common, but you do see it once in a while.
Yes, yes. So awareness is all important about the algorithm of the staging of the patients, such kind of patients if we see in our OPDs. So do you think that, sir, all of you are sitting here, do you think that the risk-based screening programs is feasible in India, or is the next option to pick up the early lung cancer in India? So I think everybody can take their opinion about this.
See, risk-based screening is a very good concept. But only thing, Indian population is a mixed one. Incidence of cancer in women also is rising very fast. They are not smokers, many of them. Raghunath gave a very, very good lecture just in a short while back. But the thing, what happens is, women who are exposed to either passive smoking or to the kitchen smoke, everything, they are equally susceptible for lung cancer. One of the ways of doing surrogate screening of lung cancer is, there is a large population of the executives, lay people who are in the well-to-do people. They are all in the 40s actually. They undergo executive health checkup.
Health checkups, yes.
What do we do in executive health checkup? We do a chest X-ray. All that needs to be done is talk to the doctor, to the doctors, as well as to bring them on the panel to the hospitals. Tell them don't do a chest X-ray. do a low-dose spiral CT scan.
CT scans.
What is the difference? The difference is maybe 500 rupees to 2,500 rupees.
Right.
It's only a 2,000 rupees more for a 28,000 or a 30,000 comprehensive panel of tests that you are going to do. Okay? So that way, just imagine the number of people who are undergoing this executive checkup per year throughout the country. It will run in lakhs and lakhs.
Yes.
But in front of 140 crores, lakhs and lakhs also is nothing. But this is probably the closest it will come to executive checkup. And I personally feel that, Indian Association of Study of Lung Cancer can actually institutionalize this whole thing by talking to the various hospitals. And, a screening, you have to have the data and then you have to have an analysis. Only then you can apply the AI algorithm and all those kind of things. And these images can come to a central kind of a repository where they can be analyzed. And this whole thing can be supported by the government. I'm sure if you put it properly to the government, you can actually convert this whole thing into a lung cancer screening. And then you include the high-risk patients, like, the minors, this thing. There is the occupational physicians society. You can talk to all those people, that they will know exactly what is the thing to be done. Start including those people also in this. So you can keep on making it wider. If you extrapolate the definition of US, saying that, okay, between 50 and 70 minors, that and all that, and try to extrapolate it here, very good idea, very nice, everything fine, won't work.
Right, absolutely.
Dr. Deshpande has actually narrated a very salient point. That's low-dose spiral CT. So actually, that's very important in pulmonologist perspective. Why I'm saying most of the people says do a HRCT. What HRCT? I think radiologists know that it skips many areas. So low-dose spiral CT means I understand there is scanning of the whole lung without any interscan delay. Am I right? So that is more important. So what we can do?
So as sir said that there is an Indian Society for Occupational Health. So the society which takes care of all the occupational hazards related diseases. So I think this is a good idea to take up with these routine lung cancer screening programs for the patients who are highly risk for lung cancer. So to the radiologist, how difficult to diagnose infective versus malignant by seeing a CT or maybe with the X-ray? How often use, means like we see that always in the reports, please correlate clinically. But as far as radiology is concerned, you are radiologist, how would you suggest, how would you go for this lesion is malignant, this lesion is, because it will save economically and resources wise?
When we are dealing with, say, masses, lesions which are 3 centimeter or more, so we have certain imaging characteristics which help to differentiate, like the borders, whether it is irregular or spiculated, which favors malignancy, whereas a space consolidation kind of lesion favors infection. And the thickness of the wall when it is a cavitating lesion, whether it's a thick-walled, irregular, asymmetric kind of wall which favors malignancy, whereas a thin, uniform wall favors benignity. Whereas when it comes to nodules, which are smaller, less than 3 centimeters, especially when we are dealing with solitary pulmonary nodules, then there is a challenge actually to differentiate. And especially in the Indian setup where we do have a lot of benign granular mass, it makes difficult. I think in such scenario, what is more important is to see for the interval change. Especially when there is a high index of suspicion, we can do a short-term follow-up. Or if we can ask the patient for any previous imaging done to see if it has been staying. So
progressing
interval
or
change
not.
is one of the most important factors.
Yes, changing the size. So as for to the pathologist, I would just ask you, do you encounter any problem to define pathologically malignant versus benign disease? Is there any, if you see, like the previous report was free granulomas with atypia, how challenging is to, if the patient is having both tuberculosis or maybe non-granulomatous disease with lung cancer, component of lung cancer?
Sir, sometimes pneumocytes can show reactive atypia in case of granulomas or necrotizing background. So in that case, that pneumocytes will be arranged in a linear row like a lipidic pattern. But once we started seeing some architectural atypia like papillary growth pattern or acinar or solid growth pattern, we are like more confident in calling it malignancy.
Okay.
It's no more a reactive atypia for us.
So sometimes, like as Raman sir said, if it is approachable, operable, or maybe if we can get away with wedge resection, directly we can go for surgery, take it out the lesion, and maybe send for frozen and with finish the surgery. So to the sir, Prasant sir, would like these kind of cases, how often you see that the patients are directly coming with already has finished ATT or maybe undergoing with ATT these kind of lesions and who have already diagnosed with lung cancer so when you come to your OPD?
I think these numbers are decreasing. I mean, so we do not pulmonary cases without get confirmation. Nobody, I think, rarely gives treatment. Empirical treatment is common in extrapulmonary, maybe 70% cases. So in pulmonary, we have to get snatch diagnosis. So I most important, do you agree on waiting for the patient, follow up the patient to get a lesion?
No. If you have a solid lesion, then there is no question of waiting. You either establish a diagnosis or you do what you already put in there.
Yes.
The wax wedge.
Yes.
One of the two, yeah.
So suppose, sir, if biopsy comes negative, how would you counsel the patient? How would you tell the patient that the biopsy is negative? And because
that counseling is already done before surgery.
So you always give a...
Oh, no. If you have told the patient, oh, I'm suspecting cancer, and then if it turns out to be
that is
cancer,
important.
he's very thankful initially.
Yes.
And then after 3 months, you get the letter.
Yes.
So it is that.
So that is more important than you have to give a counseling to the patient that we are operating the lesion which is maybe benign or maybe malignant. That is important. So I think it's already given answer how critical is sampling. And like as a surgeon, aggressive screening is how is important. Is important for us to pick up the early lesions. Very aggressive screening because everybody is involved, every center is involved with the screening programs, lung cancer programs. Is it a right approach for the future or not, as far as India is concerned?
I think sir already highlighted the important points regarding screening. And if we see like the lung cancer is increasing and there is a strong need for screening, but at the same time we have to realize we are living in a developing world where the infections and the occupational exposure is very, very high. If we talk about the identifying high risk group, in top 20 countries where the highest pollution is, more than 5 is from our country. And a lot of incidental nodules will be detected, and right now we don't have adequate infrastructure to deal with it. So, but as the cancer registries are increasing, we are now having a good data of the high risk cases where we are seeing a lot of lung cancer cases. So I think policymakers should focus those high risk areas. They should come out with some random cluster sampling methods or LDCT protocols identifying those high risk areas, and they should proceed via that approach. I think that will be a balanced approach. Otherwise, aggressive screening, it's very difficult in our country.
So I think we are living in an area where I think Delhi is needing a very aggressive program for lung cancer screening. This is how the map shows in nowadays in Delhi. It's like all black. So this is Delhi NCR. Maybe I think we are sitting on a ticking bomb. Maybe I think in the future we'll have more and more lung cancers and we'll be needing a use, the screening programs for as far as lung cancer is concerned. Thank you so much. Thanks to all the panelists for tonight.
Thank you so much, sir. I request all the panelists and the moderator to stay back on the stage for a group photography. And I also request the chairpersons and the speakers, Dr. Digambar Behra sir, Dr. Raghunatha Rao sir, and Dr. Amit Janu sir, Dr. H.J. Singh and Dr. Bhushan, kindly join us for photography.
Thank you to all our partners for that engaging discussion. Now we move on to the next session on advances in precision diagnostic for lung cancer. I would like to call upon our chairpersons, Dr. Badrinath, Dr. Hemlata DS. Let's start with our sponsored session on liquid biopsy and minimal residual disease by Dr. Om Shri Shetty.
Good morning, everyone. First of all, I would like to thank the organizers of Nalccon for inviting me here. It's a wonderful session, and also for the darshan yesterday, which we all did together. So moving from the clinic and the operation theaters and biopsies, let's move into something called liquid biopsy or the circulating tumor DNA. Just to understand from my end, how many of you know about ctDNA? How many of you are aware of it? Okay, I think it's pretty good. Fine. So the key objectives would be understanding the key concepts for students who will be here, clinical dynamics of ctDNA, MRD, clinical value of ctDNA, MRD and lung carcinomas, guidelines, and if time permits, case-based discussions. So tissue versus liquid biopsy. So as we were extensively discussing about the tissue biopsy, of course it is very much required, but liquid biopsy is also gaining momentum, and we are seeing how it is changing the role in terms of diagnosis, screening, and following it up. So both have its own pros and cons. Tissue biopsy, obviously, it would take its own time in terms of processing, taking the right amount of tissue from the representative area, and pathological screening. So it would give you a lot of information about the tumor architecture, the tumor content in it, and how much cellularity, everything. And that can be used for various analysis, right from histopathology to genomics to proteomics. So you can do multiple things with it. But again, the issue is it's limited, it's invasive, you can do it only once, and many a times it becomes difficult or challenging. Whereas it comes to liquid biopsy, you can do it multiple times and reduce turnaround time because you don't have to process it like what you would do for tissue. And mostly this is right now being standardized and validated for DNA-based markers, RNA-based markers, exosomes, these are all still in a nascent stage or probably would take some more time for it to develop. And increased cost when you have repeated sampling done. Though we say that it's easy, the TAT, there are its own issues associated with it. So with that, understand the ctDNA. There's a lot of confusion when you talk about liquid biopsy, whether it is ctDNA or cfDNA or CTCs. So of course, all these are relevant to liquid biopsy. So it is circulating tumor cells are the intact cancer cells which are shed from the metastatic tumors in the circulation. Cell-free DNA, it's nothing but these small fragments of DNA which you would pick up from the blood sample, and it would contain both. That would be circulating tumor DNA as well as normal DNA, which is there in the circulation. In this, the circulating tumor DNA content would be relatively low as compared to the normal DNA. Again, it depends on various factors. Then circulating tumor DNA and extracellular vesicles. So there have been a lot of things happening in the undercurrent. So the multiple key milestones right from 1948, it started with 1965, ctDNA been linked to oncogenesis. And in 2012, in the ACOG recommends non-invasive prenatal testing, which is still quite a popular thing. Followed by 2016, FDA approved ctDNA biomarker in real-time PCR. As we all know, COBAS, EGFR testing, which we all are following it and doing it in the clinic. Then in 2020, FDA approved NGS-based ctDNA testing. To 2023, reporting of molecular testing guidelines by European Liquid Biopsy Associations. So possible applications in lung cancer, there are multiple, right from screening, testing, evaluation, and MRD. So what's happening and what are we looking at? So the clinical dynamics of the ctDNA would be, like at the first stage, you would be taking the tissue biopsy, so that's like your baseline. So you can even draw blood at that time itself, and you can subject it to evaluation at either times. And then there would be multiple time points, so those are called as longitudinal monitoring. So you can use it for diagnosis, you can see during the therapy, you can see after the commencement of the therapy, or you can do during the monitoring. So those various lines that you see are, the tumor signals or the immune proliferation, and how do we capture it? So the beauty lies in that all this information is always present. It's just like what method to be employed to get these information from these time points. And based on that, there are so much of literature available that one can harness it for its uses accordingly. So you can do genomic marker you can do methylation studies. There is fragmentomics, which I will discuss in detail in later slides, and transcriptomics. As you can see, the red dots at the bottom are not much, because we all know that right now we are extensively working on cell-free DNA, because that methods have been established. Cell-free RNA is still in an evolving stage, so we don't have much of data. Whereas methylation, fragmentomics, and genomic signatures, there's a lot of information available, and you can capture it depending upon what technique one is using and how we are utilizing it. So this is the cell dynamics of the circulating tumor DNA. As I already mentioned, these are the fragments. So these fragments are of varying sizes. So this is a study where they looked into around 200 patients with 18 different tumors, and they checked at the fragment profiles. So usually the cell-free DNA fragments or the circulating tumor DNA is between 80 to 120 or 130 base pair, whereas a normal DNA which will be there in the circulation would be somewhere between 150 to 250 or 300 onwards. So just from the fragment size, one can make out that from where the DNA is originating, and depending upon the tumor size, the stage of the disease, the shedding would be more, and you will be able to capture it. So with that, what do you call as a liquid biopsy? Is it only blood? No. It can be any fluid which can be taken from the body. It can be CSF, it could be saliva, it could be an aspirate, it can be any liquid from which you can extract the DNA and you can make sense out of it, or there's enough amount so that you can subject it to some assay. So in terms of NSCLC, what we are talking about over here is minimal residual disease. Why is it needed? To talk about various aspects like relapse, diagnosis, whether the change of treatment, and tissue of origin, all this information can be obtained today. So when it comes to here, so for example, I'll just give in a case like, EGFR TKI the patient is on, and so during the treatment, you can take a biopsy or you can take a liquid biopsy, and you can check if it is MRD positive, which means if it is present for a specific mutation, the patient is MRD positive, you can either continue the treatment. If there is any resistance, you can change the treatment. Or if there is nothing, there can be a drug holiday. So all these parameters can be looked into, and the clinicians can take a call based on this test. So this, I think I've already explained in length. So there are two approaches for MRD detection. So you must have heard about these terms of tumor agnostic and tumor informed approach. Now when I'm saying tumor agnostic and tumor informed, what do we mean by that? So this is basically tumor informed assays are when you have a baseline, like your tumor tissue has already been subjected to sequencing, you know what the mutations are, and then from that information, when you're taking the next sample and when you're doing the minimal residual disease detection, you're actually designing a panel only for those mutations, and you're subjecting it to deep sequencing. So this is a tumor-informed approach. Now what is a tumor-agnostic approach? This is where you don't have any baseline information data, you don't know what the baseline mutation was there, so then subsequent sample when it comes, you are taking a larger panel. So, it would encompass all the genes which you would want to look for. So what are the pros and cons in it? So when it is tumor informed, you know what were the basic, it can be just off-the-shelf assay. You don't need to reinvent the wheel every time based on the patient's profile. So this becomes relatively cheaper, and laboratory doesn't have much of a burden as compared to tumor-informed assays. So the two concepts in MRD, tumor-informed assays and tumor-agnostic, whenever you're seeing the report or looking in the literature, just keep this in mind. So what are we doing over here? Actually, in lung cancer, in any ctDNA assays, we are making the invisible visible. So what are the tools for all these things? So the basic ones which we started, like as we all know, the most common, the popular one is the COBAS EGFR real-time PCR assay for liquid biopsy, which was FDA approved in 2016. Eventually, it became even more sensitive with droplet digital PCR, where we can detect one gene almost as one single nucleotide can also be detected. That's the precision that we are talking. And then comes NGS, which takes into account of all these parameters and looks into at least 10 to 15 to millions of genes, what you want to call for. It can be a whole exome, it could be a panel, it can be anything. So as you have the platforms changing, the cost also increases, the assay sensitivity, and the wealth of information that you get from these. Like real-time PCR, ddPCR, you just have 1 or 2 specific genes what you're looking at, and that's the information. NGS would give you more information. But all of these are just helping you to get the details. Now, these are some of the commercially available or widely used assays which are being used to detect the MRDA. The most common ones are the Signatera or the Natera, the Radar, Avenio. So these are all still evolving, and there are many more assays, but these are most commonly talked about. So coming to Signatera. So what did they do in this? So it's basically what they do the whole exome sequencing of individuals, selection of 16 clonal somatic variants. So basically they have a panel for 16 genes. So they're looking for only those 16 genes. And then when the patient's blood sample is drawn, they would be only amplifying for those. So only those 16 genes are first subjected to PCR, and then they are subjected to NGS. So your level of detection is around 0.001% of variant allele frequency. I mean, if you're looking at NGS report, usually the talked about term is what is a VAF. So in tissue, we say it should be more than 5%, and when it is liquid biopsy, you say it should be 0.1%. But when it is Signatera-based assay, because it is tumor-informed, you have those 16 genes. You're first amplifying your sample for those 16 genes, and then you're subjecting it to NGS. So you can go as low as 0.001%. And this was used in a trial, and where they could detect ctDNA among these patients, which the study was published in 2017 for stage 1 to stage 3 patients. So the lead time between, so from this study what was concluded was that lead time for ctDNA detection using this technique was 70 days earlier as compared to any other clinical indication of these disease. The similar one is Radar. I think in the course of time I'll just take this, a similar concept. So this is all nothing but you're taking the DNA, you're subjecting it to NGS, you're subjecting it to deep sequencing, and you're looking at the gene. So now what? Does it give you all the information? No. So now we are looking at more. Sometimes, you know, we might have seen with a lot of literature, not all data is conclusive. It's not that, you know, all hunky-dory, that ctDNA positive, then the patient would not behave well, or if ctDNA negative, patient would behave well. It's not like that. So there is much more beyond that. So methylation is another one. So the aberrant methylation patterns of these circulating tumor DNA is also a hallmark. So now we are talking about quantifying the circulating tumor DNA. So it need not be any mutation positive or negative, just mere presence of circulating tumor DNA. It can be just wild type, just shedding that, and that can be quantified using methylation-based motifs. So that's the next thing which we have in store, and it's many things are being worked upon. So what are we going to do? Like, what would it look like? So it's basically surgical case where, you know, post-operative monitoring of ctDNA, as I already mentioned, and inoperable lung cancers. After the treatment, you would sample the patient, and you would look for, like, you know, either for routine surveillance or change of treatment. So there are multiple studies which are available in literature. So this is, I'll just gonna go by phase-wise, you know, what will be done. So this is specifically for stage 1 to 3 lung cancer. This is a combined data of 13 studies. So MRD detection in radically resected stage 1 to 3 patients, it ranged between 6 to 46%. And depending upon the stage, it was like 42%, 28%, and 30% was seen in these patients. And overall sensitivity was achieved in longitudinal MRD analysis compared to single point. So like you need to take various time points and not just single point. And patients with detectable ctDNA in all these studies showed increased risk of recurrence and death, and ctDNA level persisted in the adjuvant setting even after bulk tumor resection. So that was one study. So another study was longitudinal MRD surveillance following curative treatment. This is again in the early stage. So what we can see is that the red ones are the where the ctDNA is positive, and the blue ones are the ctDNA negative. So definitely the surveillance wise it looks good. They had a better prognosis. But multiple studies have different things, and of course these all stem from various things. So they would have used a different panel, some would have used whole exome sequencing, some would have used a limited. So there is variation in the way these tests have been done. So we do not have any concrete answer for this. So individual sensitivities also range from 50 to 100%. It's just not that, okay, ctDNA positive, it is bad, or ctDNA negative, it is good. So there is heterogeneity in the data. So a lot of follow-up and many more studies are required. Then coming to prognostic role of ctDNA dynamics in the neoadjuvant setting. So there were two studies. One is the Checkmate trial, 816, where pathological complete response without ctDNA clearance. So in this also it was like a mixed bag. Nearly 50% of the patients with ctDNA clearance did not achieve complete response, implying that ctDNA negativity may not really translate into eradicational or residual tumor cells. So what does this say? The prognostic value of MRD probably extends to locally advanced inoperable disease, although data are more immature to say anything more concrete in these. So what would be the hypothetical scenario? So you take the tumor sample, at that time itself you take out a low liquid biopsy sample, then do your longitudinal study. Now the question arises, how much to do, when to do, at what time points to do. Should we do it immediately after surgery or after 3 weeks or maybe 3 months? And should we really do the treatment escalation or de-escalation based on this? So still question marks denotes areas of uncertainty which warrants further investigations. So what are these clinical challenges that we face over here? So it's basically timing of analysis, like I already mentioned, and timing of surveillance, and also lack of uniformity. So it stems from what kind of tube you're using for collecting the sample. How are you transiting? Many would say, okay, we are doing ctDNA testing, we are also ordering it, but we are not getting the desired results. So what is the transit time? Even that matters. The moment the sample comes to the laboratory, how quickly it was processed, where it was processed, how it was stored, and then comes the post-analytical. So all these parameters plays a huge role for the successful implementation of these technologies for routine services. So collection tube, it has to be cell-stabilizing. Just keep this in mind. Whenever you're ordering ctDNA-based testing, it has to be a cell-stabilizing tube or the STREC tube or the BCT tubes and not in any other tube, because any other EDTA bulbs would require you to process the sample within 30 minutes. But these tubes, the DNA remains stable even for a week at room temperature, so transportation is not an issue. So there are multiple companies which will be having different kinds of tubes, and there are studies, and the storage temperature. So the moment the tissue reaches, the sample reaches the laboratory, it's always a best practice to subject it to two-step centrifugation. First is a lower speed and then a higher speed. You can straight away store it just like that, but don't just keep it like that in the laboratory. So this is the message to the laboratory people. And then the extraction method. Then there are a lot of guidelines which are evolving. There are different methods what need to be done. And the fragment size. So many of the reports don't mention the cfDNA fragment, what is the cfDNA fraction. So be mindful about that. Ask the laboratory when you're seeing a ctDNA report which is either negative or there's no conclusive, what was the cfDNA fraction. So we are not yet gone to of course, Natera, Guardant and all would give you the tumor fraction, or Foundation would also give you the tumor fraction, but most of the laboratories in India, we have not reached to the level where we can calculate. So at least you can ask for what was the cell-free DNA fraction. So the peak in the center is basically the size, which is measured on our tape station. So that actually tells you how much is your genomic DNA and how much is your cell-free DNA fraction. And then why is it important to mention the cell-free DNA fraction? So this is our own study which we did in the center. We saw that when the cell-free DNA fraction used to be less than 10%, we could not detect anything. So, most of the times it used to be wild type. So when you're saying there is no mutation, it could be a false negative also. So when we increase the cutoff to 10%, we were able to pick up the data which used to be corresponding with the baseline data for the samples. So just see for the cutoffs. So these are the commercially available assays or the laboratories which are giving you these tests. And recommendations are also there for reporting tissue and circulating tumor DNA in NGS results in non-small cell lung carcinomas, which has been recently released by International Society of Liquid Biopsy. So if time permits, I would just take this one case, a 58-year-old female with advanced lung cancer, stage 4 non-small cell lung carcinoma. So the sample details, like the blood was drawn, BCT tube processed immediately, quality control showed that the cfDNA yield was 17 nanogram, and this is what the bioanalyzer profile looks like. Now the question is, what would you do for this? Would you go for an EGFR test, ddPCR, or would you want to go for hybrid capture or a qPCR based assay? So of course, it depends upon the institutional policy, what you have access, but in this case, the profile looks good. You have a good amount of cell-free DNA, 17 nanogram is pretty good, and if you have available, it is better to go for hybrid capture NGS panel. So this basically is the most robust method as compared to amplicon based, because number of errors are much lesser. You would get much cleaner data. So, and the chances of that, you might be picking up any mutation from this quite high, depending upon depth of sequencing. Coming to that, in this only, the NGS report says that it was EGFR L858R positive, but a VAF of 0.8%. And again, we detected TP53 at a VAF of 6.2%. Now, EGFR is the primary driver mutation with a VAF of 0.8%. Again, it would, be suspicious whether you should really act upon it because it's a liquid biopsy report. Now, let me tell you, this was not a Signatera report. This is a simple NGS report. So, in case of queries, what you need to look for, like, what is the mean depth of coverage over here? That's the question should come into your mind. If it is 20,000x, anything that is more than 10,000x is good enough. Then what was the individual gene coverage? So in this case, it was 16,000x. That means that specific mutation EGFR gene was sequenced at least 16,000 times, which was read to and fro. So I'll just take 1 minute. So you need to be mindful about that. But still, if you have any query, just go for an orthogonal testing, which is even more sensitive. That is ddPCR. So with that, thank you for your time and patience listening. Thank you.
Thank you, Doctor, for the excellent and informative presentation. Moving forward, in non-small cell lung cancer, biomarker testing isn't just another test. It's the cornerstone of precision medicine. Thankfully, our next speaker is a leading voice in answering exactly that. Please join me in welcoming Dr. Apanadar onto the stage.
So good morning, everybody. Thank you, Dr. Sandhya, Dr. Prashant, for having me here today. It's always wonderful coming to Tirupati, so thank you so much. And after that phenomenal talk from Dr. Omshri, mine's a little bit more simpler, a little bit more basic. It's always very difficult speaking after Dr. Omshri because she does such a wonderful job, but I'm going to try. I'm going to try and walk you through, I think, more real-world practice. What do we do in our Monday morning clinics and how biomarker testing, especially with lung cancer, NSCLC in particular, is, I think it's important. You just cannot practice today without doing any molecular profiling. So one thing that we do know is that with lung cancer, it's no more a homogeneous disease. It's actually a heterogeneous disease. We have understood this time and again. We've actually divided it based on its pathology, adenocarcinoma being the most common one. And again, if I look at the adenocarcinoma cohort, we do know that they're molecularly very, very diverse. And today, with the advent of next generation sequencing, we've seen that it's not just one driver. Sometimes you can have concomitant mutations where you could have two oncogenic drivers that are actually causing that disease. So we have evolved. And this is the NCCN guidelines, the latest ones. Back in the day, it was EGFR, ALK, ROS, HEC. Till last year when I was presenting, it was different. Now the new one has NRG1 fusions. We have got ERBB2, IHC, point mutations. So this has evolved, and it's similar not just for the adenocarcinoma subtype, but even the squamous cell carcinoma subtype. And this is not just limited to your metastatic disease. Today we do know, even in our early and advanced stages, especially where there's a lot of data where we can bring in immunotherapy, it is pertinent that we understand that if there is an oncogenic driver mutation, your immunotherapy is not going to do very well. So it's actually across the board today with lung cancer, early, advanced, and metastatic stages. So how do we test for these biomarkers? Now, we've already heard a talk on liquid biopsy, but the ideal, what they say, the gold standard is tissue. But when tissue becomes an issue, we do consider liquid biopsy. And over here, I mean ctDNA, circulating tumor DNA, which is essentially the somatic DNA from the tumor that's lysed into the blood is what we isolate. Now, back in the day, one of the biggest reservations we had with respect to liquid biopsy was, is it inferior to tissue biopsy? Because we're kind of used to tissue testing, right? We saw the Nile study, we saw the PEN2 study, we've seen the SLIP study. We've got a variety of studies that have actually shown that liquid is not inferior to tissue, provided that if we look at the analytical part of it, if we look at the assays, it has to be at a depth of coverage of a minimum 15,000x. Anything less than that does not bring it up to the same sensitivity as tissue. So there are a lot of nuances that goes into those assays, into those panels of a liquid biopsy for it to be at par or at least not inferior to tissue. Now, keeping all this in mind, both the samples have their own pros and cons, right? At the end of the day, if I want to do pathology, if I want to do PDL1, I want to do my my HER2 on IHC, it has to be done on IHC. It's not going to give me a diagnosis, my liquid biopsy. So tissue is important, but we do know as the disease evolves, as the patient progresses, there are going to be new mutations that one's going to pick up along the way. And sometimes liquid biopsy can help combat the issue of tumor heterogeneity, which is something that can be missed out on tissue because you're just taking it from one particular site. And because neither was inferior to one another, this was a very nice consensus that came back in 2021 from the IASCLC group, and this is from Dr. Christian Rolfo's group. And what they came out with was that when we do testing, if you do tissue first, if tissue does not pick up an actionable mutation, as a reflex, you do a liquid biopsy. Or you could do the plasma first approach, which essentially means you give a blood sample, but if the blood sample, the ctDNA, does not pick up a mutation, then as a reflex, you do a tissue. And in the most ideal setting, where cost is not a concern, you can go ahead and do tissue plus liquid complementary, which seems to be the best approach forward. Now, there's a very nice paper by Dr. Sanjay Popat, which actually alludes that it's actually more time you save on time, it is cost effective if you actually do complementary testing, but yes, that is the NHS perspective. We are a different country and with our own set of challenges, but going forward, we are going to be seeing that actually complementary testing, especially in lung cancer, can be very beneficial to our patients. Now, what methodology do we use? I'm not going to belittle any technology and say, oh, this one's better than that one, and IT is not good, or FISH is not good. No, every test has its pros and cons. At the end of the day, we just heard, just for the earlier speaker said that if you have a doubt on the NGS report, you are going to go back and do an orthogonal method to actually confirm if that's an oncogenic driver. But what we've learned is that because these cancers are so molecularly diverse, you have limited tissue, or you have a liquid biopsy, but you need answers quick. And in this case, NGS seems to be the preferred platform. So next generation sequencing will actually give you a one-shot view of all the possible somatic aberrations that could be there in that particular mutation and those genes, in that particular tumor, and those genes associated with it. My slides are moving. The slides have frozen. I can't move it. Yeah, no worries. All right, so we have a couple of, where's it? Okay, yeah. So we do have a couple of panels that we do tend to see. So ideally up front in a case of lung, you can actually start with a small simple panel, which is a lung specific panel, which is around 20 genes. That's going to have all those actionable biomarkers. But in addition, you're also going to be wanting to know if there's a TP53, there's a PIK3CA, KEAP1, STK11. These are prognostic markers that do help influence our treatments. These are usually hotspots, but I will say that nowadays a lot of the laboratories are doing full gene coverage even on the smaller panels. And in those smaller panels, they're also doing DNA and RNA. When we are looking for fusions, and you are going to be seeing fusions, you're looking at ROS1, you're looking at NTRK, you're looking at RET, you're looking at MET, fusion pickups are much better on RNA, and that's why your NGS should ideally be, even if it's a 20 gene lung cancer panel, if it's tissue, it should definitely be DNA plus RNA. Now, in addition to that, we sometimes trying to go, if cost is not an issue, we do try to go for bigger panels. But I think in lung, upfront, if you start with something small, that's perfectly fine. If cost is not an issue, you go upfront and you do one of our larger panels, which is your CGPs, which is giving you, the other genomic instability assays are there. You get HRD, MSI, TMB. But I'm not really sure how great the relevance is with respect to lung cancer, at least upfront when you are treating treatment-naive patients. A common misconception is, first let's understand CGP and hotspot. Hotspot essentially means in a gene, you have the coding regions, but you don't look at all the coding regions, you look at the most frequently mutated ones. So what is the most common? So exon 18, 19, 20, 21 for EGFR. But in those exon 18, 19, and 21, there are some rarer mutations which are not picked up on a hotspot panel because they're not frequently mutated. That's why they're called rare. So one are those hotspots panels where you can miss out on those rarer mutations or fusions which can be actionable. So beware, make sure it's not a hotspot panel. Comprehensive genomic profiling is essentially when you get a 360-degree view of a gene. And these are usually 100, 150 odd 150 odd genes. And in addition to getting a 360 view, that means all the possible somatic aberrations that can happen with that gene. In addition, you also get, the other markers, the genomic instability, the PDL1, the TMB, the MSI, etc. That's a full 360-degree view of the tumor. So that's the difference between CGP and hotspot. So be careful. Now, this was an excellent study that was done by the MSKCC group, and what they saw over there was, what they saw over there was that retrospectively, when they went back and they looked at samples where they had not picked up an oncogenic driver, and they changed the assay, they added the RNA factor to it. So they did RNA sequencing in 14%, and that's a pretty large number. In 14% cases where DNA did not pick up an actionable driver, RNA did. So that is why in your lung cancers, I can't stress how strong enough how important it is that you do DNA plus RNA, and we have been burnt in the past a couple of times because our assay did not have RNA, and we did miss out ALK fusions and ROS fusions. Chips. We're doing liquid biopsies. I know Dr. Omshri already discussed this, but these are clonal hematopoiesis of indeterminate potential, which essentially mean that this is like the junk cells that are getting discarded. They obviously, because they're in your blood, the old WBCs, especially in individuals who are smokers, who've undergone multiple lines of treatment, individuals who are the older population, we do tend to see a lot of this discarded WBC. So when we're isolating ctDNA, if you do not have a good bioinformatics pipeline that can actually distinguish between this DNA, the WBC, the genomic part of it, and the cancer DNA, you can tend to over-report what can potentially be non-cancer related. So we call these chip mutations. So you need a very, very good bioinformatics pipeline to know how to distinguish between the two. And this again boils down to the quality of the lab. This is just an experience from my clinic, from our precision oncology clinic, in around close to 660 odd cases in lung cancers. We've done small panels, large panels, we've done the whole gamut. And what we saw, the benefit was that yes, around 38 to 39% we did find actionable biomarkers. And what we did, what was interesting for me, and that's where I always use this slide to kind of solidify why NGS is important, and that's because if you see, we had concomitant mutations. We had EGFR with ALK, we had those 2 EGFR mutations with MET, and that was actually in a case where there was progression. And MET was actually a MET exon 14, which is a known resistance to 2790M, which was essentially there. you had EGFR with ROS1. So we do tend to see a lot of these interesting combinations. And then if you see over there, there's an RB1 and TP53, and I'm going to show you a very interesting case in a bit. And the slides are not moving again. See, this is different and that is different. Stop. So what's coming here and what's coming there are two different things. Wait, stop. Okay, I do know I have positive time, so I'm just going to skip a couple of slides and directly go here. What do we do in our clinic? That's the first question. So in a case where the patient is at advanced treatment, treatment naive, upfront, we do like doing a basic minimum 12 to 20 gene NGS panel, keeping obviously taking costs into consideration. My NGS panel here will be a 20 gene DNA plus RNA. I will be doing PDL1. And if tissue becomes an issue, I will do liquid, or if I need this urgently, patient has a poor performance status, then over here we do liquid biopsy first. Based on the report, we act on it. This is in the case of when it is treatment naive. Now, in the case of when it's recurrent, at this point, ideally you take a biopsy from the new metastatic site, you send that for NGS, or you do a liquid biopsy. In an ideal world where cost is not an issue, and some of the labs do give you a good bundle offer where you can do tissue plus liquid, we will do that. At this point, my patient has progressed. I will be going for a slightly wider, a slightly bigger panel because I want to get a better understanding as to what could be the potential drivers. And especially if baseline, I just had a 5 gene, 10 gene NGS panel, I want to go a little bit broad band. And if PDL1 is not done, we do tend to do PDL1 at this point, but I don't know how important it is over here. But here I would be going for a far, far more broader panel. At least this is what we practice in our clinic. So this is the usual trend that we follow with respect to profiling in our clinic. And again, the slides are stuck. I'm so sorry. It's not moving. I was actually just going to walk you through 2 interesting cases, so I kind of know my slides, so till this gets up and running. The first case is actually of a young individual that was I think it's a system issue. Yeah, I can do that. Yeah, I think we do that. It's okay. Yeah. Which one is it? We just go back up. Sorry. Okay, let's just do this. Yeah. All right. Sorry about that. Okay, so this was a 59-year-old male presented to the clinic with, persistent cough. They did a biopsy. We saw it was NSCLC, adenocarcinoma, and the patient was sent for the usual NGS. So when the patient did the NGS, they did this panel, which was an Oncomine TMB panel. It came back positive for a TP53, there was a RET, and then there was a TMB. So based on this, what the treating medical oncologist did is the treating medical oncologist started selpercatinib. Patient progressed in less than 2 months. It was absolutely a horrible response. Patient then changed hospitals, came to us for a second opinion, and this report was presented in front of me. Error number 1 is this is a TMB assay, so which means its sensitivity in picking up mutations like your EGFR ALKs may not be the best, so it's not your ideal panel because it is actually designed for calling out your tumor mutation burden. Number 2, RET, not all RET mutations are going to be responding to a RET inhibitor. It's usually for your RET fusions, and there are these 1-2 point mutations that we tend to see in our medullary thyroid cancers. Those ones are the only ones where we can actually treat with selpercatinib. So this seemed a little bit odd. What was interesting is that when this patient's original medical oncologist saw this, he saw the RET. If you see the VAF, it's around 59 odd percent, 60%. He even sent it for germline testing. I mean, it was a good catch when you do see a high VAF. So when this patient came to us, we obviously started reading the report because that's the first thing you always do. What we saw in the report, and I know it's not clear, so at the top is from ClinVar, where this is actually a benign mutation. It is not germline. Second, we put it through the JAX lab, which is one of our somatic, it's one of our somatic-based databases. And what we saw in Jackson Laboratory, that this is again a benign mutation. So ideally, that RET should not have been reported, which in turn means selpercatinib should not have been given. So the patient was started. As we saw, this is where the history is. So when the patient came to us, we said, no, we're going to redo the testing. Obviously, young individual, we sent it in then for testing. We did a liquid biopsy because we had depleted the tissue. And what we found was a very basic, simple exon 19 deletion. And on the original tissue, we went back and we checked it on RT-PCR, and it was there, which meant it was missed out on the previous, assay. Another very important factor that we picked up is the TP53 and RB1. So usually in the presence of an EGFR mutation, especially these common ones, you sometimes may see TP53 with RB1s. This is an indication of a possible histological transformation. So it goes from non-small cell to a small cell transformation. It's not mandatory, but it is a possible indication. So a lot of times if you do the right testing, so number 1, make sure your testing is right. Even if your testing is right, always check, double check, quadruple check what your mutation is, no matter how great the laboratory is. And a lot of times the tumor is talking to you, so sometimes we just have to learn to read the tumor. I'll just take 2-3 more minutes, please. All right, so this was another one which was an important learning for me. 37-year-old male, adenocarcinoma, non-smoker, PD-L1 through the roof high. We did tissue testing from a local lab, a good local lab, by the way. It came back negative. We then did reflex liquid. It came back negative. So we were very clear. We were very confident. We went ahead and we gave immunotherapy. We gave immunotherapy, partial response, but then we saw that there was progression. So we don't tend to see this in, when you're giving this combination. So we went ahead. We did tissue plus liquid. When we did a tissue plus liquid, what we saw was okay, this is kind of... So basically, we saw on the tissue there was a KEAP1 mutation, which is possibly the reason why the patient was not responding to chemotherapy. KEAP1 is a resistance mechanism. And on the blood, what we saw was STK11, which is a known immunotherapy resistance. But what we also picked up was a BRAF V600E. So that means somewhere that mutation was missed out. And when we went back and we look at the local laboratory, the liquid biopsy depth of coverage was very low. It was around 10,000x. And that could be one of the main reasons that this BRAF mutation was missed out, because the VAF is pretty low. I know we can't see it, but it's around 0.05%. So on that 10,000x, it was missed out. So this again goes back to a very basic thing. Look at your testing assays. No matter how good the lab is, sometimes errors can happen. All right, here's another one. Sorry, it's a little difficult with this. This was a 79-year-old male, and I remember this case was way back during COVID times. He was a known EGFR mutation, started on afatinib. He progressed. I think he progressed after like 18 odd months. And then around at that time, we did a liquid biopsy because tissue came back negative. And the tissue so when he had a relapse, when he had progression, we took a new biopsy that came back negative. Then we did a liquid biopsy, and on the liquid biopsy, we picked up the MET exon 14 skipping mutation. And another reason it was missed out, if you look at that VAF, which is as low as 0.4%, it was missed out on tissue because our tissue's depth of coverage was around 150 odd X, and at 150 odd X, you're not going to be able to pick up a VAF that low. So to combat heterogeneity, Liquid biopsy helps address that issue, and more importantly, this goes back to what I said earlier of complementary testing. And I'm just going to take you to the last slide. This is my last case, and then I'm going to wrap it up. This was an interesting case. This was throughout COVID. We've just been using liquid biopsy of an 81-year-old female. Known NSCLC tumor was insufficient. So remember, we set it for liquid biopsy. A ROS1 fusion was there. We started her on crizotinib. Then eventually she progressed. We again did a liquid biopsy at this point. We picked up a resistance mutation, ROS1 G2101A, which is a known resistance to crizotinib. Then we went ahead and we started on lorlatinib. Then she progressed. Then we got another ROS1 known resistance mutation. Then she was started on cabozantinib. Then she eventually progressed, and unfortunately she passed on. But the thing here, what was a good learning for us is that liquid biopsy is actually a good, reliable partner in actually taking you through a patient's testing journey, provided it's done with the right lab. And on that note, I'm going to stop before I have some more technical issues with my PPT. So sorry about that, and thank you so much for being patient with me. Thank you.
Thank you, Ma'am, for your wonderful presentation. Now I would like to move on forward to the next speaker, Dr. Rakesh, who will be providing a practical guide for the clinicians how to read a molecular report.
Laser pointer in that. So this is the next slide. Laser pointer. Yes, it won't reflect on LEDs. It will not reflect. Okay, that one you can use. Okay. Next slide, this one. Yes. Good morning, everyone. First, I would like to thank Dr. Prashant and Dr. Sandhya and organizing team for inviting me for this talk. And when I got this topic, I was really confused what to speak, because when you're working in oncology field, you are presumed that oncologists know much more than what we think. Then also I took the topic, and I have tried to keep it simpler and very basic, and I got only 15 minutes. So I will start with the first, that is a central dogma. So we all know DNA, RNA and protein, these are the three structures around which the molecular biology or the molecular test deals with. And we know DNA transcribed RNA, and we get the protein. And whatever we diagnose in molecular generally deals with these three components. And then in DNA and RNA, what is the component which is different is exon and intron. So in DNA, we have exon plus intron, and in RNA, we have only exon. And there are splicing which takes place. So molecular also deals with the splicing type of mutation which we can see in the reports. So when we see the evolution of the cancer, we always get a lot of mutations in the report. So there are some driver mutations and there are some passive mutations. So driver mutations are the one which drives the cancers, and the passive mutations are just sitting there idle, which will have no role in the cancer pathogenesis. So in a report, you will be seeing many reports which is having a lot of, like for example, in lung cancer, you get EGFR del19, which is a driver mutation. But on the background, you can see a lot of important mutation which will be there in the oncology report. So you should be aware there are two types of mutations. These are the machines which are used commonly for the molecular testing. This is basically the workflow where we do some wet lab or the preparatory steps called DNA library. We sequence it on an NGS sequencer, and we compare with the reference sequences which is available in the database, and we report a variant, whether it is a targeted panel, genome sequencing or whole genome sequencing. This is a common workflow what we do. Cancer panel. It gives a lot of information from sample type to clinical details, the tumor cellularity, and then you see the result. So you can see there are a lot of things which are marked in various colors, and which gives you a lot of information when you read the report in details. So we'll see something in basically what are the type of mutations, what is the VAF, what is this NM number tells you. So we'll see one by one what this tells you in the report. So we'll start with the mutations. So the first slide is what is a missense mutation. This is the nucleotide ATCG, which we all know are the sequences seen in the DNA. And whenever there is a single changes in a nucleotide, a single nucleotide change, it is called missense mutation. And you can see in the example, the amino acid is also changed.
The common examples what we can see in the lung cancer is the exon 21 L858R is a common example of missense mutation. Then we have a deletion mutation and insertion mutation where some amount of nucleotides are added to your normal sequence is insertion, and deletion where you delete a particular nucleotide sequence. So these are the two examples. Exon 19 EGFR is a deletion mutation example, and exon 20 insertion is a common example of EGFR. Then we move to the amplification. So you have seen a lot of report like ERBB2 amplification or HER2 amplification. So what is amplification? This is a normal cells which we have HER2 in a normal number, but in amplification the gene copy numbers are also increased, which eventually express in a form of a receptor. So this receptor dimerize either by other receptor and will start giving lot of signal for the proliferation. This is how ERBB2 amplified amplification generally do the carcinogenesis. We all know it is well documented in breast cancer. Now we can see more numbers. We are seeing cases in lung cancers also. So next is the gene fusion or gene rearrangement. So in NGS assay we have seen nowadays, earlier used to report on DNA only, but now we have DNA plus RNA. So most fusions are reported on RNA. So what is fusion? Basically this is chromosome A and chromosome B. There are two genes. So they generally break and they just combine and give a new fusion protein. So the example we have is EML for ALK. So based on the breakpoints and fusion, we have various type of EML for ALK fusion, and we know V3 is resistant to the first generation of ALK inhibitor. So lorlatinib is the treatment of choice when you get V3 type of EML for ALK fusion. So knowing this information give you upfront idea what type of fusion you are dealing with. In the report, you go and see what type of fusion, whether it is exon 20 or some other exons which has combined in the fusions. We can see large scale transitions where the changes takes place at the chromosome level, and in HRD signature what you get in the report generally deals with this kind of large scale transitions or recombination. So in HRD score basically deals with the chromosomal level changes. This is a common thing which everyone has struggled in the report. What is coverage and what is depth? Oh, sorry. So this red color are basically the reads. The reads are nothing but your DNA, how much time it has been sequenced. And when we can see this area where all are overlapping, this is a good coverage and higher depth sequence. So for somatic mutation, you require a good depth and good coverage. For liquid or for exome or genome sequencing, the coverage can be at a lower side. So for coverage, you can see this example, only 2 reads are there in a particular region, so this will be termed as a lower coverage. But if you can see this green number of reads which is overlapping, this is a high coverage area. So this is just a table where you can see targeted panel more than 250x for somatic is a generally done for somatic mutation. For exomes and genome, there is 30x and 100x is the minimum coverage what is required for any interpretation. So once you see the report, you go and check the coverage, and then you know whatever variant was reported is of a good coverage and good depth. Then you basically, what is VAF or what is MAF? So basically it is nothing but in a particular reads, if you have 100 reads, how many are the abnormal or variants? So in this example, you can see there are 42 which is abnormal, so the 42% is your VAF. So for somatic mutation, higher the VAF gives you more confidence, and somatic mutation on most NGS will have a lower VAF of 3 to 5%. Below that VAF, if you want to sequence for somatic, you have to do some other UMI or some other type of bioinformatics technique to get the variant correct. Lower VAF is generally seen in MRD detection and ctDNA based assay, you can get the lower VAF. In somatic mutation also, if you get CHIP mutation, the VAF will be at a lower side. So whenever you interpret whether that mutation is CHIP or whether it is actually a variant, you have to see the VAF percentage. Then we move to what is this number, NM number. So basically this is an accession number. It is derived from a gene bank. So each number, if you just copy it and Google, paste it on a Google, you will get this information whatever there is in the mutation or the protein. There are other numbers also called LRG, which is not commonly used nowadays, but till 2020 or 2021, we get in report LRG report. Then there are ensemble accession number also in the report. So it is derived from the ensemble databases. So that accession number gives you information about that data, which databases has provided that particular variant. Now we move to the next, what is this C.166C2A and what is P dot. So C is basically coding nucleotide sequence. So the number gives at that number that particular changes has taken place, and P is for protein sequence. Similarly, in the report, you will see G dot, which is a genomic. The whole genome, what is that number at that particular variant has happening. So in this, in all the NGS report, you are going to get this information. Then there are some other short forms which is used more than, which is a substitution or missense. Then your underscore, which tells you that deletion mutation is present. Then there is duplication. Then there is insertion, inversion, and conversion. So this all you can see in the reports. Depending on the short forms, you can tell whether it is deletion mutation or insertion mutation. Then we move to the intronic variant. So intronic variant, there is something different what is reported. So intronic variant, you will see this plus or minus sign, and this is from the 5' end, like C.88 is the closest exonic nucleotide number. From that 2 nucleotide, you are getting that intronic variant. So this is commonly intronic variant or splice site variant we seen in EGFR mutations also, where the deletion can be at the splice site. So to summarize, whatever you see in the report is like a GPS system. So chromosome is like a longitude and latitude, while the NM number basically is the state or the city name, what you can call. The codon or nucleotide position is basically the street number where you, and we ultimately have to reach the change in the protein, what is happening at that particular cancer. So which is the P dot. So this entire numbers give you entire information about the changes, what is happening. Then clinician also have to know what variant effect. Sometimes you will see in the report the terminology like synonymous, non-synonymous, non-frame shift or frame shift. So I will speak about some of the terminology, like what is frame shift. So you can see the first one is a normal amino acid sequence, but in frame shift you can see there is some mutation which happened and which leads to the deletion of this particular change of this amino site. So all the frame post that mutation has been changed and you are getting something new protein. So whenever effect of protein structure is to be taken into consideration, frame shift and stop or terminating mutation is always having higher effect compared to the other type of mutation. In the report you will get other information like what method, what they are using for the extraction, what are the kit, what are the bioinformatic pipeline. You will also get information like list of genes analyzed, which gives you idea whether your interest genes are present in the report or not. Then there are disclaimer at what WAF the report is validated, what validated percent they have used. So in a report you get all this information in the method, disclaimer and gene analyze part. Then do clinicians know all this thing? I think yes, they get upfront information about many things, what type of mutation, what is the functional impact and what is the biological consequences happening with that mutation, and they can think about the targeted therapy, what will work. In this case, if there is some resistance mutation, for example, EGFR plus MET, if it is present and it fulfill all the evidences, then the clinician can take a decision fastly and the treatment can be started. And it will also help in the discussion with the multidisciplinary tumor board. So understanding the report will benefit the clinicians also and will help them to counsel the patients also what are these variants and what they can be given. Then we move to how is it very easy to get the mutations of this? So it is like getting a needle of the haystack because NGS gives you a lot of variants and we have to find out what variant is of very important. So ACMG has given 2 guidelines, one is in 2013 and one is 2015. So first guideline was for the germline mutations where they have actually classified 5 subtype system. And in 2015, for somatic variant, they have given 4-tier system, which is commonly followed in the oncology clinic. So this is that article which gives you details about this 5-tier system of the germline mutations. So the 5 are we all know pathogenic, cyclopathogenic, VUS, likely benign and benign. But how this is derived? This is derived from the 28 standard guidelines of the population databases. So this is taken into consideration whenever you report this 5 category. I will be faster. So these are the databases which is very commonly used or very well known, CleanVar, Cosmic. You might have read in the report from the Cosmic database this particular variant is mentioned. Similarly, there is a computational tool also where it will show what is the effect of that protein structure changes happening. So based on both the databases and in silico tools, the particular mutation pathogenicity can be found out. So they have also recommended a evidence-based framework where the scoring system is given. This is the second article, which is basically for the somatic mutation, which is 4-tier system. It gives you much more idea about the diagnostic, therapeutic, and prognostic and preventive effect of a particular variant. So basically, this is a tier system which is followed by oncologists in the somatic mutation. So first one is a tier 1, second was tier 2, and third one is a tier 3 system. So tier 1, basically, there is an FDA-approved drug. It is well-powered. Studies have proved that this particular mutation is having an impact. The tier 2 will be having that variant is not reported in that particular disease, but in other disease it is there. There is no FDA approved. So based on the tier system, the oncologist can decide whether that FDA approved drug can be given or whether any off-label targeted drug can be given in such cases. So this ACMG tiered system should be followed. So this nomenclature is also there, where why this report is given in such a manner, NM number is there, then you have codon. So there is a Hugo gene nomenclature committee which tells you how to report your NGS report, and we are following that criteria only. And for uniformity of the report, I think most NGS labs is following this Hugo gene nomenclature committee recommendation. So this is just for somatic mutation, this is just a summary. AI is also used for variant classification, but there are still unanswered questions like validation of your AI pipeline, whether that AI is giving what is required, what is sensitivity, specificity of AI tools. So there are a lot of unanswered questions when you are using AI, but some of the areas like variant calling, interpretation, literature mining, it has helped lot to the NGS lab. These are the other reports which you see, comprehensive genomic profiling and Oncotype DX, where scoring systems are used for a recurrent score. These are the other type of molecular report you will encounter in your oncology clinic. To conclude, uniformity of the report should be there. Based on the ACMG guideline, tier system should be followed for all the oncology reports, so it helps the oncologist to take a decision. And also in the tumor board multidisciplinary discussions, if the report is as per the guidelines, it helps the oncologist to also counsel and to give it better treatment in a early short time. So with this, I conclude my talk. This is my team at COP.
Thank you, Doctor, for such an incredibly useful session. Moving forward, seeing the unseen, a look at the next generation of PET scan tracers that are revolutionizing lung cancer imaging. Let's welcome Dr. Nilendu Purandre to give his insightful talk.
I request the speaker to kindly stick on to the time, please. We are running a tight schedule.
Hello everyone, thank you Prashant and Sandhya for inviting me here and for the fantastic hospitality. So I'll be speaking on next generation PET tracers in lung cancer management. Now when we talk about imaging in lung cancer, the buck pretty much stops with FDG PET CT. It is a recommended and most accepted imaging modality for evaluation of lung cancer. Nearly all guidelines recommend the use of FDG PET CT across all stages. I'm just quoting NCCN guidelines here, be it early stage lung cancer, locally advanced lung cancer, loco-regionally advanced lung cancer, and since the last NCCN guidelines, even for stage 4 or metastatic lung cancer, FDG. So apart from its obvious utility in staging evaluation of lung cancer, it is extremely useful to assess response to treatment, be it chemotherapy, radiotherapy, targeted or immunotherapy. And we know its utility in delivery and planning of radiation PET. It has certain limitations. There are false positive studies in infections, granulomatous disease, which reduce the specificity of granulomatous disease, which reduce the specificity of FDG PET. There is physiological and background uptake in organs like the brain, bowel, and even adrenals, which can mask or mimic disease. And there is low metabolism in certain lung cancer histologies, which can reduce the sensitivity. So there is a need to develop a biological agent which can match FDG in its sensitivity and surpass it in its specificity. An agent which has minimal physiological uptake in tissues, and since FDG deals only with glucose metabolism, an imaging agent that can look beyond glucose metabolism, that can image the tumor stroma or tumor microenvironment. And in this era of immune checkpoint inhibitor therapy, an imaging agent that can map certain checkpoint molecules like the PD-1, PD-L1 expression. So if we have such a biological agent, it will be extremely useful. So in 2018, the researchers in Heidelberg University in Germany developed a FAP inhibitor called FAPI4. FAP is fibroblast activating protein, and that we can label it as the next generation tracer in lung cancer. So we know that the bulk of the tumor stroma is formed, by tumor stroma, and tumor stroma contains several cells like the mesenchymal cells, the immune cells, and cancer-associated fibroblasts. And if you focus on the cancer-associated fibroblasts, they are peculiar cells. They are part of the tumor stroma, and on the surface of the cancer-associated fibroblast, you have these FAP receptors which are in abundance. Now, what do these cancer-associated fibroblasts do? They promote tumor growth by secreting certain substances. They promote angiogenesis, cell invasion, etc. So these are really important cells in the tumor stroma. And if we are able to image these cancer-associated fibroblasts, it will be very, very useful in practice. And luckily, we can image these cancer-associated fibroblasts via the FAP protein, which is expressed on their surface. Now we have peptides which are available, which selectively bind to these FAP proteins, and one of these peptides is the FAP inhibitor, now which we label with a radioisotope called like gallium, and when we inject it, we can image it under the PET-CT scanner, which we call as gallium-68 FAPI PET-CT. Now this is just a pictorial representation what I just said. The green ball is your cancer-associated fibroblast. This key is your FAP receptor, which is expressed. The key is your FAP ligand, which is labeled with gallium-68, which is a positron-emitting isotope, which emits positrons. And when this whole assembly is injected, it goes and sticks to these to the key, which is the FAP protein on the cancer-associated fibroblast, and thus we can image the receptor expression in the body. Now, in our early days, when we got FAPI PET, we imaged certain cancers. This was a high-grade sarcomatoid tumor of the lung, a necrotic mass on CT scan. So we did the standard staging imaging, which was FDG PET. You can see this is FDG because you can see uptake in the brain, glucose uptake. You can see the radiopharmaceutical concentration at the primary site, but there is absolutely nothing else on the whole body PET scan. It looks completely normal other than the primary site. But when you did a FAPI, you can see that apart from the concentration in the primary, you have these 3 other foci in the bones. And they actually were marrow metastases picked on FAPI, which were missed on FDG PET. So in this particular patient, FAPI seems to have upstaged the patient, which FDG had not picked up. Another case, which was a garden variety adenocarcinoma, probably T1 or T2 lesion. Again, the whole body PET seems to be normal, just some vague uptake in the acetabulum here. But we would often call this normal or ask for an MRI, but on FAPI you can see extensive skeletal metastases, which were again missed on FDG PET. So these are 2 examples amongst many where FAPI has actually upstaged the lung cancer. So now what does literature says? There are more than a dozen studies which have compared the diagnostic utility of FDG and FAPI. I'll just quote one of them because the results of this study are essentially reflected in all the studies. So this study is from China. When they compared FDG and FAPI in lung cancer, the blue bar is where both FAPI and FDG are equal. The orange bar is where FAPI was superior to FDG, and the yellow bar is where FDG was superior. You can see that for T staging, there was no both modalities were equal. For N staging, you can see that there is a small but significant number of patients which FAPI was staged it better than FDG, and even for metastatic staging, FAPI was proven to be superior to FDG. So that's reflected even in the numbers. So if you were to review the literature of FAPI versus FDG, in all these studies, FAPI was found to be better than FDG for nodal disease, probably because of the less amount of false positivity. For primary, there was no difference, and for metastatic disease, FAPI was much better than FDG, mainly for bone metastases and even brain mets. However, FAPI has not been found to be superior to brain MRI for detecting neural metastases. And in majority of the cases, the uptake of the FAP expression on PET correlated with that of IHC. So there are about 15 studies, nearly all of them are from China, with the sample size ranging from 30 to 130 patients. These are mainly proof of concept studies and some comparing diagnostic accuracy of FAPI with FDG PET. Having said that, there are practically no studies which look at response assessment, response assessment to chemo, radiation, immunotherapy, which on FDG we find itself difficult. Response assessment to immuno and targeted therapy is not easy. So FAPI, we really don't know how it's going to function in the response assessment. Outcome-related studies are not there on FAPI. Now, FDG is practically woven in the treatment algorithm of lung cancer for staging, for triaging treatment, assessing early response, etc. But outcome-related studies on FAPI are not there. We have no studies regarding cost effectiveness of FAPI, and FAPI theranostics in lung cancer is not yet developed. Now, this is a very elegant article, written by Professor Rodney Hicks, who was the orator at the Tata Hospital EBM last year on theranostic. It's a very elegantly titled article, Will FAPI PET End the Hegemony of FDG PET in Oncology? And Professor Hicks feels that FAPI in the years to come will play an important role in the molecular imaging armamentarium, and he feels that FAPI can slowly nudge out FDG from the scenario. But we need to look at it more realistically. The question is, though now early studies have shown that FAPI is better than FDG, the question is, should FAPI replace FDG in lung cancer? For that, we need to answer the question, can FAPI compete with the widespread availability of FDG? For that to happen, centers will have to invest in gallium generator, because we do a gallium FAPI PET, not an F18 FDG. Now, that's why you need expertise in in-house labeling, you need technologists, radiopharmacists who are experts in labeling, and gallium has a limited yield in microcurie amounts compared to FDG, which is produced in huge curie amounts by the single run of cyclotron. So these are real, actual practical issues in the real world. And so there is early evidence. FAPI PET is promising, but it still has a long way to go before it's accepted widespread use in the community for lung cancer. Now, coming to certain radio-labeled PET probes, which can map the PD-1, PD-L1 axis. This is the PD-1, PD-L1 axis in cancer. Now, if you have antibodies to this PD-L1, which can be labeled with a positron-emitting isotope, and when this whole assembly is injected, it can be actually mapped non-invasively under a PET machine. So PD-L1 expression can be studied in a non-invasive manner using a whole body PET scan if we use antibodies, fragmented antibodies or small peptides, which can be labeled with positron-emitting isotope. In that way, you can evaluate the primary site as well as the metastatic sites for PD-L1 expression, and tumor heterogeneity, which is often an issue with PD-L1 expression, can actually be studied better. And you can also decide therapeutic options, whether to give anti-PD-L1 therapy and even evaluating response to immunotherapy and anti-PD-L1 therapy. So which the radio-labeled PET probes which can map the PD-L1 expression again can be labeled as next generation PET tracers. Now people have labeled nivolumab with zirconium, atezolizumab with zirconium 89. Now these are whole antibodies, they are large in size, their tissue penetration takes time and their background clearance takes time. So they need to be labeled with isotopes like zirconium 89 which have a long half-life, which present in the body for a long time. Unfortunately, it's not, zirconium 89 is not available in India. But having said that, now we have certain peptides, which can be labeled with short-lived, short half-life isotopes like gallium-68, which is more readily available. And we can inject these small PD-L1 binding small peptides and study the in vivo expression of tumor PD-L1 levels. So this is the first human study in lung cancer. This was a patient with a TPS score of 80%. You can see that excellent concentration in the primary as well as in the adrenal mets, whereas this is a patient with a TPS score of just 8% and there is practically no uptake in the primary and metastatic side. And this is reflected in the differential SUVs in the two patients. Now, last year we started our own work on PD-L1 binding in lung cancer. This was a 40-year-old female with adenocarcinoma with a CPS score of 60%. You can see extensive metastases seen on FDG PET. We injected this patient with a PD-L1 binding peptide labeled with gallium-68. And you can see that though the signal to background is not as good as FDG, FDG is, you can see this is FDG which has glucose concentration in brain. And you can see at most of the metastatic sites, there is PD-L1 expression. So this patient is likely to respond to anti-PD-L1 therapy. Same is seen on actual images, PD-L1 expression at the primary site. Another patient where a 45-year-old male with a CPS score of 72%, extensive mets on FDG PET, and on PD-L1 PET, again, almost all metastatic sites showing excellent PD-L1 expression. So to summarize, though FDG PET is a standard imaging technique accepted, recommended in all guidelines, it has its limitations. Now, the tumor microenvironment, tumor stroma can be studied more effectively by gallium-68 FAPI PET, which maps the cancer-associated fibroblasts, which are important cells causing tumor, responsible for tumor progression. There are now almost a dozen studies which have established diagnostic superiority of FAPI over FDG, but outcome-based studies and response evaluation studies on FAPI PET are still lacking. And more importantly, logistically, the widespread availability of FAPI PET is still an issue, but maybe in years to come, it might be overcome. And now we have early human studies where we have mapped PD-L1 expression using novel PET probes, and it can potentially overcome issues of PD-L1 heterogeneity because your IHC sample is obtained from just one or two biopsy specimens. And that way you can use, you can choose better patients for anti-PD-L1 therapy, assess their response, and thus moving towards more personalized medicine. Thank you for your attention.
Thank you, sir, for your insightful presentation. Now, moving on to the next speaker, I would like to welcome Dr. Bhavesh Boladia. Who will be discussing about the PD-L1 negative metastatic non-small cell lung cancer.
Slide changer, sir. Do you know slide changer? I'll do it with the one. Okay, yeah. On air, sir. On. Hello. Thank you. So, good morning, one and all, and thank you at the outset, Prashant and Sandhya, to give this opportunity.
I'll be talking about something very difficult thing what we usually struggle. We don't have much options, but we have to find some good options for the patients. So this is focusing on the PD-L1 negative NSCLC, and we'll see what's the role of Keytruda or pembrolizumab. So this is a sponsored session. Slides are by the MST team. So I'll start with a simple case which we usually see in our clinics. 65-year-old male having a good smoking history with moderate COPD and hypertension, good ECOG status, develops a non-exertional chest pain, and in a short time non-productive cough. PET scan shows metastatic disease, adenocarcinoma confirmed by IHC. And molecular test shows EGFR, ALK, PD-L1 and ROS1, which were showing the driver mutations were negative in all ALK, EGFR, ROS1, and PD-L1 was 15%. So this is a typical minimum panel, I would say any patient of lung cancer should get, but ideally we'll go for 12 or 20 gene panel, or in the most ideal case for a CGP. But as of now, at least this much is something very essential and doable. So the decision point comes in the plan of management that those patients who are driver mutation negative, and even immunotherapy is not an option for PD-L1 negative. Is that really true, or it is something else? So we can see and go through the NCCN guideline, and we see in both adenocarcinoma as well as squamous cell carcinoma, we do the PD-L1 testing, and there is a category 1 indication to do that, and also to direct treatment according to that, including pembrolizumab plus in combination with chemotherapy. So this is a high level evidence. We know category 1 recommendation, and what is the appropriate line of treatment in such patients who are PD-L1 negative, less than 1%. So we know that if the patient is good enough PS wise and systemic therapy can be given to the patient, we divide the patient either to adeno or squamous, but luckily in both squamous as well as non-squamous NSCLC, this works, and it's a preferred choice of chemotherapy plus pembrolizumab. The chemotherapy partner does change with adenocarcinoma or the non-squamous variety, which is pemetrexed, and in squamous variety we usually go for the paclitaxel or a nab-paclitaxel. So coming to our case, this patient had all these options which are available right now, but we'll go for the best, and we'll see which is the best as of now. So this is just a snapshot of the incidence on mortality rates and the regional variation of lung cancer globally. We know it is #1 killer in the world for cancer related deaths, and second most common globally. And in India, which is more interesting for us, again this is one of the, in the top 5 cancers if we see, it is the highest mortality percentage. Almost 90% of the patients we lose every year compared to the incidence when it is in the when we see a lung cancer patient. Things are actually improving, but yes, the percentage has not improved so much. We are still lingering about 80 to 90% mortality. And this is a real world express of the presentation of different regions, as well as the presentation of EGFR and ALK mutation, and we can see across all real world data, the prevalence of PD-L1 is consistent, almost looking similar, whether it is TPS score of 50% and above or between 1 to 5, or previously treated patient looks almost similar, albeit the previously treated there is a slight drop, approximately 5 to 8% lesser in patients who are harboring PD-L1 positivity. And there is a big chunk, almost 1/3 of them are going to be PD-L1 negative. This is again the distribution according to the age, according to the biopsy from where it has been taken, or the histology. But the prevalence, we can see it is almost remains the same irrespective of this stratification. So is there any data which supports the use of pembro with chemo combination in PD-L1 negative? And yes, we have data for that, and we'll go through that data set in the next few slides. So this is a elegant study, Keynote 189, where irrespective of the previous PDL1 positive or negative, everybody who was ALK and EGFR negative were randomized 2:1 to receive Pembro plus chemo combination versus a standard of care, that was chemotherapy, followed by Pembro maintenance. And there was crossover which was allowed, crossover was permitted. So this exactly resembles the way we do it in our clinical practice. So there is no bias as such. So the OS, which is one of the very hard endpoint, we all expect that it should be positive, and in this intention to treat population, we can see the median OS is doubled from 10 months to 22 months with an excellent HR of 0.6. Coming to the OS according to PDL1 less than 1 or PDL1 negative, which we say, again here there is an improvement of 7 months from 10 to 17 in the median OS, an excellent HR of 0.52. Similar benefits we see in PFS with 0.5 HR, and in those who were negative for PDL1, again HR of 0.68. Not only the PFS and the OS, but also the PFS2. So when patients progress, the patients were crossed over to the experimental arm, and almost there was 57% crossover in these studies. And again PFS2 also continues to show benefit with an HR of 0.46. ORR and DOR are again very impressive, and we focus on the last one where it is PDL1 negative, and it almost more than 2.5 times, 14 versus 33%. So do we have anything similar in a squamous? The previous one was in the non-squamous NSCLC, and yes, we do have a specific squamous NSCLC group also. That's a Keynote 407. Again, this was specifically done for squamous NSCLC, 1:1 similar design, only the chemotherapy partner was changed from pemetrexed to paclitaxel or nab-paclitaxel, showing same impressive OS benefits, improvement in 7% at median OS and HR of 0.71. PFS again positive with an HR of 0.59, and we see the separation starts very early, at as early as 2 to 3 months in the patient's treatment history. Coming to specific PDL1 negative patients, yes, there was a numerical or absolute improvement, but the HR was, the CI, the confidence interval was crossing 1. So what they do, they usually take these patients and group them together. So this was a extrapolated pooled analysis of all this Keynote trial, including 189 and 407, and this is what they compiled, the 1,300 plus patients. Out of that, 1/3, the way usually we expect, are going to be PDL1 negative, and they were either receiving Pembro plus chemo or chemo alone. And here you can see important part that 57.4% crossover was seen. So again, in this pooled analysis, baseline characteristics were well matched. There was not much difference in the habits. And again, the OS is showing very, very impressive, 11 months versus 19 months median OS with a 0.63 HR. If we see across each stratification group or the different factors, everything is in favor of adding pembrolizumab to chemotherapy. Again, PFS in this specific group, which was PDL1 negative, again is showing a 0.68 HR. And PFS2, so OS, PFS, PFS2 consistently showing good benefit, and HR of all the HRs are less than 0.7, 0.57 in this case. ORR again quite impressive, almost doubling from 29% to 50%. And when we know that such efficacious drug is there, we also look for the toxicity, and we should know how to monitor that. So luckily, the grade 3 to 5 events are not different in both the groups, whether it is Pembro plus chemo combination or chemo alone, both are at 70%. And other specific side effects which were there, which were seen almost similar in both the groups. And obviously, those which were immunotherapy related side effects exclusively seen in the experimental arm. And we know that pneumonitis and endocrine issues, encephalitis, these are going to be little higher, and luckily most of them are less than 5 to 10%. So do we have a similar data? This was a global data or complete population. So do we have something which is more interesting for us? So do we have an Asian data, similar population? So yes, they do have a again exploratory pooled analysis of this specific group. And again, the baseline characteristics were similar, showing even better overall survival compared to the global extrapolatory analysis. In Asians, the median OS has improved from 12 to 21.3 months with an HR of 0.55, PFS 0.64, improvement of 2.4 months, PFS2, HR of 0.43, improvement of almost close to 7 months. And if you see the tumor responses, quite impressive. CR and PRs together showed an improvement of 71% versus only 43% in chemotherapy. So there was a big jump of close to 30% in the overall in the tumor response. Side effects again, grade 3 and 5 side effects. Grade 3 to 5 side effects were similar, 80 and 82% in both arms. Again, specific immune therapy related are going to be little higher in the pembro arm, but luckily not much, not more than 5 to 10%. So in summary, what we understand that this combination of pembro plus chemo, either pemetrexed in adenocarcinomas or non-squamous variety, or paclitaxel or nab-paclitaxel in the squamous variety, it has a meaningful clinical benefit versus only chemotherapy alone. It is very, very evident in this specific PD-L1 population, which is almost 1/3 of our lung cancer patients. And it not only shows improvement in the efficacy parameters like OS, PFS and PFS2, but also overall response rates are quite impressive. Similar results were observed, especially not only in global patients, but also specifically to East Asian patients, where PD-L1 was negative, and this combination has manageable side effects. We have seen that it is not very high compared to chemotherapy. Obviously, there are some specific immunotherapy related side effects which we have to monitor closely, and we can come to a better outcome with managing this toxicity with a good monitoring and good counseling of the patient and their relatives. And these results are consistent supporting the global phase 3 studies, and there is a continued usage of this has become a standard of care in these patients who are negative for PD-L1 as well as the molecularly driven markers like EGFR and ALK alteration. So overall, we are always very limited, or we use only chemotherapy in such patients who are going to be driver mutation negative, immunotherapy markers negative. But that is not the case. We should not stop there. We should give them the best always first. Because we know then once the patient fails the first line, almost 30 to 40% patients we are going to lose. They are not going to reach to second line. So definitely they have to receive this in first line. And now with more and more patient support programs, this has become more and more affordable for a big group. So initially I remember being offered and accepting immunotherapy is increasing drastically. And now it is becoming almost 2 or 3 fold. So from less than 5%, it has become 10-15%, and it is still improving. So this is where I will end. This is probably my last slide, and thank you very much for the patient listening.
Thank you, sir. I request Chief Case to have if they have any insights to add to the presentation.
Thanks for the wonderful talk, sir. The topic is open for discussion. Anyone having any query?
Thank you so much. Now I request all the speakers of the session to come and join us on the stage for the group photography. Dr. Om Shri Shetty, Dr. Aparnadar, Dr. Rakesh Temde, Dr. Nilendu Purandre, Dr. Bhavesh Poladia. Now we'll have the inauguration followed by oration.
So as the preparation for the inauguration are underway, I would like to introduce our flagship innovative concept for the new generation of residents, a competitive yet creative educational reels initiative designed to help educate patients and promote holistic care.
Fact: there's no proven shortcut, and early detection saves lives. Myth 3: screening is only for people with symptoms. Fact: low-dose CT can find cancer before symptoms appear, reducing deaths by 20%. Low-dose CT scans are recommended for adults 50 to 80 with smoking or exposure history. At 60, Ramesh underwent a low-dose CT scan, which found his tumor early when it was still curable. It's never too late to quit. After 1 year, heart disease risk drops by half. After 10 years, the chance of dying from lung cancer falls by up to 50%, and your lungs start healing within weeks. Today, lung cancer care has transformed with targeted therapies, immunotherapy, and precision radiation, giving patients real hope. These advances give patients real hope for a new life. Early diagnosis and modern treatment together save lives and restore hope.
Warning, this is a message from your lungs. They can't take the smoke any longer.
I'm giving up. I have time for scrolling but not screening.
Why so sudden?
Sudden, I have given you so many symptoms but you ignored.
What? What are they?
There can be multitude of symptoms, most common being persistent cough that does not go away, sometimes blood in sputum, and later on it can progress to chest pain, exertional dyspnea. Most people ignore these symptoms and land up in trouble.
So how does lung cancer form and how can you prevent it? Cigarette smoke contains thousands of chemicals, and about 70% of those chemicals are known carcinogens. Each puff of smoke you take fills your lungs with these toxins. Over time, these toxins can build up and damage your cells, eventually causing lung cancer. So how can you prevent lung cancer? Well, the first thing to do is avoid smoking at all costs. The next thing is to avoid passive smoking. The next thing is to have a healthy diet. And the last thing is to limit alcohol consumption.
But you have good news. Lung cancer is completely curable like any other cancer if detected early. What do you have? We have low-dose CT scan, which can be done in a high-risk group of patients who have the risk factors for developing cancer. Detected early, surgery and immunotherapy and targeted therapy definitely have an answer which can cure the disease.
Youngsters follow the footsteps of their elders. So let's prevent the future getting addicted and losing productive life to lung cancer. Jai Hind, Jai Arogya Bharat.
Surgeons are the first to tell patients, quit smoking, it saves lives. Yet behind the scrubs, the reality is different. Are you aware that 1 in 7 doctors in India still use tobacco in some form? A cross-sectional study from Sri Chitra Tirunal Institute found smoking rates of 15% among medical faculty and 14% among medical students, which is quite an astonishing number. A national survey from Max Super Speciality reported even higher numbers. 37% of doctors used some form of tobacco and only 72% wanted to quit. And when asked if they want to seek active help, only 35% have agreed to do so. This is not just about personal health. Smoking impairs stamina, focus, precision, and steadiness. The very qualities a surgeon must bring into the operating room. Doctors, especially surgeons, are notorious for being stubborn, delaying help, and hiding their struggles. It's time to change that. We are already breathing enough smoke in our operating rooms every day. Let's not add more to it. Let's break the stigma, seek help, and quit smoking before it is too late.
I thank all the participants for their encouraging participation, and we really appreciate all the efforts that you have taken. There are many more reels which we'll be playing in between sessions or during breaks. Now we proceed for inauguration.
Thank you, Dr. Sandhya. So good morning, all of you. I am Dr. Karthik, Consultant Surgical Oncology at Sri Venkateswara Institute of Cancer Care and Advanced Research, Swikar. On behalf of organizing committee, it is my honor to welcome all of you for Nalccon 2025 16th Annual Conference of ISSLC. We are privileged to have distinguished speakers, experts and delegates from across the country for joining us in the spiritual capital of Andhra Pradesh, Tirupati. So thank you for being here and contributing your expertise and making this event truly special. With great enthusiasm, we'll proceed with inauguration ceremony by inviting all the honorary dignitaries onto the dais. So I would request Dr. Lakshmi Sandhya, Organizing Secretary Nalccon and Consultant Medical Oncology Speaker, to come onto the dais. So Dr. Prashant Pennumadu, Organizing Chairman, Nalccon 2025, HOD and Medical Director Speaker. Dr. Narendra, Secretary IASO, Professor and HOD Surgical Oncology SWIMS. Dr. Divya Khosla, Secretary ISSLC and Additional Professor Radiotherapy, PGI Chandigarh. Dr. Digambar Behera, President ISSLC and Professor Emeritus, Pulmonary Medicine, PGI Chandigarh, and President NAMS. Dr. R.V. Kumar, Director cum Vice Chancellor, SWIMS, and Professor, Cardiovascular and Thoracic Surgery. Mr. Kumar Nandula, Chief Financial Officer, Tata Cancer Care Foundation. Dr. Kailash Sharma, Chief Advisor, Tata Cancer Care Foundation. I would request all the dignitaries to come for lighting the lamp. Request all the delegates to raise in reverence.
Dipajyotirnamostute, Dipajyotirnamostute.
So I would request Dr. Prashant Penamadu to address this August gathering.
Good morning, one and all. Respected dignitaries on the dais, and my dear esteemed faculty members, and all delegates who have made it for the conference. And we also welcome our observer, Dr. Vasudev Naidu, who is here with us today. Our chief guest for the day, Dr. Venkateshwar, couldn't make it because of some protocol and last minute visit. But he has expressed his gratitude for and wishes for the conference. So on his behalf. So Nalccon 2025 has been a wonderful experience for all of us. And at the outset, I would like to thank ISSLC Executive Body for giving Tirupati, Swikar and Tata Cancer Care Foundation for helping us or having us host this event. It's a very proud and prestigious moment for all of us having to host this meeting today. We have done this in 2021 before in JIPMA. It was an online program. We wanted to do an offline program, and Dr. Behra, Dr. Divya readily agreed and to host this event in Tirupati. So the entire event has been a memorable experience for all of us, and we are also glad that we are able to do this event in the month of November, which is Lung Cancer Awareness Month. So that is also one of the reasons why we have chosen November to actually do. And one of the reasons is to create awareness among lung cancer. We all know that we're going to have most of them, Naveen was also telling, we don't see cases at all. So that is where we stand today. And I think with this meeting, we would spread out a word message loud and clear that lung cancers can be diagnosed early and also can be cured in today's world with so much of development that comes over. Probably every month, every 2 months, we get a new drug that is being discovered and, for that. So with these few words, I thank you all once again, the faculty and delegates, for having made this conference a successful and memorable one for all of us. Thank you.
Thank you, sir. I request Dr. Narendra to speak a few words.
Om Namo Venkateshaya. So, dignitaries on the dais, dignitaries of the dais. So it's really a warm welcome to all of you to the temple city of Tirupati. I think many of you had good darshan of Lord Balaji yesterday. So with his blessings, we are launching this program. I am wearing a double hat. I am Honorary Secretary of Indian Association of Surgical Oncology as well as President of AP Association of Surgical Oncology. Dr. Prashant is Secretary of our AP Association of Surgical Oncology. This we launched recently, around 3-4 months back. Again, one CME was conducted by Prashant at Swikar, where we launched this association, and nearly we have 90 surgical oncologists enrolled in this association. And we are planning to conduct various meetings along with various public awareness events also in this. But I envy this association, ISSC particularly, because one of the few societies which are focused on a specific disease group. I hardly see any of them, where multidisciplinary members from across the specialties like surgical, medical, radiation, oncology, pathology, radiology, they come together and work for the welfare of the patients. It's a unique thing, I envy that. And we should also, we have a plan to devise something like to bring out at least a state level wherein multidisciplinary collaboration of all the specialties across and to launch certain programs which can benefit cancer patients. Having said that, again, I know the success of any conference is apparent in the number of registrations. I think Prashant told me it has crossed 300, nearly 300. And that also reflects, the success of any conference reflects the hard work put by the local organizing committee. Again, I congratulate Dr. Prashant, Dr. Sandhya, and their team who have come out with this beautiful program. I'm going to assure that you are going to have a beautiful academic extravaganza in these 2 days. Thank you, one and all. Thank you, Prashant.
Thank you, sir. I request Dr. Divya Khosla to address this gathering.
Honorable dignitaries on the dais, distinguished faculty, respected seniors, colleagues, and dear students. Good afternoon, everyone. It is a great honor to stand before you today as the Secretary of the Indian Society for the Study of Lung Cancer. I'll be taking 2 minutes. As you all know, lung cancer remains one of the most significant public health challenges in India. And with rising incidence, barriers to early detection, and most of the patients being diagnosed at advanced stage, our work as clinicians, researchers, and educators is more important than ever. As a society, we are committed to tackling these challenges through improved awareness among the public, scientific exchange between our colleagues, and by strengthening multidisciplinary collaboration throughout the country. About the society, Indian Society for the Study of Lung Cancer, it continues to grow in strength and relevance. So today we have more than 500 clinicians across India involved and interested in the field of lung cancer. And many of our members are actively contributing to the International Association for the Study of Lung Cancer, that is IACLC, and proudly representing India on the global platforms and highlighting the important work happening within our nation. In addition, I would also like to take this opportunity to express my deepest appreciation to our respected President, Professor D. Behra Sir, for his encouragement, vision, and support. And his guidance continues to steer ISSLC towards impactful growth and meaningful contributions to lung cancer care in India. My sincere thanks also to Professor Navneet Singh, past Secretary ISSLC, our Treasurer Dr. Nalini Gupta, and all our executive members whose effort, involvement, and commitment are the backbone of the society. Now coming to Nalccon 2025, we sincerely appreciate our organizing chairman, Dr. Prasant Pinamadu, and organizing secretary, Dr. Sandhya, for their tremendous effort in planning what promises to be a resounding success, as reflected in the encouraging response of over 300 registrations and the participation of residents, trainees, and faculty traveling from across the country to attend this enriching scientific experience. The meticulous planning, commitment, and attention to even minute details have made this conference truly exceptional. The hospitality extended by the organizers that has been outstanding, warm, thoughtful, and truly reflective of the spirit. A special thanks to them for arranging the Balaji Darshan which we had yesterday, an experience that makes any visit to Tirupati truly complete. We are also extremely grateful to Savikar, a unit of the Tata Cancer Care Foundation, for the support and partnership. So thank you once again to the organizers for this wonderful academic feast and warm hospitality. I welcome and wish you all a productive, enriching, and memorable conference. Jai Govinda, Jai Hind.
Thank you, Dr. Divya. I would request Dr. Digambar Behra sir to address the gathering.
Honorable dignitaries on the dais, my fellow delegates, ladies and gentlemen. Indeed, it is a great pleasure to come to Tirupati for this 16th Nalccon. You know, I'll just try to tell you something about this Indian Society for Study of Lung Cancer. As you know, because I am basically a pulmonologist, I have nothing to do with oncology. So as a young consultant at pulmonology when I was working in PGI, that was exactly the year 1981. So I could see the patients of lung cancer. They usually report to the chest physician first, and then after we make the diagnosis, we simply hand it over to them to our radiotherapy department. And during those days, even these super specialty departments like medical oncology and others were in a very primitive stage. Actually, the radiotherapy departments all over the country, by and large, they were managing all types of cancer cases. So obviously, as usual, they are very busy. The lung cancer patients used to get maybe after a few weeks or a few months, they get their turn for getting radiotherapy, and that is so again just some sort of palliative therapy, give a few courses or maybe one course of radiotherapy and sent back home. So that was a little disappointing. Maybe at that time the there is not much also. So just simply could give drugs like vincristine, Nalccon and methotrexate. These are the three big drugs during those days. So then so that was little, as I said, that was little disappointing. So as usual, as young people, young man, you become little disappointed and think doing something. So I approached the head of the Department of Radiotherapy, Professor B.D. Gupta, to allow us so that we can start our own, we diagnose, and with his guidance, we can start this. So that is how the movement started, and then we try to gather some of the people who are interested in the field of lung cancer. So I remember Dr. Deshpande, the Raman Deshpande from Tata Memorial. He was still here today. I was very happy. So I approached him, and then some of the other people, Purvesh Parekh, Bhattacharya from Calcutta, and then Govind Babu. So those group of people, we thought to start lung cancer as a separate, association and do something. We had also a lot of people doing their PhD thesis in lung cancer. We had a lot of students at PGI. So we tried to think of to make all the specialties coming together. And remember at that time also, lung cancer was coming out to be the number 2 cancer following oropharyngeal cancer, which is still so. I think we discussed today morning, that is the second most common cancer in males in India and fourth commonest in females, and world over that is the commonest cancer, and both incidence wise and mortality wise. So it needs some special attention. So over the years, what I was telling you the story of vincristine injection, which I think many of the youngsters now will be laughing what primitive way we are trying to treat, but that was the best thing available at that time. People could survive for few weeks. It was not in months, even years. So the time passed on, and then now we are in the stage of molecular stage of the disease. You are hearing from the morning. So we could do their molecular testing. We could now the survival, we can count in years. The median survival is in years. So although it took little longer time, but we have now from weeks to we have come in years. But only issue in India is still we face the challenges, early diagnosis particularly. So that is how I thought, and I always give importance that the pulmonologist, usually any chest symptom, the patient comes to the pulmonologist first. So they should be trained. They should know about that the diagnosis should be very quick. And still, even at this time, people still get few months of anti-TB therapy before a definite diagnosis of lung cancer is made. I think to my pulmonologist colleagues, it is very important to them should know when and how to diagnose. We have got a lot of technical advancements now in the country. We have got the various intervention pulmonology. So we have got CT scans, we have got PET scan, and then what not. So the diagnosis could be changed, but only issue even with the molecular diagnostics, we are discussing since morning. The only issue is, although the good thing is that they are available in the country, but question is the available means it is not widely available. It still takes some time. It is still very costly for an ordinary patient. It is not always easy to get the test done. And the whatever medications that are available, they are also available in the country. Of course, it is there. There are patient support programs, but they are still beyond the reach of the common patient. That is another thing. So I think these are some of the important issues for lung cancer patients. So, and then the other issue is the screening. I think a lot has been talked about screening and early diagnosis of lung cancer. Although one thing is the smoking part, the smoking is a common cause or important cause, but that again India has done a lot of things about various anti-smoking measures, but that needs still more aggressive approach. And screening is not yet, we have not yet reached a uniform policy for our screening of lung cancer patients. Then there are many issues. So both at the early diagnosis, prevention, as well as the availability of various tests and drugs, they are very important. And as a society, I think we should focus on some of these points, try to learn from each other, teach the younger generation. And at the end, I will invite all this is, Prashant, this is one of the best Nalccons organized, your hospitality, and I know that how hard you have worked. And I'll request all the people who are not members of the society, they should become the members of the society. And also as part of the National Academy of Medical Sciences, I happen to be the president of that also. So on that behalf, I again congratulate you, and I again request all of you to become part of NAMS as its member or as its fellow. So with these few words, thank you all for joining in large numbers, and Jai Hind.
Thank you, sir, for your appreciating words. I would request Dr. R.V. Kumar, sir, to address the gathering.
Om Namo Venkatesaya. A hearty welcome to the spiritual city of Tirupati. Though this is a spiritual capital, we have about 10 universities, high-class universities. So it has become a big educational hub now. Now the latest child on this one is the medical hub with SWIMS, VCAR, Padmavati Children's Hospital, 75-year-old Ruya Medical College, a lot of other private institutions coming. It is growing as a medical hub as well. It gives me extreme pressure to be among you because I have seen this now for 40 years. And with Dr. Behra, I shared you a few minutes of thoughts how this thoracic pulmonology and thoracic surgery developed in the country, because I see a lot of young faces, and that's a very welcoming change. Because in 97, when I was given a lecture on lung cancer surgery in Indian Association of Cardiothoracic Surgeons at Kolkata, when I went to deliver the lecture, the room was locked. There was nobody. So they haven't even opened it. That was the stage where, from there, we see so many specialists interested in lung cancer. It is very exciting. Between 86 to 89, when I was in PGI doing general surgery, lung cancer was still with treatment, without treatment, the prognosis was same. And nothing happening from radiotherapy with old cobalt machines, and chemotherapy was still at neonatal stage. So it was dominantly surgical, and most of them present with, stage 4, and very few. In 89 to 92 at All India Institute also, 3 years MCH, I haven't seen one lung. Though we were not doing, the general surgeons were doing this one. Subsequently, I went to England, where I learnt my lung surgery mostly, and a lot of surgery for lung tumors and carcinoma lung. After I came back to Nizam Institute of Medical Sciences, Hyderabad, where I gave about 32 years of my service, it was a good experience. I could establish active thoracic program where still we do about 250 to 300 major cases in a year, though of course mostly open surgery. So in the beginning, when we started thoracic surgery at Nizam's with a dominant cardiac center, as it used to happen even in England, there was heavy resistance. So my boss HOD called me and said, now you start doing thoracic, all our cardiac cases will get infected, so don't, and your whole ward will be filled with empyemas and all, so don't. Slowly I started doing and sharing the papers. Then people realized there is a lot of dignity in thoracic surgery and there is a point. So slowly it almost took me 5 years to establish a decent surgical program in Nizam Institute of Medical Sciences. Subsequently, we had several good publications, including in thoracic oncology. The point, the lacunae which I found, which I think a lot of this young generation should concentrate on, is both, it holds both for the physicians as well as for the thoracic surgeons, is the government medical colleges where most of the education is happening, and also the undergraduate curriculum. For some reason, either we are shying away or they are not calling us, and they are not getting exposed. They become full-fledged MBBS doctors without knowing what is happening, because they just cram a few cases for passing exam, and that's it, a few theory questions and a few practical. Practical also, they fix up some tangible cases, and so that is one important thing. Unless we penetrate into the MBBS curriculum about both pulmonology as well as the thoracic surgery component, we won't make headways. Actually, we started improving our, cardiothoracic admissions into postgraduate program are awful across the country, across the world itself. But we could break that in Nizam Institute, and we never had a zero seat. Only when we approached medical colleges and started teaching what is thoracic surgery, cardiac surgery and all. So I think that is one of the very important ones. The second one is, now the latest, of course for me it is latest, may not be for you, is this VATS program. VATS program also, if you see, it's again mostly in private only. Hardly any of the, you can count on fingers institutes offering VATS surgery. Unless this surgery goes into medical colleges, like laparoscopy has penetrated, now gynecology, everybody is adopting laparoscopic surgery. This VATS has to travel. There are roadblocks. In Nizam's itself, I tried to put in the program. Our director, who used to be a physician, said, what value is it? And then we couldn't continue. So, and industry also, support is not so much. So, if you see 10 medical colleges randomly, you don't even have one medical college offering a VATS program. I understand that super specialists don't have good salary structure and all, but now there is a change in thinking. Governments are ready to accept this public-private partnership. So all of you guys who are doing great job in corporate can spend a part of your time, adopt any teaching institute and establish a program so that it becomes widely acceptable to doctors and all other specialists. And that's why we invite you for this kind of a private partner, public partnership, and also at policy level, we are working on rotating the surgical residents through private units doing a high quality work. Unless that also picks up with the encouragement from all of you, this specialty will not progress. Then from Sri Venkateswara Institute of Medical Sciences, we started this cancer screening going to doorstep with a pink bus. At the moment, we have been doing for the cervical cancer, breast cancer, and oral cancer. I'm sure we are going to incorporate lung cancer screening also into that. And state government, Andhra Pradesh government has recently launched the 4th version of cancer screening, where a lot of people, paramedics, are being trained to go door to door in the villages and map the health profile, in which cancer screening has been one of the top priorities. This is just starting this 4th version. Maybe in a year's time, we see the results of this cancer screening. So, with these few insights, how to make this program. One, as I told you, we have to penetrate into the MBBS curriculum, number one. Number two is to establish more VATS units, thoracic units in different medical colleges, especially as a private-public partnership kind of a thing. Third is to encourage the resident rotation, irrespective of private or this one. Wherever good work is being done, it should be recognized, and the doyens like Dr. Behra should help us to influence NMC and DNB so that these barriers are created by us between public and private. So they should be able to get good training wherever training is available. So, and the cancer screening. And the last one, as we know, one of the important bottlenecks of treatment is poverty in our country. So governments are encouraging with some insurance schemes, and also the private Tata Trust and all, they are doing a great work. Similarly, Tirumal Tirupati Devasthanam, we have a special program called Pranadhanam scheme, where devotees donate liberally for treatment of some of these patients who are underprivileged patients. Not only that, we also have another excellent program called Sri Balaji Arogyavara Prasadini, which is a research fund, which is devotees are donating heavily to it because they get a 100% tax exemption to it. So those can be used for the research developments, thus pooling of resources for further research in these areas also we need to explore. With that, I express my extreme happiness being with you, and I am sure with Prashant and organizers, you have a good scientific extravaganza this weekend, and also take the spiritual vibrations from Tirumala Tirupati Devasthanams. And I wish this conference all success. Srinivaso Vijayate.
Yeah, good afternoon, everyone. Requested people, dignitaries on the dais. So, we started looking at, I represent Tata Trust as a CFO for the cancer care program. So, we started looking at cancer in a very deeper way in 2017. So, wherein we said we need to set up a lot of hospitals across India. So, we came with a distributed cancer model where we set up around 32 hospitals so far. Some are along with the state governments, and some are, and majority of the hospitals were done in Assam, around 17 hospitals, and we are doing one hospitals in Maharashtra, and some are done in Varanasi, and some are done based on own and operate model, and some are done based on you complete the hospital and ask someone else to operate the model. The major idea of the distributed cancer care model should be affordable to everybody. So it's not going to cost too much of money, number one. And second thing, it should quality of care. There should not be any kind of compromise on that. That is one more thing which needs to be taken. And third thing is it should be closer to your place, because people tend to spend a lot of money going to other places, and when you're diagnosed with the cancer, then most of the money will be spent on your travel, your stay, and other things. The idea is to go and have a distributed model where it is closer to the place. So we set up a lot of hospitals in that, and this is going to be a good opportunity for everybody in that. So we hope we get a lot of support from everybody here also for making this program a little success in that. So probably get more and more ideas from everybody who's participating here in that. Thank you very much, and thank you for participating in this.
Thank you, sir. I would request Dr. Kailash Sharma to speak a few words.
Good afternoon, everybody. Dignitaries on the dais, my friend Prashant, Sandhya, all the faculty members from the country, AIMS, PGI Chandigarh, and all other institutes, FIMS from local. And I find this is, since morning, I was attending one workshop also. So I find all the multidisciplinary team has arrived here, and everybody is participating for only one organ, that is lung cancer, and how serious it is. You have seen since morning that what is the number of cases we are seeing. Now it is fourth cause of mortality in our country and in the world also. And which are the disciplines involved, right from say radiology, nuclear medicine, then molecular, then oncopathology, anesthesiology. When I saw, I'm being an anesthesiologist, I was very happy that how to isolate the lung from right to left while the surgeon is operating. That time, that workshop is also being organized with the support of the company and the different lung model, and my friend, colleague, Dr. Sunil has brought the goat lung, the live lung, to demonstrate how the trachea and the bronchus, they separate and how to isolate the lung. So with these, all this involvement right from medical oncology, surgical oncology, molecular, oncopathology, imaging, nuclear medicine, and different techniques of diagnosing the lung cancer, staging it, and the effective treatment strategies. So with all these things, I find the conference which is organized here by Swikar and the Nalccon, the national organization, with the help of this hospital, as Nandula has said, that this hospital is by Tata Cancer Care Foundation, supported by Tata Trust, a very novel approach towards the treatment and awareness prevention towards the cancer all over India. And Vice Chancellor has made very good remark on the apathy at the medical colleges, which I am very much concerned because I had 10 years of experience as a Board of Governors at Medical Council of India when it was dissolved, that there are no such courses and it is not being practiced at a medical college level right from MBBS to MS to MCH level. So this has to be there in medical college along with the help of private setup super specialty hospitals, so that our students while doing MS, they are not restricted to only hernia, hydrocele and appendixectomy. Only 3 operations. And rest of things they just saw. So lot many techniques are there, minimal invasive techniques are there, VATs are there. So he has emphasized very well on this topic that they should be imbibed and percolated at the graduate and postgraduate level of the medical college. So I have new proposals at the medical college where DM in pulmono-oncology, new course which will be devised by next year or this thing, and MCH in thoracic surgery. There is MCH in CVTS. Though here the only CVS aspect is considered, because heart and then triple bypass, that's all. They don't do lung or mediastinal or pleurectomy or something. So for that, there has to be a course which is for thoracic surgery except heart. So that also we have proposed. Let us see what happens. So I thank on behalf of the organization Svikar for this very well organized Nalccon in the city of Holy City, pilgrimage city, Tirumala, Tirupati, Devasthanam, where a lot of people have gone and paid homage to the Lord Venkateshwara. So again, while concluding my remarks, I give all the best to this conference since morning for again the few sessions today, and the best hospitality arranged by local organizers, and the Prashant is the best and very effective and energetic person, and my best friend from Tata Hospital onwards. So he has really given a very fruitful direction to this hospital, and over a period of time, this hospital will grow and it will have a very big dimension in the city and Andhra Pradesh, and maybe in the country also. Thank you very much. All the best.
Thank you, sir. I request Dr. Prashant Penumadu to honor the dignitaries with memento. To Dr. Narendra. Dr. Divya Khosla. Padma Shri Digambar Behra sir. Dr. R.V. Kumar. Mr. Kumar Nandula. Dr. Kailash Sharma. I would request Dr. Vasudeva sir, Andhra Pradesh Medical Council Observer, to come on to the dais, sir. I would request all the dignitaries for a group photo there. Stools in place, we can have a group photo now. Sir, I would request to please sit on the dais, sir. And I would request Dr. Sandhya to give vote of thanks. Sir, please be on the dais. Dr. Sandhya will give vote of thanks.
Respected esteemed faculty, distinguished delegates, and dear colleagues. As we conclude the inauguration ceremony of Nalccon 2025, it is my privilege and honor to deliver the vote of thanks on behalf of Swikar, the hosting institution and a proud unit of the Tata Cancer Care Foundation. First and foremost, our heartfelt gratitude to our chief guest, Dr. S. Venkateshwara, IAS, though Sir could not join us today due to unexpected commitment, he has called and conveyed his program and ensuring that every session reflects the spirit of innovation. We extend our deep thanks to the ISSLC leadership, including the President and the executive members, for their guidance, support, and unwavering commitment to making this conference meaningful and impactful. Behind the scenes, many hands and hearts have worked tirelessly. Our sincere gratitude to the organizing committee, whose meticulous planning and dedication kept every detail in place, and a special mention and a word of appreciation to the video technology led by Mr. Madan and Mr. Lovaraj for their contribution. A big thank you for our AV and technical team under the leadership of Mr. Nagarjuna, whose seamless execution helped the scientific flow uninterrupted. We appreciate the efforts of the stage management team who ensured the smooth conduct of each event. We are equally grateful to the transport and logistic team led by Mr. Yugender, who ensured comfortable and timely movement of all our delegates and faculty. To every member who worked on registration, hospitality, accommodation, and on-ground coordination, your quite consistent effort has been the backbone of this conference. A very special acknowledgement goes to the entire staff of Swikar, the clinical team, the support staff, and the administrative staff. Your dedication, your spirit of service, and teamwork reflects the ethos of the Tata Cancer Care Foundation and made Tirupati a warm and welcoming venue for all. We also thank our industry partners and sponsors for supporting the academic growth and contributing to the success of this important platform. A warm and heartfelt thank you to our media partner for amplifying the message and reach of this magnitude. Above all, our deepest gratitude to every delegate who traveled from across the country and participated wholeheartedly. Your enthusiasm turned Nalccon 2025 into a vibrant meeting of minds. As we conclude, we humble off our thanks to the divine blessings of Lord Venkateshwara for guiding us through these enriching days. Thank you once again.
Thank you, everyone. Next, we have our ISSLC oration on lung cancer. I request Dr. Digambara Behra sir and Dr. Divya Koshla to stay back for chairing the next oration. Now, a brief introduction about our orator, Dr. Prabhat Singh Malik. He is currently the additional professor in the Department of Medical Oncology at All India Institute of Medical Sciences, New Delhi. He completed his MBBS from SS Medical College, followed by an MD in medicine in MGM Medical College, Madhya Pradesh, and subsequently obtained his DM in medical oncology from AIIMS, New Delhi. He joined AIIMS as a senior research associate in 2013 and has since progressed to his current position as additional professor. His major research interests include lung cancer treatment, genomic characterization, targeted therapies in non-small cell lung cancer, cancer immunology, genomics of young onset lung cancer and genetic susceptibility, and the application of liquid biopsy in cancer diagnosis and management. He has received multiple research grants for various projects and is actively involved in advancing and refining lung cancer care. He is currently leading a Department of Biotechnology funded project as a principal investigator titled Comprehensive Genomic Characterization of Young Onset Lung Adenocarcinoma in India. This project involves conducting whole exome and transcriptome analysis of tumor tissue from young onset lung cancer patients and comparing these data with those from late onset lung cancer cases. Sir has also awarded a research grant as principal investigator by the Indian Council of Medical Research, ICMR, to evaluate the efficacy of low-dose nivolumab in combination with neoadjuvant chemotherapy for the treatment of non-small cell lung cancer. Dr. Prabhat serves as the coordinator of the Lung Cancer Guidelines Committee of the National Cancer Grid and is a member of the Guideline Development Group for the Department of Health Research, ICMR. It is our honor to welcome Dr. Prabhat Singh Malik to give the oration.
It gives me immense pleasure to welcome you all to this oration. So every year for the annual conference of the Indian Society for the Study of Lung Cancer, we invite applications for this oration, which is supported by Dr. Reddy's. And the selection is based on the applicant's overall contribution to the field of lung cancer. It is open for all ISSLC members. An independent selection committee reviews all these submissions and finalizes the awardee. So this year also we received multiple applications, and after rigorous and thorough evaluation by the scientific selection committee, so Dr. Prabhat Singh Malik was selected for this prestigious oration. His exemplary work and sustained contributions make him truly deserving of this honor. So let's listen to his journey.
Thank you, Dr. Divya. First of all, I thank ISSLC for this prestigious opportunity. And special thanks to Dr. Prashant and Dr. Sandhya for hosting us in this holy city of Tirupati. So, in next 20-30 minutes or so, I would just give you a glimpse of last decade in thoracic oncology, and our senior professors and people who are sitting here. And we have listened to them that thoracic oncology is one area which has literally seen the paradigm shift. And that too in a shorter span of time, I would say in last 1 decade or so. I mean, we have literally moved from a time from therapeutic nihilism, what Dr. Behra was alluding to a time where we have, I mean, literally we are spoiled for cafeteria choices. So, and this is where we started in 2002. This landmark paper was published in New England Journal of Medicine, that whichever combination with platinum, and these were considered new generation platinum-based doublet at that point of time. So whichever regimen you use, you have equally bad survival outcomes, and median survival of these patients used to be close to 1 year or even less. And this is where we are now in 2020 and beyond, that in a subset of non-small cell lung cancer patients, we are seeing 5-year progression-free survival beyond, I mean, up to 60% or 65%. I mean, this is a subset, but there's a huge leap which thoracic oncology has seen. And why this has been possible? Because our understanding of this disease has improved. We have started looking at lung cancer not as a single disease. We started looking at a histology-based classification from adenocarcinoma, squamous cell carcinoma, and so on, from genomic classification that they all have different driver alterations which can be therapeutically addressed. And now we have moved to the transcriptomic classification, which gives us a broad idea about the disease biology. So that's actually the key which has led to this development. I would just give you a brief glimpse from where I started my training and my journey in thoracic oncology. This was the time somewhere 2009 and so. I was asked to look at the data of lung cancer patients whom we were treating. And before that, I mean, our general perception was that the most common histology in India which we see is squamous cell carcinoma. And there were obvious reasons to look at the histological subtype, because this was the time when histology was becoming important to decide treatment. There were certain chemotherapy drugs which were working better for adenocarcinoma, and molecular alteration, that understanding was gradually picking up. So I was asked to look at all the histology slides as well with my pathologist. So what we found that earlier, a lot of patients were being just reported as non-small cell carcinoma, and when I asked my pathologist, they said that you people have only spoiled us because you were not really asking for the histology. You were interested in seeing non-small cell lung cancer or a small cell lung cancer, and that's where the therapy were being different. But when we looked at the histological subtype, a lot of those patients were actually classified as non-small cell lung carcinoma, adenocarcinoma histology. And when we looked at this data, and we found that actually it's adenocarcinoma histology which is becoming common in India as well. So it's not that a shift in histology is happening because of some change in our habits. It was probably our reporting system which was making this difference. So these are some of those observations which we were making at that time. And this is for the students, I mean, why this histology-based selection was becoming important. In 2008, this landmark trial was published. I mean, we do treat all adenocarcinoma with pemetrexed platinum doublet and consider it as a so-called standard of care. And this trial actually started to look at the non-inferiority. So it was a non-inferiority design for all histology taken together, and what they found that this drug worked better for only adenocarcinoma histology, and it's detrimental for squamous histology. And this question started with a non-inferiority. With a subgroup analysis, the regimen becomes standard of care. Until date, it is considered standard of care. I mean, it's just a tolerable drug, but that time, the cost was one of the important considerations. So we asked this question whether it's still like with a subgroup analysis, should we change our practice altogether, and or we look at it more deeply. So we did this small phase 2 randomized trial, which looked at the survival outcomes with pemetrexed carboplatin versus paclitaxel carboplatin, because that's the regimen which we have been using in oncology in other indications as well. And it was quite affordable and cheaper at that point of time. And we found that practically there was no difference neither in progression-free survival and overall survival. So whichever regimen you select is okay, that's perfectly fine, depends on your patient tolerability and affordability. At that time, we also observed that the concept of multidisciplinary approach was not literally existing. So we were actually working, all medical oncologists, radiation oncologists, surgeons were working in isolation. And when we found that a lot of patients who could have been offered radical intent treatment, be it a radical radiotherapy or be it a curative intent surgery when we get together, was not really happening, and it was resulting in detrimental survival outcomes of these patients. So, I mean, from 2013 onwards, I think Dr. Sunil is here, we did not, I would not really say that it was truly multidisciplinary approach, but a simple change which we made, that we started sitting together and maybe in adjoining rooms when we were seeing these patients, and we started talking to each other when we were discussing some stage 2 or stage 3 patients, that let's start them on chemotherapy and then consider them for surgery. We can plan the surgical plan and everything done in advance while these patients are on chemotherapy. And when we looked at our data, I mean, largely these are the patients who were operated after neoadjuvant chemotherapy, again, a retrospective analysis with a lot of selection bias. But what we observed that patients whom with systemic therapy we are able to achieve an N0 or N1 status, these patients have better outcomes as compared to patients who have persistent N2 disease. And these were, like, I mean, the major indication for neoadjuvant chemotherapy at that point of time was the presence of N2 disease in these operable patients. But we only had systemic chemotherapy. I mean, immunotherapy were, these approaches were developing and mostly approved for the metastatic disease. So we thought, can we do something better? I mean, that's not something where we really want to go ahead with still with all these newer drugs. Can we improve on outcomes with available chemotherapy? And dose-dense strategy, which was becoming quite popular in breast cancer and other cancer types. So we thought that let's try whether if we add dose-dense paclitaxel in neoadjuvant setting, can it change something? It was a phase 2 single-arm study, and we found that it was associated with very impressive objective response rates. I mean, if we compare, at the time, neoadjuvant chemotherapy was not really considered as a standard practice, except for a small subgroup of patients with resectable N2 disease. Otherwise, it was all adjuvant treatment. What we see in our India, our problem is more of locally advanced disease and not that truly screen detected disease. So we really need to do something better for these patients. And then came the era of immunotherapy. The immunotherapy has been literally the game changer in last 1 decade, and with exceptional success in metastatic disease, a subgroup of patients who have high PD-L1. I mean, this is the follow-up survival data of these landmark trials, which shows that almost 1/3 of the patients with metastatic disease are surviving beyond 5 years. So that's quite impressive. And with these success stories, actually, this strategy was introduced in more early stage disease and locally advanced stage disease, and integrated with a multidisciplinary approach in surgical aspect and chemoradiation stage as well. And now we have the mature data for Checkmate 816 trial, which has established neoadjuvant immunotherapy as, along with neoadjuvant chemotherapy as a standard of care in patients with potentially resectable disease. And look at the magnitude of difference in 5-year survival. This is absolute difference is 10%. And if you remember, with a difference of 5% in overall survival, we consider adjuvant or neoadjuvant chemotherapy in operable cases as a standard of care. So this is the magnitude of difference is almost double what we could get with systemic chemotherapy. But the problem lies here. This is the data from Tata Memorial that less than 3% of patients of cancer, I mean, not only lung cancer, all cancer type, based on their indication who could have been offered immunotherapy, I mean, less than 3% of them can have access or can afford these treatment. So we do have wonderful treatment, but if a large majority, I mean, 97% of our patients are not having access, it's useless for us. So can we really do something better? So based on these ideas, we thought, can we tailor the dosage and make these strategies more affordable and accessible to our patients? So we have started this phase 2 randomized trial, which is supported by ICMR, because for such strategy, you won't really get pharma funding. And there are not many takers for these kind of ideas. So it's funded by government agencies. And there is a good pharmacological rationale for students why the low-dose immunotherapy should work, because if you look at the early phase trials of immunotherapy, the dose response curve for immunotherapy is literally flat. It doesn't matter if you keep on increasing the dose to even 10 milligram per kg, that does not increase the response rates. So why to increase? I mean, you need to ask this question to yourself, that the dosage or that strategy which we are using is really appropriate or optimum strategy, or we can do something better. And we do see, if we look at the lab data, that 80% of the PD-1 receptor occupancy, a T cell, is achieved at the doses as low as 0.3 milligram per kg. So what we are offering is probably 10 times higher. So can we do something on that? So based on this, we have designed this phase 2 randomized trial. We are adding the same chemotherapy backbone, paclitaxel carboplatin in neoadjuvant setting versus neoadjuvant chemotherapy with low-dose nivolumab, 40 milligram flat dose given at 3-weekly interval, and we are looking at a surrogate endpoint. So to prove this idea of low-dose immunotherapy, we intentionally selected this cohort for 2 specific reasons. One, that when you give it in metastatic setting, you have to give it for indefinite duration. So the cost of trial is going to be super high, and nobody would probably able to sustain the cost of the trial alone. I mean, leave the rest of the things. In neoadjuvant setting, you just have to give 3 doses of immunotherapy, and you have early surrogate endpoints which directly correlate, like major pathological response and complete pathological responses, which we are seeing when you are giving immunotherapy in neoadjuvant setting. So that gives us an advantage that we can actually complete the trial and prove our point and concept at a very limited cost to the funding agencies. So we just calculated that if this dose strategy, this work, the cost of immunotherapy, even if we give it for longer duration, would be almost 10 to 12% of what we are currently spending on the full dose immunotherapeutic strategy. Another unique subset which we do see probably Western population, I mean the Western world, they don't see these patients more often, is a subgroup of patients who have poor performance status to begin with. I mean, these are sick patients, and they are mostly excluded from most of the clinical trials based on which we design our guidelines and the treatment strategies. And there is a clear-cut equipoise. I mean, we don't know how to really treat these patients who present with performance status in 3 and 4. And PS, although it's considered one of the most robust marker for overall survival, take any disease, including lung cancer, but it is an overall assessment. It indicates, I mean, it can be determined by the comorbidities, the age, and in our setting, it's mostly the high disease burden and late presentation. So should we keep all patients in the same basket, or we should select these patients who can be offered some sort of a systemic treatment and improve their outcomes? So when we, I mean, in our clinical, I mean, everybody in the routine clinical practice would encounter a situation when they use their clinical discretion and they use systemic chemotherapy to treat such patients once in a while. So when we looked at our retrospective data, but largely dominated by patients who had performance status 2, I mean, which are kind of borderline candidates. But it does show that, I mean, using some abbreviated chemotherapy protocols is still feasible, and it does improve their outcomes. And some of those patients who have good response, eventually they live longer and they have better quality of life. So, but this was the retrospective analysis. Always there is a challenge in looking at such data sets. So we thought, let's test this prospectively, and we designed this phase 2 single arm study. And when we defined the criteria for selecting patients for systemic chemotherapy who have poor performance status, so we selected patients who had poor general condition because of high disease burden. These were the patients less than 65 years of age, with controlled comorbidity or no comorbidity, and good organ function reserves. And we use an adaptive strategy of using low dose paclitaxel, that's 60 milligram per meter square weekly for 3 weeks, and then we assess the performance status at 4th week again, and to see how many patients have an improvement in performance status and their quality of life, whether they become eligible for a standard platinum-based doublet or not. And to our surprise, almost 1/3 of the patients with this strategy eventually have at least 1 point improvement in their performance status. And many of them eventually received the platinum-based doublet. Although the overall outcome of this entire cohort was not really great, but it gives us a little bit of confidence that if we carefully select these patients, we can actually offer them systemic chemotherapy. By this time, we have already this published randomized trial called IPSOS, which has established that immunotherapy can be offered to patients who have poor performance status at presentation. And it is, in terms of survival, it is modestly better as compared to single agent chemotherapy. So we thought that why not to just combine these two strategies. And now we are currently running this phase 2 randomized trial to see if we can incorporate low dose immunotherapy along with this adaptive strategy of using single agent chemotherapy and then escalating the treatment based on the response. Coming to the molecular profiling of lung cancer, we all understand that the non-small cell lung cancer is not a single disease. This is defined by the molecular alterations. But what is unique in India, we have a separate, or a different molecular profiling as compared to the Western population. We do have a lot of EGFR mutation. This is in the tune of 30%. So practically every third patient which you are seeing in your practice with lung adenocarcinoma has an EGFR mutation. On the other hand, it's just 10 to 11% in Western population. And not only in lung adenocarcinoma, we do see sometime EGFR mutation even in squamous cell histology, and this is shown here, up to 10% patients of squamous histology. I mean, there is a selection bias here, probably patients who have been non-smokers or female patients who were diagnosed with squamous histology they probably had. But that makes sense to even test these patients to find. Why it is important to find a driver alteration? Because if you have a driver alteration and you are using a targeted therapy, the survivals are significantly better as compared to the patients who do not have a driver alteration, or who have a driver alteration but you are not using an appropriate targeted agents. And the same thing was shown in our own institutional data as well. So, but the problem is that the overall pathway from patient diagnosis to obtain a tissue, then obtain histological diagnosis to molecular testing is reasonably long. And it's quite long in many of high volume centers like ours, where even getting a date for a biopsy takes some time. And many of these patients would eventually deteriorate over this period. So why not to use some better strategy, the plasma first approach? I mean, liquid biopsy has already, I mean, you have listened to that in the morning session, that liquid biopsy is already there in your clinic. But do we really need to test with NGS with all our patients, or can we do something else? So this is more of a pragmatic approach. In India or Asia, where every third patient you are seeing have an EGFR mutation, why not to just test every patient at presentation for presence or absence of EGFR mutation by liquid biopsy? This is one study done at the institute from my pathology colleague with us. So what we found that if we are sending liquid biopsy at the time of initial presentation, the turnaround time is significantly shorter. We are getting answers in 2 to 5 days. So that was the average time in the plasma first approach, as compared to the tissue first approach, where the median turnaround time was around 12 days. So there is a difference. I mean, I do accept that the sensitivity is lower. It's with the available methods, now the sensitivity has improved up to 70%. So, I mean, negative you can always test on tissue and do the subsequent downstream analysis, but at least those patients who have an EGFR mutation, they should get the EGFR TKI, which are available in generic forms. At least the first generations are available. At least that treatment can be started to these patients. And so then we thought that it is just the diagnosis and taking the initial treatment decision where the liquid biopsies can help us, or we can do better. So we thought, let's see. I mean, we know that patients who have ctDNA positivity to begin with, they have poorer outcome because it correlates with the overall disease burden. And patients who fail to clear ctDNA, when they are started on targeted agents, they have inferior outcome. So we thought, can we do some sort of a risk stratification and treatment escalation based on these liquid biopsy kinetics? So this was an initial phase 2 study which we did. And we took all patients who had ctDNA confirmed EGFR mutated non-small cell lung cancer and treated them with TKI for 3 months. Look at their radiological response and ctDNA response. Patients who became ctDNA negative were continued on TKI alone. And patients who had persistent ctDNA, we added chemotherapy. And what we found that at least half of the patients are able to achieve a ctDNA negative status in 3 months with TKI. And this is first generation TKI, not the novel generation TKI. And if we add chemotherapy to patients who are really high risk with presence of persistent ctDNA, I mean, we are able to achieve a progression-free survival as good as with those patients who are ctDNA negative. So that gives us a little bit of confidence that this kind of adaptive strategies or treatment escalation based on risk stratification is feasible. And based on this, we have started recently this phase 3 randomized trial funded by ICMR in collaboration with Tata Memorial. Here we are taking all patients who are having sensitizing EGFR mutation, randomizing them to receive either TKI with chemo combination, which is current standard of care, or following a adaptive strategy that is treating them with TKI alone for 3 weeks. And then by this time, we will have the NGS results and baseline ctDNA results available with us, and taking decision if these patients are ctDNA positive to begin with, or they fail to clear ctDNA, or they have a high-risk feature like P53 co-mutation, which can be tested by NGS, and we can have this information by 3 weeks, and only adding chemotherapy to patients who qualify these high-risk feature, and the low-risk patients who can be treated with monotherapy alone, so that we can avoid the toxicities and attain the comparable outcomes. What is another unique feature? I mean, most of you would agree with me that we do see a lot of younger patients who have diagnosed at a relatively younger age, because we are a young nation. So the average age of lung cancer in our India is 55 years. For West, it is 65 to 70 years. And that's what we were discussing in the morning as well, when the discussion about screening for Indian population was being discussed. So if we follow the NLST or Nelson criteria, probably we would be missing half of our population. So the same criteria would not work for us. So, but what we observed, and which is really disheartening to see, almost 10 to 12% of our patients which we see in our clinic are diagnosed at very young age, less than 40 years of age. Majority of them are non-smokers, but even if they would have smoked, they probably haven't smoked enough to get lung cancer at such an early disease. So there is something else which is happening. We looked at our the clinic data. It's almost 140 patients who were diagnosed at very young age. But what was striking in this observation, the presence of ALK and ROS1 gene rearrangements, which we see generally in 7 to 10% up if we take the entire lung cancer cohort. So the frequency of these alterations were in the tune of 30 to 40%. And you don't see, I mean, that high ALK frequency in any of the subgroup of non-small cell lung cancer, even if you take just non-smokers alone. So there is something unique. And when we look at more comprehensive profiling of these patients and that compare it with that of late onset, if you see these purple dots represent the structural variants or the gene fusions. And majority of them are ALK, RET, and ROS. So these are uniquely present only in young onset, and I mean, although it's a small number, but it's hypothesis generating that what's happening in these patients, why they do get these gene rearrangements at such an early age. And that's what we are currently looking at in this DBT funded program, where we are looking at the complete whole exome and transcriptome profiling of young onset lung cancer, both somatic and germline, and comparing it with that of late onset. And we hope that probably we will find some unique differences in carcinogenic process and probably would find some unique therapeutic vulnerability for these patients. I mean, we all understand that lung cancer is a disease of smokers. So if you smoke, you would get lung cancer. But one question which is probably one asked to that not every smoker is getting lung cancer, right? And a lot of non-smokers are getting lung cancer. So is there any unique susceptibility why these people get? I mean, we understand that if we talk about hereditary cancer syndrome, we always discuss about breast cancer, ovarian cancer, and prostate cancer that we have been taught about. So we thought, let's see, I mean, how much proportion of our patients who are having lung cancer have some sort of genetic susceptibility. So we looked at this was a prospective study over last around 4 years or so. So we prospectively collected 3-degree family history, 3-generation family history for almost 750 patients. And we found that around 18% patients have significant familial aggregation of various cancers. So when we say significant familial aggregation, there is no such one definition for it. We considered having at least one first-degree relative diagnosed with any cancer, or 2 or more second-degree relatives diagnosed with any cancer. So that's how when you do some sort of genetic analysis, you have to have some rationale to do that. Otherwise, it would create a lot of apprehension in subjects who are undergoing these testing as well. So to our surprise, when we tested almost 100 patients with non-small cell lung cancer with familial aggregation for genetic testing, so 17 out of these 103 had known pathogenic or likely pathogenic germline alterations, which you can qualify into any of the known hereditary cancer syndromes. And when we went ahead and tested their unaffected first-degree relatives, out of 12 healthy individuals who underwent the test, 8 of them having the same pathogenic alterations as the family member was having. And majority of them, I mean, again, we are familiar with BRCA1, BRCA2, and to our surprise, the most common alterations which we find, it's a small number, but the most common genes were ATM, BRCA2, BRCA1, and other DNA repair pathways. So there is certainly, there is a lot of scope. We need to really look at it more prospectively and more comprehensively, that what are the risk factors which predispose us, and it would have implication on our preventive strategy. And who knows, maybe it might open up new therapeutic avenues, like it has opened up in breast cancer, ovarian, and prostate cancer. So the more we do, probably more we learn. So to summarize, I would say that precision oncology in thoracic is the new standard of care, and molecular profiling not only guides the therapy, it would guide our prognosis as well. A unique epidemiology of this disease in India give us an opportunity to delve into the newer risk factors and newer therapeutic opportunities. But access and affordability remains a major challenge in India, and it's our problem to probably, we have to sort it out with more collaborative research and more innovative ideas. So I think this was the past, and the future of thoracic oncology seems quite bright. For oncologists or clinicians, it is becoming overwhelming information when we sit in the clinic and patients walk in with a lot of data and a lot of information. But I do believe that probably in our lifetime we would see a time then when patient would be walking in with a barcode on a microchip, and the job of the clinician would be just to scan that barcode and find out the right treatment for that patient. So here I end, and whatever I have shown, it's not my work, it's the work of the entire team. I mean, some of the people are shown here, and many of them who are not here, and I do acknowledge the generous funding from several organizations like DBT, ICMR, and so on. And thank you very much for this opportunity.
Thank you, Dr. Prabhat, for delivering such an excellent oration. And I would like to request Professor Behra sir to kindly honor Dr. Prabhat. And I would like to invite, because as this oration is supported by Dr. Reddy's, so Dr. Reddy's representative, Mr. Shiva Ramakrishna, to please come forward. The award for oration carries a check of Rs 40,000, a silver plaque, and a certificate. Congratulations, Dr. Prabhat.
Thank you very much. A few announcements. So like as we generally have a short tea break, we'll have a short lunch break, and we will be resuming sessions in about 20 minutes from now. Yeah, and also would like to announce the executive body meeting, which is likely to happen in the Hall B, that's a Senate Hall, and in the same floor now. And I also invite you all for the gala dinner today. And also kindly note that we are rescheduling a few talks and a few panels. So the first talk will be on tailoring surgery, followed by the high-risk panel, and then we would continue the other sessions. So we also invite you for the evening gala dinner today. That's at the tags, where buses will be provided at 7 o'clock from 7 onwards from the venue, and then we will safely drop you back too. Thank you, and let us join back in the hall in 20 minutes. Thank you. Yeah, e-poster sessions. All those who are presenting their e-posters, please make sure that you are available for the judges to evaluate your posters in the Hall C, which is adjacent to the Senate Hall, that is the Hall B. And the judges would come to your e-poster area and evaluate your posters. This will also happen during the lunch area, so you can quickly grab a bite and be there for your e-poster evaluation.
Join us as chairperson. Thank you, sir. I will invite Dr. Narendra sir, chairperson for the session. Dr. Devyani to take over.
Hi, thank you. Good afternoon, everyone, and thank you so much for having me here. I've been allotted a very interesting talk, and this is something that is a field that is very rapidly evolving. and I'm quite excited to present stuff that I read about in preparation for this talk. So it's tailoring surgery for early stage non-small cell lung cancer, current guidelines and future directions. So what's the definition of early stage lung cancer? By definition, it is T1, T2, N0, N1. So the image on the left is what the world calls early stage lung cancer. But in India, we are still calling the image on the right early stage, which is very different from the other image. Why is the world suddenly talking about it? Why has it suddenly become a thing? Because imaging has improved quite a bit in the last few years, and evidence for lung cancer screening has come up in a very big way, with a lot of countries actually adopting lung cancer screening as a part of their national screening programs. So in the Western world, almost 40% of the early lung cancers are screen detected. There is a better understanding of segmental anatomy of the lung, and of course there is better surgery because vision has improved, surgical dexterity has improved. The consumables that we have today are something that we wouldn't even imagine a couple of years back. So this, I would like to present this scan to everyone in the room, everyone who deals with lung cancer on a daily basis. Would you biopsy this? So who would biopsy this? If I could see a show of hands, please. Right, so I don't think there's any right or wrong answer to this question. Both are all right, but giving a biopsy to this kind of a lesion gives us a definite diagnosis. It facilitates appropriate preoperative staging and prognostication. It helps us plan our surgery and explain to the patient better as to what we are going to do with them. And we have a reduced dependence on intra-op frozen section because we already know what we are dealing with and the extent of dissection and lymphadenectomy that we want to do. The next question that begs to be asked in today's world when we talk about early lung cancer is, would we do an upfront NGS? All the evidence that we have for neoadjuvant therapy in the early lung cancer space is the immunotherapy data, which starts for stage 1B onwards, and the neoadora for osimertinib, which starts for stage 2 onwards. So unless your tumor is equal to or more than 3 centimeter, or it is node positive, these are the two indications where you would be in a better place to do an upfront NGS, even in an early lung cancer disease. I don't think there is any question as to how you would want to approach this disease. The guidelines itself mention that minimally invasive is the way to go. So there is no point in debating about it. Whether it is multiportal VATS, uniportal VATS, or robotic, that is according to the surgeon's preference and of course the patient's paying capacity. There is emerging data now that, especially for segmental resection, robotic is favored because it allows for more precise dissection, especially around the veins in the intersegmental plane, and gives better outcomes in terms of post-operative air leak. But other than this, there's little to choose between any minimally invasive approach as to what the surgeon is most competent with. What surgery will we do for this type of a tumor? So the evidence for sublobar resection came in with two very big trials recently. The first of which is the Japanese trial, the JCOG 0802. It is a phase 3 multi-center, so 70 places all across Japan, randomized control trial, where they took peripheral tumors which are less than 2 centimeter and node negative and randomized them into either a lobectomy or a segmentectomy. They managed to accrue more than 1,000 patients, which is a feat in itself for any surgical trial. And segmentectomy was found to be not just non-inferior, but actually superior in terms of 5-year overall survival. However, the frozen section was an absolute must for this approach, where both the primary and the nodes were sent for frozen section. And if the node was positive or a margin was inadequate, it mandated a strict conversion to lobectomy. Like every trial, this trial had its pitfalls. The local recurrence rates were actually double to the tune of 11% in the segmentectomy arm as compared to the lobectomy arm. There was a modest improvement in post-op lung function, which was 3.5%, but it fell far below what was anticipated. Segmentectomy is associated with a steep learning curve, not just in executing the surgery, but also in planning the surgery. Intraoperative frozen section is mandatory if we are to follow this approach. And there was evidence that there is increased post-operative complications, especially air leak. The risk of loco-regional recurrence was much, much higher when the nodules were pure solid or if the margins were inadequate. This brings me to this study, which did not become very popular, but it is very, very interesting. It's a single center retrospective study, but it is a center which was one of the 70 centers involved in the JCOG trial. So during the time that they were accruing for the JCOG trial, they had 3 cohorts of patients. So cohort A were early lung cancers who were accrued to the JCOG. Cohort B were early lung cancers who were amenable to a segment, but not accrued to the trial. And cohort C were early lung cancers which did not stringently meet the criteria for JCOG. So as expected, as you can see, cohort C, lobectomy did better because these patients were not for a segment any which ways. But what's interesting is to see between cohort A and B. So they're exactly the same population of patients. A is under a trial setting, B is in a non-trial setting, and the improvement in overall survival is not so magnificent in cohort B, which shows that unless the surgical rigor is absolutely matched as to what the JCOG did, you are not doing justice to these patients by giving them a segmentectomy. The second trial was the CalGB, Altorquis trial, which added not just segments but also wedges for these peripheral less than 2 centimeter tumor and pitted them against a lobectomy. And surprising results, even a wedge was non-inferior in terms of DFS, OS, irrespective of type, no increase in risk of loco-regional recurrence. And this kind for all thoracic surgeons sounded too good to be true. Like we toil away with our lobectomies and our segments, and here you can just go in with a wedge and get the same results. It seemed quite counterintuitive. And that is what the real world data also showed, because when you see the STS database and see the patients who were offered a wedge for early lung cancer, they actually did worse in terms of survival and local recurrence, and less than 25% patients had nodal sampling. So what happened is that the CalGB trial gave a clean chit to anybody to go in and just wedge the tumor out without performing what is now defined as a high quality wedge. The French registry also showed the same results. Early lung cancer, wedge versus segment versus lobe. Segment and lobe did equally well, wedge did inferior. So in my opinion, wedge is not an inadequate surgery for early lung cancer. Planning the segment needs a good anatomy of the segments of the lung, not just in vivo while performing the surgery, but also when we look at the scan, so that we know which is the segment that we want to excise. A 3D reconstruction is nowadays a prerequisite to perform a good segmentectomy, and even on paper, it is found to show decreased operative time, less number of staplers used during the surgery, and less air leak in the post-operative period. If the nodule traverses the intersegmental plane, we have data today to perform more than one segment. Multiple segments are also the surgery of choice for synchronous second primary lung cancers. And we have more and more data emerging, especially from the Japanese surgeons, to perform segments for lesions even between 2 and 3 centimeters. Which brings us to the question that these nodules are usually part solid or GGOs. How do we actually localize them during our surgery? So 3D recon is the imaging, but intra-op we have preoperatively placed IR or navigation guided wires or fiducials, intraoperative ultrasound, radio-opaque dyes and fluoroscopy. You can have a hybrid OR with an integrated CT machine to go in and perform the segment. And more recently, there is robotic bronchoscopy assisted injection of RFID chips into the nodule, which then you can use a tracer while performing the surgery to have a real-time localization of the tumor, or integrate the scan and your surgical input into an augmented reality device and see it real-time. Which the next question comes is, most of these patients are going to be lymph node negative. What are we going to do about their lymph node dissection? So until 2017, the Mokles meta-analysis clearly stated that it gives better staging, better outcomes with SMLND and not much increase in the morbidity. So go ahead and clear all those lobes. But with lesser and lesser surgery being performed for the parenchyma, the same applies for the nodes, and we have evidence for lobe-specific lymph node dissection, sentinel lymph node dissection as well. There's also data emerging in the immunotherapy era that if we perform an aggressive lymphadenectomy, it may inversely impact survival because it's going to change the immune microenvironment and not allow the immunotherapy to act as well. Interesting times. So what will you tailor your surgery according to? So there are tumor factors and there are patient factors. Like we said, size, location, the character of the tumor, The histology and the nodal status dictate whether you're going to do a segment or a lobe. Everything in green, you go for a segment. Anything in red, you go for a lobe. Multiple primary lesions, you want to save as much parenchyma, you will go in for a segment. More important, we cannot discount the patient factors. So patients more than 70 years, again, the ad hoc analysis of the JCOG showed that this patient population actually benefits from doing a segment. Poor lung function err in the direction of segment. We do not give much importance to the last two, but I think it is the most important fact. If you're doing a segment on a patient, you are actually trusting that patient to come to you for follow-up every year with a scan, because the only way that the patients with segmentectomy had better overall survival in the JCOG trial, despite having double the number of local recurrences, is that their recurrences were picked up in time in a way that you could give curative intent therapy. So unless you have faith that your patient can deliver that kind of diligence in terms of follow-up, segment is not an option for him. Not just the surgery, the follow-up has also become very tailored. You do a sublobar resection, we already discussed an aggressive follow-up is a must. Any high-risk histopathological factors, again, err in the direction of a more aggressive follow-up. High risk for second primary lung cancer, your patient continues to smoke despite surgery, more aggressive follow-up. And AI has come in a big way, which generates prognosis for you, recurrence risks, and tells you how you need to follow your patients up. So early lung cancer and AI, this is an interesting marriage which has come in. And AI is not just for characterizing the lung nodule and predicting the risk of malignancy. It also, if you feed it the info, it will give you the accurate T, N, and M stage. Maybe all our invasive mediastinal staging, the EBUS and the mediastinoscopy are on their way of becoming redundant. It also predicts histology. It can give you the molecular marker status. Maybe in the next few years, you won't have to wait for those 15 days to get your NGS reports. It helps you navigate surgery, not just in nodule localization, segmental planes while you perform your surgery. It gives you accurate prognostication and recurrence risks. So I'd like to conclude saying that, so we had this great discussion on everything that early lung cancer brings to the table. But the reality is, for all of us sitting in this hall here today, this accounts for less than 10 to 20% of the cancers that we are operating. So I think our focus also needs to be on how we pick up early lung cancers. And in today's world, for us, that would be opportunistic screening, which is underutilized. We have to tailor surgery according to the tumor and patient. It has to be an informed and shared decision making. And there is going to be an evolving role of the surgeons and their chemistry with AI, because that is the future and we need to accept it. Thank you, I'm done.
Thank you, Doctor, for such an insightful and thought-provoking discussion. I would like to request our chairpersons to remain seated on the dais. Joining them will be our panelists of the next session, Dr. George Karimundakal, Dr. Priya Ranganathan, Dr. Srinivas Kanumuri, and Dr. Dibakar Sahu. Our moderator, Dr. Sabita Jivnani, will be talking regarding preoperative pulmonary evolution and optimization in high-risk patients.
I have to get my laptop. Good afternoon, everyone. Devyani has actually made our job quite easy. So we are not going to be talking about surgery in detail. This is a panel which is going to focus on high-risk patients and how we evaluate them and optimize them. So we are not going to talk about staging. We are not going to talk about imaging. We are not going to talk about multimodality treatment. Can I start? Yeah. So we have Dr. George, who's a thoracic surgeon, Dr. Priya, she's a thoracic anesthesiologist, Dr. Srinivas and Dr. Dibakar are both pulmonologists. So I already gave my disclaimers, and all these patients that we have discussed are going to have already been discussed in a MDT. Dr. Prashant Penumaru gave me the brief that we have to discuss at least 4 common scenarios of high-risk patients who come to our clinic, and then he went on and said you have to do this in 30 minutes. It's a topic which actually requires more than an hour. So we are going to do it in the form of a rapid-fire round, and I would request all the panelists to be very crisp and concise. So I'll start with George. George, what do you think is a high-risk thoracic patient? Is there any fixed definition?
No. No.
How do you think your patient is high risk? How would you define it?
So I wouldn't go absolutely by numbers. I wouldn't go absolutely by his effort tolerance because the numbers would contradict it. Probably you could use some of the scores, but except for the Thoraco score, I'm not really comfortable with any of the other validated scores.
Yeah.
But I'm not ready to decide high risk based on any one of these factors.
Yes, because since you are the one who's going to get this patient in the high-risk JC, so that's why I started with you. So most of the guidelines say that we have to have a stepwise pathway. Describe your urgency and functional status of the patient and objective assessment. First always comes the cardiac risk, then pulmonary, and then you identify frailty and other comorbidities and you optimize your patient. So 1 in 4 thoracic patients may be high risk, but high risk does not mean inoperability. So we'll quickly move on to the first case. This is a 68-year-old male who had a triple vessel coronary artery disease, underwent bypass surgery 8 years ago, and was planned for a right upper lobectomy. We did the usual workup, 2D echo was normal, the pulmonary functions were okay, and then ECG also was all right. He started complaining of non-specific chest pain since 1 week. And we repeated an ECG, and this did not show any fresh changes. So Priya, George has sent this patient to you. So are you happy inducing this patient tomorrow?
No, definitely not. He will need further evaluation, and I think we would first look at the CT scan to look for coronary calcification, which itself is a risk factor for...
He's already undergone CABG, so picking up calcification in this setting will not be very reliable.
Sure, but I would ask for a dobutamine stress echo and a cardiology opinion in this setting, and also look at some submaximal tests, maybe a 6-minute walk test in this patient.
Why not an angiography? Why would you ask for a stress test?
Yeah, so if you go as per the AHA algorithm for evaluation of patients, not everybody needs an angiography. A patient with a negative stress test at high work.
So definitely some form of stress evaluation before you think of getting this patient on table. I would now come to Dr. Srinivas and our pulmonologist. So what do you think? This patient has 7% reversibility on the FEV1. Do you want to start him on inhalers?
Yeah, definitely.
What is your threshold for starting patients on inhalers?
Because he is going to for surgery, there is a 7% reversibility is there. And definitely we start bronchodilators.
Okay. Dr. Dibakar, do you agree or do you think 7% is okay? We can go ahead.
Yes, definitely. The patient who is a 68-year male, and is there any history of smoking? So
yes, there is history of smoking. So he stopped after his CABG.
Smoker, 68-year male with the timed vital gas FEV1 of 68% without reversibility, then most probably is a case of COPD. So we have to start with that so that their lung function will definitely going to improve. The FEV1 will going to improve. That will also the predicted post-operative FEV1 will going to definitely improve.
So with this 7%, would you think of postponing surgery? Suppose he didn't have the cardiac risk factor.
7% reversibility actually is the reversibility to the bronchodilator. Those patients who are COPD are not very good for reversible. They are not very good reversibility criteria will not going to be that high. But we should start with the bronchodilators like beta-2 agonist and the anticholinergics.
Any contraindication in a cardiac patient for starting the inhalers?
No contraindication.
Okay. Coming back to George. George, what factors would trigger you to delay this surgery?
To me, this patient is not particularly high risk because he's been revascularized just 8 years back, that there is a coronary issue is very unlikely. You could do a stress test. Probably my cardiologist would say he's okay to go ahead without doing anything. That's point number one. 7% reversibility will not delay my surgery. More than 10%, I would give a bronchodilator and check whether it's improved after 10 days. 7% is sort of borderline. I would expect this much. CVD is probably because he's a smoker, I would expect a little bit of COPD. So I wouldn't delay surgery in this patient. It probably doesn't, he's revascularized heart. The chest pain can be probably explained by the lesion itself. And so it's not too high risk for me. I wouldn't delay.
Okay. Coming back to Priya, I'll give you a chance, 1 second. Priya, what do you think are prohibitive cardiac risk factors which would urge you to delay this surgery?
So from the anesthesia point of view, acute LV failure is the only prohibitive risk factor, but we will rely on the cardiologist's assessment as to whether this patient needs revascularization and which should take priority, the revascularization or the surgery.
Right. Dr. Dibakar, you were saying something.
I want to add that this 7% reversibility is not like reversibility to the normal lung function. It is a reversibility criteria which we use for the short-acting bronchodilator, which is reversibility criteria to differentiate between bronchial asthma and COPD. It's not like the patient will reverse directly after a single dose or something, but this is a criteria of the FEV1 criteria.
Are there any guidelines which say what is the cutoff at which you should start, at what point of reversibility? Like George said 10%, you're saying 7%.
It's not like, according to the reversibility, if the patient is having the obstructive airway disease like FEV1 is less than 70% with FEV1, FBC also below 7.7 or 70% of predicted, then you can level it as a case of obstructive airway disease, so inhalers to be given as per the...
Okay. George, you wanted to add something?
Yeah, actually the warning sign is for the surgeon, because I would be concerned if I hit the artery, LAD or the RAD. So actually it's high risk for the surgeon in terms of pure surgery. It's an upper lobectomy if I'm operating in the region of the
graft which has been taken.
The graft is saying. I can't see the sternotomy. This thing there.
Yeah. Okay. We'll move on to the next case. This is a patient who underwent a stenting 3 months ago. So she's 72 years old, diabetic, and she had a MI 3 months ago. She underwent angiography and a stent was placed in August 2025. And she was on multiple drugs, 3 drugs for diabetes, a beta blocker, and dual antiplatelet and a statin. So incidentally, during this workup, she had a small central nodule in the right lower lobe, which was biopsied, and this came out to be adenocarcinoma in situ. Her PFT numbers were okay. So coming back to George. George, do you think at this point, at 3 months after a stent, you think we can plan her for lung surgery?
This is quite a common scenario.
Yes.
Depends on what kind of stent was placed. If it is a bad metal stent, then possibly you can stop one of the antiplatelet drugs, the clopidogrel, and do the surgery. If it's a medicated stent, it's a tough call. But I have operated one patient in which they stopped both the drugs and I could operate. So you'll have to work in close coordination with a cardiologist.
So, but you think at 3 months it's okay?
3 months
I
is okay.
purposely kept this case because there's no scope of neoadjuvant in this.
No.
And SBRT is not well established in situ carcinoma.
Yes.
So the only way forward is surgery now.
So if they had done the imaging prior to placing the stent, I would have requested them to place a bare metal stent, which would allow me to stop one of the antiplatelet drugs and operate this patient within 3 months.
I'll come back to Priya now. Priya, the next 2 questions are for you. You can see there is a host of medication going around. So how do you optimize this? What do you stop? What do you continue?
Yeah, so just to go back a little bit, as George said, if you could have done just a balloon angioplasty, then the patient could have undergone a lung surgery within 14 days. If it was a bare metal stent, then after a month, you're okay to stop the antiplatelets. Now, this becomes a little tricky because if it's a drug-eluting stent, then the recommendation is ideally 1 year of dual antiplatelet or at least 6 months. But what we would do at this stage is stop the clopidogrel, obviously, continue the beta blocker and the statin because beta blocker is indicated in this patient. Manage the dapagliflozin, so stop it at least 72 hours before surgery. The one thing is that the patient needs to understand the risk of stent thrombosis in the perioperative period and it will be better to operate on this patient in a setting which has facilities for emergency coronary revascularization if there is a stent thrombosis.
Can you elaborate why we need to stop the DAPA?
Dapagliflozin has been shown to cause a ketoacidosis in the perioperative period. There's a lot of mechanisms by which it does that, but the current recommendation is unless there is, it's been started for a particular heart failure indication. If it's for the management of diabetes, then you need to stop it for 72 hours before surgery.
Right. So are there any pathways by which we can optimize this patient? And this question is open to all the panelists. Do you want to do a stress evaluation at just 3 months from revascularization?
No, I think 3 months post revascularization with a 45% ejection fraction. If the patient is doing well clinically, a stress evaluation is not indicated.
Great. Yeah. What about Dr. Dibakar and Dr. Srinivas? Anything you all want to add to this case? She has no reversibility, and this is what her PFT looks like. It's a small nodule. She requires only a right, probably a segment.
So we advise some breathing exercises, and I strongly believe in advising yoga pranayama. There are a lot of papers, even short duration of yoga, even 2 weeks of pranayama increase the respiratory parameters. And there are studies in breast cancer. The yoga can increase the wound healing also.
Right.
And it decreases the stress, and it has a role in improving the lung functions.
Right. George, you had a point you were
and
saying.
One more thing.
Yeah.
Any history of smoking is there?
No, she's a non-smoker.
A smoker.
George, you wanted to say something?
So one thing is a stress evaluation, no, but I would at least make the patient walk a bit. A 6-minute walk test would be good enough for me, or a stair climbing test. Secondly, there is data from Serfolio's group where they have operated with dual platelets, antiplatelet drugs, although I have not dared to operate with clopidogrel unless in an emergency. So there is an option of operating with dual platelet antiplatelet drugs as well.
And how would you counsel your patient? What complications are you expecting?
Whether we get to operate this patient also depends on the risk appetite of the surgeon, the entire team, as well as a patient. So I would stress about the possibility of stent blockage, that's one, and the possibility of postoperative bleed in spite. I've had patients with clopidogrel stop for 5 days on aspirin who had significant intramuscular hematoma. So those are the two main complications. The cardiac function-wise, I'm not concerned unless the coronary vessel gets blocked again.
Right. So we'll quickly move on to the next case. These are some scores which I put up here, and preliminarily these were usually used to predict cardiac events after major surgery. So the first one is RRCI, that's a revised cardiac risk index, which was given to us by Lee in 1998. And in that they have clubbed all intrathoracic surgeries in one elevated risk group. So it was not very useful because all the surgery that we do is intrathoracic. So then Brunelli's group went and dissected this out, and they said only pneumonectomy is high risk, and they looked at these 4 factors, and this was a better predictor of cardiac events after thoracic surgery. So this is our third case, a 70-year-old male, hypertensive and diabetic. He's deconditioned, very frail, BMI is just 18. He's a current smoker. He has dyspnea after 1 flight of stairs, so his MET equivalent is less than 4. And ECG, he has a non-specific left bundle branch block, some coronary calcifications. I have not put up the images. The PFT, he could not perform DLCO. 2D echo showed diastolic dysfunction, and he has emphysema in both the upper lobes. So, coming to George, further functional evaluation. Do you think he's a surgical candidate with so much going on?
Unlikely. I would discuss with everyone in my team, but the main worry is the dyspnea after 1 flight of stairs, it's a combined index of his cardiac and pulmonary function, and there he's failing. So I'm a little bit concerned about this patient.
Right. Priya, any functional evaluation you want to advise? You want to take a cardiac opinion?
So definitely a cardiac opinion. I would be interested in knowing, is this patient a candidate for neoadjuvant therapy? Can we buy some time in which we can build his nutrition?
Yeah, it does look like, looking at the size of the tumor, yes.
Exactly. Do some chest and, overall physiotherapy. Also, if he's unable to perform DLCO and there are multiple other issues, he would be a candidate for a CPET, which would give us a better idea of his VO2 max and his anaerobic threshold. My particular concern is because this is an left upper lobe mass, there's going to be quite a bit of cardiac retraction during the procedure. So I would be extremely keen on sorting out the cardiac issues before we went ahead.
Dr. Srinivas and Dr. Dibakar, when we are evaluating the patient's pulmonary risk, we know that the FEV1 is low, he cannot perform DLCO. Now we are looking at some objective parameters. So what would you advise? Straight away a CPET or some low cost test?
So low cost, we can go for a shuttle walk test or 6-minute walk test.
But he is breathless after one flight of stairs. So how do we go about it?
Better go for a CPET. CPET, very difficult also, honestly, for this patient to eat also.
Dr. Dibakar, anything to add?
The pulmonary risk assessment is by CPET or the low technology like a 6-minute walk test gives us the exercise tolerance of the patient. Having said that, CPET is very labor intensive. We have a CPET with a bicycle ergometer in our department and it's very easily said, but it is very difficult to do in a patient. So I think CPET is only for the patients, for the persons who are actually athletics. That very difficult to interpret and routinely we are not doing routinely. But 6-minute walk test can be done easily with the walk distance and the desaturation that can be done. And also as I've seen that the PFT is moderate obstruction is there and there is a smoker and your CT showing emphysematous changes. So it is a definitely case of COPD. So should start the inhalers and you can easily evaluate the patient again for PFT and the DLCO. The definitely DLCO going to be less and then the anesthetist and the surgeon has to take a call whether after 2 months or 3 months they can be taken up for the surgery or not. But definitely the FE1 going to increase if he is taking the inhaler properly.
So I think looking at this picture, doing a CPET at this stage has no meaning because it's obvious that the CPET values are either going to be low and even if they're normal, we are not going to operate on this patient. I think it's wiser to repeat the CPET after a couple of months of optimization. If he's clinically in a much better state, you may not even need the CPET. But if at that time he's still borderline, the CPET could help you to decide one way or the other.
Yeah, I think smoking cessation also should start first. Yeah, George, go on.
I'm a surgeon, but I'm going to say that he's a current smoker, coronary calcification. Too many interventions required in this patient to get him on table, and he's still going to be a high-risk candidate for surgery.
Yes.
I would recommend non-surgical treatment for this patient.
To induce this patient for you, George.
So actually I've picked these cases from our own HRJC and this guy did not come on table. So good call, George, there. I think your thoughts are still aligned with ours. So this is how we do a CPET and it is a combined testing for your cardiac, pulmonary and muscular capacity and the patient is actually monitored throughout and like Dr. Srinivas and Dr. Dibakar said, it is usually suitable for patients who are borderline fit, not somebody who's so unfit who can't even walk up one flight of stairs. So there are various thresholds where you have a VO2 max of less than 10, less than 15 or more than 15 which helps you actually decide the extent of resection. And like George was talking about thoracoscore, I've just put it up here. So it takes into account not only a lot of comorbidities, much more than the RRCI and the thoracic RCI, but it also takes into account the age, the ASA score. So it's a more wholesome kind of score and it is more applicable when you're discussing these patients. So we come to the fourth case and we are doing very well on time. So this is a 67-year-old lady with fibrotic ILD. Her PFTs are not very great, but to add to that, she's also obese. She has a history of tuberculosis in childhood. She has been taking her inhalers off on biopsy adenocarcinoma. So to the two pulmonologists first, is interstitial lung disease an absolute contraindication?
ILD is not an absolute contraindication to surgery, whether you have to see what is the extent of ILD in that patient, and also the DLCO is 48%, so definitely there is a perioperative risk of going the patient to type 1 respiratory failure. And the FBC is also very low, not very low, but 62%, and the patient, and also perioperative steroids. If the patient is already on steroid, the fibrotic ILD usually not been started with the steroid upfront, but if a patient who is having other ground glassing pattern, and what is the fibrotic ILD is, whether it is CTD associated ILD or not, then with the steroid being started, then we have to optimize the steroid, and there is obviously there is a risk, and the patient like BMI is 30, so if the patient having any risk of OSA, like before the PSG, we can have some screening tools like stop bang and modified Berlin, and we can go for the PSG. But itself is a patient, he is not only OSA, not having any obesity hypoventilation syndrome, that is not very high risk of post-operative complications in only a OSA patient. And obviously perfenidone, if it has been started, we can continue, but upfront.
Does it have any role in the acute setting?
No,
like we are
no.
planning this patient for surgery, say next week or a week after that.
Perfenidone is an antifibrotic, so perfenidone and nintedanib is an antifibrotic. It's not having any definitive role in optimizing the patient. It will reduce the decline in the forced vital capacity in those patients.
Right. George, what are your thoughts about this case?
See, this patient is high risk even without the ILD. His DLCO is 48%. She requires a right lower lobectomy. Even without the ILD component, she's going to be a bit of a problem. Especially periop, because her BMI is 30. She's probably got a component of OSA also. That's why the DLCO is this way. I would be a little bit concerned. I will have to talk to my pulmonologist. If they agree that it's a reasonable risk, I would go ahead. The reason I would try at least a segmentectomy is the risk of radiating an ILD patient is also quite significant.
Yes.
So your options of treating this patient with a curative,
yeah, so it will become either surgery or just systemic treatment.
Or systemic therapy.
Yeah, radiation oncologists are scared to touch ILD.
So it's a little bit of a problem. Again, depends on the risk appetite of the whole team. If the pulmonologist is comfortable, we would be ready for treating the OSA in terms of BiPAP and all, which we would need to support the patient for first. But she's going to be a segment, not a lobe, definitely.
Yeah, that's why. Even though she's 3 centimeters, we should try to do something less than a lobe. Priya, anything to add?
Yeah, no, I think screening for OSA is definitely warranted because you need to correct and optimize anything which can help her PFTs do better and her periop do better. So I think that is something which is definitely warranted. Steroids, it would depend. If you're going in minimally invasive, you're not too worried about wound healing, then you should go heavy on the steroids, but then that balance has to be decided by the approach and the...
So what are the intraoperative and postoperative problems that you have with these patients, George, when you operate on somebody with ILD and this kind of DLCO?
Generally, no. I wouldn't intraoperatively, because we routinely operate patients with an FE1 close to a liter absolute value of 40% or less. And there's enough data on surgery for emphysema at a lower level. So intraop, I don't expect any problems related to ventilation or saturation or any other
Adhesions?
No.
Air leak?
No. You would be, the surgeon has to be careful in the choice of staplers. This particular one, I would use a black cartridge on this one. I'm doing a segment, there is no fissure. I got into trouble when I've used a green cartridge. Right. So that's that's a thing which you would look out for. Surgically, air leak is a concern from wherever I cut. So I would encourage use of a lot of staplers, particular black cartridges in this one.
Any options for controlling air leak on table? What all can we use and how do we do it?
I think that's part of my panel tomorrow. You can't.
You can't discuss it here. Okay.
But sharp dissection, follow the fissural planes. This is on the fissure, so I can't make out absolutely.
Yeah,
I think it's on the fissure.
Yeah.
So it's only one parenchymal cut. I would use staplers absolutely. Even for the smallest bit, use a stapler because they just tend to be an air leak from there.
Yeah, Priya, you were saying something. Please go ahead.
No, I think more than intro-op, it's the post-op when they trouble, because that's when the ILD flares up. I think you need to be super careful about fluids in these patients, because any excessive fluid is going to worsen interstitial edema, and that's going to worsen gas exchange.
That's a great point, yes. Be very careful with the fluids.
Yeah. The other thing is the OSA component. So if they have OSA, then you need to restart them on their CPAP as soon as possible in the post-op period. Also, watch and maybe, be extremely liberal with antibiotics in the peri-op period, because you do need to cover them for superadded infections, especially if they've been on steroids. So I think that would be the approach. And of course, aggressive physiotherapy, early mobilization, all of that. But I think it's the first 48 to 72 hours where things tend to worsen.
Dr. Dibakar, you were saying something? Did you want to add anything?
Regarding perphenidone or?
Yes, you were, I thought you raised your hand, that's why I asked you. No?
Rajni has her hand up there.
Yeah, please go ahead. I think two people in the audience. Yes, go ahead, please. Can you grab a mic? Just grab a mic. Sir, you have a mic, you can go ahead till
Yes,
then.
I think regarding ILD, I think everybody knows this, the fibrosis end stage of any disease. And there is no drug yet to reverse the established fibrosis, whether it's pirfenidone or whether it's whatever nintedanib or in steroid. So there is no role of, so it's better to switch over to take care of the allergic component by inhaled corticosteroid rather than giving the oral steroid for ILD. So and we don't recommend steroid nowadays for any ILD. I think we agree on that.
Right. Yes, Rajni, please go ahead.
Steroid with complications, no drug is better than continuing oral steroid and complications. I believe that.
True, sir. Rajni, please go ahead.
Yeah. So I think with this patient as well as with some of the earlier cases, the one part that, we're talking about posting a patient 1 week out. Anywhere else in the world, it would probably take a lot more than 1 week out. If we could even buy 14 days, prehabilitation, and not just chest physiotherapy, strength training and nutrition. I would pump protein and start them on a good regimen with a good cardiopulmonary physiotherapist.
Yeah, I'm coming to that.
That's the part that I think the prehab is going to determine the post-op outcome. Fibrotic ILDs, all ILDs, touching an ILD lung for any kind of resection is always going to come with the possibility of a flare. So be ready for using steroids after, even if you weren't on it before.
And suppose if this patient is on steroids, then how long would you wait before taking up this patient for surgery? Any of you?
I don't think we wait. There are recommendations for steroid sort of cover in the peri-op period if the patient has been on steroids within the last 3 to 6 months. But that's more from the angle of HPA, the HPA axis suppression.
Right.
Yeah. So I think it's a call that you have to take oncologically. If you can't wait, you go ahead.
So this is the largest database that I found on interstitial lung diseases undergoing surgery. Out of 128,000 patients, 1,800 had ILD, and the mortality was 5% versus 1.2%. And ILD was a strong predictor of mortality when we adjusted even for center volume, extent of resection, PFT. And the group that did worse was when the DLCO was less than 40%. So like Rajni pointed out, there are many modifiable factors that we have to look at. Nutrition, other systemic comorbidities, look at the stop bank score for OSA. And this was a systematic review published just last year where they looked at 22 models for risk prediction in thoracic surgery, and none of them could accurately predict the complications. So it all boils down to shared decision making. Please involve your patient, especially if they are high risk, in what their expectations are and what they want. So with that, I'll thank all my panelists for being such a so interactive, and thank you everyone.
Thank you, doctor. Thank you to all the panelists and moderators. I request chairpersons to remain on the dais. Now I welcome Dr. Alagu Ganeshan sir to talk on solitary pulmonary nodules, diagnostic approach and red flags.
Okay, laser. Sir, which one, sir? Your name, sir? Like Ganesh, one second, sir. Hello? Ganesh, okay. HDMI, yeah? No, no. I will give laser. Okay.
Very good afternoon to everyone. First of all, I'd like to thank Prashant and organizing team for giving me this opportunity. Now, since we are in a post-COVID era, we have seen a lot of CT chests being taken up by every general practitioner, and we are seeing more and more number of these solitary pulmonary nodules in our daily practice. So what is a solitary pulmonary nodule? It is an oval or round opacity, not larger than 3 centimeter, well marginated, surrounded by well aerated normal pulmonary parenchyma, and it should not be associated with any lymph nodes, atelectasis or pleural effusion. So solitary pulmonary nodule, normally we have, if we're going into it, less than 3 centimeter we call it as a nodule, anything more than 3 centimeter we call it as a mass, anything else we just label them as linear or sheet-like opacity. Solitary pulmonary nodules, we've got 3 broad types. One is the well opacified solid one, another one we call as a pure ground glass. When do we call a lesion as a pure ground glass? When you're able to see the underlying bronchovascular markings clearly. And sometimes we have a combination of both, which we call as a part solid. Now, among all these things, which is the most dangerous one, if you think, it is the part solid nodules. Because nearly 63% of them can harbor malignancies, right from an in situ carcinoma to an invasive adenocarcinoma. So, whenever you see a solitary pulmonary nodule, if it's a part solid, be more careful. And same way, pure ground glass have a malignancy percentage of around 18, and the solid nodules only compromise 7%. This is one particular reason why we tend to follow this part solid and pure ground glass nodules for a period of minimum 5 years, and for solid nodules, the observation period is up to 2 years. Now, how do you measure these nodules? The measurement is always done in the lung window, and we have to look at the plane in which the maximal dimension is seen. For example, in this shows the maximum dimension. Then you look at the maximum long axis, then take the perpendicular maximum short axis, the average of the both, and we round them to the nearest whole millimeter. Now, when you have a partial solid lesion like this, we have to make 2 separate measurements where you measure the entire opacity and also the measure the maximum component of the solid one. Whenever you have a speculated lesion, we have to exclude the speculation and take only the lesion for measurement. So in a day-to-day practice, whenever you get asked for a CT scan for evaluating pulmonary nodule, please ask for a thin section, something lesser than 1 millimeter, rather than just reformatting a standard CT. And whenever you get a chance, always try to pull out the previous images. As I told you, if you have any lesion, solid pulmonary nodule, which staying stable for 2 years, you consider it to be stable, and for subsolid, you have to follow it for up to 5 years. And while comparing previous scans, any interval change of even more than 2 millimeters is considered to be significant. Now coming to the size, if you see, once the lesion crosses 8 millimeter, the incidence of malignancy starts to increase. So we normally in many studies we have 6 to 8 millimeters is the cutoff sign where the malignancy chances start to increase. And margins, whenever you see any lesion like this, like a corona radiata, has a high probability of it being malignant, whereas a smooth or lobulate margin is more likely to be benign. And whenever you see a lesion which has got the same consistency of the subcutaneous fat, you are most probably dealing with a fat-containing lesion, which is characteristic of hematoma in almost 50% of cases, and sometimes even mets from liposarcoma or RCC can present the same. And whenever you see a calcific solitary pulmonary nodule, when you see a diffuse central or a popcorn or a concentric or laminated calcification, it could be a granuloma. Popcorn calcification is a little characteristic of hematomas, and sometimes even osteosarcoma and chondrosarcoma mets can have the same calcification. Coming to malignancies, almost 10% of lung cancers can present with calcifications, but the calcifications in a malignant mass will be more of an amorphous, punctate, or an eccentric type of calcification. And suppose you see a cavitating solitary pulmonary nodule, what you need mainly look at is the wall thickness. If the wall thickness is somewhere less than 5 millimeters, more likely to be a benign, an infection or a granuloma, and if you have a thick lesion, it is more likely to be malignant. In our population, even such thick walled abscess can be tuberculosis, but that will take based on the history and the number of lesions present. And whenever you see a lucency within the nodule, this is what we call as a classic Yair bronchogram or a pseudocavitation. This is characteristic of adenocarcinoma or lymphoma. So having seen these all various high risk factors, the most commonly clinically used predictive model is called the Brock University model, where you take into factors of age, sex of the patient, family history of lung cancer, emphysema, nodule size, nodule type, the location of the nodule, whether it's upper lung or not, nodule count and speculation. And this is actually meant for non-smoking patients more than age of 35 years. And if you see that the presence of speculation, location of nodule in the upper lung, a partially solid nodule and female sex have higher probability. And based on this, you get a cancer probability score, and anything less than 5% is low probability, more than 65 is considered to be high probability, and anything in between is intermediate probability. So you see a solid nodule, how do you follow it up? Suppose you see a single lesion less than 6 millimeter, or even multiple lesions for that, low risk, you need not follow the patient at all. Whereas a little high risk patient, you can have an optional CT at the end of 1 year. In intermediate 6 to 8, low risk patients, you just examine, take a follow-up CT at 6 to 12 months, and then repeat a CT at the end of 1.5 to 2 years. High risk cases, you reduce the short duration first CT at around 3 to 6 months, and then consider a repeat CT at around 1.5 to 2 years. Anything more than 8 millimeter, then we have to consider a repeat CT at 3 months initially. Still there is suspicion, you go ahead to the PET or a biopsy. At high risk cases, again you follow them up to 2 years. So basic thing is solid nodules, you have to follow them up to a minimum of 2 years. Subsolid nodules, less than 6 millimeter, a ground glass alone, no follow-up is indicated even for a partial solid one. Whereas more than 6 millimeter, you first take a CT around 6 to 12 months in case of ground glass, and then if it's persisting, you follow them up to 5 years. This is biennially in the case of pure ground glass. If it's a part solid, you make the first CT at around 3 to 6 months, and then an annual CT for up to 5 years. So take home message is always follow up ground glass and part solid nodules for up to a minimum of 5 years. Then coming to when you follow up solid nodules, how do you calculate the volume doubling time? So if the diameter of the lesion increases by around 26%, that itself the tumor doubles. This is based upon the volume of a sphere 4/3 pi r cube. So like you see in this particular lesion, when the lesion is less than 6 millimeter, the volume is around less than 100 millimeter cube. But when it just jumps to around 8 millimeter, the volume almost doubles. It's more than double. So if the diameter of the lesion increases by even 25%, the volume is doubling. That's how you look at the volume doubling time. If it is ideal malignant nodule, will have a doubling time between 200 to 400 days. Anything lesser than 20 days is infection, and more than 400 days is benign. And if the solid nodule stays stable for 2 years, you can just ignore it. And the subsolid nodule, when you keep on following up, these are the following red flags where you can have an increase in the size of the pure glass component alone, or there can be new appearance of a solid lesion inside the GGO. You can have an increase in the GGO, the solid component, or the GGO component. In all these cases, it pushes towards an increased suspicion of malignancy. And for any particular case, you have to take a contrast CT. And if you see that the nodule is enhancing by more than 20 Hounsfield units, that means you are probably dealing with a malignant nodule. So whenever you have a contrast CT, you just look at this. But this is also particular to this particular subset where the nodule should be homogeneous. There should not be any necrosis, fat or calcification. Otherwise, you may get false positives. And if you are doing PET for any particular reason, and if you see the PET SUV uptake more than 2.5, it is more probably malignant. And this is especially recommended for a subset of patients where the solid nodules is more than 1 centimeter. And same way, if the solid component, a part solid nodule is also more than 1 centimeter, you can go for PET. Less than that, PET is generally not recommended. And there are many theories where they talk about MRI evaluation, but for all practical purposes, none of us do MRI because of the artifacts involved. So just to summarize small things like, if you take a classic solitary pulmonary nodule, which is very most evident in this is just a simple carcinoid. You see some small speculations in this, and this is an adenocarcinoma. Here you have a part solid nodule, and this is a case of an adenocarcinoma lipidic subtype. And here you have a classic ground glass where you can see the underlying bronchoscopal markings, and this is an adenocarcinoma in situ. And very rarely, many times you'll be seeing this type of lesions. These are called pleurophissural nodules. They'll be like more of triangular or linear things along the fissure lines, and these are always almost benign because of their intrapulmonary nodes. With this, I'd like to conclude my talk. Thank you. Any questions on this? Thank you.
Thank you, Doctor. That was a thought-provoking session. I would like to request the chairpersons remain on the dais. Joining them will be our expert panelists, Dr. Durgatosh Pandey, Dr. Kader Hussain, Dr. J.K. Saini, Dr. Sweeti Gupta, and Dr. Rupesh D. I now call upon our moderator, Dr. Sunil Kumar, to give his talk on early lung cancer, shifting paradigms in diagnosis and management.
Thank you very much. It's wonderful to be here in the land of the God. And so we have in the panel 2 surgeons. Yes, maybe, okay, fine. So because, and 1 pulmonologist, 2 radiation oncologists. Huh? Radiologist, 1 radiologist and 1 radiation oncologist. You will cover for medical oncology also, I believe? Or anyone can chip in. Why I'm saying that? Simply because ever since in morning we have gone through a lot about the early lung cancer particularly. And after Devyani's talk, now it's more or less clear that what we see and what we perceive in terms of the management, that is also will be quite variable, and you will be seeing that there as well. I'm sure there are no disclosures from any of the panelists. I apologize if some of the names have been substituted because that was in the last moment. Dr. Saini has substituted for the pulmonary part. Now, how much is the early cancer prevalent in our country? And this is the data from National Cancer Registry. I had an opportunity to analyze that data. Almost a data of more than 45,000 patients. And this is what we have. I'm starting with this slide, and if time permits, I would like to end with this slide again. So you have localized patients which are around 15% or so, almost equal in males and females. So this is the one group which we are talking about. But mind you, this is a hospital registry data, and it has a lot of heterogeneity in that, but then given the volume, we have to buy that. Now, straightaway I'll start with each one of you. What do you think is the early lung cancer in your opinion? There are multiple points listed here, and it may be that your opinion might be variable, what is being listed here, but at the same time, for the audience, what you will consider as so-called early lung cancer. Start with maybe Dr. Durgatosh at one end. and more importantly, I will request to keep in mind whatever literature we are getting, particularly the recent literature, in terms of labeled as early and also / resectable lung cancer.
So early lung cancer, if we go by definition, it will be node negative or N1 disease, and it would be T1, T2. This would be by definition. Now, if you want to extend it, the cancers that are amenable to upfront therapy without having a multivisceral resection, multi-organ or multi-structural resections would come in the purview of early lung cancer.
Okay,
that would be my point.
Let me put it in this way. So the traditional thought is that anything which is resectable in a traditional way is early lung cancer. Do you agree or not?
I don't agree, because even N2 disease would be a resectable thing after neoadjuvant therapy. To my mind, that is not an early lung cancer. If you go by just a definition, as I said, T1, T2, N0, N1, you can include some of the T3s in which you don't need to resect the chest wall. For discussion point of view, from the management point of view, but if you want to go to a definition wise, it is T1, T2, N0, N1.
Majority of the literature which is coming now, they have included quite a spectrum of the disease, but still that is being labeled as early lung cancer. Any variance of opinion? Or do you agree with what Dr. Durga
No, sir. Stage 1 and 2, non-N2, yes. Stage 3A is a heterogeneous group which includes N0 to N2. So should not be considered as early lung cancer, but now as the AJCC 9th edition has added N2A, N2B, so single station N2.
That's what I was coming to. So what about stage 1 and 2 being labeled as early lung cancer? Agreed or not?
Stage 1 and 2, yes.
If you say that, I imply that you are talking about 8th edition.
Yes, sir.
Right? But when we move further, and this is what we have now. The N2, which was there in 8th edition, now it has been split, and now it's part of the 2B as well. So by definition, it is part of the stage 2. Why it is being so? Here, this is what we have. So this is about the stage 2 and 3A. When we apply the same principles of 8th edition to the proposed 9th edition, and when you apply the 9th proposal to 9th edition, the data collected for that, both are tending to be same. And this was the basis why the single station, now there are 2 categories for N2, and single station has been brought in the domain of stage 2. So that changes the game for essentially, to some extent, surgical aspect, also for the decision making regarding the multidisciplinary. Just for the audience, almost entire of the Japan, the N2 so-called even earlier also, single station particularly, all of them will be going upfront surgery. And entire data from ISLC, what has been as surgical data for N2 actually exclusively has come from Japan. But, and yes, this was the proposal paper initially, but the same paper also says that treatment of T1 N2, that is the new category 2B, as per the 9th one, should not change from what the clinical guidelines recommend for stage T3A cancers, stage for which we have recommendation based on the trials. But this paradigm is going to change in the coming years, and this has been debated a lot in the current edition meeting. I happen to be the member of the ISLC staging committee as well, and for the 10th one, this is likely to change again. So for all the part of the discussion, essentially that goes to the 8th edition, because that's what the data we have. Now quickly from the pulmonary, also from the surgical side, that we have more or less gone through that what is the bare minimum required. CT, PET CT, and MRI may be beyond T1 or so. Particularly for PET CT, I'll go to the radiology side. What is there that you will be labeling as suspicious / probably involved, both from T point of view and N point of view? What all factors do you take into account before you label it?
In PET CT, sir?
Yes. CT, almost everyone we have heard a lot, so probably we don't need to discuss too much. But my point is my question is very pointed. For labeling a T suspicious and labeling a N suspicious, what factors do you take into account?
SUVs are mainly. More the SUV, it will be...
Anything else?
And we have to see the contrast elements also in PET CT.
Okay. So now let me shift the focus on N staging part. When do you label a node as suspicious? Because that brings a totally different, set of investigation to be followed, although there are riders for that. Why I'm saying that in the morning discussion also, we have to play around with our resources in a very, very judicious way. And theoretical part is fine, but then what is practical and pragmatic, that also have to be kept in mind. Regarding the N part.
Morphologically, the node should be round.
Okay, let me put it in this way. SUV of T is 12 and the single mediastinal node of SUV of 2.5 or 2.8 versus same node of 6.5 or 6.7.
6.5, 6.7 will be mostly metastatic 7 compared to 2 to 2.5 SUV.
So, but both of them will be labeled as N plus.
Yes, sir, both of them. In a case of, proven case of...
Is there any factor of taking the ratio or comparing that with a primary when you would decide about the nodal involvement?
So there will be a benefit by comparing the primary.
Okay.
But if it is a proven case, even the micrometastasis will have a very low SUV.
And that's the reason why I brought the point of being a pragmatic. And many a times we do not have this facility and you have to go by the primary stage. Any difference of opinion?
So a small node which has a SUV
less than 1 centimeter
of more than 50% of that of the primary should be considered suspicious. A node which has a short axis more than 1 centimeter or 12 millimeters, regardless of the SUV, needs to be evaluated. But if it is smaller node, if you see the primary, if you see the node, more than half of the primary SUV
I completely agree with you. Unfortunately, none of our nuclear medicine colleagues, they subscribe to this idea. They are very clear that This
is a decision which has to be made by the clinicians.
Perfectly fine. But then, as per all the guidelines also, essentially we are forced to do invasive mediastinal staging in such kind of scenario. What about biopsy? We heard a lot.
So I would do a biopsy if it can be done in all such cases. I would personally do a biopsy, although I understand that in certain very small peripheral tumors, you can straight away go for...
Should or must?
I would personally do it, but I accept people who would not do it, do a wedge for a peripheral small tumors. I would accept that.
Dr.
Biopsy is a must.
Dr. Hussain.
When the clinical suspicion is very high for lung cancer, especially less than or equal to 3 centimeters, and the PET-wise there are no nodes at all, I will not do a biopsy because when I think that the clinical suspicion of lung cancer is very high.
I recall a couple of cases in the morning where it was insisted that it should be done.
Yeah.
Yes, maybe agreed, but this is what is the, data from the Violet trial. 40% of the patients in this trial actually went without biopsy or intraoperative biopsy. Even after that, 96 patients remained without biopsy. Okay, so maybe I'd like to skip this question because it has been either discussed earlier and one more talk is going to be covering for this one, so I won't be going into that. What about invasive mediastinal staging? So I have listed already, so what are the points where we definitely will like to go? Do you want to bring the bar lower or higher? Surgeons, both this. Again, must versus should.
Invasive mediastinal staging is a topic which is, the relevance of which is slowly receding. Mediastinoscopy has already receded. The things which you have mentioned here are classical indications of doing EBUS and invasive mediastinal staging. But as I said, if you go by a pragmatic view, as we all suggest, and it is my own opinion, and I have voiced this opinion previously also, the PET-CT has a very good sensitivity but a very bad specificity. So if you have a lymph node which is suspicious on a PET, and you have a tumor which is more than 4 centimeters in size, the patient would require a systemic therapy whether before or after. Such patients, even if they go before, I mean, they have neoadjuvant chemotherapy and they then get operated, it doesn't harm them. Nowhere in the world and very few organs, when two therapies
Dr. Hussain,
are required, sequencing of therapy has made any difference. So in that sense, this can be avoided. But if you have to talk in a group, in an educated audience, yes, these are the patients in whom you should do invasive mediastinal staging.
So once you finish your staging and after doing your EBUS and still the nodes are negative.
No, when do you do EBUS?
That's what I'm saying. When do you do EBUS?
Yeah, after all, EBUS is also invasive mediastinal staging.
So when we have a suspicious lymph nodes on the imaging whites, especially when it is more than 3 centimeter, definitely we do.
I have already listed.
Yes.
So apart from these, any other criteria where you like to lower the bar?
No, sir.
So for EBUS?
Yeah. Where you really want to figure out that where is that hidden N2? After all, that is the purpose.
Which will change the management strategy to go for a neoadjuvant treatment or surgery first.
Okay. So as long as it's surgically resectable, you won't insist for that.
Yes.
Am I correct?
Yes, sir.
Okay. This was the paper, almost 1,100 patients, and they analyzed the probability of getting mediastinal node involved. So their opinion is that anything above T1 actually qualifies for that. But we have to keep in mind that this is in context of the Western population where the possibility of anything which is signing is much less likely to be inflammatory or for that matter compared to our country. So that has to be kept in mind when you interpret this paper. Yes, sir. Please. If you are really brief, then please go ahead. Okay. Now, coming to the same question again, what is the relevance of mediastinal scope today? Which all patients, Dr. Hussain, you may start, you will be doing, or are you, how many of you will be as of today?
I don't perform mediastinal as
Anyone? So which all cases mediastinal after EBUS?
No, I would not do. If the EBUS, if EBUS says that single station node is positive, I'll accept that.
More important is negative.
If the EBUS is negative, I would not insist on a mediastinoscopy. The decision is made.
Yeah, that's what he is saying. Please.
So there are, yes.
If EBUS is negative,
yeah,
we need to do if we think that there is a N1 node in the PET-CT scan and the EBUS is negative, still we need to evaluate with the mediastinoscopy and confirm it what is that.
I agree with you that that's what is the guideline, but then that brings the question that what is the value of missing an occult N2? How much price we are paying by?
So there is a very good paper by, it's an old paper of Serfolio, which looked at the occult N2 disease. The patients are not harmed. If you have a PET, in that case, in that paper, none of the patient had got an invasive mediastinal staging.
Now
the mediastinal staging was only based on PET. They found occult N2 disease in up to 15% of patients. They did not do worse.
So I'll go to pulmonologist now. Now, in general, what do you say that if we talk about anyone, any center or so, overall to the country wise, how much it is reliable to assure that, okay, you don't need to do mediastinoscopy? I can quote the Western data, that's fine, but let's talk about realistic
In PET positive and EBUS negative lymph nodes.
Yes. So if EBUS is saying negative, how much credence it should be given that, okay, we don't need to do anything further.
Okay, but as per...
Because all the guidelines are still saying, and I agree with Dr. Hussain, that yes, as per the guidelines, that if EBUS is negative and PET is positive, that has to be, mediastinopy should be done.
we go as per guidelines only, sir, in our institute.
So what is adequate EBUS, in your opinion?
In detecting the occult N2 disease, sir.
Yeah. So how many passes? Can you tell us the protocol?
Ideally, 3 passes should be taken from each lymph node.
So if there is a reliable center, reliable person, the protocol has been followed, then probably negative should be taken as negative. Okay, now let's come to the management side. I mean, I don't need to intend putting this as a case scenario or so, but just this is only for representative purpose, and this is one of our patient only. Now, Devani's talk was very much about very early cases, T1A and B, and that was essentially sorted out that wedge versus segmentectomy with their own riders are there. I like to go the extent of the nodal dissection. What about the mediastinal side? Surgeons, MLND versus quick one line, what is the take?
So far, our practice has been a systematic mediastinal lymph node dissection, but we now understand that lobe-specific lymph node dissection may have its value in the with the emerging role of immunotherapy.
What about sampling?
No.
The trial which was done, SEOG trial, and that is again kind of equivocal, that yes, both are essentially equivalent, but still the author suggested that mediastinal dissection is preferred. But how much is the value of that? That is still kind of a matter of debate. Any difference of opinion? No? So agree that preferably mediastinal systematic lymph node dissection should be done. If you are okay, I mean, so you can go for lobe specific, but the rider goes that it should be early disease relatively, not the locally advanced or so. Okay, so I have listed a number of them. All of these trials, essentially they include patient both 2 and 3A. Some of them stage 1 also, 1B also. All of them immunotherapy plus chemotherapy followed by surgery, followed by adjuvant, plus minus adjuvant. Given now the staging system is changing, what do you think? All stage 2 patients should be taken up with this protocol? Radiation. You will have to substitute for the medical oncology also.
Sir, I think we should continue with this care only, the immunotherapy, even though the staging is in, and then see the response later on.
There is so much of data that chemo-immuno is the norm now.
Yes, sir.
So what is the role of upfront surgery given this much of evidence? Surgeon side. Stage 2. 3A I can understand. Let's talk about 2.
I think still we have a lack of data comparing between the neoadjuvant chemoimmunotherapy versus surgery first. I think I agree with the chemo and immuno first, and then down stages, then go for a surgery as far as the biology is concerned.
So only data, the survival data which came from the Pembro group, and that insisted that even in stage 2 also, the advantage is there.
Yes.
Being a surgeon, I'm self trying to play that, yes, but then that part is still a debate, and that is not clear that whether all patients with stage 2 should be given chemoimmuno or no. What about?
I don't think it has percolated into practice so far. There are several riders to it, this perioperative Pembro. If you consider the entire group subset from stage 2 to 3A, the whole subset really does have a difference.
Even in Nivo group, actually, it's faring slightly better.
Yes.
Rather not significant, but yes.
So that's the reason why a non-significant improvement does not translate into practice. And this stage 2, all stage 2 should undergo this perioperative pembrolizumab. I don't think it has percolated into practice, and I am not practicing
Actually, the consensus guideline from ISLC, now it's coming up that yes, it should be given a thought.
Given a thought, but
yes,
how many people are practicing? That's the question.
So once the staging system has changed, it very likely that it will become a norm. Particularly when you, now, if you talk about 3A, that is fine. But stage 2, again, there will be scenario where you have to choose between N2A and N2B. Probably that is going to, make a decision making that yes, all N2/even N2A.
If stage 2 includes N2A,
yeah.
I agree with that group. But there
Now
are
it has
several,
included.
no,
Now it
there
has
are,
been included.
there are several stage 2 without N2A.
Yeah.
Right. So I do not agree with that group. Non-N2A stage 2 need not have a perioperative pembro. Stage 2 N2A should have a perioperative immunotherapy or at least a chemotherapy.
So all of them have essentially included resectable lung cancer, and that includes previous stage N2 as well, which includes multi-station. So that is coming in the domain of surgery, but then at the same time, we also should be prepared that yes, stage 2 patients, there will be a vast majority who will be going here onwards for neoadjuvant chemoimmunotherapy or so. And the choosing point will be essentially either single versus multi-station N2. If it's a single station N2, you may go ahead with surgery. If it's just by virtue of being N2, probably that will tilt the balance towards chemoimmuno, although that has been brought in the domain of stage 2. Problems associated with then chemoimmunosurgery, surgery after chemoimmuno. That if you take this approach, this is the data that cancel surgery almost 20%, pneumonectomy almost 15 to 17%, because there are multiple problems of fibrosis, some progression, so multiple factors are there which makes the surgery difficult. And how will you prefer the surgical approach for these patients? Upfront, very clear, that was also discussed. What about the post-chemo immuno setting? Still you would like to try with MIS or it should be open? Surgeon side.
Post-chemo does not make a difference.
No, post-chemo immuno.
Post-immuno, yes.
Because post-chemo is out of question now, because whatever data we have, that is
post-immuno will make a difference, especially if you had a lymph node in a strategic area. If you had a lymph node near the pulmonary vessels.
I'm not trying to say that this is what you get routine, but yes, be prepared, and this is very, very frequent. We are also at the institute not very too old about post-chemo immuno. We just crossed, I think, 25 or so. But then, yes, this is very, very common scenario. Fibrotic kind of field. Nodal yield is also not very good, very optimal, because planes are not very good. More important is the timing of surgery. What do you prefer regarding the timing of the surgery, when it should be attempted? Post-chemo immuno. Because these patients we are going to face more and more in future.
4 to 6 weeks is the we follow.
4 to 6 weeks.
We follow.
Majority of the trials, they have actually, yes, taken within 4 weeks or so. This was the MD Anderson data, that how these patients were tackled. Double immunotherapy, and 73% of them actually underwent open surgery. So like I said, significant fibrosis, difficult nodal dissection, extent of MIS will be much less, and nodal yield is going to be lower. So this is the timing for this. Adjuvant, quick take. Although we do have one talk about that, but then yes, I'm talking in terms of the early lung cancer.
So regarding adjuvant chemotherapy, stage 1A, we can give for observation in the adjuvant setting. 1B onwards, adjuvant chemotherapy.
Essentially, you mean more than 4 centimeter?
1B is more than 2 centimeter, more than 1 to 2 centimeter. 1B. Stage 1B.
T2 onwards?
T2 onwards.
No, you will include T1A and B. You will not
sir,
be giving.
Sir, T1A not, T1B onwards.
T1B onwards.
Onwards.
Okay, you are lowering the bar further, although majority of the data is for 3 centimeter or more.
Okay. And radiation, no.
So I say 4 centimeter? Some of them have 3 centimeter. So, yeah.
So radiation, no. Only in the setting of margin positivity, radiation has to be added. Otherwise,
Okay.
no.
Okay. Chemo, immuno. If you have given immuno before that.
So then if it is in a perioperative, in the adjuvant setting, you will be continuing with the immunotherapy
Okay.
part.
Okay. What about the patients achieving PCR?
So regarding the immunotherapy part,
Yes.
that part I'm not very
So
sure.
this
If
is
somebody
the.
can-
Okay. 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 Fine. So adjuvant I am skipping then, for all practical purpose. Now, this is what essentially the recommendation from the ISLC, that regarding the question of neoadjuvant versus adjuvant, why this discussion was there, it says that we do not have data from any phase 3 trials directly comparing neoadjuvant to perioperative. More so, it also says in near future we are not going to have that. How many of the audience who are sitting here do you think that conducting a neoadjuvant versus adjuvant trial, chemoimmuno I am talking about, is feasible in this country? None? I can understand that, yeah. So this answer is not going to come from us anyway. Radiation you have already talked about. So maybe I'd like to conclude now. So now this is a rapidly changing entity. What was there 2-3 years back is no more the same. Perioperative biopsy will be preferred, preoperative, but then there are certain scenarios where you can go ahead if, directly also. Invasive mediastinal staging should be revisited, and we have to take the call based on how the suspicion of the nodal involvement is there. Neoadjuvant versus adjuvant for resectable cancer, there is no clear answer yet, but that has to be sorted out. And surgery after neoadjuvant chemotherapy again will be very challenging. Like I said, I will be ending with the same paper, and this is the reality after analyzing almost 45,000 patients. Localized only, this was the treatment pattern. Only 5% of the patient, or at the most 7% of the patients, could undergo any surgical treatment wherever the tumor was early stage or localized. That's the reality of our country. Thank you very much.
Thank you to all the panelists and moderators. Now I will there will be a photo session. Now I would like to call upon.
I kindly request the chairpersons and the previous panel members to join for a group photograph, please. Dr. Sunil, Dr. Durgatosh, please, right now for the, yeah. Dr. Sweetie, Dr. Rupesh, Dr. Kader.
We thank the chairpersons and all the panel members and the moderator for a beautiful session. Now we invite our next moderator for the session on perioperative systemic therapy in lung cancer, Dr. Vamshi Krishna sir. We invite all the panel members, Dr. Kiran Kumar, Dr. Bhargavi, Dr. Nishita Shetty, Dr. Abhishek Raghavan, Dr. Shilpa K.
So good afternoon, everyone, and thanks to Dr. Sandhya and Dr. Prashant for having me here. I have been asked to talk on neoadjuvant and adjuvant, that is basically perioperative therapy in NSCLC. A couple of caveats. First of all the patient, we will discuss only the trial and the study. And for the purpose of discussion, all patients can afford everything. So let's not start by saying patients if they can afford. Let's assume they can afford. Because the topic is going to be basically on chemoimmunotherapy. My previous speaker laid the grounds very well for how we are going to discuss this. He talked about all the chemoimmuno, so we'll discuss all that in detail. I have to apologize to my panelists because I was not able to send them the slides in time. I kind of finished them late, so sorry for that. So we will look at essentially this group of patients, starting from 2A to 3A, and some of 1B, not everybody, some of them if they were included or not. So that's essentially the group of patients who now qualify for a perioperative systemic therapy. So let me just start off directly from that end. Dr. Shilpa, who are the patients whom you would send for a neoadjuvant or a perioperative therapy?
Sir, as you have mentioned, patients with high risk stage 1B, 2A, okay. 2B, 3A, 3B, up to T3 and 2.
T3 and 2. So somewhat like a single station of few nodes in the N2.
Yes, sir.
All right, perfect. Dr. Bhargavi, same for you?
Yeah, the tumor should be resectable.
Okay, tumor should be resectable upfront.
And the node positive. And should not have the actionable driver mutations because we are planning for the immunochemotherapy.
Perfect. So non-driver mutant, operable, preferably node positive. So if it is node negative but larger in size, you know, that 2A, 3.
Even size also matters, more than 4 centimeters.
More than 4 centimeters. Excellent. Dr. Raghav, anything to add or you're fine with this definition?
Yes, sir, that's all, sir. Yeah.
Perfect. So we will just take a quick second to stage. So Dr. Prasad, your thought on how do you stage these patients? I mean, we saw the previous session, so not much in detail.
PET CT, this is what we do. And invasive mediation staging, only if the indications which I discussed in the previous.
Okay, only if in doubtful status and a PET MRI brain. I think that's what we would all be doing. Very good. Dr. Nishita, biomarkers. Patient has come to you with a biopsy saying it's a malignancy, NSCLC. What biomarkers would you do?
So if I'm planning for perioperative therapy, I would at least, now we ask NGS for all because it's easily available, but at least basic would be EGFR, AL-cross and RET maybe.
EGFR, AL-cross?
EGFR, AL-cross definitely, and without RET.
MET? RET. Okay, so RET, why RET? I mean, if I can ask you, because of the Libretto 30?
In context of perioperative systemic therapy, I mentioned.
So none of the trials have excluded a RET. They have excluded
there
only...
There is some data for RET positive.
From the Libretto 431, which said it did not work, and that's why you have the Libretto 432 going on now. So from that angle. Okay, fine, okay. I mean, normally usually we would avoid EGFR, ALK definitely. The others, we don't know if immuno will work or not, so it's still an evolving field. That's how I would put it. Excellent. Dr. Shilpa, any role for pre-op chemotherapy? You know, this is something that your surgeon might say, okay, immuno cannot be given for any logistical reason. Would you want to give pre-op chemo alone?
This actually, we need a multidisciplinary approach, sir. And
operable tumors. Surgeon can operate. No. Would you still offer any patient pre-op chemo?
Pre-op chemo, yes, there is enough data, but the data is more if there is an immuno is added.
Okay,
and
fine.
Given a chance, if immuno patient is not fit and upfront operable and the surgeon is confident, probably we can go for upfront surgery followed by an adjuvant.
Okay. No, the reason why I brought this about is there is a meta-analysis of actually IPD data. So, you know, that showed the benefit of pre-op chemo was there as compared to no pre-op, but the benefit was around 3 to 4%. This is an old paper. So by and large, what everyone felt is anyway the adjuvant gives you the same 5% benefit. So no point in giving pre-op, you might as well give it adjuvant. So that's how the thing has evolved. So just to put it out there. Perfect. Now, why we are discussing this is the very nice thing which came about in, one of the things, so this is how they described it. They called the neoadjuvant chemo as the starter, they called the perioperative as a sandwich, and they called the adjuvant as a dessert. So, this is a nice way of portraying what we are doing. Right. So, let me start from this end again. Dr. Bhargavi, adjuvant immuno versus a neoadjuvant or perioperative approach. My previous speaker did allude to it. So, what's your thought on this?
I would prefer neoadjuvant only.
Okay. Any reason, or what is the
because
data
the
for it?
Because the tumor is still intact, so there is more antigenic load in the, so it will be work better. And what are the prime T lymphocytes that will be useful in the adjuvant setting also.
Okay. Dr. Prasad, you agree with this? It's a hypothesis, by the way.
Kiran sir. Name is Kiran.
Huh? Sorry, my mistake. I have been calling you the wrong name. My mistake.
No,
Kiran. Yes, Kiran.
So the thing is, adjuvant, there are few trials are done. Adjuvant is not extremely positive. It depends on PD-L1 expression. Pembro, it worked irrespective. So the data
Pembro was negative for 1 to 49, positive for more than 50, and positive for less than 1.
Less than 1.
So it was all over the place, essentially.
All over the place. But the neoadjuvant, all the checkpoint inhibitors are working well.
Working well. Okay, we will ask what you mean by working well later. Yes. Right. Okay. Dr. Raghav, your thought on this? So, adjuvant IO versus neoadjuvant perioperative. Your thoughts on that?
I would go with that perioperative approach, sir, because of the amount of data which we have. Neoadjuvant, only we have this nivolumab checkmate 816. That is the only neoadjuvant trial which shown overall survival benefit. But with the perioperative approach, now with that keynote 671, we have a good amount of data showing better PCR rates with event-free survival benefits also. So I would prefer to go with the perioperative approach.
Okay. Dr. Shilpa, your thoughts on this? Would you agree with, first of all, Dr. Bhargavi's point? Because that is the theory, that you have a tumor there, so your T lymphocytes will actually work. You subscribe to that view, or you agree with that?
Yes, sir, I agree with that. Okay. And apart from that, the survival, the very good surrogate marker nowadays for the survival in lung cancer is the PAT-CR.
Why do you say that? Can I ask you why you say that? Because this is proven in breast cancer. It is generally not really proven anywhere else. Do you have data to suggest that if you get a PAT-CR, you're going to be having an overall survival advantage?
Yeah, it is there, sir.
I'm not aware of it because there's no clear data on this. That's the reason why I asked.
Even the durvalumab data, if you see, the patients who have achieved PAT-CR, they had a significant survival benefit when compared to those who have not achieved PAT-CR. So when this entity of PAT-CR becoming as a surrogate marker for this thing, I think probably neoadjuvant or perioperative has to be given, even though the patient is operable.
Okay, we will discuss that later because the previous panel, many of the panelists were a little skeptical of the benefit of doing a PAT-CR because that's what many said that we really don't know. And as rightly pointed out, there's not many trials which have actually looked at a perioperative versus surgery directly upfront. So that's what.
PAT-CR, we cannot say as of yet that it is surrogate for overall survival. I think one analysis was done which showed the correlation coefficient is around 0.5. It's not very well.
That's exactly what I was trying to give. Dr. Nishita, your thought on this, adjuvant versus neoadjuvant perioperative?
So coming to the PAT-CR, there are no direct studies which have been powered to see that, but indirectly they've extrapolated the evidence.
I think PAT-CR is going into the DNA of all medical oncologists. You say PAT-CR and all medical oncologists get very happy.
But so many of them have at least taken a major pathological response. Yeah.
Fair enough, which is completely an arbitrary 10% major pathological response. I don't know where 10% came from. If my pathologist says 5%, I can believe that as well, right? We don't know where the 10% has come from. Anyway, the reason why
one more thing is I agree with all, but only one thing is I would definitely inform my patient that there is a significant chance of him not becoming fit for surgery later on.
We will discuss that. We will discuss that as well.
The other important is the micrometastasis being cleared with
the theoretical micrometastasis which we have been chasing for last 50 years. Correct. Agreed. So this is a meta-analysis. Actually, there are several. I have just highlighted 2 of them which actually try to compare. Again, this compared the perioperative or neoadjuvant versus chemotherapy alone as an adjuvant, and what they found is if you give either a NIC or PIC stands for neoadjuvant and perioperative, AIC stands for adjuvant immunotherapy. All the 3 have shown PFS advantage, but OS was seen only when you used a neoadjuvant or a perioperative, not with the adjuvant immuno, with all caveats. So generally this is not something we would advise. This is one more meta-analysis which also looked at specifically at resectable NSCLC, neoadjuvant perioperative over surgery followed by adjuvant. Now this is a systemic review and meta-analysis point made previously, there's no head-to-head. It's a systemic review, and in the absence of studies, I think this is good enough. So this, again, when you looked at overall population, we look at all the trials that have been used and powered, look at the perioperative and neoadjuvant, they're all kind of nicely away from the unity, whereas all the adjuvants are close to the unity. Again, when you look at the overall survival in all the population, none of the adjuvant immunos have shown any survival benefits. The survival in IMpower 010 was kind of a post hoc analysis where they looked at PD-L1 positive and said yes, but otherwise not there. All in the neoadjuvant, at least when you do a complete group analysis, it is at least towards this away from the unity, so it shows a positive benefit in OS. And there is no AGN here still, by the way. This included only some of the other studies. So again, for me to conclude, at least you would find a benefit of neoadjuvant or perioperative over an adjuvant immunotherapy. Now, interestingly, the benefits were seen in these subgroups: squamous cell, stage 2, and all PD-L1. Why is this important? These three are actually where your adjuvant doesn't work. Your adjuvant immuno doesn't work in these three subsets, whereas perioperative neoadjuvant will work. So if you want to use immunotherapy in this setting, probably the periop or the neoadjuvant is the way to go forward. Adjuvant is not the way to go forward, right? So let's look at the studies. Now, if you see the 5 drugs which we have, you have pembrolizumab with the Keynote 671, the Tislalely with Rationale 315, you have durvalumab, AGN, nivolumab, 2 studies, 816 and 77T, and you have a toripalimab with the NeoTorch. I have put the colors here, so any of my panelists can tell what the color scheme represents. Anyone in the panel? Just a guess. Okay, so the first 2, that is Pembro and Tislalely, have in these 2 studies shown overall survival and EFS benefit. The next 2, Durva and Nivolumab, have shown only EFS benefit, no overall survival as of now, till now. Okay, the overall survival subsets leave it, but overall survival is not been demonstrated in the study. Toripalimab, I have kept it in white because this actually has shown OS benefit, but the full paper I could not get. There are publications with lot of caveats. The toripalimab had a mostly male patient, almost entirely in China, 90% smokers. So we are not sure if that population is exactly what we look at. So I've kept it a bit aside. But this is the 4 drugs that are available today. So obviously when we have 4, Nishita will ask you, how do you choose between them? What are the things that you would look for?
Yeah, so as you said rightly, OS benefit, because we are very comfortable with that being the primary endpoint. So pembrolizumab would be my go-to for that.
Okay.
And otherwise, it depends upon multiple other factors like pathological CR. I would keep it very low. So mainly, I am more comfortable with that because we have used it in many other indications. You're very much aware of the toxicity. So that would be my way.
Okay. Dr. Shilpa, next.
Sir, I would consider all the 4, sir. Definitely taking into, everything is important, but you take one over the other, probably the EFS, OS, and the toxicity. And given the better tolerance of the drug and this thing, so Pembro would be a good option.
Okay.
Yes.
Raghav, Dr.
Yes,
Raghav?
sir, I would go with the rest of the panel, sir. I will consider all these factors. Just one point to add, sir. We have that OS data from Checkmate 816, sir, which showed improvement.
Trend. It was a trend to improvement.
Correct,
it is not yet a significant thing.
Correct,
Full maturity is not there.
Yes, correct.
Yeah.
I'll go with Pembro because it has OS data.
Okay.
Others I will be doing cross-trial comparison. So.
Okay. Dr. Bhargavi.
See, my concern is mainly the OS and event-free survival followed by the toxicity. PAT-CR is the least preference.
Least preference, okay. So again, it's very interesting. You put a bunch of medical oncologists and ask them to talk, ultimately all of them will say we like pembrolizumab. I don't know why. It is not, it is independent of any other reason I sometimes feel. It's just that we have been using this drug for a while and it does show good data, at least in this setting. So that's something that we have all seen. Right, so the reason why, if you put a comparison, this is the comparison. And we talk of PAT-CRs and we are looking at the percentages, it's somewhere between 18 to 25%, except the Tislalely, which is actually showing you 37% PAT-CR, which is significantly higher. Now, again, whether it was because of the population use, I don't know, But this is presented from the 2025 WCLC. So your PAT-CR is around 17 to 25%. And again, for non-oncologists, you know, we typically look in breast cancer at somewhere around 50% PAT-CR. When we are talking of other cancers, the PAT-CRs, we are looking at 40-50%. So 25% is huge for lung, but does that difference actually translate into a survival? As of now, well, it's an open question. The other interesting thing is the resection rate. Now, I will discuss this later, but when you look at the resection rates, I did not put the AGN one, I'm sorry, it's around the same. So the resection rates with immuno or without immuno are around 80% in both the arms. So this is the point made by the prior speaker as well. You will have around 20% not fitting in, and this is a bit of a concern, but we have to understand that this 20% does not mean that never underwent a surgery. They could have undergone a surgery later as compared to the required thing, or there were other reasons. It was not just because of toxicity. Because of toxicity or death, it was only 2 to 3%. There were other reasons why these patients did not undergo surgery. So whether this is reflective of a real world or not, that's something we need to talk about. Look at the hazards, and again, the best hazards are actually seen for the NEJ, the Checkmate 7070 and your tislelizumab. It's 0.58. If you look at your AGN and the Keynote, it's around again, Keynote has 0.58, the AGN has 0.68. OS, like I said, the only two studies which have shown OS benefit include the Keynote and the tislelizumab, 0.65 and 0.72. So that's the things in a nutshell. So Dr. Bhargavi, you know, looking at all this, again, you'll stick to your gun and say, yes, Keynote is the way to go. Or you're okay with the others as well?
Keynote.
Keynote, okay. Doctor, would you agree that there are some places where Checkmate is also better, or a Checkmate 816? Because Checkmate 816, you only need 3 nivos. You don't need 1 year of nivolumab.
So again, you asked me not to bring the financial thing, but if financial thing is a concern, 816 is the way to go. So.
What about the rationale? Rationale is the way to go. If you ask me, it's equally cheap.
Equally cheap.
Yeah, it's like cheaper, and you're getting a OS benefit. Would you be comfortable with that?
I would be comfortable.
You would be comfortable. Very good. Dr. Raghav, your thoughts on this?
Yes, sir. Same like if there is no any issues of concerns of using the long duration of immunotherapy, Checkmate, like 3 cycles we can give and we can subject the patient. Or else, as per the data we have, pembrolizumab is the first line of choice.
Okay. Dr. Shilpa?
Probably we are used to pembrolizumab, and the toxicities are also aware. Tisli, we are still, we need some more for personal experience regarding toxicity and also.
So, Dr. Dishita, your thought, can we use this for everyone and say everyone goes here, or do you want to further subclassify or look at subsets?
No, according to the data, it can be used in most, but only regarding Tisli, I'm not very comfortable because I feel FDA approval also is...
approvals, we'll come to approvals too. We'll talk of approvals also.
I mean, when I'm talking from all aspects.
I will come to approvals. I anticipated and kept that point for you guys. Okay. Does PDL1 matter? Because, you know, we have had this whole PDL1 story over the last 7-8 years. PDL1 very important, PDL1 not important. Do you think it matters? Dr. Bhargavi, from your side. PDL1, does that matter or not? I will show you the data. That's the reason I'm asking.
Yeah. Whatever all the trials, irrespective of the PDL1 status, we have benefit.
Okay.
But
not completely true, but yeah, go on. So
the more the staining, the magnitude of benefit will be the more.
Okay.
So PDL1 is particularly important.
Practically of no use. Okay. Dr. You all agree with this?
I agree. Practically not much use.
Okay. So again, the data is actually all over the place. Yeah. So the data is actually a bit over the place. You have PDL1 and histology both matter. When you look at this is the 816. Okay, we have to remember there are 5 trials. So we have to remember this is 816, which showed an EFS benefit. Look at the subset. Your PDL1 is less than 1. It's practically at unity. There is it's just not there. Your PDL1 1 to 4, more than 1 benefited. 1 to 49, okay. More than 50, very good benefit. That's what everyone says. Then when you look at the next one, this is the 7070 that has come this year. Again, PDL1 less than 1, it is touching the unity. It's better than the earlier one, but it's still touching the unity. The best results, more than 50% is where your results are. And if you're 1 to 49, again it is showing benefit, but not as good. This is your nivolumab, and this is, by the way, the same study looking at the stages. This is also something we discussed earlier. The stages wise, if you look at, the hazard ratio for stage 2 is actually crossing the unity again. Stage 3, it is nice. Squamous, it is nice. Adeno, not so much. And that's the PDL1. So again, when you dive into the data, BG, you wanted to ask something, Prashant? Possible. Possible. Absolutely. I mean, again, I completely take your point. We can just go by the headline news, but the reason why I'm asking is when you are talking to a patient and you have a patient who is, say, squamous with PDL1 less than 1% stage 2, is that a patient where you would push for an immunotherapy? Because that's where subset where it doesn't really seem to work. Or would you push it for a stage 3 adeno with high PDL1? You know, that's the reason why I have kept this question. You're not wrong to give it. But should we start, dividing our patients and then giving? I agree that these are not powered analysis. These are all post analysis, but it's what it is. Again, this is the durvalumab, and again you see the same thing. When tumor cells is less than 1%, it is more close to the unity, and otherwise more than 50, it seems to work. This is the Keynote 671, and again you see the same thing. Less than 1%, it is not matching. So again, this all I'm asking because the approvals are according to that. So Nishta, you spoke of approvals. Approvals also are given accordingly in some centers. So that's the reason why. So after these 5, so Nishta, I'll start with you. Do you agree irrespective of PDL1, or you would like to do a PDL1 and still give the immuno irrespective?
As of now, I would go with the data irrespective of PDL1.
Okay, you would still give it irrespective of it. Dr. Shilpa, should you even do a PDL1? Like somebody said, it doesn't matter.
Especially for pembrolizumab, irrespective of the PDL1.
Okay, this is the pembrolizumab data, and I am telling you the hazard ratio is 0.91. Numbers are small, point made, but it's not insignificant. 100, it's around 138
but the hazard
by
ratio
400.
keeps coming down when the PDL1 positivity increases.
It's less than 1 is 0.91. If I tell you a hazard ratio is 0.91, it's nothing, it's negative, practically speaking.
But EFS
this for the
benefit
OS,
is there.
yes.
OS is not there, but EFS benefit is there. Sir.
Okay. So, Dr. Raghav, do you agree with that?
Yes, sir. Irrespective of PDL1.
You would still give it irrespective of PDL1. Dr. Would you agree with that? Or would if your surgeon now after listening to this comes tomorrow and tells you, no, this PDL1 is negative, you are still giving, how do you justify it?
I would not check PDL1, sir.
You will not check PDL1. Excellent. I think that's one way, a good way of going. Dr. Bhargavi, don't check PDL1, just check EGFR ALK, start your chemo, start your immuno. Wonderful. Same. Excellent. So, does the platinum matter? Again, there are some data on this. Does the carbo versus cis? Because we know carbo works as good as cis. Now, interestingly, when you actually looked at the trial, this is from the AGN, and the AGN looked at this, cisplatin versus carbo, and they found that cisplatin worked better. I don't know why. I think this case, I agree with Dr. Prashant, we are digging too deep into the data, but again, they looked at it. And why is this important? When you look at, I've just used the NCCN as one of the things. It's an obligatory NCCN slide that comes in every presentation of a medical oncologist. So, for that reason. But Pembro approval is only with cisplatin. Pembro is not approved with carboplatin. So, all medoncos love carboplatin, all of us love pembrolizumab. That combination is not approved as per NCCN because the trial did not include carboplatin, whereas the nivolumab and the durvalumab included carboplatin. So, Dr. Nishta, again, approvals, this is where it matters a lot because they are saying give it only with cis, not with carboplatin. You think it matters or it just?
No, I don't think it would matter because even if you see in the Durva group, 75% had received carboplatin.
So that's why Durva, it says you can use either.
Yeah, you can use both. But
Durva says use either. Nivo, you can use either. But
so 75% carbo was used. So I would take the same
you
thing for because it's more comfortable and.
Yeah, Dr. Shilpa, again,
we are the patient is not fit enough to receive cisplatin either because of any contraindication, probably.
So if you are in the US or you're in a state-funded Western country, let me put it that way, where the state pays the insurer, if their label is with cisplatin and the patient cannot get cisplatin, you cannot give pembrolizumab. That's how they work. So again, whether we don't work that day, we have the luxury of using some medical sense and deciding to do, but this is the approval status. That's why I'm asking. Very good. Dr. Raghav, anything for that?
So generally in my practice, like whenever I'm considering adjuvant or neoadjuvant in lung cancers, I would go with cisplatin, sir.
Okay.
So I'll go with cisplatin combination here.
Okay, fine. You agree with that or?
Either cis or carbo, sir, depending on
Cis or
patient.
carbo.
If patient is fit, cisplatin.
Okay. Dr. Bhargavi, ctDNA, the holy grail. All medical oncologists have to talk of ctDNA. Is it important? Are you doing it? Do you think it matters?
We are not doing routinely, but as per the trials, those who are having the ctDNA clearance, they will have the better survivals.
Absolutely. So this is the reason why I've kept this, because post-operative ctDNA matters as per the studies. And this year's ESMO, we had this data from the AGN study. And what they found was that 10% patients remained MRD positive, 90 were MRD negative. Those who were MRD positive were usually stage 3. DFS were much worse in the MRD positive versus negative, 15% versus 89%. That's a big difference, 15 versus 89. So DFS trend is there in both the Durva as well as this 10-20 patients, not many numbers, but it matters that if you're ctDNA positive, you're likely to do worse. So Dr. Nishita, would you do this, and what would you do with the result? Because I think the audience, many will ask, okay, it's ctDNA positive, it will recur faster. What do you do about it? Can you escalate treatment as of today?
No, as of now, we don't have data to act on that.
So do you think we should be doing ctDNA just for prognostication, or as of now, we are not sure how to use it?
If you have the luxury, it's only to prognosticate.
If you have the luxury, you can do it. Very good. Dr. Shilpa.
Yes, so probably of academic interest.
Okay. So again, it's interesting. The reason I put this up, because the similar data was shown from Checkmate 737T, where they also showed that those who cleared their ctDNA had much better EFS benefit, and those patients who had the ctDNA clearance, even without a PAT-CR, they still did well. So that's the other point. You could have no PAT-CR, but ctDNA clearance, you would still do well. So that's the reason why I have kept these studies. Very good. So next thing, would co-mutations matter? Dr. Nishad, you said about multiple mutations, and I said we won't do it, but let's assume you do it and you find co-mutations. Would that matter to you? Again, there is some data, that's why I'm asking. Yes, Dr. Shilpa.
Co-mutations in the sense?
Other mutations like KEEP, STK1, STK11, KEEP11, all these are coming in a big way now. Again, the reason I ask is this. There was, from the AGN this year, they showed that if you have KEEP1 and KTM2C, the EFS benefit was not seen in the Durva arm. So if you have a subset in this patient who has these KEEP1 mutation, they don't respond well to your treatment. Similarly, the same thing was seen in the 70-70. So even if there were such mutations, there it still seemed to work, though the benefit was probably a little lesser. So somewhat contradictory results. Durva doesn't work, Nivo seems to work. Again, we don't know what to do about it. Excellent. Safety-wise, just quickly, Dr. Bhargavi, any thoughts of safety? Non-medical oncologists, are you happy with the drug? Safe enough, or is this the safety that we are looking for?
Almost all the immunotherapy drugs are well tolerated when compared to that one.
Well tolerated. Excellent. That's what the trials show you. They are pretty well tolerated. Okay. This is again about all the trials. So, Dr. Nishad, your question: do approvals matter in practice?
Yeah, I think when legally you are bound, it matters.
So which is the approval that you feel matters to you here? FDA, NMPA. We have 2 minutes, right? 2 minutes, I'll finish. NMPA, DCGI, FDA, EMA. Which approval?
DCGI because I'm an Indian,
DCGI.
and FDA because
only DCGI.
It's yeah.
Dr. Shilpa, only DCGI? Yes. Okay.
DCGI definitely.
DCGI definitely.
Probably the other two also would be fine, including.
Okay.
Much more.
Dr. Raghav.
FDA and DCGI.
FDA and DCGI.
No PAP without DCGI.
No PAP without DCGI, so you need DCGI approval. Dr. Bhargavi, only
Same.
Okay, so I have spent 45 minutes talking to somebody when I could have just finished in 5 minutes. Because only one drug is approved by DCGI. Okay, that DCGI has approved only the AGN. Okay, so we could have stopped our discussion and stopped talking of pembrolizumab. Pembrolizumab is not yet approved by DCGI. So all of you on the panel will not use DCGI, will not use pembrolizumab from tomorrow. It is not approved, we will not have PAP for it. Okay, so that's why I brought it up. No, again, to understand, see, DCGI will approve when the company approaches it. So I believe Pembro will soon become available in the PAP in some time, but this is important. The EMA and FDA approvals don't always match. I showed you the PDL1 data. The Checkmate studies, are not approved in EMA for a PDL1 less than 1%. It's approved only for PDL1 more than 1, though the same thing in FDA is approved. Now, interestingly, Tislely, somebody commented, is not approved, it is approved by the EMA. So, it is not approved by DCGI, but you are happy with an EMA approval, you can still go ahead and use tislelizumab. And I showed you the data, the overall survival is there, it's one of the 2 studies. So, logistics, finances come into picture, it's a good option. You can use it because it's approved by EMA, not approved by DCGI, but it is approved by the EMA. So, that's about the approvals. Remember, all approvals are for resectable, more than 4 centimeter, node positive, EGFR and ALK negative. Okay, that's the caveat which we need to remember. So, okay, so this is what I would normally do in an early lung cancer stage 2, 3A, surgically fit, preoperative is better. At this point, adjuvant IO, not so much. Borderline fit, definitely a neoadjuvant approach with a perioperative is better. Single station approach with perioperable, still perioperative. Multi-station, bulky nodes, go with a CTRT. Our chemoimmuno will not do great things. That's how I take it. So thank you very much, and that I would like to end here, if no other questions.
I would like to request the panelists and moderator to join for a group photo. Thank you, doctors. Moving forward, I would like to call upon Dr. Shivani Sharma for a sponsored session regarding rapid NGS in cancer genomics from biopsy to actionable mutation in 48 hours.
So, good evening, everybody. From a very exciting talk, we go to something which is from pathology. Rapid NGS in cancer genomics is something that I'm going to talk about. We are talking now about NGS in hours, and therefore itself it is path-breaking. So development of lung cancer, we know that genetic and epigenetic alterations, activation of growth-promoting pathways, and inhibition of tumor suppressor pathway, any of these paths can be taken to cause lung cancer. The molecular etiology itself can be any activating mutation, a fusion, it could be amplification, or we can have TP53 or RB1 gene mutations. But we understand that any of these mutations will be complex and heterogeneous. There is molecular testing and lung cancer treatment decisions that are interrelated. And we have plethora of technologies with us, right from PCR, FISH, NGS. And we know that DNA, RNA, both are required for a complete analysis. So let's set the background. We understand that for the basic thing, tissue is the gold standard for diagnosis. What is important with the tissue is the adequacy of the tumor content. We will always consider the turnaround time and the technology that we want to have. So if we go to the basics, what would be the specimen that comes to the lab? It could be a small biopsy. It could be a cytology specimen or a resection specimen. What am I supposed to do? Accurate morphological diagnosis and also preserve the tissue for molecular diagnosis. Few examples, the entire biopsy, if it's around 0.8 centimeter, does not mean that the entire tissue is viable. There'll be certain areas as marked red, which will actually have tumor. And all of it is then has to be adequate, and there could be areas of inadequacy in terms of hemorrhage or necrosis. At times, the tumor content is there, but the tumor is not apt for testing. The reason could be pre-analytic errors. Let's deal with the case. So day one, the pathologist gets a biopsy. This is a 65-year-old male patient, non-smoker, 3 centimeter mass in the lung. This is what I see on my slide. It is not a characteristic morphology of either squamous or adeno. So definitely I need to give an information whether this is primary lung. But what I want to do first is to look at it and understand whether this is epithelial or not. So the first stain being CK8/18. I'll do a TTF1 and napsin, and both of them being positive. I know that by day 3, this is a non-small cell lung carcinoma. I would favor a poorly differentiated adenocarcinoma, and I know the tumor content. What next? If we go by the guidelines, we are already at a place where histological subtype is made, and now a biomarker testing needs to be done. And this biomarker testing gets updated every year. And now we have NRG1 in it, HER2, so we need a test that is able to tell us whether chemo, targeted, or checkpoint inhibitors need to be given, and as we have just understood that EGFR, ALCROSS are a must. So what next? You have the quantity, you have the quality, and now you have to understand what would be the analytical clinical sensitivity. So what would matter would be the DNA, RNA input, multiplexing capacity, a sample throughput, or risk of error-prone sequencing. With this, it's important to understand that there is increasing complexity with the number of gene panels that you're trying to order, whether it's 10 to 15, 50, 150, or 400. And also, you would understand and try to see whether clinical relevant genetic alterations can be done with either DNA or the RNA to have the whole plethora in place. So what would be the NGS workflow? The sample gets accessioned. Thereon, it undergoes the adequacy, content, and quality criteria. It goes for the DNA RNA extraction, and then we go ahead and do the library preparation and further the NGS run. Once the NGS run is done, again it undergoes the quality check, the bioinformatics pipeline, and then the NGS report comes in. So definitely, it's a story of days. So if you have a 12-gene panel, you will be at day 10 at this point of time. If a 50-gene panel, maybe a day 18 or 20. And if it's a 500-gene panel, you'll be greater than 20 days. So what does the guidelines say? According to most of the guidelines, the turnaround times should not exceed more than 10 working days. However, in real-world clinical practice, some delays in NGS are bound to happen, and we face that every day. These could be due to logistics factors or run failures. What do we need to do? Upfront, rather than sequential gene testing, is first thing that can be done, or improve the logistics, ordering time and tissue selection, or choose a lab that is equipped with orthogonal confirmation in rare genetic test discovery. But what about this delay? Does it impact us? Yes. It can cause symptomatic progression, clinical deterioration, can also have psychological impact. So here is the solution. A lung cancer sample triage where speed meets the precision. So rapid NGS for personalized cancer care offers more than 50 genes, and the reports can be given within 72 hours. Very unlikely, but yes, this is the gene list that covers more than 50 genes, and as we have just seen that genes like KEAP1, STK11, NRG, everything is there. With this, there is an RNA panel that is there. So CNVs, the fusion driver genes, the splice variants, everything in one panel. And how do we do it? So this is the Genexus platform, which is an integrated sequencer. The beauty of this sequencer is that it's a closed system. That means we have the input sample, that is one touch point. The library preparation, templating, sequencing, and analysis that we saw took days together, takes hours. And therefore, the variant filtering and reporting can be integrated into your lab information system within days. So are we compromising on quality? No. The sample QC, nucleic acid QC, library, NGS run, bioinformatics, everything is being followed. The reporting guidelines remain the same, and you have a similar final report. So what would be the journey of sample now? Day 1, I have the biopsy. I do the morphological analysis with tumor subtype and tumor content. Day 2, I order the IHC for subtype confirmation, and parallel, I send it for the nucleic acid extraction. I wait for a day, and day 4, I have the report for the entire panel of NGS score prime. If required, can do the PDL1 further. So the entire journey can be shortened to just 4 days. Now what has happened? We have a minimal human intervention, which means that the pipetting is minimum. We have a minimum nucleic acid input. That means if small tumor content is there, it can work wonders. There is seamless informatics. And all this stringent workflow is leading to an impact, which is error-free run, closed system, and improved lab efficiency. and we are delivering an efficient output with no rejection, no run failure, and reduced need for batching. But lung cancer journey is with roadblocks. It is quite possible that there is less tissue or tumor depletion. It is quite possible that the run has also failed, or it is possible that we don't have the biopsy tissue at all. The same panel can be run for liquid biopsy and deliver the same excellence with an accelerated TAT of 48 hours on the same platform with the same set of genes. Have we worked on this? Yes. So this is a data of our own lab where we have done 265 patients with this liquid biopsy panel, and the maximum patients were of 184 cases were of lung cancer. What is the landscape of mutations? We achieved plethora of mutations here with TP53 and EGFR being the most common mutations, which shows that the percentage positivity is coming well. There is minimal test not performed or non-diagnostics. We published this data and we'll be presenting it in San Antonio, Texas in 2026, and very proud to say that this has worked for us and we have been able to give impact to the patients in minimum hours. So where does this panel stand in terms of TAT? We are in a high-end diagnostic lab where gene panels have a TAT of 20 days, 15 days. Now this panel has TAT of 2 days in the lab after it has entered the molecular department. So I would like to conclude that this is a test that is relevant. We are playing with time to save people's life. It is affordable, it maintains the quality standards, and we are analyzing the data at the back end with all the information that we have. Thank you.
Thank you, Doctor. That was a wonderful presentation. Now I would like to call upon all the panelists, Dr. Saurabh Radhakrishnan, Dr. Yashwant Kashyap, Dr. Narendran, Dr. Anusha Ji, Dr. Jagadishan. The moderator, Dr. Rakesh Reddy, will discuss all about small cell lung cancer.
I think people are still having some tea or something. So, thank you. Thank you for assembling at a non-scheduled time. It's only 15 minutes earlier than scheduled, but since my flight is coming up, there was a slight change in this. So, I was given 30 minutes or 40 minutes, whatever it is, but I will complete in 30 minutes. But I think I have to discuss all about SCLC. So, that itself shows that for a session that was, I mean, almost 10 hours long, only half an hour was given for small cell lung cancer. So, it shows how much blindsided small cell has been in lung cancer. But if you see in lung cancer, which is in as per Globocon 2022, an incidence of 80,000 plus cases, which is a gross representation in itself, about 15% of them is supposed to be small cell lung cancer. So we are counting about 14 to 15,000 per year. It's not a less number. But this statistics also shows that because of the therapeutic nihilism that is associated with small cell lung cancer, both the limited stage as well as the extensive stage, we don't have as much of developments happening, but that is changing in the last decade or so. So that is what we will be focusing on. So how we have changed in managing small cell lung cancer in last 5 to 10 years and how it is going to change in the subsequent years. So I think this is not the font that I prepared in, but to the panelists, let's start from one end. So we have 2 radiation oncologists and team medical oncologists. Madam, you are a radiation oncologist. And another radiation oncologist is? Yeah, doctor. So 3 medical oncologists. We'll start up. So what is the trend that you observe? Madam, you can start from your end. Dr. Anisha.
Hi, sir.
Yeah.
So trend in
Small cell lung cancer.
Small.
So, yeah. Do you see an increase or same what it was during your training and your practice, or is it
So
increasing?
it will come, less patients will come to radiation department nowadays, sir.
Yeah.
So most of the cases are extensive stage only.
Okay.
Only 30 to 35% are coming in the limited stage.
Okay.
So.
Okay, around 30% are coming in limited stage. So, to this end, sir. So, what is the usual presentation? Like, what do you see your presentation of small cell lung cancer in your clinic? How do the patients present?
So, later nowadays, most of them present with relatively good PS. Previously, we used to have in our area, we would have a poor PS patients like PS2 or 3, sometimes of course PS4, but most of the time they are like PS2 at the least. The PS3, PS4, maybe people are coming earlier to the pulmonology side and they detect the mass and do the biopsy and then they are reaching us earlier.
So, you mean that the diagnosis has hastened a bit,
yeah,
and we are seeing it in
earlier stages.
Okay. So, so when you diagnose small cell lung cancer, do you, I mean, on the biopsy, do you recommend IHC for all the patients?
Yeah,
or
yes.
are you happy with just a morphology?
Because clear-cut diagnosis is important, because neuroendocrine is a big DD and prognosis and whole treatment matters. So our final diagnosis based on PET scan, and if need, there should be a difference between neuroendocrine and clear-cut small cell, because whole prognosis and management differs.
So
that's
you are
why
saying
I do.
whether it is a low-grade neuroendocrine tumor or a high-grade neuroendocrine carcinoma. Maybe the morphology itself will suggest, I mean, a low-grade will look much more indolent, high-grade will be small cell carcinoma, especially small cells, 2 to 3 times size of lymphocytes.
Yes.
Nucleoli not very distinct, finely dispersed chromatin, very. So, I mean, the morphology itself is enough, or do you still?
No, we do IHC also and KI, maybe because many patients now are coming with non-smoker also, so
Okay.
with SCLC. So we need to differentiate.
Okay, so any thoughts on this regarding staging and diagnosis?
So the IHC, why it's important, because this small round cell tumor, again the lymphoblastic lymphoma also can mimic small cell carcinoma.
Okay.
And the Ewing's,
So better to be on safer side and do the
Ewing's sarcoma also can mimic. So better to go for IHC before
LC and EC can occur like this, large cell neuroendocrine or small cell. Okay, right, fine. So concluding the staging part also, any difference, or do you do PET scan for all the patients?
PET CT.
PET CT or MRI brain?
And MRI brain.
So PET CT and MRI brain. So get a biopsy, get a PET CT, get MRI brain, get IHC on the relevant. So what is the timeline that you are looking at? Like a patient walks to you with symptoms, and by the time all this investigation happens, what is the timeline that you want to achieve for your patient before starting treatment?
As soon as possible, within
as soon
1
as
or 2
possible
days.
is good. So in my place that I work, like, so what we aim at is 3 to 4 days before we get all this battery of tests, because the difference is in small cell and non-small cell. In non-small cell, we need more of therapeutic workup that needs to be done. Sometimes we wait for certain investigations before initiating. But small cell does not give you that time. So for all the students that are listening to, then this is important. You cannot wait forever for all these things to come up with. So what are the proportion of large limited stage, and how do you stage, Dr. Jagdishan?
In JIPMER, in the last 5 years, we have seen around a total of 600 lung cancer, among which around 30 patients of small cell lung cancer.
30?
Only 30 patients,
Okay.
30. So which means around 5% of the overall lung cancer population,
Okay.
which we have registered. So in this 5%, probably a 50-50, because the number is so less. So I could only say 15 to 20 patients of extensive stage and another 10 patients whom we have given a radical intent treatment.
And how do you use it that you differentiate between limited stage, extensive stage? It's very functionally very easy classification, you would say. And what radiation oncologists mean by being encompassed in a safe radiotherapy portal?
It's quite an older concept. So older concept was encompassed in a radiotherapy portal, We have added the safe to indicate that we will be able to treat any amount of volume in a single portal, which is what technically means. But logistically speaking, in a practical sense, we will not have a non-metastatic disease occupying the entire hemithorax. Very unlikely to see such a disease.
Yes.
So one-sided lung disease is limited disease. Anything beyond that can be called as an extensive disease.
Okay,
Even if we have a nodes.
thoracic.
Even if we have a nodes. So T size of any T4, N2 disease, we can still include in the limited volume disease.
Okay. So does contralateral nodes fit into this safe portal?
Contralateral hilar or mediastinal nodes can be included in the single fold, but here the safe means we have to not going beyond the safety limit of normal organs. We can't go beyond the normal limit of the lungs or heart or great vessels. We can't go beyond the normal dose limit to those organs.
Okay, sure. So any biomarkers that you would consider, sir? Like do you do NGS, PD-L1, TMB, anything in small cell like what you do in non-small cell?
At present, no, because the small cell, the way it has changed, you anyway have a immunomarkers. You can start treatment with immunotherapy is also a part of it now, especially in the maintenance part, you can have immunotherapy. So because of financial issues, obviously we don't use it upfront. In the recurrent setting, if we have a biopsy, then we might send it for a markers. That is a practical thing. But otherwise, yes, I would definitely like to send.
Okay. Yashwant, do you do?
I do NGS, but not found much benefit. But I do for all of my small cell.
Okay. Any particular reason that you do? I have not seen any actionable mutation in any of them.
Sometimes there are histology like small cell,
mixed histologies,
large cell. So I sometime for picking other mutations.
Okay, right, fine. So just to encapsulate all the discussion that has happened, pathology makes the most of the diagnosis. Light microscopy, you can make a diagnosis. IHC is sometimes needed, not uniformly for all the patients, but maybe you can do TTF1, CD56, synaptophasin, one of the neuroendocrine markers, along with Ka67 to differentiate between small cell and large cell neuroendocrine variants. Something that is coming up, molecular classification. Any of the medical oncologists wants to take up regarding molecular classification of small cell lung cancer? So, yeah, please go ahead.
No, actually, in the clinical practice, we are not regularly.
Okay.
Probably in the research work, it may help.
Okay, Yashwant, you have something to
even
add?
in the small cell carcinoma, some patients may respond well to the immunotherapy, some patient doesn't respond well to immunotherapy.
Yes.
The PFS matters. So
Yes.
that can be explained with the gene expression profile and the molecular
Yeah, so
classification.
in your small cell lung cancer also, you will see about 30% of patients doing very well and about 70% of patients not doing well. So probably this is the answer, and this gene expression profiling molecular classification was tried out as an explanation for the Caspian data, and they found that there is an SCLC-I phenotype which is about 10% of patients which had a very good overall survival. The median overall survival for that cohort is 26 months, whereas for the whole Caspian cohort it was about 12.7 months. So it's almost doubled. So probably this explains the identification of that particular cohort might benefit. And going further, there is one thing called SLFN11-IHC, which probably indicates PARP inhibitor sensitivity. So there is data of temozolomide plus veliparib in recurrent SCLC, where this particular IHC marker, if it is there, there is a much better sensitivity. And DLL3, that is T-cell engager therapy, tarlatamab, that we will come down later. So this data suggests that about 75% of small cell lung cancer are extensive stage. Do you agree? Anybody think that this is overestimation or underestimation?
We agree.
So somebody feels that it is about 50-50, 3/4, 1/4. So majority what we see is small extensive stage SCLC. So coming to limited stage SCLC, we'll start with Dr. Anusha. As you are saying, you are fond of limited stage SCLC. So what is the treatment outline? What is the radiotherapy plan and how do you go about it?
So main treatment of choice for limited stage small cell cancer is CTRT. But if it is very much bulky and invading the great vessels, so then we can plan for a induction chemo followed by CTRT.
How many cycles of induction chemo?
2 cycles.
Okay.
2 cycles, and we can start as early as possible after this induction chemotherapy for the CTRT.
I'll stop you here, Dr. Jagdishan. My idea is that concurrent chemotherapy radiation should be started as soon as possible. And Dr. Anisha alluded to a point of induction chemotherapy. So what induction, how many cycles, what you would
It
do?
has been proven that early radiotherapy started within 9 weeks of starting the first chemotherapy can help. So what we practice is second and third will go along with the radiation.
Yes.
So total of 4 to 6 cycles is what is practiced in the major trials. And the trials that have compared the BID fractionation regimen, that is the gold standard of radiation protocol. So we deliver 2 radiation doses per day. But in our setup, because of obviously practical issues, we will go ahead with only single day fraction.
So if you don't have any limitation, you would want accelerated hyperfractionation as your go-to?
Yeah, it's a hyperfractionated treatment. So we are giving more fractions, but 2 fractions per day. So technically, we will try to cover.
What's the dose? Like?
It is 45 gray given in BID doses. That's a gold standard version. But we can still go ahead up to, in the recent scenario, if we are giving 2 fractions per day, we can add something called as a SIB boost. So we can give more dose to the primary target, whereas the nodal and others can receive.
And you go until 54 gray in total?
54 gray and the SIB.
So, further fraction is then hyperfractionation, conventional fractionation is there, 60 to 66 gray in 30 fractions, daily single fraction only. So will be completed in 6 weeks.
So does it really matter in terms of outcomes? Like if you...
Outcome is very much obviously better in hyperfractionation only, in hyperfractionation. So because of that, we are, in our center also, we are choosing our conventional fractionation.
So if there is a fit patient where you think you can manage the patient through esophagitis, you would prefer. But none, the Adriatic trial, which I am going to discuss, it did not show any difference in benefit between conventional fractionation and accelerated fractionation, where almost 60 and 40% had received each of those. So does immunotherapy change the way that the outcomes are happening for radiation fractionation? What do you two think?
So immunotherapy also influences the overall survival and the outcome, but still here immunotherapy means durvalumab is increasing the pulmonary pneumonitis. So that is the one thing we have to see here.
Yeah, fine. Do you ever send patients for surgery? Small cell lung cancer. When is the last time you have sent a small cell lung cancer for surgery?
Never.
Never? Never. I have never sent it. So choice of concurrent chemotherapy, sir, I will start with you. What is the choice of concurrent chemotherapy regimen?
So it's the 2 options, mainly etoposide cisplatin, and that is the thing.
Yashwant, carboplatin? Yes or no?
No, generally this patient in limited state, better to cisplatin is better.
Okay. So, Jagdish, you think this, Narendra?
As you said before, in the immunotherapy era, there's no difference between cisplatin versus carboplatin. There's no difference between whether accelerated radiation or a normal RT. So, carbo is equally good in limited stage.
Agree. So, you choose what? So, what is the most disconcerting side effects that you have to manage when giving the platinum doublet in radiation?
So if it's carboplatin, mainly thrombocytopenias and cytopenias. Cisplatin,
that we know, but most is esophagitis, right? For this central radiation, role of PCI in limited stage SCLC.
Patients who have shown some response with the CTRT regimen can be taken up for PCI.
Can be or should be?
Should be taken up for PCI in limited stage.
Okay, all comers. Dr. Anisha, you also feel all comers should receive PCI?
If negative on MRI, after that CTR.
Of course, that is what prophylactic means.
Then.
Yeah, all comers. Okay. So, what is the prognosis you would counsel the patient for in the current status?
So, based on the response, it's definitely better than extensive.
Okay. So, let's say median overall survival of maybe 3 years is
3
what.
years.
And how can we improve on it is the latest question. Then that's where Adriatic comes. It's probably one of the most influential practice-changing trials in small cell lung cancer, where limited stage SCLC was taken, 4 cycles of platinum and etoposide along with concurrent radiation, and followed by consolidation with durvalumab versus comparator with placebo, and up to maximum of 24 months or progression, whichever comes earlier. And what it has shown is a significant improvement of median overall survival of 56 months versus 33 months. You can see a 23 months of improvement with using of durvalumab. Similar improvement in median PFS. Did not matter much if it was a hyperfractionation, did not matter much if it was a conventional, did not matter if you gave a prophylactic cranial irradiation or not. Both the groups are benefited, but we have to remember here, even in this trial, prophylactic cranial irradiation, the patient cohort who got PCI, they did much better than those who did not get PCI. So probably in limited stage SCLC, the role of PCI is still definitely there. That is how I read into the scenario. Radiation immunities, all grade did not differ much. The grade 3 did not differ much. So durvalumab addition did not cause an increase of radiation immunities. That is what we were actually worried about. So definitely a meaningful improvement in terms of long-term outcomes for small cell lung cancer, where we are seeing prognosis of 3 years of median survival. It has suddenly shot up to 4.5 years or 5 years. To the medical oncologist, want to do durvalumab for all your patients or not?
All patients.
All the patients.
Who had responded. Who had responded.
Who had responded, obviously. Yes. Right. So even I want to do, and that's what we have been doing. So let's come to upfront extensive stage SCLC. What is the current treatment paradigm that you follow? Yashwant, you can start. Yeah.
Chemoimmunotherapy.
Chemoimmunotherapy. Yes. Any difference of opinion, sir? You are saying that immunotherapy, you would want to do it in second line or subsequent lines?
Extensive stage chemoimmunotherapy.
The standard is chemoimmunotherapy. So if you want to do immunotherapy, do it in front line first, upfront. Yeah, so that is clear. So what is the barrier to deliver this optimal treatment paradigm?
The cost is the main.
Cost is the main barrier. Performance status of the patient. Of course. So because PS 3 and 4, you might not be able to give the doublet. So how do you manage this? Like, this is a real world problem. Let's say you have an affording patient coming with PS3 extensive stage SCLC. Do you do something different?
So one thing is most of the underlying problems. We get the pulmonology to optimize the lung function, and with many times patients improve with that. The PS might improve.
Very good.
So, and then we go out with the treatment.
Okay. So maybe something like starting off with single agent platinum, maybe a weekly platinum with immunotherapy, and then adding the subsequent
we give carbo with immunotherapy here.
Yeah.
And
add etoposide from the second cycle. That is very doable. Yes. So platinum agent of preference. Yashwant.
Carbo, because extensive stage with immuno no longer is important. So we give carbo with.
So whether you do cisplatin or carboplatin, it is immaterial. You have to use platinum. How many cycles?
4 to 6 cycles.
4 to 6 cycles. If you are using immunotherapy, Narendran, you will do how many cycles?
4 cycles.
4 cycles is good enough. You need not go until 6 cycles. So that is another thing that is important. So addition of IO upfront is one thing that everybody wants to do. But is there any other strategy? Like you start off with chemotherapy alone and then consolidate with IO, or do a maintenance IO. Does that work? Like patient took some time to arrange funds. Does that still?
Like financial reason is there, then we don't have any other choice. We go like that.
Exactly.
But otherwise, you started upfront.
Right, fine. So coming back here, extensive stage SCLC in the era of immunotherapy and even without immunotherapy, what is the role of prophylactic cranial irradiation? We'll leave it to the radiation oncologist.
Thank you for leaving something to us. Extensive stage, there is no role of prophylactic radiation. We'll treat only when there is involved disease in the brain or wherever it is.
Dr. Anisha,
that's a general concept.
No role?
So, not completely, sir. I can't agree. But definitely there is a role of PCI.
So which patients you will give? Like let's say you have done MRI upfront and you decided that there is no brain metastasis for that patient. Will you do?
After good response after chemo, so then I definitely consider for PCI after chemo.
Okay, if the patient is obviously younger and no neurological comorbidities prior.
And
what's your counter to that? There is a small debate happening here only. One says no, one says yes.
So I will not counter a colleague. So what I would suggest is whatever radiation protocols that is tried in extensive stage is 30 gray in 10 fractions for the thorax and palliative doses elsewhere. So 30 in 10 is indeed a palliative fractionation regimen. So technically means there is no curative radiation protocols described for extensive stage. So we can reserve all these doses when the disease progresses after chemoimmunotherapy, be it the local or distal, wherever it is. That's the philosophy.
So you are saying the same for the role of consolidative thoracic RT as well?
Yeah, that's what. So consolidative thoracic RT doesn't mean we are throwing full curative intent dose. So all the trials have shown only 30 gray in 10, 20 in 10, 20 in 5, all are palliative doses. So the timing of radiation can be determined depending on the response. Earlier we used to give routinely, the trials also have suggested benefit, but when we have two lines of treatment like immunotherapy, chemotherapy, we can reserve the radiation until the disease progresses.
So in the era of immunotherapy, if you are using, so you are saying that there is no role of prophylactic cranial irradiation for all comers?
We do not know because there is no head-on trial which have compared with or without RT in immunotherapy.
Yeah, and in none of the pivotal phase 3 trials of immunotherapy, consolidative RT is not part of any of the trials. Prophylactic cranial irradiation was left to the choice of the,
having said this, symptom control can definitely be achieved with RT. If the patient has hemoptysis, there is no point just continuing to give chemoimmunotherapy when the patient continues to throw up a lot of blood in the sputum.
So that's very insightful comments from all of the panelists. So just to synthesize all of them in subsequent slides, in extensive stage SCLC, prior to immuno-oncology era, it is actually a reality for majority of our patients. We will not be using immunotherapy for them. So platinum-based doublet is what we would want to do. Even if the patient's PS is not good, we'll try to improve upon it and try to give a platinum-based doublet. Cisplatin plus etoposide is what we prefer. Carboplatin is also equally good. Consolidated to thoracic RT, prophylactic cranial irradiation in patients who respond well, and retaining a good GC after chemo completion with no neurological comorbidities definitely is what is routinely practiced, and with this the response rate happens in about 50 to 60% of patients, a median survival of around 10 months. So this is what was achieved prior to advent of immunotherapy. And second line chemotherapy, very, very limited options. What percentage of your patients go on to second line chemotherapy, sir, Dr. Saurabh?
Very few, actually, maybe not more than
20%, 30%?
Yeah, 20 to 25%. Because
any change, like
20 to 30?
I think everyone will progress. Everyone will progress ultimately.
No, they will, but they will receive. Will be fit enough to receive a second line chemotherapy. So only about 30% of our patients will ultimately end up receiving second line chemotherapy. Everyone will progress, yeah, definitely, that is true. So this point is well taken, that cisplatin is equal to carboplatin. Prophylactic cranial irradiation, consolidative thoracic RT, CREST trial prior to IO era showed a benefit of consolidative thoracic RT. 30 to 40 gray is what you get?
30 in 10.
30 in 10, fine. And this is what was I was trying to allude to, the ERCTC trial which showed a benefit of prophylactic cranial irradiation. MRA is not mandatory. And it showed a benefit of PCI, but in the Japanese multicenter Japanese clinical trial where MRA is mandatory to differentiate between PCI or no PCI, it was early terminated for futility, that it was not benefiting the patients, and it ended up adding more morbidity. There are other failed strategies like high dose chemo, accelerated chemo, adding more drugs, more chemo cycles, more than beyond 6 cycles, maintenance therapies, biotherapies, everything failed until the advent of immunotherapy. Even in immunotherapy, the initial trials with nivolumab and pembrolizumab failed. One of the few areas where pembrolizumab failed and subsequent other drugs have made the mark, and that is atezolizumab and durvalumab. Probably it's something to do with the trial design as well. So what it actually did was the atezolizumab over and above carboplatin plus etoposide, 4 cycles and maintenance of atezolizumab until disease progression. Similar with durvalumab, but it allowed both carboplatin and cisplatin as the platinum of choice. The 5-year overall survival is around 12%. The 3-year overall survival is 17.6% for atezo and durva versus placebo of about 6%. So around a 12% improvement in 3-year OS. So a definite significant improvement of OS and the consistently separated curves is what we get to see. We get to see also from these curves that about 70 to you can see a rapid fall in the first 1 year of almost 60% of patients, and then you get the curve separation. So these are the progressors, they don't respond well. So these are probably the patients SCLC A type or something like that, SCLC N type, which do not respond. So the other responders, the curves that are separating, are the probably the SCLC inflamed phenotype, which we have to find out, but we don't have biomarkers presently. So that is where we stand. So only IM Power 133 and Caspian were the new trials. Any role of biomarkers, PDL1 and TMB? Yeah.
We do, but still, irrespective of that, we use.
Okay. Do you do?
No, not routinely.
Do you do? I don't do. I don't do either NGS or PDL1 because I don't think it informs the choice of immunotherapy drug also. So there is no role for PDL1, there is no role for TMB. So what's your take on the new entrants? Serplulimab, toripalimab, tislelizumab.
Actually, this Chinese data is there for serplulimab, and all three we have small cell. Probably not phase 3 data, but all three I have.
All three are phase 3 data.
Okay.
All three are phase 3.
I don't know whether serplulimab has phase 3.
Yeah, Astrum 005 is a phase 3 data.
So I'm comfortable with all three Chinese immunotherapies.
Yeah. So I think we are now, we have beyond the usual options, and apart from durvalumab and atezolizumab, we have option of serplulimab also. So this this flowchart is already well discussed. So coming to refractory or relapse stage, what's your thought process when a patient relapses?
How early relapses based on that? If the platinum free period is there, I may consider again a platinum free period for only 4 to 6 months is there.
More than 3 months is the definition.
So then I will probably second line I'll use irinotecan with carboplatin. So I may consider adding again a platin.
If it is a resistant disease?
Only irinotecan.
Or topotecan?
And we have other options like tarlatamab is there now.
We have tarlatamab? We don't have, it is bloody expensive. So a dose of tarlatamab costs close to 30 lakhs.
So option is there.
It is there, but it is not there.
This is where we insert a radiation course.
Yeah. So you can still consider radiation. So absolutely no role of immunotherapy. Across the trials there was no benefit, and approvals for both Pembro and Nivo that were initially granted by FDA were later withdrawn. So if you have to use immunotherapy, use it earlier. Lurbinectedin is one drug which has shown benefit, but important is the dose. 3.2 mg per kg, not the dose that was used in Atlantis trial along with combination of doxorubicin. So use 3.2 mg per kg. So the dose is important, and it is similar to trabectedin but is more expensive. And one thing that was already mentioned is targeting DLL3, delta-like ligand 3, by T-cell engager therapies, and that is tarlatamab. It is not yet available in India, but the early data shows that it is very, very clinically efficacious even in this difficult to treat population. So this is what we see: platinum resistant or platinum sensitive relapse more than 3 months or less than 3 months. Less than 3 months, platinum resistant, topotecan or irinotecan. Platinum sensitive, you can reuse platinum. So thank you all the panelists. I'll just summarize. It's an aggressive disease. Don't do extensive workup. Trust treatment as soon as possible. Limited stage SCLC. Start of radiation along with chemotherapy as soon as possible. Maintenance IO has improved outcome. Extensive stage SCLC, try to use IO. The newer IOs, the cheaper ones, are also good enough or as bad enough as the established ones. Molecular profiling might define who gets more benefit. Questions are being asked of prophylactic renal radiation and consolidated, so not for all the patients, especially in extensive stage SCLC. New agents are coming, but they are expensive. Probably when they become more accessible, we will be better off. So with this, I will end the panel discussion, and thanks all the panel.
I have just a question. Yes. I just want panel members and who are off the stage.
Yes.
Anyone following the MRI brain surveillance instead of going for PCI? Whether anyone is following in the regular practice in the.
I think if the patient is agreeing, that is one thing that I am very comfortable in doing. Not for the limited stage SCLC, because I think the data still is strongly in favor of continuing PCI.
Adriatic trial, they have almost only 25% they received PCI.
Yes.
Almost remaining 75% they still had a MRI surveillance.
Even in this, and that 25% of the patient who got prophylactic renal irradiation, the improvement And in the patients who got PCI is much significant. It's almost, I'm not really able to recall, but the difference, the delta is quite significant in terms of the benefit. So in limited stage, I still believe there is a role. But if you want to do an MRI surveillance, it must be still be good enough.
And again, for PCI, is there any role for the hippocampal sparring regularly?
Hippocampal sparring results in only 3% relapses at the hippocampus. So the trial has suggested we can still go ahead if it is merely a 3% relapse failure rate.
Okay.
So we will go for hippocampus because there is a reduction in the IQ points, especially short-term memory, for as long as the patient lives in that 1 to 1.5 years.
Fine. I thank you so much for the engaging discussion.
Thank you all. I request all the panel members and moderator to gather for a group photo. And I also thank Dr. Rakesh for a very engaging discussion and very well summarized. So let's take a break from lung cancer and have a next session, a sponsored session by Dr. Vamshi Krishna on redefining chemotherapy-induced nausea vomiting prophylaxis.
Small announcement, those who have registered for the bronchoscopy workshop, kindly gather at the Richard Wold stall, which is present in our dining area at 5:30 p.m. Dr. Prakash will be monitoring that session.
Also, we are sorry for rearranging the schedule because of certain flights and other things to be arranged.
Good evening, everyone, once again. So we are moving out of lung cancer for something, and as the past few minutes demonstrated, anticipating something is always a problem, and that's actually what all our patients say. They come to the chemo ward and anticipate the vomiting and anticipate the nausea. So, anticipation is not always good, and this is where I would be talking for the next 10 minutes or so about this drug called Nalccon. Now, full disclosure, the slides have been provided by the sponsor. So this is about the drug which is netopitant plus palnosatron combination, and it is used for CNIV prophylaxis. What is CINV? And I think every person in the world, when we tell them you need chemotherapy, this is what they say. We are going to get vomiting, we don't want it. We are going to get nausea, we don't want it. And it was a pretty common problem earlier, because I still remember when we were doing our training, we used to actually give some injection and put a bucket right next to the patient and say, okay, this is for you. Things were that bad. And things have improved. So CINV essentially is chemotherapy-induced nausea and vomiting. It's important to realize that the pathogenesis is multifactorial. Essentially looking at the 5-HT3 pathway and the NK1 pathway, which is not there only in the gut, but also there in the CTZ. That is the chemotherapy trigger zone, which is in the brain. So they can be delayed, there can be breakthrough vomiting, you can have acute CINV, and most importantly, you can also have anticipatory CINV where the patient actually comes and anticipates the vomiting from earlier. Incidence wise, it is pretty common. The CINV is not very uncommon. You can have an acute CINV incidence ranging from 30 to 90%, of course, depending on the type of drugs. Risk factors include younger age group, any nausea, vomiting in the prior chemotherapy cycle, females, any history of anxiety and motion sickness, any history of alcohol or tobacco usage, and also depends on the emetogenetic profile. Again, this is a question which we ask all our postgraduates to remember. What is the Haskell criteria for the emetogenic drugs? And these emetogenic potential is divided into moderate emetogenic risk or high emetogenic risk. Very important to note that there is that drug which you can see there, the fourth one, carboplatin. It's something which people don't understand or remember, that carboplatin high dose is actually also a highly emetogenic drug. We did discuss on a panel as well about carbo versus cis, and by and large we are happy with carbo, but this is one of the side effects which we tend to ignore. Now we are having ADCs. So you have TDXD, you have other ADCs which have come in. These also are actually having high emetogenic profile, which is something we tend to forget when you start using these fancy new molecules. So other than that, you have some oral anti-cancer drugs which also have high emetogenic profile, which we should remember to use. So starting from the days of the only dopamine antagonist, then you had the 5-HT3, then in the last 10 years we have had these NK1 receptor antagonists and combination therapies which were used, which have been used. So this would be different kinds and we use it in different combinations. By guidelines, if someone has high emetogenic chemotherapy, you should use a 5-HT3 plus a dexamethasone plus a NK1RA plus or minus using olanzapine. So high emetogenic, we all are pretty clear that you have to give everything at those patients. It's the moderate emetogenic where sometimes we slip up, but even in moderate emetogenic, the addition of drugs like olanzapine is becoming common. And if you have higher moderate, something like carboplatin, NK1RA should still be a component of your treatment. Because again, sometimes we are accused of over-treating, but the point is if you do not treat the patient well in the first cycle, every subsequent cycle they will have anticipatory nausea and vomiting. So it's always better to tend to over-treat in the beginning than later on. So standard guidelines would recommend the incorporation of at least 3 drugs. So in that scenario, why this combination? So this is a better combination because this exhibits enhanced inhibition of the responses. Now palnositron also inhibits a crosstalk, therefore this combination of 2 drugs is better than just using one alone. So this is why we are using this, and together both these pathways can be targeted. Now pharmacokinetics wise, it has a longer half-life as compared to other drugs, so it is better to use this combination. Netopitant has around 96 hours of a half-life, so it works for at least 1 week. So it's a very long acting drug. When you combine this or compare this to only a single drug like aprepitant, there is a meta-analysis. Again, it's difficult to get phase 3 trials in these settings, but when they looked at the findings, NEPA seems to do better as compared to only aprepitant. Again, there's a 2022 paper, Indian experience with NEPA, which showed that there was a complete response rate of close to 94%. Effectiveness in CR in the delayed phase was around 95%, and complete protection was around 87%. So again, this study used mostly high emetogenic protocols like AC and Paclitaxel. So again, this showed a pretty safe, good application of the drug. So NEPA is both efficient and well tolerated in patients on a HEC protocol. Again, several small studies are there. Like I said, these are not headline grabbing studies, but they are important for the patient. So a single dose combination demonstrates a better efficacy compared to a 3-day aprepitant regimen. And we all are aware that if you give aprepitant orally, 3 days patient may or may not take it on the 2nd, 3rd day. So it's always good to give it a single drug. And when you give a single drug which is a combination, you're going to have better responses. So again, the use of Nalccon in Moderately emetogenic studies also, you do have some studies like this one, the Pachyferrat study, which again compared using a single dose NEPA to 3-day aprepitant regimen and showed almost same results, a little better, numerically higher results with the NEPA. So comparing it to the IV, again there have been some small studies, not very big again studies, but all the studies seem to show that the response with a NEPA combination, a fixed dose NEPA combination is better than a only IV injection. So it has it's also easy to swallow, it's an oral tablet. Now there are some studies which are looking at how to reduce the DEXA usage, because again the dexamethasone does have some glucocorticoid receptor expression, and these do have some implications on treatment. So there was a non-inferiority study which evaluated a dexamethasone sparing regimen but having NEPA, and it showed comparable CINV prevention. Again, remember that when we say DEXA avoiding, we are talking about the DEXA orally given on days 2, 3, 4. You are not talking about that single dose of DEXA when we give it before chemotherapy. That is still to be given. But the oral DEXA which we give can be avoided. So again, there is a potential for decreasing the number of doses of antiemetic, and it also helps in reducing the anticipatory CINV in the following cycle. So again, a bottom line that NEPA is a good drug, it is well tolerated, and actually for all medical oncologists, it has become part of our jargon. We are using it so frequently that I was actually surprised we have to still have a sponsored meeting on this, but still it is good to remind people that this drug exists and that we should be using it for everybody. So again, just to give us a final summary slide, that 1 dose of NEPA is better efficacy compared to 3 doses of aprepitant. Single dose giving you protection from CINV for around 5 days, and it offers same efficacy as the IV and has easier convenience because it's an easy to swallow tablets. Oral NEPA can be dissolved and given by Ryle's tube. It's always better to give NEPA from the first cycle, because if your patient gets admitted for vomiting or requires frequent admissions for the vomiting, it's more expensive. So it's always better to just give off 1 NEPA. So that's about NEPA, and again, I think we are already, most medical oncologists, very familiar and comfortable with the drug and using the drug in our daily practice. So thank you.
Thank you, Dr. Venkatesh. Now I call upon Dr. K. Venkatesh Chaudhary for a sponsor session on novel treatment option in lung cancer with focus on pembrolizumab.
Good evening, one and all. So today, for the next 20 minutes, I will be discussing novel treatment options in lung cancer, focus on pembrolizumab. So coming to my disclosures, the slide deck is provided entirely by the MSD team. And this is the brief tables of contents which I will be describing. We will be discussing today. So first will be the disease burden of the lung cancer existing presently, and the lung cancer classification. So first 30-25 slides will be basics, more or less basics, and then we move to role of pembrolizumab or immunotherapy. Then we come to the key trials, landmark trials associated with pembrolizumab. So lung classification, then diagnosis and staging of lung cancer, and the differential diagnosis like pulmonary tuberculosis for lung cancer, and treatment options presently existing, and immunotherapy in that role of pembrolizumab. And coming to the few landmark trials like Keynote 024, 010, 189, and 407. At various levels of PDL1, first line, second line, these are the various trials, and brief summary to the end. So with this brief content, so we'll move on to it topic by topic. So coming to disease burden of lung cancer. So the new cancers and death worldwide, this is the Globocon data of 2020. So we all know incidence-wise, lung cancer is the second most common. And coming to mortality, lung cancer is the predominant most common cause, up to 18%. So this is by cancer site and worldwide data. And coming to the Indian data. So Indian data, breast cancer is the most common cause of incidence wise, and lung cancer is 4th most common cause, 5.5%. Next, coming to classification. So we all know lung cancer classification, histology-wise, non-small cell, which is predominant 80 to 85%, and small cell component, which is about 15 to 20%. And coming to non-small cell histology, adenocarcinoma is predominant with 40 to 45%, and squamous 20%, and others mixed being adenosquamous or other mixed combination varieties being 40%. So now we all know all the lung cancer stages are subjected to molecular testing, and this is one study with 154 patients. Though we have a lot of patients with many more studies with thousands of patients also. But this study, what it has implied is EGFR is being predominant with 32.4%, which is targetable. But of course, TP53 gene is predominantly seen in 37.6%, which has a Q mutation, which we see in many of the NGS reports. Then KRAS being 18.2%, and ERBB2, had to being 3.2%, and BRAF being about 2%, and other mutations. So this is the brief. And overall, the picture says EGFR, the targetable mutations, EGFR is the common one. Yeah. So coming to some brief discussion about the pathogenesis, the possible or probable causative of stem cells of bronchus or basal cells, which are believed to give rise to differentiation of like ciliated cells, mucus, and neuroendocrine cells. So the lung cancer may arise from these differentiated and undifferentiated cells, which are either from central, could be small cell carcinoma and squamous, and or peripheral adenocarcinoma. The interactions between the inhaled carcinogens and epithelium of airway, upper and lower airways, leads to formation of DNA adducts. So if these adducts are persisting or misrepaired, they result in mutation and cause genomic alterations. So lung cancer pathogenesis is also affected by genetic component, which leads to host susceptibility to lung cancer, with or without the exposure to carcinogens. So predominantly carcinogens like smoking, history and all, so it leads to alteration of DNA adducts, misrepairing, and cause the malignancy. So that's about the pathogenesis. So far you discussed about classification, incidence, prevalence, and classification, and pathogenesis. Now we'll move on to staging of the lung cancer and diagnosis. So it's a multidisciplinary team management. So it starts from the patient itself who presents with the symptoms. Then primary care physician orders for the diagnostic tests based on his clinical performance, what all could be the possible tests to be done immediately. Then based on the staging, surgical intervention, radiation oncologist and pulmonologist will be brought into picture. Before that, tissue has to be collected. And once tissue is collected, pathologist will be doing the morphology testing, then IHC. Then based on that, we proceed for molecular testing. So earlier days we used to do like when the NGS was quite costly or were not widely available, we used to do PCR, ALK, and ROS limited tests, and PDL1 in addition. But now with the prevalence of the many gene panels, limited gene panel, lung gene panel, and advanced gene panels, and thanks to many few companies which have come forward and giving NGS for free, the 72 gene panel. So with this, we could be able to generate more data, predominantly in the molecular field. And then pathologist performs the NGS and MDT discussion. What's the final plan to the patient based on the final stage? So same, this is the timeline. So initially when patient comes, usually by 1 week, entire workup in the first 3-4 days, entire workup will be done. Then sample will be sent for biopsy. And we know the TAT time for getting biopsy is usually 1 week. But if the patient is sick or if he needs immediate, so we can get by 48 hours PCR test, IHC, even PCR test EGFR, which we used to do earlier. But TAT time usually for molecular testing is about 2 to 3 weeks. So meanwhile, if patient is symptomatic, we can proceed for chemo based on the stage. If not, then we can wait for the molecular testing reports. That's the common practice which we will be doing. So then coming to the imaging, so most of the patients present to us by outside clinician or physician or surgeon so most of us, many of us come with the PET scan already, but these are the various modalities which could be done. And MRI brain also, which used to be done. So what are the various molecular testings done? Once the diagnosis is established, and after smoking cessation counseling and integrating palliative care for metastatic setting cases, so if the final HPR is adenocarcinoma, large cell, or non-small cell not otherwise specified, then this is what the 9 gene panel or 14 gene panel, whatever we are doing, simple lung panel along with PDL1 testing and IHC. This can be done as a must for all. And if a squamous, based on their smoking status and other comorbidities, even squamous patients also deserve molecular testing, because we do see even in squamous also EGFR coming positive and few other mutations positive, and PDL1 is also needed for those based on the PD-L1 status, we can go for the immunotherapy with chemotherapy in metastatic settings. So all these things. So even squamous cell patient. So simply, irrespective of histology, we can proceed for NGS testing in the present scenario with the available medications. So coming to differential diagnosis. So patients with, so this is one of the very common scenario in our country. So patients with lung cancer are often misdiagnosed as tuberculosis. And several factors are responsible. That's because of lack of awareness, inadequate infrastructure, socioeconomic factors. So still, I do see some patients, even by seeing X-ray, many of patients being started in few of the remote areas, anti-tubercular treatments, and later, once patient has progressed and he has come in a very bad comorbid performance status, then diagnosed to have malignancy. So still, it's happening. So that's why there is a lack of awareness. And this leads to delay in treatment and also diagnosis. And there are many similarities between both the disease, like tuberculosis and malignancy. Like both are very common, high prevalence, involve the lung parenchyma, and above all, characterized by similar symptoms. So like cough, hemoptysis, breathlessness. So it all depends. Pleural effusion, if there's pleural effusion, it could be because of tuberculosis or also even malignancy. So a missed or wrong diagnosis of lung cancer by clinician or general practitioner can lead to delay in the treatment or wrong treatment entirely. And if the clinicians, including the general practitioners, are aware of the predisposing factors and the effect of bronchogenic carcinoma, this may lead to an early diagnosis of cancer and better treatment outcomes in the patients. So coming to the treatment options. So far, past 8 minutes or 9 minutes, we have discussed about, in brief, about basics of lung cancer or basics of lung. So now for the next 10 minutes, we'll be discussing about the management. So what are the available treatment options and how bad is lung disease? So many patients with non-small cell are diagnosed with advanced disease. So if you see up to about 85%, 80 to 85% present with advanced stage. And stage 1, about 3% in stage 1, about 3 to 5% in stage 2. And stage 3 more or less about 8%. And remaining 85% constitutes advanced stage. And if you see the survival by stage, of course, this is way back in 2016. The survival, if you see stage 4A and 4B is almost 0%. But now with the targeted therapy era and precision medicine era and immunotherapy era, we could see 4B patients also being surviving for long. Even I will show you a few slides with 5-year survival rates of few diseases, irrespective of PD-L1 status or PD-L1 positive, or based on the scores, we will see what's happening with the PD-L1 status and immunotherapy era. And if they are EGFR and ALK positive also, we have excellent drugs which are showing great 5-year survival rates, but not 0 at least. So coming to summary, early stage, we all know surgery and adjuvant therapy if nodal disease or more than 4 centimeter based on the latest trial. And of course, if more 1B and all, we have even if EGFR positive and also if ALK positive, we have data for adjuvant studies. And SBRT for patients with unfit for surgery. And locally advanced multimodality for stage 3. Inoperable cases, concurrent chemoradiotherapy followed by immunotherapy and as a consolidation. Definitely CTRT followed by radiotherapy. This is the fun for locally advanced what we are following. And of course, even in locally advanced now we got perioperative immunotherapy role, preoperative neoadjuvant role, immunotherapy, multiple advances have come. And metastatic disease all depends on patient fitness, patient molecular NGS or molecular study status and PD-L1 biomarker studies. So more or less, more than all this, molecular fitness, patient fitness is important. And considering his more performance status and coming to molecular status is smoking, sex, female. So these are the things we can consider and have a assumption probably that they could be target therapy being positive, so they would do well. So these are important factors to consider before starting any therapy. Because I'll see if you see some NCCN guidelines, PS 3 to 4 best supportive care. They don't even suggest treatment therapies also. But that's not the real scenario. We have to go by patient. If performance status is not good, if there is spinal cord compression, patient will come in PS4. It doesn't mean that he has to call off. So assessing the patient condition, comorbidities, and why he is in such a condition, these are the main crucial factors in considering the treatment. So yeah, chemotherapy, targeted therapy, and immune checkpoint era inhibitors. These are the 3 modalities in various phases, in various modalities being curative setting, palliative, metastatic setting. These are the various modalities which are being used. So NCCN recommendations coming for metastatic disease or non-small cell in brief, PD-L1 more than 50% in adenocarcinoma, pembrolizumab, or other immunotherapy agents. But also, even if above more than 50%, pembrolizumab with combination chemotherapy like pemetrexate, carboplatin can be given, or ABCP regimens, or nab-paclitaxel bound regimens, and semipilimab and tremelimab, durvalumab based regimens can be given. And also a few indications, nivolumab and ipilimumab also. Similarly, in squamous, pembrolizumab alone if PD-L1 more than 50%, or other immunotherapy molecules alone, or a combination therapy with paclitaxel carboplatin with immunotherapy also can be given. With pembrolizumab, paclitaxel carboplatin can be given as a priority, category 1 recommendations. And in addition, other immunotherapy molecules are also being tried and recommended. So coming to PD-L1 score from 1 to 49%, same, 1 to 49% combination therapy, immunotherapy with chemotherapy, pemetrexed with pembrolizumab with pemetrexed carboplatin is the standard recommended preferred choice. Also other regimens can be tried. And squamous, instead of pemetrexed, paclitaxel or now albumin-bound paclitaxel with carboplatin and pembrolizumab. In addition, other medicines also can be tried, and few indications patients are not so fit enough, then monotherapy also can be given. But that's not a standard, but it depends on patient-to-patient assessment. So yeah, as I already said, PS 3 to 4 best subparticular, but definitely no. The patient consideration factors are very important. And PS 0 to 2, yes, biomarker-directed therapy, and if there is a response, continue the therapy. But if there is a progression, change the therapy. That's a simple, basic thing. So this is about so far same what you have discussed earlier, based on the PD-L1 status and contraindications to immunotherapy or not, based on this chemotherapy alone or chemotherapy with immunotherapy can be tried. So what happens? So already this my colleague Dr. Bhavesh has discussed today morning, PD-L1 negative. So in these patients, is there role of immunotherapy, pembrolizumab? Yes, definitely yes. There is data which is favoring with a survival benefit also. So not that irrespective of PD-L1 status, pembrolizumab has its own benefit and outcomes. So same, this also follows the same, even PD-L1 negative also, based on the performance status and histology, adeno versus squamous, to proceed with the chemotherapy and immunotherapy combinations. Yeah, this is for the squamous. So squamous and adeno, only thing is paclitaxel and pemetrexed will be deferred. So newer backbone. So far we have moved from chemo era to addition of targeted therapy, target therapy alone, or combination of target therapy with chemotherapy, immunotherapy with chemotherapy. So these are the various modalities which are going hand in hand, adding one to other, and finally for the patient benefit and survival and improved outcomes. So coming to role of pembrolizumab. So yeah, same. First line based on PD-L1 score, combination therapy. This is already described. So what exactly is the rationale for assessing PD-L1 expression? So upregulation of PD-L1 is a mechanism may used to avoid immune destruction. Expression of PD-L1 has been reported in many tumors, including non-small cell lung cancer. And NCCN practice guidelines recommend PD-L1 testing. And category 1 tests, other tests which are EGFR, ALK and PD-L1 testing. These three are at least must. At least they have role in curative setting as an adjuvant or in a palliative setting also, even if these are positive, good targeted agents in the first line. So pembrolizumab, we all know, almost all of us have given n number of times. So usual dose is 200 mg over 30 minutes and every 3 weekly, along with either monotherapy or combination chemotherapy. So what are the various landmark trials of pembrolizumab? So next 5 minutes we'll be discussing this. In non-squamous, that's adeno or other things, if PD-L1 more than 50%, the trial is Keynote 24, and if it's less than 50%, 189 along with chemotherapy. And similarly in squamous, more than 50, Keynote 24, and less than 50, Keynote 407. It's in the first line. And coming to second line, Keynote 010 in PD-L1 more than 1%. So in second line, PD-L1 more than or equal to 1%, and in first line, more than 50 or less than 50. That's how they are. So coming to the first trial, Keynote 024 in PD-L1 first line treatment, TPS more than or equal to 50. So all the studies I described, first 3 studies, the eligibility criteria is same, no EGFR ALK, PS 0 to 1, untreated stage 4, PD-L1 more than 50%, and no untreated brain mets and no other active or no contraindications for immunotherapy. So this study primary endpoint is PFS with secondary endpoint being OS, and other endpoints are overall response, safety. So randomized 1:1 chemo versus immunotherapy, and immunotherapy is continued for 2 years, and maybe second course of immunotherapy was given either patients who have completed 2 years and relapsed later, or because of after achieving CR they have stopped immunotherapy for some or the other reasons, they can be restarted. Those are the patients who underwent second course. And overlap crossover has happened in other arm, chemotherapy arm, who have progressed crossover to pembrolizumab. So overall survival, so here the overall survival, median overall survival is 26.3. This is in more than 50%, monotherapy alone versus 13.4, and 66% crossover has happened in the other arm, standard arm with chemotherapy arm. So if you see 5-year OS, 32% versus 16.3%. Monotherapy of pembrolizumab. So coming to PFS, median PFS is about 7.7 versus 5.5, and about a 3-year PFS was about 22 versus 4%. And objective response, about 46% objective response in pembro versus 31 in the chemo arm, and duration of response was about 29 months versus 6.3 in chemotherapy arm. Adverse events, more or less tolerated, no alarming adverse events, which and toxicities reported with pembrolizumab alone. So coming to other study, chemo with immunotherapy in keynote 189, from 1 to 49% of PD-L1 score. So more or less this is same eligibility criteria. Endpoints, primary is OS and PFS here. Secondary are other response rate, safety analysis and all. So chemo, pemetrexed with platin and pembrolizumab versus placebo and chemo arm. So OS, if you see here, protocol specified, it was about, OS is about 22 months in the pembro arm versus 10.6 months with a hazard ratio of 0.6. And 5-year OS is about 19.4% versus 11.3%. And PFS is about 9 months versus 4.9 months, median PFS. And 5-year PFS is 7.5 months versus 0.6 months with a hazard, and median PFS hazard ratio is 0.5. And tumor response rates are well maintained. And outcomes, if you see overall response rates in 86%, and median duration of response is about 57.7 months. And safety, more or less all patients tolerated well, no alarming symptoms and no major symptoms. So with 5-year pembrolizumab with pemetrexed maintained OS PFS benefit versus placebo. And coming to squamous, 407, here the chemo arm is, as we already discussed, Paclitaxel with carboplatin with pembrolizumab. And so primary endpoints are PFS and OS, secondary are overall response rates. And so if you see median median PFS is about 17.2 months OS versus 11.6 months with a hazard ratio of 0.71, and 5-year OS was 18 months versus 18% versus 10%. And PFS, 5-year PFS was 10.8 versus 3.5%, and median of 8 versus 5.1. Yeah, tumor response rate, duration of response also. If you see here, PD-L1 less than 1% also in the down. So if you see, not that there is no response, even less than 1% also there is response, PD-L1 less than 1% or more or less like negative. Yeah, so the outcomes, overall response rate about 90% if you can see. And safety, well tolerated, no issues. So this is the conclusion about this study in squamous. So it is recommended in squamous also. Second line, so PD-L1 more than 1%. So here only pembrolizumab versus chemotherapy. So overall survival, more than 50% is about 0.55 hazard ratio, 34.5 versus 12.6, and 5 years 25 versus 8, and more than 1%, 15.6% versus 6.5%. PFS, more than 50% is 18.2 versus not in 5 years, and 9.4 versus 0.7% for more than 1%. Overall response rates also well maintained and sustained along. Yeah, coming to summary, lung cancer is one of the leading cause, and may arise from differentiated and exposed non-smokers also have increased relative risk of developing cancer. TNM stating treatment options, still pembrolizumab, immunotherapy and target therapy plays very crucial role in the management. And coming to various all these trials, PD-L1%, even negative also doing well with pembrolizumab, more than 50% alone, 1 to 14% combination. Yeah, thank you. Thank you. And I thank Prashant sir and Lakshmi madam for giving the opportunity.
Thank you, doctor, for your valuable insights. Moving forward with the next session, the art of palliation in lung cancer, I would like to request our chairperson, Dr. J.K. Saini sir, to grace the stage. I would like to call upon Dr. Gopal Krishna, MS, onto the stage to deliver a talk on endobronchial palliation and refractory pleural effusion, optimizing symptom control in advanced lung cancer.
Good evening, one and all. First of all, my sincere thanks to Prashant and his team for giving this great opportunity. And today I'm going to talk about the optimizing symptom control in advanced lung cancer, especially focusing on endobronchial palpation and refractory pleural effusion, which are both two important and impactful pulmonary interventions what usually we'll offer from interventional pulmonology to the end-stage lung cancer. And this is where I work. I'm from Vijayawada, and I'm working in Ayush Hospital since 15 years. And coming to the lung cancer, the leading cause of cancer-related mortality and morbidity. And unfortunately, most of our patients will present at the late stage, that is stage 3B and 4. And most of the times, so we have to offer only the palliative care rather than a cure. So our focus is shifting from cure to care now. And so it's a palliative care is a continuum and not the end. So coming to the, what is palliative care? So we have a classical definition by WHO, an approach that improves the quality of life of patients and families facing life-threatening illness. So the palliative care not only offers the symptomatic treatment, but also include the psychological support, spiritual well-being, communication, and decision-making. So it's not the giving up, it's an active and compassionate care. So coming to the art of palliation. So art of palliation is not just a science, it's an art, because we have to balance the science and empathy. And it's what the most important thing what we need for art of palliation is active listening, compassion, and cultural sensitivity. So, and the art needs more of timing, that is when to talk to the patient and family, and what tone we have to talk, and finally it's a teamwork, how to program the treatment and how to individualize the treatment, because every patient is a unique, every disease is unique. So we have to customize the treatment plan according to the patient needs and disease pattern. So coming to the common symptoms what we encountered during the lung cancer practice, the first is the dyspnea, this which accounts for 60 to 80%, followed by cough 50 to 70%, and hemoptysis will be seen in 20 to 30%. And the most important thing is the pain, which accounts for 40 to 80% of patients will need a palliative care, especially patients with lung cancer. So the common complications where the lung cancer related complications need palliative care are central airway obstruction, which accounts for 20 to 30%, followed by the most important thing is the recurrent pleural effusions, which accounts for 50 to 55%. And in some case of hemoptysis, approximately 20% of patients may need palliative care. Sorry. So what is meant by endobronchial palliation? So the interventions aimed at relieving the airway obstruction caused by the tumor in growth. So our aim is to relieve the obstruction, restore the breath, and improve the quality of life. So here we can see the n number of causes where the endobronchial lumen will be compromised. So the etiology maybe is different, but the pathology is same. It may be either primary cancer or maybe a metastatic tumor can involve and can invade the bronchi, can cause endobronchial luminal obstruction, which may need a palliative care. So our aim that obstruction can be a endoluminal or an extraluminal, and sometimes it may be a mixed. So the pathophysiology behind the endoluminal obstruction is mainly, it can be either a fixed obstruction or it may be a variable obstruction. And the symptoms mainly depends upon the level of obstruction. So usually the patients may develop dyspnea on exertion when the tracheal lumen was compromised to 8 mm, or if it is the more than 50% of lumen was compromised. And patient may become dyspneic at rest when the tracheal lumen is narrowed to 5 mm, or if it is the lumen is reduced to 25% of its original diameter. And these are the common symptoms we'll encounter during advanced lung cancer: cough, breathing difficulty, hemoptysis, chest pain, stridor, hoarseness, and dysphagia. All these things need to be addressed, and we have to have a proper plan for management of all these symptoms. And apart from treating the symptoms, palliation also offers, sometimes it may need to relieve the post-obstructive collapse or infection. And sometimes it could be a bridging procedure. So before going for systemic therapy, we need to do some palliative procedure and make the patient to fit for that systemic therapy, also come under palliation. Then coming to the endobronchial obstruction, for diagnosis, we need to have a proper imaging, which includes especially the CT and PET CT, that it will give a precise information regarding the airway anatomy and invasion of the tumor lesion and the vascularity of the surrounding structures. So we can plan the treatment according to the lesion and its pathology. And spirometry sometimes is needed, especially to identify and to qualify the respiratory physiology. And bronchoscopy is the gold standard treatment. It will give a precise information regarding the airways, the amount of invasion and infiltration of the airways. So the aim or the goal of endoluminal obstruction is mainly the palliative debulking, especially when the tumor is infiltrating the airway lumen. And airway stabilization, if it is the tumor is causing an extrinsic obstruction, so the airway stabilization can be provided with the help of airway stents. And with these both palliative debulking techniques and airway stabilization with stents, we can offer airway restoration completely. Again, the palliative care is not a single man show, it's a multimodality treatment. You need to have all the other specialty support, and you need to have both the flexible and rigid bronchoscope and other instruments like airway stents and bronchial blockers. All these things are mandatory. And coming to the flexible and rigid bronchoscope, most of the times we use both the rigid and flexible. And the advantage, each scope is unique, and especially the rigid is more useful for all these palliative procedures because of its advantage having a better airway control, and we can able to control the bleed perfectly with the rigid bronchoscope rather than a flexible bronchoscope. Though coming to the treatment modalities, the thermal ablation techniques commonly what we'll use for palliative ablation are laser, electrocautery, and APC. Laser is a little bit expensive, may not offer many centers, but poor man's laser is electrocautery, which is available in all hospitals. So can do all these ablative procedures with the electrocautery available in the hospitals very safely. And APC is especially for to rapid hemostasis circulation, especially a bleeding tumor. And non-thermal interventions like cryo, dilatation, debridement, and stent are useful for airway restoration. And most of the times we need all these kind of instruments for palliation of airway tumor. And this is the algorithm usually we'll follow, and depends upon the complexity of the tumor, that is, it is endoluminal or extrinsic or maybe mixed. And so we have to plan the treatment and tailor the treatment according to the patient's disease nature. So we can offer the treatment, either it may be a simple debulking, or sometimes we may combine the procedure either with a debulking and stent, or sometimes we have to do an extra procedures, or sometimes we have to do an ablative procedure for a bleeding tumor. I want to show you one good case, where the palliative care is the treatment of choice. This is a case of a 50-year-old female known to have carcinoma lung, which was adenocarcinoma, was diagnosed almost 15 years back, 10 years back, and she received the chemo. And now she presented with the tracheal metastasis, and as a routine, like she presented in a severe respiratory distress state. And this is the CT, and you can see the bronchoscopic image here. The entire left lung is gone due to the previous tumor, and we cannot even identify the tumor. The entire mediastinum was shifted into the left hemithorax, and what you are seeing is the right lung. And you can see the tracheal lumen was having a critical narrowing by the highly vascular tumor. And you can see the bronchoscopic image, how the tumor is aggressive, and it's highly vascular, and the patient was presented in the emergency situation, and even without any diagnosis. That means the biopsy was also not done. So this is how the patient was presented in the emergency. So you can see the tumor occupying the lower portion of the trachea with engorged vessels all over the tumor, and the patient was in severe respiratory distress. So here in this case, we need to have a biopsy to confirm the diagnosis, whether it's a primary tumor or it's a metastatic tumor from the pre-existing mass. And at the same time, we have to restore the airway by doing a debulking, and at the same time, we have to restore the airway and maintain the patency of the airway by placing a stent. So what we did here, we did a rigid bronchoscopy, and initially we did the tumor debulking at the same time by securing the hemostasis. So we used here the electrocautery snare to cut the tumor. So just we ensnared the electrocautery snare around the tumor, and so we can able to cut the tumor with the electrocautery snare. So here you can see the snare was firing, so the tumor was cut, and so the entire posterior wall tumor was removed. We can able to achieve the luminal patency completely. And now I am extracting the tumor. So you can see the chunk of tumor is coming out of the airway. And after doing the hemostasis with the APC, so what we did, and we placed a stent. The problem here is like the tumor was involving the carina. So where to place the stent? Because the ideally it needs a Y stent, but the problem here is the left main bronchus was completely occluded. I don't have an opening for the left main bronchus. So, but I have to secure the carina as well as the lower trachea. So what we did here, we placed a straight stent. The distal end of the stent was deployed in the right main bronchus, and the proximal end was brought into the trachea. So we covered the right bronchus, and we bypassed the left main stem bronchus, and we covered the entire lower trachea. So this is the stent where you can see the stent, the distal end was there in the right bronchus, and you can see all the patent right lower lobe and upper lobe bronchi. And the left bronchus was bypassed, and the airway was protected by placing the stent here. So this, I think this is the best example of a palliative care. So we did here a debulking procedure, and at the same time we restored the airway by placing the stent, and we can able to do a tissue biopsy and everything in the same sitting. I think this is the best example of palliative care, and this is the post-operative X-ray. You can see the stent here, which was sitting in the right main bronchus, extending into the trachea. So endobronchial palliation can provide a symptomatic relief, especially breathlessness can get relief in 70 to 90% of cases, and improve the quality of life and oxygenation. And it allows the patient to continue the systemic therapy and reduce the risk of emergency airway interventions. Then coming to the refractory malignant pleural effusion, which is a very common manifestation of advanced lung malignancy. And it is defined as recurrence of pleural effusion in spite of optimal pleurodesis or drainage. And this is the most common cause of dyspnea and pain, especially with advanced lung cancers, which indicates the poor quality of life and advanced stage of the disease. The pathophysiology is very simple: tumor invasion into the pleural cavity and increased capillary permeability. All this can lead to a refractory pleural effusion, and most of the times it's associated with a very poor guarded prognosis. So the clinical manifestations of a refractory pleural effusion is rapidly progressing breathlessness and chest pain. And most of the times, the recurrence happens immediately after thoracentesis. And how will you approach the refractory pleural effusion? We need to have a precise imaging which includes the ultrasound and CT that give a proper picture of the pleural cavity. So the ultrasound and CT can show the clear image of pleural cavity, that is about the adhesions, pleural thickening and all. And what the procedure, palliative procedure will offer for a refractory pleural effusion or repeat thoracentesis, indwelling pleural catheters, the chemical pleurodesis, and thoracoscopy is the gold standard that can offer both diagnostic and as well as therapeutic procedure. And targeted therapy is sometimes it is needed. And this is the algorithm usually will follow for a refractory pleural effusion. If there is no any trapping of lung, so talc pleurodesis is the ideal or goal, ideal of treatment. And if lung is trapped, then IPC is the treatment of choice. So IPC is now emerging is a promising procedure for management of refractory pleural effusion. So because it's a daycare procedure, can be inserted very easily, and patient's compliance is very good. And the best good thing is that it's a self-manageable. So apart from the malignancy, we can use the IPC in other situations like refractory heart failure, refractory hepatic hydrothorax, and infections due to chronic lung diseases. All these things, all these conditions, we can use the IPC. It is usually made up of a silicone catheter, and it will have a multifenestrated tube with a polyester cuff in the middle of the tube. So this polyester cuff can induce the fibrosis in the pleural, especially in the subcutaneous layer, that can prevent that prevents the dislocation of the tube from the pleural cavity, and at the same time it prevents the spread of infection into the pleural cavity. And the best advantage of these IPCs are like it's provided vacuum containers, so the patient can manage himself at home, and he can drain the fluid himself at home with the provided training. So as like other any procedure, the IPC also having some complications. Sorry, just I can take one more minute. This IPC can cause pleural infections and catheter tract metastasis, symptomatic loculations, and chest pain. All these are the complications of IPC. The most important thing is the cost, because it costs around 50,000. So most of the advanced malignancy patients may not may not afford this IPC. So we came with a simple solution. So here we use the simple surgical drain as a replacement for this conventional or commercial in IPC. Here we can reduce the cost enormously, which this cost not more than 1,500. So we use this surgical drain as an indwelling pleural catheter, and we did for approximately 50 patients, and the results were very promising. The technique is same like IPC, and the results are very good. And actually we compared this surgical drain with our own IPC experience, and the results are very promising, and there is no much side effects. And finally, we presented this paper in the World Congress of Bronchology and Interventional Pulmonology in 2022. So the take-home message: the repeated thoracentesis in refractory pleural effusion can cause infections, adhesions, and loculations. Chest drain can give a rapid symptomatic relief, but causes increased pleural risk of infection. Thoracoscopy is the diagnostic, so it can offer both diagnostic and therapeutic. Pleurodesis is not useful, especially in trapped lungs and collapse. Indwelling pleural catheters can provide symptomatic relief and safe, and it is self-manageable. Thank you.
Thank you, Doctor. That was a very insightful discussion. Up next, I would like to call upon Dr. Rajini Surender Bhatt for talk on integration of early palliation care in lung cancer evidence and clinical practice.
Thank you very much for this invitation to be part of this wonderful program. I'd like to thank Dr. Prashant, Dr. Lakshmi Sandhya, and Dr. Ravi Kumar, who isn't here, but who've been in touch. And thank you very much for the wonderful hospitality. It's been a wonderful morning listening to all the programs. My topic is integration of early palliative care in lung cancer, and it's sort of ironical that usually palliative care is always the very last topic on most conferences about any subject. So I do think it will be wonderful if we start introducing early palliative care in all academic sessions as well. And this is something that I think has been a wonderful trend that we've been seeing across all specialties in pulmonology, definitely. So all the national conferences in pulmonology, in bronchoscopy, whether it's the Indian Association of bronchoscopy or even the Indian Society of Heart and Lung Transplant, now spend a good amount of time on palliative medicine. The scope of palliative medicine in India has expanded. We've had an MD in palliative medicine since 2012, and now there are DNB courses as well that are available. That being said, palliative medicine as a specialty has been practiced in India for more than 32 plus years. So this year was the 32nd or the 34th Indian Association of Palliative Care Conference in Jammu in February. So I'm just going to do a quick temperature check. How many people in this room have full-fledged palliative medicine departments at the places where you work at? So not too many hands going up. How many have pain management? A lot more hands for pain management. So I think we're getting somewhere, and the whole idea is to learn that and understand that pain management is one part of it, and palliative medicine has got a much wider scope of practice. My interest in palliative medicine as a physician doing pulmonary, critical care and interventional pulmonology started about 10 years ago when I saw this fabulous paper. It's about early integrated palliative care for patients with advanced respiratory disease, and it included patients with lung cancer, COPD, ILD, all dependent on oxygen. And they were randomized to either receive the best possible treatment for whatever their disease was, COPD, ILD, lung cancer, or early integrated palliative care for breathlessness support services. Surprise, surprise, survival benefit. And no surprises, reduced emergency room visits, reduced hospitalizations, and less death in an ICU. Now, if this were a drug, all of us would be using it, but it's not. It's palliative care, it's multidisciplinary, so we don't yet use it as much as we should. If we had a drug which for any cancer told you, we've listened to a lot of talk which was about, if this is going to give you an overall survival benefit, would you do it? Yes, we would push for every 6 months that we could get. And here there is a modality of treatment that could definitely give you 3 months, 6 months, 1 year, 5 years, much more, only if we use it wisely. So what is the need for early palliative care? Because it does give you survival benefit, not just quality of life benefit. And it addresses not just the patient, it addresses the caregiver as well. We incorporate non-pharmacological and pharmacological modalities and procedures. Dr. Gopalakrishna gave us a nice example earlier of the kind of palliative care, interventional, endoscopic palliative care procedures that are available. Advanced medical directives, end-of-life care, making sure that the end of life is not distressing. And there's one statement that we say often in palliative care: the way in which we die lives on in the memories of those we leave behind. So it's making sure that the trauma of the death of a loved one does not mar the memory of a life well lived for the caregivers you leave behind. This has changed dramatically the practice of palliative care over the last several years. So the survival benefit with palliative care has made us realize that we need to integrate it earlier. I have an earlier one of the ATS statement from even 10 years prior, 2002 or something like that, where it was treatment and there's a proper sharp demarcation and then palliative care, and now then it started integrating. And now more recently we have statements which tell us when do we start integrating palliative care. And it's literally at the time of diagnosis of any life-limiting illness. So primary palliative care by the primary physician, whoever is the one who's diagnosing the illness, starts early. And you need specialist palliative care only when the palliative care needs become more complex for a patient. But so for lung cancer, ideally, early palliative care is defined temporally from the time of diagnosis. We spoke about what is early lung cancer, and there were lots of definitions about what would you call early stage, what would you call late stage. And we saw a disparity in views here. Early palliative care is something that is rarely practiced in our country. Most of the time, I see patients referred to me in this area, where they are already in the end-of-life phase, and I'm called in more for active care at the end of life, in the active phase of dying, or to declare somebody DNR, DNI, convince the family. But if I had been referred early, if I'd been asked to see the patient earlier, I might have had much more that I could offer for palliative care, for quality of life. So the whole idea of bringing us in early is defined by time, 31 to 365 days within the diagnosis. That's called early palliative care according to multiple papers. So when we do meta-analysis of reviews of papers which have looked at early palliative care, they have ranged from 31 days to 365 days of diagnosis, within 1 month to 1 year of diagnosis. I usually see them in the last 1 month of life. So I would really urge everyone to rethink and start scoping out. There are directories available of palliative medicine services across India. Reach out, make connections with your friends in palliative medicine. It will allow our patients to live longer, better quality of life. We've moved away in cancer care. The landmark study, which I'm going to show you later, just a little glimpse of it, was in 2010. It was Jennifer Temmel and others at MGH. And that was early integrated palliative care for advanced non-small cell lung cancer. And they had an improved survival benefit by 3.5 months. From 2010 to now, in 2025, how much has lung cancer treatment advanced? You've already got much better therapies. You've got better diagnostic modalities, more screening happening, catching it early, but the referral to palliative care remains still desirable. It's only coming in the later stage, because now we are moving into survivorship care, and survivorship is a different game altogether. Our patients are living longer with cancer, with disease burden. There's plenty of evidence, as I said, for the benefit of early palliative care. We have all these studies from about 15 years ago, all of them showing improved quality of life. I would say 65% of studies have definitive evidence that early integrated palliative care improves quality of life. About 50% of them will tell you that there's reduced hospitalization, and there will be that many that say that these patients will not spend the end of their life in an ICU away from family and not using non-beneficial treatments like ventilation and things like that. So advanced care planning, goals of care discussions, and appropriate utilization of health resources and money. Financial toxicity is huge in cancer care in India. So having palliative care come in early actually allows you to use that money wisely. What is early palliative care then? What is your trigger for referral? So is it severe physical symptoms? Is it patient's request for certain things? Is it certain advanced acute palliative care emergencies that come up with spinal cord compression or delirium, things like that? And now we realize that it's a combination of these things. It really needs to be driven by the primary care physician. So even if the patient is not saying it, if you know that it can offer, bring us in early, then it doesn't seem like we are called in just when there is no hope left. I have a very fortunate situation where the medical oncologist and the surgical oncologist, their offices are right opposite mine, and I consult with them as a pulmonologist as well as a palliative medicine physician. But I know that what we have is a tiny little oasis where we are able to provide integrated care for our patients, and therefore I know that it can be done, even though the models might be different, and we look at how that can be possibly integrated into different areas. Early on, about 2017 or 18, there was a study for the feasibility of introducing early palliative care in ambulatory patients with advanced lung cancer. This is a study out of Tata Memorial Hospital. And over here, they found that only about 30% of patients kept their follow-up appointments in palliative care, even if they were referred at the time of diagnosis at TMH. That was mainly because it's a referral center and patients went on to other places. And at that time, we didn't yet have the network that we have now of the Directory of Palliative Care of the Indian Association of Palliative Care and the number of specialized palliative care centers that are coming up. I think things have changed now. So you now have, in the post-COVID, post-pandemic era, with the advent of telemedicine and acceptance of telemedicine, you have studies now coming out of AIIMS New Delhi, where telemedicine has proven to be a way that even if you've had your initial visit in person with the palliative medicine department, you could continue on with telemedicine and still get the benefit of early integrated palliative care. One of the most difficult symptoms to treat is breathlessness. That's my area of interest, chronic refractory breathlessness. Availability of morphine becomes a challenge for many of our patients. Again, quick show of hands, how many people have access to outpatient morphine for dispensing to patients? Very few hands. This is actually something we put down as a requirement to be a center of excellence. Now, this is something we're proposing, that if you are a center of excellence for cancer, you should be able to dispense morphine for outpatients, because you are going to have a lot of patients who have refractory pain or refractory breathlessness, and it's not okay to just give them relief while they're in the hospital with you. They will need it for the next several months as they progress towards the end of their life. They need connections to maintain it. If they are coming to you as a referral center, how will they continue to access morphine where they go? So there is a push to bring palliative medicine to the primary health center level. Some states have done it well. In other states where you do not have well-organized networks of community-based palliative medicine, reach out to NGOs near you. There is a lot of non-profit organizations which work on pain relief and access to morphine, and they will be able to help your patients. So making the connections, reaching across to people in pain management who have access to morphine, outpatient morphine to be delivered to patients at home would make a great difference. How do I check in on my patients on a day-to-day basis? When they come in to see me, how are you today is the main idea, right? High symptom burden in our cancer patients. You already heard Dr. Gopal speak about the percentages of patients who have these burdens. 50 to 70% of patients, high symptom burden for a long period of time. We tend to look at them in symptom clusters. I can't solve all their problems. They will probably have 7 or 8 complaints, all of them at a rating which is 5 or 7 out of 10 and more. Let's look at the 3 most pressing concerns. If I can make that better over the next 2 weeks and then continuously improve further. Are the symptoms related to the primary underlying condition? Are they related to surgery, radiation, or the medications? And what are the sequelae and disability that the patient is left with? That is what we try to solve with palliative medicine. We're looking at not just physical pain, we look at total pain. So that's physical, psychological, social, and spiritual. And with that, I'm going to go into a couple of cases. Young 55-year-old male, surprise, surprise, he's that one person whom you find very early in lung cancer, right? The kind we never usually see. He's referred to pulmonology by an ophthalmologist for anterior uveitis. His IGRA is positive, MANTU is positive. He has a small lesion on the X-ray. CT chest is done, a small area of consolidation with minimal cavitation. He's sent to us for a radial EBIS-guided transbronchial biopsy. Turns out to be adeno-CA. No lesions on the PET, undergoes a robotic right lower lobe lobectomy. He's upstaged at the time of surgery, is treated with chemotherapy, receives radiation, and then has persistent cough and breathlessness. He has a repeat CT scan, paramediastinal GGOs, initially treated with steroids for radiation, for post-radiation pneumonitis. The cough persists, the breathlessness goes away, the hypoxia goes away, but there is severe intractable cough. It's like, you should listen to this man cough. He's got hacking cough, his ribs are hurting, severe anxiety in the wife. This was a late marriage. They have a 10-year-old child. It was a late marriage, many years of infertility treatment, a child who's only 12 years old. The patient and their wife's concern is he's too young. You have to give him the best options. Every little symptom that is not managed drives the anxiety up the wall. So here it was more a matter of working on cough, cough, cough. Cough is a pretty hard symptom to treat for many patients. So we used benzonatate, we used gabapentin, perinorm, voice and speech therapy. And we used counseling for the wife, because she was the one who was really freaking out. How many have access to oncopsychologists in your centers? Let's advocate for more oncopsychologists, because they're really so wonderful at being able to alleviate the whole family's journey with cancer. Because we're not just treating a patient, we are treating a family. A young man with a diagnosis of cancer, never smoker, scared about all of this. We have to address his wife and child's concerns too. 32-year-old man with a left lung pleomorphic leiomyosarcoma, metastatic now, 18 months prior. He comes to us after an episode of a cardiac tamponade, underwent a pericardiocentesis. We did what Dr. Gopal Krishna does, which is put in a Plurex catheter for the recurrent pleural effusion. Now, this is a young man, married just 2 years ago. 6 months into his marriage, he was diagnosed with this malignancy. He's the eldest of 3 brothers. He's the one who's taken care of the family always. And you ask him, what does he want? He says, I want every day that you can buy me, and I want every day in a way that I am contributing in a meaningful way to my family. I am the one who used to do all the shopping, all the groceries. I managed my brothers and my parents' finances. I need to continue doing that as long as you can possibly get that for me. So we work on management of his breathlessness, and we train the caregivers on managing the Plurex at home. We got him 2.5 more months with morphine, pregabalin, and nutritional support, managing his heart failure. And at the end of when the time came, he passed away in the ICU with his family at the bedside, no invasive measures, but full palliative sedation to make sure that he did not have severe breathlessness and distress at the end of life. The last case that I'm going to show you is an 84-year-old lady, former chess champion for Kerala State, a designer who's lived a full life. Again, advanced metastatic lung cancer, had been treated in another state, comes to us where her daughter lives in Karnataka. So she's brought to us at a point where she's been told no further treatment. But she has a strong desire to live as best as she can. She has milestones she wants to see. She has a grandson's wedding, another grandchild who's due with twins. So she wants to see these milestones. Our oncologist and the palliative medicine team worked together, made a plan for her. We got her another 18 months, all of it out of the hospital. All of it out of the hospital, with breathlessness managed, with her fatigue managed. Literally until Diwali, she was doing good. It's only around June that we went to best supportive care and said no further chemotherapy. And after that, she was managed well. Lot of anticipatory grief in the daughter. Wonderful Karunashray counselor who helped work with her. The patient died at home. So we work with the patient to decide, would you want the end to be at home? Do you want it to be in the hospital because the nursing needs might be too high? So that's the whole goal of palliative care. It's not just the patient, it's the family and how the end of life should be. One person who gets left behind in all lung cancer care is the caregiver, the immediate family. There's a wonderful resource available. It's called the Lung Connect India Foundation. Please do look it up. Refer your patients and their families to it. They have lots of videos which help the families to decode the medicalese that we talk. All these terms that we say and we think that our patients will understand. This is an organization that helps them. It's wonderful work that's being done. Reach out to all the possible sources of support for your patients beyond the medical, surgical, and radiation treatment that's possible. Thank you.
Thank you, Dr. Rajni. It's a great pleasure to listen to you. It was wonderful talk, and I would say it's a very nice and rare combination of pulmonary medicine with palliative care. And you have rightly pointed out so many symptoms, which is a challenge in day-to-day practice, coming to breathlessness at the end of life and cough, which is a huge challenge. Very well taken take-home messages. Thank you very much.
I would like to call upon Dr. Hanisha Pulavarappu to give her sponsored session on neoadjuvant non-small cell lung cancer with Opdita plus chemotherapy in neoadjuvant non-small cell lung cancer, the switch you need to optimize curative intent treatment for resectable cancers.
Good evening, everyone. At the outset, I would like to thank the organizers of Nalccon, Dr. Prashant Garu and Dr. Sandhya Madam, for giving me this opportunity, for coordinating everything so beautifully and organizing such great sessions. So today's topic is sponsored by BMS. This is a sponsored session. The role of Nivo plus chemo in neoadjuvant NSCLC, the switch you need to optimize cure for resectable NSCLC. Lung cancer is the most common cancer diagnosed worldwide. It is the foremost contributor to cancer-related deaths, resulting in 1.38 million deaths per year worldwide. According to the Globocon 2020 report, the estimated incidence of lung cancer in India was 72,510 cases. In India, majority, 90% of the lung cancers are diagnosed at an advanced stage of the disease. The reason for this we'll come to know later. Hardly 7% of the patients are diagnosed at an early stage in India. The 5-year survival rate remains poor, less than 10% in India, as opposed to Europe, where it is approximately double, that is 20%, and in the US, it is 15 to 19%. If you look at the estimates, worldwide estimates for NSCLC, 50% of them present in the non-metastatic stage, that is stage 1, 2, and 3.
J.K. Saini and Dr. Venkatesh for a group photograph, and Dr. Gopalakrishna if he's also there in the ground. So important announcements. Just a group photograph. Yeah. So the ISSLC GB will be conducted in Hall B. That's a Senate Hall. And parallelly, we will also have the quiz here, which will be conducted by Dr. Prakash. So we've actually done a preliminary round of quiz. It was an online quiz, and about 40 students participated, and the top 12 were selected for the quiz. And I think I would leave it to Dr. Prakash to take you all through. And all the GB members of ISSLC are requested to assemble in Hall B for the GB meeting. So the buses to the gala dinner will be available from the from Fortune at the lobby from 7:15. Since there's a delay, we thought at 7, but I think from 7:15, 7:30, we should be leaving from here. Distance is about 7 kilometers. It takes about 12 to 13 minutes, so it's not very far off, and we'll drop you all back at your respective venues. So and we'll also try to wrap everything in another 15 minutes. Thank you.
No, but they are not able. Okay. Hello? Yeah. Hello, good evening everyone. So I'll be the quiz master for your stage round. I'll just invite the top 12 selected people. So you can come here, pick up a chit. There's a number written on the chit. There are 4 ones, 3 ones, 3 twos, 3 threes and 3 fours. So all those who pick 1 will be in team 1. All those picking 2 in 2 and 3 and 4 of course. Okay, and we'll then start the quiz. And there are 4 rounds in the quiz. We're terminating with a rapid fire. And I'll tell you the rules as we go along. Okay, so Dr. Bhavita, Dr. Vedant Shripad, Dr. Muthu, Dr. Shubham, Dr. Hema, Dr. Akash, Dr. Sai Naga. So one by one, please pick a chit. Yeah, please show me. 3, please sit in 3rd row. Yeah. 2, second one, please. 3. Biswajit, Dr. Biswajit, 4, 4th one. 1, first one. Dr. Rohan, Dr. Vishnu, Dr. Manish, and Dr. Mary Jeffrey. Okay, I hope all the 12 are here. Hello, whoever wants to remain in the audience are most welcome, and please don't prompt the participants. So, and we are giving you a buzzer, okay, to each one of you. Yeah. So this is your buzzer, okay. So just hold it, don't press it now. So we'll have a check also of the buzzer. There is a folder called quiz. Okay, it's in this. Thank you. Okay. So we'll just have a check of the buzzers, okay? So, no, not now. Team 1 can press buzzer. Okay, it's working. Okay, team 2, press. No, don't press it again. Don't press it, just keep it. Team 2. No, you have to press it up. Down. Okay. 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 So it's basically to be kept on a surface. So otherwise you have to press the back dot. Okay. So we'll go at it again. I've now reset it. Can team 1 press? Okay. Yeah, it's okay. Team 2. Okay. Team 3. Yeah. Team 4. Yeah. Okay. All the buzzers are ready. Right. So we'll start with, we have total of 4 rounds. The first round is a buzzer round. The second round is called the Ponsieve, as it was meant to be a Harry Potter themed quiz. So Dumbledore's Ponsieve, in which he shows his memories. So it's based on that. The third one is a new round. It's recent advances, and the fourth is a rapid fire. Okay. So I'll tell all the rules. Everything will come. So I'm Dr. Prakash, and I come from National Institute of TB and Respiratory Diseases at New Delhi. Okay, and I welcome you all. So we can have a just brief introduction. Please stand. Tell your name and institute. Okay, Dr. Hema from AIIMS Delhi. She's a surgical oncology resident. You? Dr. Vishnu, medical oncologist from Nizam's, Hyderabad. Dr. Biswajit, PGI Chandigarh, department, radiation oncology. Oh, this is a good team. One med-onc, surg-onc, rad-onc. Yes?
Dr. Vedant, medical oncology SR from JIPMAR Pondicherry.
Okay.
I'm Dr. Jeffrey from medical oncology, CMC Vellore.
Okay.
I'm Dr. Rohan, surgical oncologist from AIIMS New Delhi.
Okay.
I'm Dr. Manish, surgical oncology from AIIMS Delhi.
Okay.
I'm Dr. Bhavita, medical oncologist from SWIMS.
I am Dr. Shubham Sahu, pulmonary medicine from AIIMS Bhubaneswar.
Okay. Welcome, doctor. Because I'm a pulmonologist, we have a connect already. Doesn't mean I will favor you.
I'm Dr. Nagashri, surgical oncology, Kidwai, Bangalore.
Kidwai, Bangalore, okay. So we'll all give you mics, okay. Before starting, I want to make one point very clear. One is we need to have a judge. Sir, will you both be willing to be judges for the quiz? Yes. So for the judge, I'll only have questions like somebody has answered half, whether we have to give them half points or 0. Only that call you will have to take, sir. Yeah, okay, thank you. And from each team, we'll only have one person who will answer. So suppose you are the nominated one and he answers the correct one, you answer the wrong answer, I'll take your answer only. I'll take the person who has been nominated. So who is nominated among you three? You can change it for each round, that's not an issue. Okay, for this round who's nominated? Yeah, so give the mic to him and hold buzzer to be held by any of you. Okay, and all three of you can hold it. From team 2 who is answering, you will answer. From team 3, from team 4, you will answer. Okay, your introduction.
Dr. Akash Bhange from IMS and Some Hospital, Bhubaneswar, medical oncologist.
Okay.
Dr. Muthu Irappan, medical oncology from JIPMAR.
Okay. So we are ready, we'll begin. Okay. Okay. Now I'll reset it before every question. Okay, make sure the orange light is buzzing, visible. That means it is. Okay, so somebody pressed it. Please don't press it. Okay. So we'll go ahead. Everyone has a mic. All teams have a mic. Mic. Team 1, please give team 1 a mic.
Hello.
Okay, so we'll go ahead with round 1. I'll just introduce the rules and then we can go to the questions. Okay, so this is called the duel challenge. So it's a duel. So I throw a spell at you and you throw a spell back at me. So I throw a question at you and you throw an answer at me. Okay, so it's total 20 questions. Each question carries 10 points, -5 for the wrong answer, sorry. And past question carries 5 points if right and -5 if wrong. Past question will be in the order itself. Okay, so if team 2 is buzzing, it will pass to 3, pass to 4, and then pass to 1. And then it will go to the audience. Is that clear? Okay. So please be ready on your buzzers. Everyone seeing the yellow one. I'll reset it every time. Okay. And in case of any discrepancy, so anyway only one team can press it. The moment you press it, the buzzer, all the other buzzers will be invalid. Okay. Ready? Ready? Team 1, team 2, team 3, ready? Okay. So your first question coming up. So also please note, judge also to please note, sir, that answer needs to be told with immediately after buzzing. They cannot press the buzzer and then start thinking and discussing. Okay? You do that and then you press the buzzer. Do you get it? Otherwise, it will give you -5. That will be decided by the judge. Okay. Raj, एक scorer चाहिए. So you can be the scorer. Take a plain piece of paper and sit. Na? I'll tell you how to do it. Okay, so ready? Ready? Okay. So the first question coming up now. All of you please check your buzzers that it has the yellow light, orangish light. Okay. First question coming up. What is the theme of World Lung Cancer Day 2025? That's why we are all here. It's a conference of lung cancer, please. Anyone? No buzzers? Nobody? Anyone from the audience wants to answer? Do we have chocolates? Okay, so nobody's answering. It's breaking barriers, championing early detection and equal care. Right. So maybe we'll have more luck with the second question. We'll go ahead with the second one. All teams are ready. Okay. Check your buzzers. On 1st November 2025, which country for the first time introduced generational ban on smoking in the country? No newspaper readers either. Is the first time that some country has done this. That's why this question. Nobody? Anyone from the audience? No. No, wrong answer. Anyone from the audience? No? Sorry? Or? No, both are wrong, but very close. Starting letter of the country is same. No? Another one? Yes, Maldives is the correct answer. Unfortunately, we can't give you points. Okay? So it's Maldives, and they declared that anyone who was born after 1st Jan 2007, that is, they have not yet attained 18 years of age. So anyway, they are not smoking, so they cannot smoke further also. So it's called a generational ban. Okay? So coming for the third question, okay? You're performing a staging e-bus for a right apollo-carcinoma. You sample station 7, and the aspirate yields a frank bloody aspirate. What is the likely structure you have punctured? Anyone? No buzzers? Come on, this is a simple question. Okay, team 3 has buzzed. Negative marks is there if you answer wrong.
Aberrant pulmonary artery.
No, that is a wrong answer. -5 to team 3. Okay, it passes to team 4. Do you have an answer? Yes or no?
Yes.
Yes.
Left main PA.
Left main PA, that's a wrong answer. -5 again. Team 1 wants to try. Team 1. Team 2. Pass. Anyone from the audience? Yes, left atrium. Who answered? Okay. We'll give you a chocolate, sir. So it's a left atrium. Left atrium is at the junction of the main carina, just below it. On the contrary, it's also taught that one of the reasons for main carina's playing is LA enlargement. So 2 ways you can remember the answer. Okay. So coming to question number 4, buzzers check. Buzzers check. Okay. So that's a left atrium. Next question. List 3 patient-specific factors that would make you recommend SABR over surgery for stage 1A NSCLC. Yes. Who has buzzed? Yes. Team 4 has buzzed.
More than 75 years with poor lung functions.
Yes.
And comorbid conditions like ILD.
Okay.
Comorbid conditions more than 75 years.
Okay.
With poor lung functions.
Okay.
This is the.
So we'll give that to you. They get 10 marks. So the answer is medically inoperable, high surgical risk from severe comorbidities, and patient refusal of surgery. So 10 points to team 4. Okay. So I'm resetting the buzzer. Please check your buzzers. Next question. All teams ready, please. First proposed in 1975, developed based on 50 observations in patients. Set of histological diagnostic criteria for differentiating multiple primary lung cancer, also called synchronous primary lung cancer, from lung metastasis. What is the diagnostic criteria called? SPLC from lung mets. Anyone? No? No buzzers? Medical oncologists in the house? Nobody? Anyone from the audience wants to try? Anyone from the audience? No? That is what I want. No, 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 that is not needed. If the judge accepts, we can, if she wants to name the criteria, but she doesn't know the name of the criteria, she wants to tell what is inside. Will that fetch her marks, sir? Okay, we can do half. So you can buzz in. Okay.
Metastasis
on
the same primary.
No, it's a table. Can you tell the points on the table?
Yeah, radiological criteria. One is speculated.
No. It is not like that. No. I think you are confusing it with some other criteria. You will get -5 for that because you buzzed. I'm sorry, we can't. That's the rule. Okay. It's called Martini and Melamed criteria. Okay. So it basically, if there are two upper lobe lesions and if the mediastinum is not involved, either you biopsy both and both are of different histopathology, or you prove that the mediastinum is not involved and then they are synchronous or metachronous primary lung cancers. So that's the table that was there. I did not add the table, but you get the point. Okay. So -5 for team 1. So next question, please be ready. Following lobectomy for a 4 centimeter adenocarcinoma, what favors? Okay. Yeah.
PNA, LVSI, vascular invasion,
yes.
and node positive.
Okay, that's a perfect answer. So 10 points to team 4. So that's the second 10 pointer that they have. Okay, so tumor size more than 4. Suppose intraoperatively it has increased in size. High risk features such as visceral pleural invasion, lymphovascular invasion. That is what he said. So that's the correct answer. I'm resetting the buzzers. Okay, for the next question. Come on, team 1, 2, 3. You need to take chances. What is the standard dose or fractionation of definitive CTRT? Okay, again team D has buzzed, team 4 has buzzed.
60 gray, 30 fraction, and 32 gray is the critical OR dose for each of the D mean 32 gray.
Okay, sir. It's 34, he said 32, but the first answer is correct. It's okay, so we'll give full marks. So judges are liberal, so you get full marks, yes. So next question, all the teams be ready, please. Yeah, teams ready? Okay, that's 60 gray in 30 fractions, and it's a 34 gray, okay, 34 gray, or a V35 less than 50%, that's the criteria. A patient has osimertinib for EGFR mutant NSCLC, develops progression. What's the most common resistance? No, you have not buzzed. Who's buzzed? Team 1 has buzzed, yes. Met amplification, beautiful. And okay, that's it. 10 points to team 1. Okay, I'm resetting the buzzers. Time for the next question. All of you be ready. Okay, besides EGFR cross 1, name 3 other actionable mutations that are to be done in an. Okay, team 1 has buzzed again. Time.
NTR ke met ret
okay.
met NTR.
Okay, we can give that 10 points again to team 1. All of you please buzz fast. So only one buzzer will be taken. Okay. So you want to try? Is there anything wrong with the buzzer? You want to check again? Please check. Okay. Team 3. Okay, fine. So next question, please be ready. Okay, so these are all the mutations that have to be tested. Next question coming up now. What is the current ESMO definition of synchronous oligometastatic disease? Buzz only if you are sure. If you wrong answer will attract -5. Be wary of the negative marks. Okay, nobody, anyone from the audience? Anyone from the audience wants to try? No? Okay, team 4 wants to try, yes?
It's a lung lesion with a less than or equal to 3 up to 5 metastases.
Beautiful, 10 points to team 4. Okay, so single organ with 3 to 5 metastatic lesions. Of course, it is disputable, but that is the original definition that ESMO and NCCN have till now given, so we'll accept that. Okay, so all the teams be ready. 10 points to team 4 for that. Okay, so next question coming up now. Central located 3 centimeter NSCLC. What is the preferred invasive method for mediastinal staging if EBUS is non-diagnostic? Anyone? So many surgical oncologists in the house. Yes, team 2. Answer the question. You're buzzed, you'll anyway get negative if you don't answer also.
Cervical mediastinoscopy.
Okay, so mediastinoscopy, we can give marks for that. Either VAMLA, TEMLAS, anything of that you have to do. Okay, so 10 points to team 2 for that. Next question coming up. Okay, buzzers ready. What class of drug is added to a 5-HT3 antagonist and dexamethasone to create triplet regimen? Team 1 has buzzed. No, that's the wrong answer. -5 to team 1. Passes to team 2. It's already 5-HT3 antagonist is there. You're telling 5-HT3 antagonist name again.
Aprepitant.
Aprepitant is
NK1
the... Sorry? No, we have taken an answer. Now you can't come and say that, na? Should have interrupted your teammate. We have given it also. Okay? At least before they answered, you could have told. So that is the correct answer. 5 points to team 2 and -5 to team 1. Okay? So next question, be ready. It's a neurokinin receptor antagonist. That is a triple therapy. Dexamethasone plus 5-HT3 antagonist plus a neurokinin antagonist is considered triple therapy. Okay? Right. Next question coming up. Buzzers ready. A patient on EGFR has solitary progression, single bone site, excellent control. Yes. What is it termed as? What is the preferred management?
It is an oligoprogression.
Yes.
We can give local therapy RT and then continue the same.
Perfect answer. 10 points to team 4. Okay, so it's called an oligoprogression, and we continue osimertinib because it's a single progression and give local therapy in the form of RT. So next question, buzzers ready. 54-year-old male, smoker, SI, 300, dyspnea, facial swelling, CT image is shown. What is the next best step according to guideline? Okay, somebody has buzzed. Team 3 has buzzed. Yeah? Okay?
SVCU.
Yes? The question is, yeah.
Stenting.
Perfect answer. Team 3 gets 10 points. Stenting is the first step told by the guidelines, and only if there's no feasibility of stenting, we can go for directed therapy such as chemotherapy, radiation specific to the site, or chemotherapy if that also is not feasible. Okay, so that's the correct answer. And buzzers ready for the next question. Question 15, minimum predict PPO DLCO that is generally considered. Team 1 has buzzed.
40%.
40%, that is the correct answer. That 10 points to team 1. Okay, buzzers ready, we'll make it quick. 38-year-old non-smoker, progressive dyspnea, brassy cough, recurrent pneumonia requiring antibiotics. Don't press now, there's a CT coming. She underwent a pneumonectomy for carcinoid 18 months back. I'm showing you the X-ray and the CT scan. Okay, so I want a diagnosis. Come on, surgical oncologist, this is your bread and butter. Okay, so I'm playing the CT again. 18 months back, pneumonectomy, presents with dyspnea, recurrent dyspnea, brassy cough. Playing the CT again for the last time. Okay, somebody has buzzed. Team 4 has buzzed. Yes?
It's like cardiac torsion. Like
I want the name of the syndrome. -5 for team 4. Passes to team 1.
Collapse.
Wrong answer. -5 to team 1. Pass. Team 2 passes. Team 3. You want to answer. If you answer and it's wrong, it's -5. You tell me if you want to answer it or not. Answer to the mic. No. I won't take that. Then I'll pass it to the audience. Then you tell me the answer. Okay. If you want to just answer it without points and without negatives. Team 3 wants to answer. Answer? No. Anyone from the audience wants to answer? Yes. Anyone wants to try? Yes. I heard some answer. Sorry? No. Yes. Anyone? Yeah. Now you can answer. It is shifted. What I want the name of the syndrome. Even she answered that correct. That point. What she said is also right. The name of the syndrome is post-pneumonectomy syndrome. It's due to torsion. There's the name of the syndrome. I have not kept it. I can't change it. No, we can't. It's a name, na? It's a name. It's due to severe mediastinal shift and counterclockwise rotation of the heart. That's what is described in the book, and I can't give you points for that. Okay, so buzzers ready. Next question coming up. ALK positive develops photopsia blurred vision. Name the drug classically associated with this condition. Yes, team 1.
Lorlatinib.
No, not lorlatinib. Passes to team 2.
Brigatinib.
No. Passes to 3. -5 to 1 and 2. 3 wants to try. 4 wants to try.
Alectinib.
No, not alectinib. The one which is most commonly used in India because of financial issues. So crizotinib is most commonly associated. So you told everything A, B, C, everything apart from this. Sorry, three answered wrong. No, 3 didn't answer. 4 answered. Yeah, 4 is also -5. So -5, -5 and -5 except for team 3. Okay, so next question, buzzers ready. Patient post-plobectomy, post-op day 2, high output serous drainage, pleural fluid create by serum create ratio more than 1. Serous drainage, what is the diagnosis? Please read the question carefully and then answer. Surgical oncologist colleagues. Anyone wants to try? No buzzers? Diagnosis and initial management. No half answer. Half answer will not be decided by me, but it will be decided by judge, sir. No, pass. Anyone from the audience? Okay, any of the team wants to answer just for that? No negatives, no points. No, wrong answer. Yes. So urinothorax would have been if it's not a serous and a clear drainage. That's why the serous drainage is there. Yes, chylothorax.
Sir, but it is not creatinine, it is chylomicrons. We
No, chylomicrons is there, but chylomicrons is a absolute test.
No, sir, we never tested creatinine.
If you read lights, one of the other criteria for which exudate is positive is creatinine, bilirubin, cholesterol, everything you can test. Okay, so that's why it's a confusing question. That's why it's there for a quiz. If I say chylomicron positive, anyone in the audience would say it is chylothorax, na? Management is NBM and total parental nutrition, restrict medium fatty diet. Okay, so next question, buzzers ready. 19th question, 2 class of bone modifying agents in bone mets that are used in chemotherapy and critical treatment check. Okay, team 3 has buzzed. No, you have to buzz. Yes?
Sir, zoledronic acid and
Yeah.
denosumab.
Okay. And critical check?
Calcium levels and creatinine levels.
Okay. So that's the correct answer. 10 points to team 3. Okay. Buzzers ready. Last question coming up of this round. What is the double effect principle in palliative care? And particularly relevant when using high dose opiates for dyspnea or pain during end of life care. Anyone? No buzzers? Okay, no problem. They didn't buzz. Anyone wants to try? Anyone from the audience wants to try for chocolates? Nobody? No, that is a known side effect. So usually double effect is when there is a bad effect and a good effect. Since your intention of treating the patient is good, even if a bad thing happens, it's okay. So that's an ethical thing. So ethical framework argues that action with both good and bad is with a morally permissible if the bad effect is lesser than the good effect. Okay. So since I'm giving high dose opiates for alleviating the symptoms, even if the patient develops respiratory depression, it's okay. But we have to alleviate the symptoms of the patient. So that's intent of relieving suffering. Okay. So that's the thing. So we'll go to round 2. But by then, scorer can update the points of the individual teams. No. Click करना है बस. Hyperlinked. Okay, so we'll go to round 2. Do we have scores? Yes, team 1, 15, team 2, 10, team 3, 15, 35. So team 4 is leading the round. Sir? Yes, sir. $15.35. Okay. Maybe we didn't give them one -5, I think. She didn't add. You gave? एक बार sir के पास go to sir and check it up ना. Okay, we'll go ahead with the second round. Meanwhile, the scorers are just 3 and 4 are same, and 1 and 2 maybe 15-15 or 10-10. They'll just tell in 2 minutes. So round 2, we'll go to round 2. Round 2 is called the punsive. So there are a total of 8 questions, and we'll be going in round robin fashion. So we'll start with team 1 for this. Okay, so for the first for questions 1, 2, 3, 4, that is the first round, there'll be first page, which is the first clue. If you answer at that point, you'll get 20 points. But if you take the second page, that is the second clue, then you will only get 10 points. Okay, so remember that. And if at any time you answer wrong, it is minus 10. Okay, if you don't know, you can pass. Okay, question will be passed on to the next team. Pass question will carry 5 if wrong. Okay, ready? Team 1 will get the first question. If you take the clue, it is 10 only. If you don't take the clue and answer, it is 20 points. Okay, 59-year-old female admitted to the emergency with fatigue and altered mental status. She has non-productive cough and X-ray shows a mass in the right lung. Her random blood glucose is 36 milligram per deciliter, and after infusing 25% dextrose, she is absolutely fine. What is the diagnosis? Do you want to, please, our audience is requested to not prompt, please. Do you have an answer? Or do you want the second clue? No, okay, no, that's the wrong answer. You get minus 10. So, but can you tell me what it is? I want to know the diagnosis. Paraneoplastic is a vague and broad answer. Secondary to? Secondary to? I'll give you 10 seconds. If you can answer by that, I'll not give you negative, otherwise. I want the name of the disease and the syndrome. There is a named disease, there is a named syndrome. I want both. Then only your answer is correct, na? That's an easy guess, no? It's a lung cancer conference. It's obviously cancer, and it's cancer-associated paraneoplastic hypoglycemia. That's an easy guess. I want a syndrome. Okay, passes to team 2. Team 1 gets minus 10. Okay, team 2, I'm giving you the second clue. That is the X-ray, so that is the CT, and that's the histopath image. Do we have an answer? Plus 10 if you get it right, minus 10 if you get it wrong. Yes. Can we? No, not now. You can try after we exhaust the teams for no points. Passes. Question passes to 3. Passes. You want to try? You want to try? Yes or no? So we'll make it quick because there are too many questions left remaining. No? Passes to team 4. Yes. No, wrong answer. Minus 10 to team 4. Yeah. Solitary fibrous tumor of the pleura, and the syndrome is called? Solitary fibrous tumor of the pleura, and the syndrome is called? Doge-Potter syndrome. Doge-Potter syndrome, sir. Okay? So, no, we can't give you points, and unfortunately, neither of the answers you told correctly. So, minus 10 to 1 and 4, other teams are okay. So, the second question is to team 2. Ready? Okay. So, 45-year-old woman referred to the nearby clinic for fever, upper abdominal pain. Ultrasound abdomen showed hepatitis with some ill-defined lesion. They also did a CT. Biopsy showed CMV with titers positive. Other workup like HIV, RBS, everything was negative. X-ray CT is shown below. What is the diagnosis? If you don't know the answer, you can take the clue. You want the clue? So it is one of the components which may not reverse post-resection, and a famous cricketer is known to suffer from this condition. I don't want the diagnosis. I want the complication. Yeah. We can. Sorry. So we will give you 10 seconds only. We are running short of time. What? No, the complication is CMV. So I'm asking the full diagnosis of the patient. Question 10, 9, 8, okay, 6, 5, 4, 3, 2, 1. Passes to team C. Team C wants to try. No. Pass. D wants to try. No. Pass. Team 1 wants to try. Anyone from the audience wants to try? Sorry? No, not germ cell. A famous cricketer suffered from it. You must know the cricketer by now. Yuvraj Singh suffered from what? No, it was a thymoma. He suffered from thymoma. Yes, he suffered from a mediastinal tumor, which was a thymoma. But I'm asking, what is the complication of a thymoma, which leads to CMV retinitis? Immunoglobulin deficiency, also called Good syndrome. Okay, so team C for the question, 57-year-old male, admitted to our hospital due to dry mouth and eyes, progressive limb weakness, 2 months duration. I want both the answers, okay? The diagnosis and the complication. Five, 4, 3.
Clue, sir.
You want the clue? Acetylcholine receptor antibody was normal, and repetitive nerve simulation showed low compound muscle action potentials and post-exercise facilitation.
LEMS.
LEMS,
Lambert-Eaton.
secondary to?
Secondary to so paraneoplastic.
Paraneoplastic syndrome, most common cancer associated with LEMS.
SCLC.
SCLC. That is the correct answer. They get 10 points because I took the clue, team 3. No, this is not a buzzer round. Buzzer is over. So 3 points to team C. Okay. So that is LEMS and it is SCLC. Next question is to team 4. Okay. 16-year-old female admitted to the hospital, recurrent hemoptysis and coughing up of this. And she's also having chest pain for the past 5 months. Do we have a diagnosis? There's everything on the screen. That's all the question is. If you answer at this, it is. So I want the diagnosis and I want the name of the symptom that she's having. She's coughing up this. This is the first slide. You want the clue? I can go for the clue. You want the clue? Okay. This is the resected specimen. Yes, and the symptom of coughing up this is called? What is she coughing up? What is she coughing up? Tell na, correct. The answer is correct. Sorry? Hair. Yes. So what is it called? Okay. Sir, I think we can give them, sir. They are 10 points to team D. It's called trichoptysis. Okay? Trichoptysis. So hemoptysis is blood and trichoptysis is. So the fifth question, this is direct question, 10 points. Goes again to team A. Okay, originally identified as an antigen recognized in a patient with Hodgkin's lymphoma, cell line L428. It is named after a German city where it was tested using a 96 well plate. Okay, the gene locus was sequenced in 1996 and found to contain approximately 30,000 bases. What test or marker am I talking about? Team 1 wants to answer. No. Pass. Passes to team 2. No, this is not a clue. This is just one question. It passes to team 2. Team 2 wants to answer. We'll make it quick. Otherwise, we'll have to skip one round. No. 3. No. 4. No. The K67 marker. So it is known because it was named after the German city of Kiel. That is why Ki. And the 96 well plate, the 67th well tested positive. That's why it's 67, which we use ubiquitously for small cell lung cancers. Okay. So next question is to team B. This person in question at the age of 60 was diagnosed with cancer in his foot. Cancer. The swelling became painful, smelly, ugly, and doctor said he needs amputation. But miraculously, he is said to have been healed by Jesus Christ. Okay. And because of self-healing of this cancer, he is still worshipped by Catholics as by people suffering from untreatable malignancies. Not only that, in modern medicine, there are so many cases of spontaneous regression of all the tumors that are noted. So I want the name of the person. Who am I talking about? On whom it is known. Come on, medonc people. No? Spontaneously regressing tumor. That's basic question. Anyone wants to answer? No? Nobody? 2, pass, 3, pass, 4, pass. Okay, so I'll give the answer. It's called St. Peregrine tumor. There's so many reported cases, around 100 to 150 reported cases in the world. So it's named after Peregrine Laziosi, and that is the healing of his tumor. Okay, that's the original description in the Italian museum. Question 7 to Team C. On December 2nd, 1943, German military bombed the Allied control port of Bari in Italy. One of the sunken ships was secretly carrying this gas bombs. The explosion released over 100 tons of this substance into the harbor and affected hundreds of civilians and military personnel. Okay, 2 young professors who did autopsies of these people, Goodman and Gilman of our pharmacology book, they thought it might also kill the cancer cells in the lymph nodes, and that is the initiation of the first chemotherapy in the world, and that was first used on a 48-year-old man with lymphosarcoma in its terminal stage. So what drug am I talking about? Team C wants to answer? No? No try? Okay. Team 4 wants to try? Team 1? No? Nitrogen mustard. Beautiful answer. Beautiful. So it was nitrogen mustards. They were carrying mustard gas and that exploded. That marked the first chemotherapeutic agent. The patient, however, recurred in 6 weeks and died due to lymphosarcoma. And the second drug was methotrexate and pemetrexate both. Okay, so last question of this round to Team D. They get plus 10. Team C gets. 48-year-old physician, undifferentiated squamous cell carcinoma, employing nitric oxide. He opened up the chest and found that it was also involving the left upper lobe. Okay, so only a lobectomy would not have sufficed. So he went ahead with the first one-stage pneumonectomy in the world. So to keep it simple, who performed the world's first one-stage pneumonectomy? Do we have an answer? Is there a surgical oncologist in this group? You are the surgical oncologist. Do we have an answer or do we pass? Pass. Passes to Team 1. Anyone? Passes to Team 2. Passes to Team 3. Anyone from the audience? First pneumonectomy? Nobody? Sorry? You were very close. Very close. Evarts Graham. Okay, in 1933 performed the first one-stage pneumonectomy. So that's all we have for this round. We'll go to round 3. Nobody's answering well, underprepared, I think, or very tired after the conference. So do we have scores? Team 1? 10. Okay. Team 2? 0. Team 3? Team 3 also 10. Team 4? 0. No, not in this round. Tell me the total score. Okay, and Team 3? Total. First round it was 15, na? Yes? Okay. Team 1, 10, 10, 25, 35. Come on, you still have so many points to take. So team round 3 is going to be more difficult. It's a newer advances, but let's hope we get some answers. We'll start this time from D. Okay, so we'll go 4, 3, 2, 1, and next is a rapid fire. So first question to Team D. Okay, it's called Newts. 8 questions. Correct answer carries 20. Wrong answer carries -10. But if you're sure of the answer, you can double it and you'll get 40 points. Okay, but if you double it and answer wrong, it is -20. Doubling or negative is also double. Okay, so once answered wrong, question will be passed. Okay, and passed team cannot double it. Okay, so first question to Team D. Tracers targeting immune checkpoint inhibitors like PD-1, PD-L1 are used to express and predict the effectiveness of immune checkpoint inhibitor therapies. What is the tracer that has been studied? There are specific tracers which target PD1 and PDL1 and have been used in assessing the response to immunotherapy. What are the tracers that I've been talking about? Actually, half the questions we have asked till now have all been discussed in today's classes. If anyone had listened to the class by Professor Nilendu sir, you would already know the answer to this. So team D passes to team C. Passes. Passes, yes. No, that is the wrong answer. No, it's -10. No, that is not PDL1 testing. That's a general alternative for FDG PET. Team 1, pass. Anyone from the audience? Yes, beautiful. Zirconium 89. So zirconium 89 atezolizumab and zirconium 89 labeled nivolumab. Okay. So these were the newer ones. Next question, second question is to team C. Mariposa trial studied what therapy drugs?
Yeah, I'm sure about the answer.
I don't know. You may be sure. You want to double it? Is that what you're trying to say?
I was asking if he's
No, if you, that is up to you. But if the answer is wrong, then you will get -20. That is it from my side. I can't ask you to double. Yes, quickly.
I'll double it, sir.
Okay, you don't want to double it. Okay, tell me the answer.
It's about EGFR TKI.
Okay. No, I want the name of the drugs.
Lazertinib.
Okay.
Amivantamab.
Okay, that is the correct answer. And they get 40 points for that. Okay, so team C gets 40 on doubling it. Okay, so next question is to team B. The multicentric open labeled phase 3 randomized control trial non-inferiority studied segmentectomy versus lobectomy in stage 1 NSCLC, which is T1A, B, N0, M0, and proved non-inferior outcomes. What is the name of the trial? I want the name of the trial. If it's wrong, you get -10. You're sure you want to double it? Okay, so they have doubled it. Yes?
Violet trial.
Sorry?
Violet.
No, it's not the Violet trial. They get -20 for that. So it passes to team 1. You can't double it. Yes, that is the correct answer. It's JCOG 0802 or WJOG 4607L. So both trials. So they get +10, team 1, and they get -20. Okay. So next question is fourth question to team 1. First proposed by the WHO in 2015, the concept of STAS is known to be associated with poor prognosis in early stage NSCLC, regardless of the subsequent approach. Expand STAS. You want to double it? Yes. Spread to airway spaces. That's a beautiful answer. So they get 40 points for that. So STAS is spread through airway spaces, or tumor spread through airway spaces, or the lipidic pattern. So whenever lipidic is known, it is having a poor prognosis despite surgery. So we'll come back again to team D, which is the fifth question. On 7th October 2021, the FDA granted recognition to the first tumor mutation database included in public human genetic variation database. It is the first mutation database also to be recognized by the FDA. What is the name of the database? You want to try? No? Pass. Team C? Pass. B? Pass. A? Pass. Anyone from the audience? No? It's the OncoKB database put forward by the Memorial Sloan Kettering Hospital. So that's the first FDA approved database. Okay. Next question is to team C. First in-human trial to establish safe dose of vaccine for lung cancer along with chemotherapy was started in the UK in 2022. It's still recruiting, and they're recruiting till 2030. This is the world's first mRNA-based cancer vaccine. What is the name of the vaccine? The first and only vaccine for lung cancer with in-human trials. Anyone wants to answer? No? Pass. Pass. Passes to 1. Passes to 4. Nobody? Anyone from the audience? No? BNT 116. BioNext Target. That's the name of the company also, and they have patented it. They're currently recruiting. Okay. So question 7 goes to team B. Team 2, sorry. Published in NEJM October 2025, open label multi-centered phase 1-2 study, dose of 20 mg in patients with locally advanced or metastatic HER2 mutant NSCLC. What is the name of the drug? Okay, it was published in NGM in October 2025, just a month back. You want to answer? You want to double before answering? You want to double? What is there to lose when you already received minus 40, is it? No, minus 40, na? Sorry, minus 20, sorry. We'll
double, sir.
You want to double? Double. They have doubled it. Okay.
Neratinib.
Sorry?
Neratinib
no.
to oral TKI.
No. Anyone wants to answer? No. 3, 4, team 4, team 3. No. That's the SOHO 1 trial. It's not the correct answer. Last question of round 3. Approved by the US FDA 15/04/2025. AI-based lung cancer screening screens both the lung and heart in 30 seconds. Okay, so it provides dual screening. For the first time, it has been approved by the US FDA with a speed of 0.124 seconds per rotation. I don't know what it means, but that's what it says on the description of the US FDA website. Anyone wants to answer? No? 1 passes, 4, 3, 2, pass. Okay, so that's called the Spotlight or Spotlight Duo. Okay, so that's the latest application. So it's AI-based lung cancer screening and cardiac screening both. Okay, so that brings us to the last round. So for this round, it's the rapid fire. This is the last round. You have 75 seconds per team, only 75 seconds. There are maximum of 12 questions. So, sorry, there's no negative marks in rapid fire. You can answer every question only once. Okay, so, but once you answer, you cannot go back to that question. But if you pass, you can go back to the question if time permits. And if I start a question and your time runs out, you can still take that question. I'll allow you to take that question alone. Okay, not the next one. Is that clear? We'll have scores of total after round 3. Team 1. Okay. 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 Team 4, 35. Okay. So 60, 65, 35, and minus 40. Right. So, sir? Yes, sir. Okay, sir. Okay. 4 is 35, same. So, please. No, not team B is okay. Team C, sir is saying 55. You are saying 65. Please confirm it with sir. Na? Okay. So in rapid fire usually we give the chance for the highest team to retain the title. Okay. So we'll start with the team that finished the lowest first in round 3. So we'll start with team 2. Then we'll go to team 4. And once ma'am confirms it with sir, we'll decide whether 1 or 3 has to go first. Okay. So we'll start with team 2. Ready? So who's going to answer? Okay, you'll be the answering. Okay. So there's 75 seconds on the clock. So can we have a timer, sir? Can you please have a timer? Yes. So 75 seconds on the clock. You can start the start when I start reading the first question, sir. Ready? Timer ready? Rapid fire ready? Okay. So this is called the house cup, because you get the chance to win by scoring many points. So total of 120 points are there for grabs. So if you answer all 120 and the others don't, you can still win the cup. Okay. So maximum number of questions is 12. So we'll start. Team 1, you are ready? Okay. Timer is ready, sir. Start the timer when I start reading the first question. Okay. So identify this person. Pass. Identify one author from this book. It's the official textbook of the IASLC. You want to answer? Pass. Pass. 2 IHC markers for small cell.
Synaptophysin and chromogranin.
Okay, correct. Identify the incision type. That is the correct answer. Identify the area denoted by red. What volume does it depict when it comes to radiation fields? Sorry? You want to answer or you want to pass? Pass. Tumor size 3.5 in right lower lobe, 1 centimeter in right upper lobe, both malignant. N2 M0. What is the stage? 3B. Okay, that's the correct answer. Mention to NTRK inhibitors.
Entrectinib and larotrectinib.
That is the correct answer. First node to be sampled in this tumor. Stop. So we'll allow you to take this question. Your time has run out. First node to be sampled during staging in this cancer. This is the cancer patient with a tumor here, and all the others are nodes. Which node do you want to sample first? Can you point it out? During a staging EBUS. 7. That is the wrong answer. So you sample the N3 side first. So N3 is the opposite. Yeah. So N3 is that. Nah? The 7 is N2 for both sided lesions. Okay. So you can answer this, but you will not get points. Most common site of METs in lung cancer? Adrenal. That's correct. True or false? Current smoker, 1B disease, planned for lobectomy. Risk of post-op complications is 2 times higher than a former smoker. Is this statement true or false? Okay. Sorry?
True.
It's true. It's false. It's 4 times higher. Identify the histobad diagnosis. No, they are for this thing, sir. We have answers. You want to answer this?
Lepidic.
No, it's not lepidic. It's non-invasive adenocarcinoma. No, it's golden S sign. I put it because many people answered in the wrong in the prelims also. So they didn't get Tony Mock. They didn't get Harvey Pass. They got this 3, 4, 5, 6. That's all. So 1, 2, 3, 4. 4 questions, 40 points. Okay. So next is Team D. Team D is ready. Who is going to answer? You are going to answer. Others can help him in answering. Okay. So second team, 75 seconds, sir. Ready? I press start only when I start reading the first question. Team 2 is ready? Ready? Timer ready? Okay. Identify this person. Pass. Tell me one author of this book. Pass. 2 markers for squamous cell carcinoma. Correct. That is the correct answer. Identify the incision. Anterolateral thoracotomy is correct. Identify the area denoted by blue and what volume does it depict. Okay. Tumor size 5 centimeters, involves main pulmonary artery. N1, M0. What is the stage? Stage 3B. That is the wrong answer. Mention drug active against NRG1 mutation. Pass. Pre and post chemo PET is shown. What is the term used to denote this? Assume no other lesions anywhere. That is the correct answer. Most common primary leading to endobronchial lung mets. True or false? Patient with SCLC post chemotherapy develops febrile neutropenia. MASCC score is 20. He can be treated on OPD basis. Pass. False. Okay. Identify the cancer type. Okay, that is correct. Identify this X-ray. Stop. We'll let you take this question. After this, you cannot answer anymore. You have 10 seconds only to answer this, since it's the last question. No, that's the wrong answer. Anyone wants to answer this? Pulmo, probably. You're the pulmonologist. Do you want to answer this question? No? Anyone from the audience? Yes, it's a Luftischel sign. Beautiful. That's a Luftischel sign. So we'll see how many they got. They didn't get Kazuhiro Yasufuku. He was the inventor of the EBUS, because of which staging has become a cakewalk for us. Jack Roth is the name of the book. P40, P60 they got correct. Anterolateral CTV 3A, not 3B. 410 is 3A. Zenoctutumab, CMR is correct. Breast they didn't answer. False is correct. Squamous is correct. So 1, 2, 3, 4, no, 5, 6. 6 questions, 60 points. Okay, 6 correct? Or did I miss any? Correct. Okay, so what was the points of team 3 and 1? At the end of the last round, 55 or 65? 55. So team 3 will go third, and team 4 will get the chance to defend. Okay, so you're ready, team 3? Okay, so who is going to answer?
Myself.
Okay, so 75 seconds on the clock. Team 3 is ready. We are starting the quiz. Okay, identify these 2 people.
Pass.
Pass. Identify the author, one author of this book.
Devita.
Name of the author. Author, not the book name, the
Pass,
author name.
pass.
2 IHC markers for adeno.
TTF and CK7.
Okay.
Nalccon.
Identify the incision.
Utility incision.
Sorry?
Utility incision, lateral utility incision, port utility.
Pass, pass.
I'm sorry, I didn't get it. Identify the
Pass.
area by yellow.
Pass, pass.
No. Tumor size 3.5, eroding chest wall, N1, M0, stage. 3A, that is a correct answer. Two drugs active against MET exon 14 skip mutation.
Capmatinib and depot.
That is the correct answer. PET CT is generally not recommended for nodules less than -mm because of high risk of false negatives. No, wrong answer.
6 mm.
Most common cause of malignant pleural effusion in non-lung tumors. Non-lung.
ovary.
No, that's the wrong answer. True or false, patient diagnosed with case of adenocarcinoma 3A, neoadjuvant chemotherapy, preferred platinum is carboplatin.
True.
True, that is the wrong answer. Identify the histopath diagnosis. And I've given a clue also down.
Neuroendocrine tumor.
Okay, we'll come to that later. Identify the most likely diagnosis.
Pulmonary thromboembolism.
No, that is the wrong answer. Have you missed any? Do you, sir, stop. Okay, we are out of time. Okay, so sir, can we give Devita? The book name is Devita. She answered Devita, but the name is Vincent Devita Jr. We can give. We'll give them. That's one. That is true. And incision, what did you say? What was the name you said?
No, actually I was saying the utility incision for VATS.
What incision?
Utility.
Utility, no, that's the wrong answer. ITV you didn't answer. 3A you answered. Capmatinib you answered. That's 8 mm. Breast more than ovary, but CA breast is the first one. And that is, no, I had typed it wrong. For neoadjuvant, preferred is cisplatin as per NCCN. And it's a typical carcinoid, so we'll give that to you. And the last is diffuse pleural thickening, so that is wrong. So 1, 2, 3, 4, 5. 50 points to team 3. Okay, so last team and the last round, who is going to answer? You will answer, okay. Please, Mike. Sir, 75 seconds, sir. Start once I start asking the first question. Okay, ready? Ready? Okay. Timer ready? Ready. So we'll start now. Identify these persons.
Pass.
Pass. Identify. No, not the name of the book. Now, one author. 2 IHC markers for mesothelium of the pleura.
CK7.
Wrong answer. Identify the incision.
Hemiclamshell thoracotomy.
Yes, that's a clamshell thoracotomy. I denoted by green. What does it indicate?
PTV.
Sorry? PTV, that's correct. Tumor size 3.5, N0, M0. What is the stage?
Stage 1B.
1B, that is the correct answer. 2 drugs active against red proto-oncogene. Okay. 2 drugs, not 1. Pass. 2 contrasts other than 18 FG which can be used for PET CT. Okay. Okay. We'll give that. Most common malignancy leading to cannonball mets. Sorry? No, that's not the most common. That's not the most common. True or false, diagnosed case of adenocarcinoma, PDL1 70%, exon 19 deletion. Preferred choice is ICI plus targeted therapy. False. Identify the histopath diagnosis. Identify this syndrome.
Superior circus syndrome.
Stop. We'll let you take this question.
SVC syndrome.
Sorry? Pancoast is a tumor. Do you want to tell the name of the syndrome? We'll still give you. Okay, we'll give it to you. So that is one. Okay, and we'll answer the. So first 2 are wrong. Third is also wrong. No, no, no. You should have told the full name, sir. Okay, we'll give it to you. We'll give it to you. So that is 1. 2 is clamshell. WT1 is wrong. You said CK7. That is for adenocarcinoma. PTV is correct. 1B is correct. Cell per catem will give 5. Dotatate, dotanoc, that's okay. Renal cell is more than choreo, is more than testicular cancer. 10 is false. I don't remember what you said. No, I don't remember. Wait. Yeah, you said false. Okay. So, and 11 is wrong. 12 is correct. Okay. So, 1, 2, 3, 3.5, 4.5, 5.5, 6.5, and 7.5. So, 75 points. So, there is no need for a tie break. Otherwise, the tie break was there. We had one question for 150 points. Because the person who carries the golden snitch gets how many points? No Potterheads in the house, is it? So that's why the last one was called golden snitch. No Potterheads? I'm sorry. Okay, so that brings us to the end of the quiz. So we'll have a look at the scores. So it'll take 2 seconds. They're just calculating. Okay. In second place is team 3 with 105, and in first place, they are the winners of the quiz, is team 1 with 135 points. Okay, so I thank the organizers for giving me this opportunity to conduct the prelims and final round. I hope it was enjoyable. Thank you.